And to deliver this talk, I'd like to request Dr. Rantu Burman sir to kindly come over the stage. Sir, please.
Good morning, everyone. Respected my chairpersons, teachers, seniors, and my friends. So, my talk will be on invasive and opportunistic fungal lung infection, a growing concern. As we all are aware that India is the capital country of diabetes, HIV infection, and the increasing prevalence of hematological as well as the solid organ malignancies with increasing use of the immunosuppressive therapies. The fungal infections are growing alarmingly, which is a really it's a real concern. So before going to the topic proper, I would like to brush up something about fungus. So what is fungus? Fungus are actually ubiquitously found eukaryotic organism. That means fungus is found everywhere in the environment and it has a definitive nucleus like that of animal cells. It also has a rigid cell wall which contain chitin and polysaccharides. It is estimated that almost 1.3 million different types of fungus are available in the environment, out of which only 300 species can cause human disease. Almost 3.8 million deaths annually across the globe, and nearly 70% of all these fungus in related deaths occur due to the invasive candidiasis, and rest are by the cryptococcosis and aspergillosis. Now, if we look at the classification of fungus, that is clinical classification, the fungus are classified mainly. The first group is the yeast. Yeast are basically unicellular organism which divide by asexual reproduction, forming the pseudohyphae. Uh, Candida species are the commonest species, which are usually the normal commensals of our GI tract, but due to immunosuppressive states, that can be lead to severe candidiasis, invasive candidiasis. As such, candidiasis does not cause isolated pulmonary lung infection, even in an immunocompromised patient. Most of the time, the colonization is there. The next important group of yeast is Cryptococcus. Cryptococcus species belongs to mainly the Cryptococcus neoformans, Cryptococcus getis, and these are notoriously known for causing severe meningitis, particularly in the HIV patients. Next group is moles. Moles are multicellular organisms which divide by both sexual and asexual reproduction, forming the hyphae. The main two groups of moles are basically Aspergillus species and the Mucorales orders, which includes Mucor, Rhizopas, and Rhizomucor. These moles are notoriously known for causing severe devastating syndrome like sino-orbital cerebral syndrome and pulmonary syndromes. Next is dimorphic fungi. Dimorphic fungi means it can behave as a yeast or it can behave as a moles. In the environmental temperature, that is outside our body temperature, they behave as a moles, but inside our body they behave as a yeast. These dimorphic fungi are also called endemic fungi because these fungi are mainly present in particular geographical locations. Example of dimorphic fungi are histoplasma, blastomyces, coccidiosis, paracoccidiosis, porotrix, and these are mainly found in the North America and Central America. And in Asian country, the Gangetic plain, we get some cases of histoplasmosis. Next is the dermatophytes. These are basically superficial infection that doesn't cause any invasive infections. Pneumocystis, initially it was thought to be a protozoa, but in 1980 it was classified as a fungus which can cause severe pneumocystis jirovecii pneumonia. So these are the common fungal pathogen that can cause infections, but Aspergillosis, pneumocystis, cryptococcus, mucor, histoplasmosis, these five groups are commonly known for causing pneumonia or lung infections. So what is invasive fungal infections? There must be presence of fungal elements either as a mold or yeast in the deep tissue That must be confirmed by culture and histopathology. Then it is called invasive fungal infection, which have a very high mortality rate and morbidity rate. So when we approach to a patient with fungal infection, the fungal infection in particularly basically present with pneumonia or bronchopneumonia. So they usually present with cough, sputum production, hemoptysis may be present or may not be present, usually present with pleuritic type of chest pain, and fever may be present, may not be present. Because the most of the patient is immunocompromised patient, therefore fever may not be present. And sometimes in radiological X-ray or CT scan, we may get asymptomatic some radiological findings. So most of the time we get nodules, masses, and cavitary lesions, which are usually caused by mold infections and predominantly, and ground glass opacities predominantly caused by pneumocystis jirovecii. But both can be present in vice versa. So in the microbiology, diagnosis of fungus, first is always the direct microscopy. So whenever we get a good sputum sample, tracheal aspirate or bronchoalveolar levels, first we always do with the fungal stains, and a good microbiologist can detect the fungal hyphae or pseudo hyphae by stain with the potassium hydroxide, calcoflower, GMS and past stains, although it is a non-specific and low sensitivity. Culture. Culture of fungus is always the cornerstone diagnosis. If we get the samples from the sterile sites, particularly if there's blood culture sensitivity of yeast is almost 50 to 95%, while for the moles it is 1 to 5%. One main drawback of the culture is that it has very slow turnaround time. For yeast, most of the yeast it takes 30 to 36 hours, but Candida glabrata it takes up to 80 to 90 hours, and moles it takes up to 4 weeks. So we cannot wait to get the culture reports and to start the antifungal drugs. Again, if the sample is from the non-sterile site, we cannot distinguish whether it is a colonization or it is a tissue invasion. There's the histopathology. Histopathology, the samples are mainly we get through biopsy, that is transbronchial biopsy, or it may be through CT guided or imaging guided biopsy. So it is invasive procedures. So it is difficult sometimes to get the samples because the patient may have neonates in elderly patient hematological malignancies. So it is difficult to sometimes to get the samples. Again, in the sample, sometimes the microbiologists find to differentiate the in between the filamentous fungus, like whether it is a aspergillus or is a fusarium or is a scedosporium. Again, for to diagnose cultural based diagnosis, we need a very expertized microbiologist who can identify this fungus. But in our part, these are really a rare thing. Therefore, we have to diagnose the fungus on the basis of non-culture based diagnosis. The non-culture based diagnosis basically belongs to whether antigen detection, antibody detection, or by molecular studies like PCS. In antigen detection, first is always the 1,3-beta-D glucan, which is a polysaccharide fungal cell wall component, is a pan-fungal antigen found in almost all the funguses except in mucorales and the yeast phase of blastomyces, and most of the cryptococcus BDG are usually absent. The sensitivity and specificity depends almost 70 to 80%, particularly useful culture negative patient in deep-seated candidiasis or culture negative pneumonia. There can be a false positive 1,3 beta BDG if the patient is receiving beta lactam antibiotics, if the patient is receiving albumin, IVIG, patient on hemodialysis. So this in that context we may get false positive BDG. Galactomannan is also important component of fungus, particularly very specific for aspergillus. Overall sensitivity specificity almost in an 80 to 90%. We also should know about the cutoff values. The cutoff value if the blood is more than 0.5 and in the bronchoalveolar levels is usually 1. If the combined the test specific sensitivity is high, uh, the beauty of the test is that this can be detected in the serum before the appearance of the clinical symptoms as well as the radiological symptoms or culture negativity. As well, the false positivity with the cross reactivity with the fungus may be found, or the previous piperacillin tazobactam causes false positive galactomannan. So I will present a case, a 45-year male diagnosed case of acute myeloid leukemia on induction chemotherapy with steroids, presented with history of fever for last 7 days, dry cough and breathlessness for last 3 days. Patient also had absolute neutrophil count of almost 200. So this is the CT picture of that particular patient with a uh, nodular lesion in the right lower lungs with surrounding ground glass appearance, typical of halo signs, and his galactomannan in serum and bile was positive. So my diagnosis was this is a case of probable invasive pulmonary aspergillosis, and patient was treated with initially IV voriconazole followed by oral voriconazole for 12 weeks. Patient got improved radiological as well as clinically. So aspergillus spores basically present everywhere in the soil. The incidence of invasive aspergillus is almost 2.1 million cases with a mortality rate of more than 85%. The clinical manifestation of aspergillosis mainly depends upon the host immune response and the pulmonary lung architecture. So this is the spectrum. In a normal host, usually there is no sequelae. If the patient is having pre-existing cavitary lung disease, patient may develop aspergilloma. In a COPD patient usually develop chronic necrotizing aspergillosis, which is a semi-invasive form of aspergillosis. And in immunocompromised patient usually develop invasive pulmonary aspergillosis. If the patient have pre-existing asthma, atopy or cystic fibrosis, due to the hypersensitivity, patient may develop allergic bronchopulmonary aspergillosis. So these are the important risk factors. The classic risk factors usually have the patient have neutropenia, not only neutropenia, if there's prolonged and profound neutropenia, if the patient received corticosteroid therapy more than 3 weeks at a dose of 0.3 milligram per kg, patient underwent hematopoietic stem cell transplantation, acute myeloid leukemia patient, advanced age. These are the classical risk factors. And COPD and critically ill patient, particularly in ICU, these are the emerging risk factors. So radiological diagnosis is presence of one of the following four pattern of CT is diagnosis. If there is a consolidation without the halo sign, air crescent signs, cavity. So diagnosis of invasive aspergillosis, basically it was done on the patient of immunocompromised patient, particularly by European Organization for Research and Treatment Cancer in and Invasive Fungal Infections. They have categorized the invasive aspergillosis into three groups: proven, probable, possible, on the basis of compatible host factors, clinical criteria, and mycological evidence. Treatment according to the Infectious Disease Society of America, voriconazole is always definitely the first choice because it's a broad spectrum azoles, except in mucormycosis. Although it is a fungistatic, but in aspergillus is always a fungicidal azoles. So should we start early? Alternative voriconazole or isavuconazole or amphotericin B liposomal. Echinocandins are usually not first line of drugs because these are fungistatics, but combined drugs should be treated in a refractory cases. The new advances in the antifungals, particularly the isavuconazole is a near azoles, was found to be non-inferior or equally effective in voriconazole, particularly in basic mold disease. Isavuconazole is a water-soluble azoles, therefore it has a predictable pharmacokinetics and it doesn't routinely require therapeutic drug monitoring. Okay. Next is mucor. Mucormycosis is the most lethal and angio-invasive fungal infections caused by mucoral family. Disease burden is 70 times higher than that of the global average. They are mainly found in hematological malignancies, poorly controlled sugar, diabetic ketosis, and then we have recently seen in SARS-CoV infections. They can cause devastating rhinocerebral, sinopulmonary, and necrotic cutaneous form of presentations. This is a reverse yellow sign, that is presence of ground glass opacity inside the consolidation. The diagnosis is mainly done by culture, but up to 70% cases can be negative. So currently no validated serological biomarker is available. So we have to depend upon radiological clues and PCR. So treatment of the underlying causes, early initiation of the antifungal therapy, particularly the amphotericin B, liposomal, and surgical debridement of the affected tissue. Last case, a 35-year-old Female present with a 7-day history of progressive dyspnea, non-productive cough. On examination, she is respiratory distress and her room air saturation was 80%. She is a known case of HIV with CD4 count 40. And this is her CT, which have bilateral ground glass opacity in the both lungs, sparing the peripheral zones. So it is obvious what is the diagnosis. The diagnosis is pneumocystis jirovecii pneumonia. It is very extremely challenging to diagnose due to diverse and non-specific presentation of pneumocystis. Classical factors, predisposing factors we know, usually presents with productive cough, non-productive cough, fever, and progressive dyspnea. Hypoxemia is characteristics. In jirovecii pneumonia, where are we? Common in advanced HIV cases, clinical diagnosis is required in most cases. In a right patient, right presentation, right X-ray. BDJ and sputum PCR can help us, but it is not confirmatory. There are a lot of therapeutic options regarding the dose of cotrimoxazole, doses of steroids, and we don't know the pattern of resistance, very high mortality rates. So I have to stop here. Thank you.
Thank you, Rantu, for your excellent presentations. And the fungal infection in the subject of internal medicine is very important because most of the time it is diagnosed little delay and with complicated cases with multiple organs involvement. Sometimes we have to very choosy
Yes.
because you have to see the do no harm policy to the patients. So any question query from one or two question from the audience?
Languages. Tuberculosis often comes as a differential diagnosis in case of your cavity formation. There are some characteristics of the cavities which are formed by tubercular infection, mycobacterial infection, and there are some special characteristics depending upon the anatomical location, other characteristics of the cavity. And there is a particular radiological sign that is known as Monod sign also. So will you throw some highlight or speak a few words how to define it because it is a common problem which is faced by the physicians here
Yes, sir.
in India.
Definitely. So in our part, tuberculosis, we cannot ignore tuberculosis. Tuberculosis is always the first diagnosis. So whatever sample we have available, first is the respiratory samples. If we get a good quality sputum, tracheal aspirate or bronchial virus, first is the gram staining for tuberculosis, sir. Then we have to stain for this sputum microscopy. Then we have to send for it this called Truna test. We have to send definitely the culture test. Otherwise, first is the microbiological diagnosis, then the tissue diagnosis. From that way, we can differentiate. Otherwise, how can we
The,
distinguish?
it is not question, just a comment. The problem with the fungal infection, that pulmonary fungal infection, common the sample collection.
Very
The oral cavity may be contaminated with a lot of fungus. That's why during sample collection, the oral cavity should be rinsed with normal saline
exactly, sir.
before collecting. Otherwise, we may get false positive
Up to
result.
normal individual, 15%
Yes,
may have
yes.
colonization. 15% may have aspergillus colonization.
Sir, when to suspect? Is it the only immunocompromised or any other?
Yes, that is why the emerging risk factors are particularly in ICU patient. If the patient is getting the broad spectrum antibiotics, broad spectrum antibiotic, and my patient is not responding, then we have to think of something different bugs are there. If there's a radiological abnormalities are there after getting of all these broad spectrum antibiotics, if the patient is on central line, all these lines, catheters, patient was on total parental nutrition, patient is having fever, increasing counts, patient going hypotensive. So is organ involvement there, then we have to think of sepsis, fungal sepsis. So not necessarily always there must be immunocompromised state, but in COPD patient, in critically ill patient, if your patient is not doing well after getting good antibiotic, good broad spectrum antibiotic, we should think of fungal because it is not very rare.
Thank you. So it is the high degree of clinical suspicion that actually leads to a diagnosis of invasive. Thank you. Thank you very much. If there is any question, we can conclude this.
Thank
So
you.
let us conclude the session.
Thank you, sir.
Thank you for that insightful session. Now I would like our chairpersons and the speakers to proceed to the felicitation area. Moving forward to our next session, it gives me great pleasure to introduce the chairpersons for this session, Dr. Kamal Kumar Jain, Dr. Naruttam Sonowal, Dr. Anjan Jyoti Bhargav. I request you to kindly chair the proceedings. I'm also very delighted to introduce our speaker, Dr. Srimanta Madhav Borua, who will speak on the topic Skin, the Mirror of Internal Health. We kindly request Sir to begin the session.
Slide itu no? Up down itu. Good morning, everyone. Respected chairperson and respected delegate. It's a vast topic. It will be very difficult to complete within the time. I will try. That skin, the mirror of internal health. Yes, yes. হাতী মাৰি ভুৰুকাত ভৰাব লাগিব. Then I'll skip some slides because of time. The skin manifestation of internal diseases we can divide according to the different system. Now, in the endocrine disease, that coming to the first diabetes. Skin manifestation of diabetes can be divided into three: non-infective, infective, and fissures due to vascular insufficiency. Non-infective manifestations of diabetes, as all of we know, that acanthosis nigricans, that commonly it is found in the axilla, nape of the neck, and flexo areas. Granuloma annularis, that is with central depression, affect the fingers and back of the both the hand. Bullous diabeticorum, it is a painless blister found on the hand and feet in case of long-standing diabetes. Then necrobiasis lipoidica diabeticorum, single or multiple red brown lesion, commonly in the pretibial area. Then scleroderma diabeticorum, characterized by marked increase in the dermal thickening on the posterior back and the upper neck in a middle-aged overweight person. Then stiff hand, we can get the prayer sign and the contexture in the fingers. Eruptive xanthomas are not uncommon in diabetes. And coming to the infective skin manifestation of diabetes, like the necrotizing fasciitis, dermatophytosis, candidiasis, and some fissures due to vascular insufficiency in diabetes, like erysipelas, like erythema, digital gangrene, that periangual telangiectasia, rubiosis faciae diabeticorum. Then coming to the next endocrine disease, hyperthyroidism, velvety smooth skin, hyperpigmentation we may get, pretibial myxedema, fine line, mild but diffuse alopecia, koilonychia, onycholycosis, and focal or generalized hyperpigmentation, and vitiligo may be associated as a other autoimmune condition. It is the picture of pretibial myxedema. Then coming to the another disease, Addison's disease, hyperpigmentation, commonly in the mucous membrane or in the sun exposed area. Coming to Cushing syndrome, we may get global atrophy with the dermal and epidermal component affecting. Then multiple striae we may get purpura ecchymosis. Then coming to the skin manifestation in renal diseases. Renal diseases, xerosis is common due to uremia. Then uremic pruritus is a common condition in the patient with chronic renal failure. Then perforating disorders we may get in the skin, that is umbilicated papules and nodules with cell keratin plaque we may get in chronic renal failure patient. Then calciphylaxis is not so common. Then nephrogenic fibrosing dermatopathy, it is also not a common manifestation, but we may get uremic frost is common. We may get in uremia patient common in the forehead and the scalp. Then calcinosis cutis we may get in patient with chronic renal failure. Then coming to the skin manifestation in gastrointestinal diseases. IBD is known for its many skin manifestation like fissures and fistulas, oral cons, metastatic cons, pyoderma, erythroderma nodosum, then pyoderma gangrenosum, pyoderma vegetans, and chronic aphthous ulcer is also common in IBD. Erythema nodosum is not only IBD, we may get in many other skin conditions, but 3 to many other internal diseases, 3 to 10% patients with ulcerative colitis, and 4 to 15% patients with Crohn's disease, we may get erythema nodosum. Pyoderma gangrenosum is found in about 5 to 12% patient with IBD. Then acute febrile neutrophilic dermatosis is also found in patients with IBD. Aphthous ulcer, particularly recurrent aphthous ulcer, is found about 10% cases with Crohn's disease and 4% patients with ulcerative colitis. Celiac disease, we may get that cutaneous signs of malabsorption along with that skin manifestation like dermatitis herpetiformis. Gastrointestinal polyposis. Polyposis may be associated with many internal disease syndromes like the Peutz-Jeghers syndrome, Gardner syndrome, Cowden disease, and Benian-Rayleigh-Rovell-Siva syndrome. Then Conkety-Canada syndrome, then Breed-Hogg-Dubé syndrome, then many other syndrome, and neurofibromatosis may also be associated with that polyposis. The chronic liver disease, we know that is spider nevi, then caput medusa, palmar erythema, and jaundice. It is well known to everyone. Hepatitis C may be associated with necrolytic acral erythema, and it is a well demarcated acral dusky, discolored with peripheral blister formation progress to the keratosis. Hemochromatosis, also known as a bronze diabetes, there may be hyperpigmentation is most evident in the skin in sun exposed area, particularly on the face. Skin manifestation of the disease involving multiple system. Tuberous sclerosis. Tuberous sclerosis, the angiofibroma is common in tuberous sclerosis, is found around the nail, scalp, and forehead, previously incorrectly called as adenoma sebaceum. The previous terminology was adenoma sebaceum. New terminology is the angiofibroma. That periangual fibroma also may be found in tuberous sclerosis. Sjogren's patch and S-leaf macules are that are the classical of tuberous sclerosis. Neurofibromatosis type 1 may be associated with multiple neurofibromatosis tumor, and that is 1 in 3,000 births. It is not so uncommon. That is the cafe spot of the spots of neurofibromatosis, axillary freckles in a patient with neurofibromatosis. Stark-Weber syndrome. Stark-Weber syndrome, that is the most common neurocutaneous syndrome behind the neurofibromatosis and tuberous sclerosis. In Kawasaki disease, although it is not common in adult, common in the children, then morbilliform and scar lentiform lesion we may get all over the body along with the small vessel vasculitis. Noonan syndrome and Leopard syndrome, that the multiple lentiges, formerly it was known as Leopard syndrome, is a very rare condition, of course. Then the Leopard syndrome is characterized by lentigens, the ECG abnormality, ocular hypertelorism, pulmonary stenosis, abnormalities in the genitalia, growth retardation, and deafness. Skin manifestation in autoimmune diseases. SLE is known for its skin manifestation that that include the acute cutaneous lupus erythematosus, subacute cutaneous as lupus, then chronic cutaneous lupus. That is the acute cutaneous lupus, there may be localized molar rashes that is highly photosensitive. There is a tendency for scarring and but in butterfly distribution. Generalized lesion found in 5 to 10% cases with morbilliform eruption, more often in the sun exposed area, sparing the knuckles. Subacute cutaneous lupus, that irregular red scaly patch, non-scarring papillosquamatous lesion, highly photosensitive, associated with anti-Ro and La antibodies. Chronic cutaneous lupus is another another disease variety, also called as discoid lupus. That that is that is a pre-malignant lesion may be there, and scarring alopecia is common. Sarcoidosis is a chronic multisystemic disease. that people may develop skin lesion, particularly the skin rashes, then lymphadenopathy arthritis, which is popularly known as Lofgren syndrome. Lupus pernio, this is the inflammation of the subcutaneous fat that is commonly found in the neck and nose, lip, and cheek. Then systemic sclerosis. Systemic sclerosis has two clinical subtypes, limited and diffuse. That is the systemic sclerosis. We may get the salt and pepper distribution of the skin, then Raynaud's phenomenon, and scleroderma phases, that tight faces, sclerodactyly, inability to open the mouth properly. This is the salt and pepper distribution, this is the Raynaud's phenomenon, and this is the scleroderma phases. Dermatomyositis, polymyositis and dermatomyositis, that Gottron papules, then heliotrope skin rashes, Holster sign, and Salt sign. These are the classical of polymyositis and dermatomyositis. Jogen syndrome, dry skin. Due to dry skin, we may get the pruritus, then eczematous like skin rashes we may get in Jogen syndrome. These are the arterial vasculitis. Some individual with Sjögren syndrome, we may get arterial vasculitis in the skin. Skin manifestation in vasculitis. Vasculitis, the Wegener's granulomatosis, skin manifestation that we may get that this type of skin manifestation in Wegener's granulomatosis. Then coming to the Henox-Conlin purpura. Henox-Conlin purpura is a vasculitis, particularly in the lower limb. We may get the palpable that purpura along like this. Along with that, we may get the macroscopic or microscopic hematuria. Behçet's disease, that common symptom. Behçet's disease include the oral sore, genital sore, eye inflammation, and skin lesion. Skin lesion is the various skin problem we may get, including acne-like sores, nodules, and particularly in the lower legs. This is in case of Behçet's disease. Then skin manifestation in nutritional deficiency. Zinc deficiency is associated with ectoderma and enteropathetica. It is particularly in the children. Vitamin A deficiency is associated with the toe skin, that is that rough skin, particularly in the hands and the face we may get. Vitamin C deficiency may be associated with the follicular hyperkeratosis, then the fragmented corkscrew hair, and perifollicular hemorrhage. Niacin deficiency, the dermatitis, that is the particularly necklace-like distribution, we may get dermatitis. Skin manifestation of exanthematous fever. Measles, it is well known. On the fourth day, there will be raised fever appearing first behind behind the ear and the hairlines. Then Koplik spot. In rubella, the mucopapular rashes we may get in rubella. Rogeola or exanthematous sabitum, that is particularly in the infant. Then erythema infectiosum. Then scarlet fever is associated with that skin rashes within the 24 to 48 hours after the onset of fever. Hand, foot, mouth disease, although common in children, we may get in adult also. Skin manifestation of infectious diseases. Anthrax, we may get painless papules involving the hemorrhagic bulla with surrounding browny, non-pitting edema. Cutaneous tuberculosis is not an uncommon condition, needs a high level of suspicion to diagnosis. Lupus vulgaris, that is the hypertrophic form associated with soft tumorous nodules, ulcerative form, and that is not an uncommon condition. Then tuberculite, demonstrate tuberculosis focus in case of skin tuberculosis. Secondary, in case of HIV infection, we may get lot of skin manifestation like the herpes, varicella zoster, molluscum contagiosum, then human papilloma virus. Then the fungal infection of HIV, that is histoplasma capsulatum fungal infection, previous speaker has already discussed. Then pityrosis versicolor we may get. Then Kaposi's sarcoma in HIV patient. And scabies is well-known condition, there may be crusted Norwegian scabies. Miscellaneous disorder associated with the seborrheic dermatitis in case of HIV, that psoriasis, Reiter syndrome, then lot of skin manifestation may be there associated with HIV. Syphilis, yes, primary syphilis, there may be initial skin lesion, then more importantly, secondary syphilis. We may get that commonly involve the skin, mucous membrane, and the lymph node. We may get this type of skin lesion in the secondary syphilis, particularly palm and sole. Uh, Thank you, sir. Thank you for your patient hearing.
Thank you. Skin is a major organ who can give so much of clinical clue in medicines. So Simananda, you have presented very nicely, meticulously. You have covered up all the diseases. So one query from my side. Can you highlight some malignancies related skin manifestations?
Yes, lot of internal malignancy may be associated with skin manifestation, particularly your that acanthosis nigricans may be associated with CA stomach, CA colon. Then this already I have highlighted that many malignant conditions and autoimmune disease leading to malignancy. Some the Pausch-Jaeger syndrome and that Mann syndrome, Mann's type 1, type 2, all maybe have many things due to paucity of the time. I have not included many things that humpy bumpy lump may be associated with the Mann's type 2. So lot of endocrine and non-endocrine tumor, apudama, that may be associated with the skin manifestations.
Excellent presentation. Yeah.
Yes.
Sarcoidosis,
Yes.
lupus pernio.
Yes, sarcoidosis I have mentioned.
Yeah,
Sarcoidosis.
lupus pernio, that is one of the major manifestations. Secondly, you can also talk about the tuberculosis, Seggar,
Yes.
and other manifestations which may be due to this particular mycobacterium infection. CSS, Wisner's granulomatosis.
Yes.
But it is a huge subject. I can appreciate your limitation. So I must congratulate you again.
Yeah,
Thank you.
it was an excellent presentation. It was just like a revision of Harrison.
Yes.
If they are PG student, they will get quite a good,
Their degree of idea.
very nice. All revision was done.
Yes.
And as we all know, skin is the biggest organ and it's a sign of our internal health. A
Yeah.
good skin means you have a good health. So this is just a comment. Excellent presentation. Thank you.
So I think the list is very exquisite, and most of the diseases or the images which we have seen are pretty common. But I think one factor which will be a hindrance in delayed diagnosis is that in most of the patients, the primary consultants will be a dermatologist. So by the time we think or we put differential diagnosis of all these things, it may be pretty late. So that is one of the limiting factor in diagnosis.
Yes, sir. Exactly.
That's a good point.
One or two questions from the audience, if you have.
Good.
If no questions, we conclude the session here.
Goswami sir is very much interested to complete in time. To conclude. Yes, sir. Yes, sir. Time is important. Yes, sir. Thank you, sir. It is appreciable.
Thank you for that enlightening and well articulated talk. Now I would like our chairpersons and the speaker, sir, to kindly proceed to the felicitation area. Moving on to our next session. It is my honor to introduce our chairpersons for this session, Dr. Palak Das, Dr. Kaushik Mohan Deka, and Dr. Animesh Debnath. I request respective faculties to kindly chair the proceedings. And our speaker for this session is Dr. Tridip Kumar Das. Sir will be speaking on the topic antibiotic stewardship, what a clinician should know. Sir, we warmly welcome you to begin the session.
A very good morning to everyone. At the very onset, I'd like to thank the organizing committee for this great opportunity to be here. So this is really a very pertinent and a very important question for all of us. What exactly we should start, what for how duration, what. So antibiotic stewardship, what a clinician should know. So this is the line quoted by famous Alexander Fleming, who discovered penicillin. It is not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentration not sufficient to kill them. There is the danger that the ignorant man may easily underdose himself and by exposing his microbes to non-lethal quantities of the drug, make them resistant. So there he was talking about the most toughest thing which we are facing right now. That is the AMR or antimicrobial resistance. So antimicrobial resistance is when germs like bacteria, virus, fungi, and parasites evolve to resist medicines meant to kill them, making infections harder, sometimes impossible to treat, leading to longer illness, higher mortality, and major health and economic burdens. So the most important causes of antimicrobial resistance are misuse and overuse of antibiotics, which we have been doing every now and then, poor infection prevention control, incomplete or inappropriate treatments, agriculture and veterinary misuse, lack of rapid diagnostic tests to differentiate whether it's a viral infection or any bacterial infection, poor antimicrobial stewardship in any hospital or any nursing home or long-term care facilities, slow development of newer antibiotics and biofilm formation, especially in catheters, etc. So you can see in the slide that 62% of people self-medicated themselves. 71% of people doesn't know whether they are running with a viral infection or bacterial infection. 53% of the people share their antibiotics with others. They think that I'm feel better, that definitely are going to also feel better. 39 to 40% people never use the completed drugs. This is the major concern that we are facing. A lot of resistant organism in the community nowadays. Like India itself, we are facing with E. coli, Klebsiella, Acinetobacter, Pseudomonas, Staph aureus, etc. So 6 out of the 18 most alarming antibiotic-resistant threats cost the US more than 4.6 billion annually. So these are organisms like vancomycin-resistant enterococcus, carbapenem-resistant Acinetobacter species, then methicillin-resistant Staph aureus, carbapenem-resistant enterobacteria, then ESBL, as well as multidrug-resistant Pseudomonas aeruginosa. So there are a lot many studies has been going all over the world. These are one of the study which has been published about the global scenario with emphasis on the Indian's perspective, basically on the what you call antimicrobial resistance. So if we talk about the top 10 country with the highest amount of consumption of antibiotics, we can see over in the slide that India top the list in everything actually basically. So over a span of around 15 years, the consumption of medication or antibiotics has been double from 3.2 to 6.5, you can see over here. So antimicrobial resistance is an urgent global public health threat, killing at least 1.27 million people worldwide and estimated nearly 5 million deaths in 2019 alone. In the United States, more than 2.8 million antimicrobial resistant infections occur every year. More than 35,000 people die as a result of it. Antimicrobial resistance is a major global health problem. Over 3 lakhs lives have been lost each year since 1990 in India due to AMR. This is a picture we can see that over nearly 3 lakhs people died annually. Definitely attributable factors are basically overuse or of antibiotics, poor infection control, antibiotic use in agriculture, and spread of resistant organisms. So this is a study which was carried out by ICMR. They have done a lot of studies with a lot number of patients. They have found the 5 most commonest microbes found in India in culture, like E. coli, Klebsiella, Pseudomonas, Acinetobacter baumannii, Staph aureus. But the most concerning thing they found over in this study is that they found resistant organisms like resistant antibiotics colistin, which is one of the most important antibiotic nowadays, and as well as resistant to carbapenem in the ISO setup. So how resistant basically occur very precisely. So if a non-resistant bacteria enters on the body, so once there's a mutation help. So if you're going to give any sort of antibiotics, it will kill only the non-resistant organisms. So resistant organism will definitely multiply, and they will thrive in your body to get more infections. So if we talk about the history of invention of antimicrobials, so this is the slide where you saw the pre-antibiotic era, the golden age of antibiotics, Me Too drugs, and discovery of white. The golden age of antibiotics where penicillin was discovered by the famous Alexander Fleming, but within a span of around 10 years, it has been found or discovered that in the year 1948, penicillin-resistant Staph aureus is declared a global pandemic. Then methicillin was used after that, but it was also resistant after a few years. So in a Me Too drugs means a lot many drugs have been introduced in the market in this area. Just slight changes have been done with the molecular structure just to reduce the adverse events as well as the resistant. But over this era also a lot of antibiotic has been got resistant. Discovery of white is the last phase where not many antibiotics have been discovered, and also we are getting a lot of resistant antibiotic, especially the colistin. It has been postulated that by the year 2050, 10 million antimicrobial resistant related deaths may be predicted every year. It's a very great concern. So 2001, WHO declares antimicrobial resistance a global health public health problem. So this is the same slide. We can see the resistant phase in the 1940s. We can see the penicillin resistant was identified in 1960. MRI said that the methicillin resistant Staph aureus was discovered in late 80s. Where vancomycin resistant enterococcus was detected, and in 2000, vancomycin resistant Staph aureus was also detected. This is the scenario that we are facing right now. This is a slide where you can see a lot of antibiotics which have been invented or discovered. We can see not many antibiotics have been discovered very recently. A few drugs like what you call this avicas, there is a ceftazidime with avibactam, as well as bevomir, there is a meropenem with bevobactam. These are the newer drugs which are on the market right now. So according to CDC, 20 to 50% of all antibiotics prescription in the acute care hospital setting in the US are either unnecessary or inappropriate. So like the hospital setting, 40 to 75% of antibiotics prescribed in nursing homes and long care facilities may be either unnecessary or inappropriate. So with the slow development of antimicrobials, accelerated emergence and spread of resistant organisms, antimicrobial stewardship is of utmost importance to optimize the use of existing antimicrobials. So what is antibiotic stewardship? So antibiotic stewardship is the coordinated effort to optimize antibiotic use in humans and animals, ensuring patients get the right drug, right dose, right route, and the duration for the best outcome while combating the global threat of antimicrobial resistance. So in 1996, John McGowan and Dale Girding first applied the term antimicrobial stewardship, where they suggested a causal relationship between antimicrobial agent use and resistance. So these are the 8 goals of the antimicrobial stewardship program: to educate health workers to limit antimicrobial resistance, to decrease adverse antibiotic events, to reduce healthcare costs, to decrease Clostridium infection, especially after using a lot of antibiotics, to reduce inappropriate antibiotic use, to improve patient outcome, to increase adherence to the local guidelines. So with the above goals in targets, the AMS or the antimicrobial stewardship program include the following core elements: leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. So definitely the hospital leadership commitment dedicate necessary human, financial, information technology resources, accountability, appoint a leader or co-leaders such as physician and pharmacists responsible for program management and outcomes, pharmacy expertise, action, implement interventions such as prospective audit and feedback or pre-authorization to improve antibiotic use, tracking, monitor antibiotic prescribing, impact of interventions and other important outcomes like Clostridium difficile infection and resistant patterns in the society. Reporting, regular reporting information on antibiotic use and resistance to prescribers, pharmacists, nurses, and hospital leaderships. Education is a very important part. You need to educate prescribers, pharmacists, nurses, and patients about adverse reactions from antibiotics, antibiotic resistance, and optimal prescribing of medications or antibiotics. So what are the 10 golden rules for hospital optimal antibiotic use in hospital settings? Enhancing infection prevention and control, prescribing antibiotics when they are truly needed, prescribing the appropriate antibiotic at the right time, administering antibiotics in adequate doses and routes, initiating as soon as possible to get the culture report, using the shortest duration of antibiotics based on the evidence, especially culture, achieving source control. You need to identify the source and you need to control the infection, supporting surveillance and educating staff and improving awareness about the antibiotic stewardship as well as the antibiotic resistance, supporting multidisciplinary approach for the successful of the whole program. What are the key principles for clinicians to be so we need to treat infections, not colonize them. Avoid antibiotics if you're suspecting this to be a viral infection. Use local antibiotic if you're having a local antibiotic in a hospital, in a nursing setup, or any government medical college. Start with empiric therapy only when it's very much needed. Never to targeted therapy once culture are available. So before prescribing, what are the checklist we need to do? Is the infection really bacterial, or there is any other evidence? Are cultures taken before starting therapy? What does the local antibiogram recommend? Consider We also need to consider patient factors like renal, hepatic, allergies, any also risks of drug to drug interactions. So empiric therapy can be done, but you need to choose the site of infection, local susceptibility patterns, patient's severity of illness. You should use broad spectrum agents only when they are very truly needed. You need to reassess the patient once you have started with some empiric therapy after 48 to 72 hours. So de-escalation therapies, you need to review the culture report. Once the culture reports are available, we need to de-escalate the therapy. We need to narrow down the antibiotic as soon as possible. Switch from IV to oral when the patient is stable. Stop antibiotics if you're really suspecting this to be a case of what you call viral etiology or treatment course is completed. We cannot go for antibiotic for 15, 20 or 1 month time, 20 days, 20 days. So this is very important actually to know the de-escalation strategies. Appropriate duration, you definitely need to know the appropriate duration. For example, if you are treating a patient in OPD for community or pneumonia, definitely it's fine enough to go for 5 to 7 days. So avoid prolonged therapy without infection, without any proper indication. So definitely when you're going to start with any antibiotic, we need to monitor and follow up, reassess for any clinical improvement, drug toxicity, and after follow-up, you also need to do some lab results to show whether the patient is really improving or not. Documented evidence is always there. You need to, first important thing is that we need to educate the patient about the adherence of antibiotics, because most of the patients will never complete their things and there's a high probability of getting drug resistance. So there are a lot of issues of concern which has been put forward by CDC. The CDC has published antibiotic resistant threat report in 2013 and 19. The report categorized the threats into 4 tiers based on the level of concern to human health: urgent threats, serious threats, concerning threats, and watch lists. If they considered urgent threats as carbapenem resistant Acinetobacter baumannii, Candida auris, Clostridium difficile, carbapenem resistant Enterobacteriaceae, etc. Serious threats like drug-resistant Campylobacter, ESBL, vancomycin-resistant Enterococci, multidrug-resistant Pseudomonas aeruginosa, drug-resistant non-typical Salmonella, MRSA, and drug-resistant tuberculosis. Concerning threats like erythromycin-resistant group A Streptococcus, Watts leak, most of the antifungal nowadays are becoming resistant. This is a great concern basically. In the similar fashion, WHO also created a priority list of pathogens in 2017 and 2020 based on the substantial threat to morbidity and mortality. The priority list is categorized into 3 tiers like critical priority, high priority, and medium priority. Critical priority like carbapenem-resistant Acinetobacter baumannii, carbapenem-resistant Pseudomonas aeruginosa, carbapenem-resistant as well as third-generation cephalosporin-resistant Enterobacteriaceae. High priority like vancomycin-resistant Enterococcus faecium, vancomycin-resistant as well as methicillin-resistant Staph aureus, clarithromycin H. pylori. This is you get concerned because if we're starting with HP kit and the clarithromycin is one of the important drug for HP kit, if it is get resistant, then definitely it will be also difficult for the patient to get relief of H. pylori infection. So medium priority like penicillin non-susceptible Streptococcus pneumoniae. So every dark cloud has a silver lining. So newer antimicrobials are in the pipeline, like for carbapenem-resistant CRE as well as for gram-negative. Cefiderosol is a drug, is a siderophone cephalosporin that uses newer generation of cephalosporin that is very much effective against the carbapenem-resistant Enterococcus. The newer generation drugs, meropenem, vaborbactam, which has been US FDA approved, combines carbapenem with a beta-lactamase inhibitor, very effective in complicated UTI and complicated intra-abdominal infections. The next drug is imipenem cilastin relebectam. It targets ESBL and also effective against the CRE enzymes. Plasmomycin next generation aminonucleic for resistant gram negatives. For gram positive, we can use lefamulin, a very novel pluromulin of community acquired pneumonia. The next generation oxaloadenine like contezolid and riedazolid, these are very effective against gram positive activity. Newer combination like sulbactam and dorlobactam approved in 2023 for specific infections, particularly those caused by carbapenem resistant Acinetobacter baumannii. Very recently, cefepime and engerobactam. This is a drug which is based in basically the engerobactam. This is discovered, invented in India in Chennai by Oxford, and it's been recently 2024. It has been got US FDA. Is an Indian developed combination approved for severe UTI, pneumonia, and bacteremia. Phenofloxacin is a fluoroquinolones for UTIs and other infection. But there is always some barriers to antibiotic stewardship. Clinician knowledge deficits regarding the use of antibiotics, opposition from clinicians to antimicrobial stewardship, limited access to reliable clinical diagnostic, limited or unenabled access to quality assured microbials, fear that without withholding antimicrobials and especially antibiotics will lead to poor outcomes, limited or lack of communication between healthcare providers, limited infrastructure or administrative support for antimicrobial stewardship programs or interventions, limited access to data, especially to the prevalence of AMR in the community, limited public and patient acceptance of antimicrobial stewardship, and public access to antimicrobials such as antibiotics, that is over-the-counter drugs we are getting. So take-home messages are: start right, refine fast, stop early when possible, culture before antibiotics, use local guidelines as early as possible, de-escalate therapy after we're getting the culture report, and shorten the duration. Stewardship is for patient safety and is a global responsibility. Thank you so much.
Thank you, Dr. Das. It was a nice presentation and on time. So to be on time, we'll just ask one or two questions from the audience.
Excellent presentation, sir. You have nicely elaborated all the things in a short time. So my question is, so how frequently you interact with the microbiologist regarding the any drug resistant case? What your comments regarding minimum inhibitory concentration when any drug?
That is very important actually. When we talk about MIC, definitely that is the important thing actually. Whenever suppose the patient is very much serious and we need to, before starting the antibiotics, we need to go for the culture. Any culture. If you're suspecting this to be a case of urinary tract infection, go for urine culture, blood culture. So this, even if you can go for fungal culture, you can start with the empirical therapy. But once we get the what you call culture report, the lowest MIC value, because right now we're getting a lot of patients getting drug resistant, as you have told you. So this is a thing that MIC value, lowest MIC value, you can start as early as possible. So you can start with any antibiotic, but suppose you have started with meropenem, the patient is very much serious, but after a few days you got a report that the tigecycline or other drugs or linazol, whoever drug is sensitive, then definitely you can start. That is MIC value, and communicating with them, that is a very important thing. Communicating with the microbiologist is a very important thing. So we never do actually. So as a clinician, we should always know what we need to do.
Yeah, we should again reassess that, then again
that definitely is a very important thing. We always not need to reassess for clinical improvement. Suppose you have started to antibiotic and the patient is suffering from fungal infection, how the patient will get improvement? That is a very important thing and very pertinent actually.
Thank you.
That's very fine. We used to give antibiotics for 15-20 days for till 1 month. See, the thing is that suppose a patient present, we cannot get the culture immediately.
Wait for 48 hours to 72
hours. If the patient is very much serious, if the patient is very much serious in the ICU setting, you are not getting any culture report, I'm not going to start with any antibiotic.
No, time is also important.
Time is really important, but are you not going to start with any antibiotic?
How many cases will
get? How many clinicians basically say very honestly, are you not going to start with any antibiotic if the patient is in ICU?
50% to 80% cases always we get culture negative. It doesn't rule out any infection, in fact.
No, that's the thing. So you need to go for the culture report. Once the culture report shows that there's a viral infection, there's a fungal infection, stop it. That's fine. Yeah, it definitely will take time. Definitely will take time.
Excellent talk, Dr. Tadip. One comment is important. Now, time has come to develop regularly an antibiogram in the hospitals. Irrespective of whether it's a medical college or a bigger hospital, antibiogram is a must. And on that, you must develop an antibiotic policy. And that must be updated at regular interval, at least yearly twice. And that is the message to be given to everyone. That's how you can think of an empirical treatment depending on antibiogram. Otherwise, you cannot have any empirical therapy. What has been suggested in the US, we cannot apply. It may vary between two medical colleges. It may vary between two hospitals. It may vary between two hospitals in a metro.
Yes, definitely.
So that's why an antibiogram
it's all about the geographical location,
yes.
Actually.
And a crosstalk with the antibiotic microbiologist is a must. Thank you.
And the take-home message is right drug, right indications, right duration, and right IV oral routes, and ultimately early de-escalations to the narrow spectrum antibiotics. Thank you so much.
Thank you.
Wonderful presentation.
Thank you. Thank you for the enlightening session. I now request our chairpersons and speakers, sir, to kindly step towards the felicitation area. Let's proceed to our next session. It is my privilege to introduce our chairpersons for this session, Dr. Rajiv Borbora, Dr. Bhabatosh Roy, and Dr. Nayanjyoti Bays. I invite you, sir, to preside over the session. Our speaker today is Dr. Pradeep Kumar Sharma. Sir will deliver a talk on the topic When Fever Meets Joint Pain, a Diagnostic Dilemma. We warmly welcome you to take the stage.
Should I start? Respected Chairperson, sir, my respected teachers, my seniors, and my friends. Thank you, Kusami sir, Sarat, Arup, and the entire organizing team for giving me this opportunity to stand here. So I'll start with a patient. So this patient came around 1 week back to us. He was from Manipur. And problem was that there was a language problem. And if we cannot take a proper history, always we feel irritated. But what we can gather was that he has joint pain for around last 1 year and mainly involved the ankles, knees, and elbows. And it seems that he has recurrent joint pain. And he also had fever. He was taking alcohol daily. He was an army man. And we did the ultrasound that was showing cirrhosis of liver. And this was the battery of test that was done. And type IgG and IgM was positive, though Wedel was negative. His total count was towards the higher side. Synovial fluid analysis was done. The synovial fluid total count was 6,400, and it was sterile. ESR was high, that was 70, and CRP was elevated, that was 19. Rheumatoid factor was positive, and CCP was negative. So how we approach suspicion? Actually, when a patient comes with fever and joint pain, so there should not be any battery of test. We should always think first, what is the differential diagnosis? Then we should order investigations. So like this patient, when we examined, he had swelling, definitely elbow was swollen. But what was interesting was that below that elbow, there is a soft tissue swelling. So when we saw clinical exam, found this clinical examination, we thought that we should not be doing any messing around. We should focus on the elbow joint or the swelling. This was the X-ray. The joint actually looks like it was a neuropathic joint. So much of damage in the elbow joint. So we thought this might be some infection. So there is no point in doing any blood test or anything. So we focused on the joint and we did the synovial fluid analysis and CV nut was positive. So he was having tuberculosis of the joint. So what are the differential diagnoses we think of? I will spend some time because 12 minutes fever with joint pain, I cannot actually cover everything. So first thing we always think is it viral fever? Viral fever mostly are self-limiting. They usually are over by 3 weeks time. There is actually not much synovitis. They mostly most common is arthalgia. But there are exceptions, like say hepatitis B. That can be associated with transient polyarthalgia, even arthritis, but that is also associated with transient skin rashes. And we should also remember that hepatitis B can be associated with vasculitis like polyarteritis nodosa. Then hepatitis C, that can be associated with cryoglobulinemia when patients has arthalgias, fever, Raynaud's, and skin rashes. Chikungunya I will come to just in a few minutes. Then there can be bacterial arthritis. Bacterial mostly they are septic arthritis, though mostly they come with monoarthritis with fever. But some bacterial infections like gonococcal arthritis, they can have oligoarthritis or polyarthritis. Brucella, Bhupen told me that 1 month back he had a patient of Brucella. So Brucella can mimic reactive arthritis or they can mimic tuberculosis, but there are some differences. Like say tuberculosis, they lead to gibbous, but Brucella usually does not lead to gibbous. Then Brucella can mimic spondyloarthropathy also, but Discitis is not a feature of spondyloarthropathy, but brucella can lead to discitis. Then reactive arthritis, they can present with fever and joint pain, but mostly they are monoarthritis or oligoarthritis, and this usually there is a preceding history of diarrhea or urinary tract infections. Then Lyme disease, I have not seen, but again, usually there is a there are features of arthritis as well as neurological manifestations. Fungal and parasitic infections are possible with fever with joint pain, but they are not that common. What are the autoimmune diseases we think of when patient has fever and joint pain? Mostly we think about SLE. Nowadays, SLE, I don't think any of us miss actually SLE. Then Still's disease that can be associated with fever and joint pain and vasculitis. Other diseases like rheumatoid arthritis, they can have feverish feeling, but that frank fever is not that common in rheumatoid arthritis. When a patient of rheumatoid arthritis presents with fever, usually we think of other diseases like whether patient has infection or patient has vasculitis. Acute rheumatic fever, usually that is not my field, and that is mostly when we think about acute rheumatic fever, usually we refer to a cardiologist. In case of children and elderly, we should always think about malignancies, especially leukemias and lymphomas when a patient has fever with joint pain. Then gout and pseudogout, they have a sudden onset fever, mild fever may be there, but usually that is not chronic. Usually they are over by few days time. Then other diseases like sarcoidosis or hemochromatosis, IBD-related disease, or Kikuchi's disease, they can be associated with mild fever and joint pain. Then there are autoinflammatory disorders that especially seen in children, like familial Mediterranean fever, but that is fortunately not common in adults. That's why becomes a bit easier for us. In case of pyrexia of unknown origin, some differential of this rheumatic disease should be always there, like in case of adult, Still's disease. Then vasculitis, like polyarteritis nodosa and Takayasu can be missed when patient has pyrexia of unknown origin. In case of elderly, it is temporal arteritis. We should always be remembered in case of pyrexia of unknown origin. Just few lines about chikungunya arthritis, because that is very common, one of the most common actually virus that is associated with arthralgia or arthritis. Usually patients have high fever, headache, rash, myalgia, and severe arthralgia and arthritis for 3 to 7 days. Arthritis can be debilitating in chikungunya arthritis. That's chikungunya means actually that which bends up in the local language from Africa. So chikungunya can be associated with non-specific post-viral arthritis. They can present like rheumatoid arthritis or spondyloarthropathy, or there can be persistent arthralgia. So how they define? Most of the studies actually define when post-chikungunya arthritis as arthralgia or arthritis persistent for more than 2 months after the infections. There is history of febrile arthralgia lasting at least for 2 days, associated with either chikungunya IgM antibodies or IgG antibodies or RNA RT-PCR. So these are the studies. So chikungunya arthritis can actually arthralgia or arthritis can persist up to years. There have been studies up to 6 years. And there are studies from India also, from Kerala and Maharashtra. And the ranges, how common is arthritis in chikungunya? That ranges from 13 to 50%. And you can say chronic arthritis lasting more than 1.5 years. That can be up to in 1/3 of the patients. So chikungunya arthritis actually is very, very common. So, and it is not a benign condition. We can see that mild or moderate severity can be seen, disability can be seen up to in 75% of the patients. So and we have to remember that chikungunya IgM or IgG antibodies, they are very, very sensitive, but they are not specific. So other arbovirus can give rise to actually positive IgG or IgM antibodies, like dengue even. So chikungunya IgM antibody can cross-react with dengue viruses. So how to treat? There is actually no proper studies. So they can be treated with steroid and hydroxychloroquine. Hydroxychloroquine also recommended by WHO, but whole of studies have shown that it is not very effective. Methotrexate is one option. Then combination of DMARD, methotrexate, sulfasalazine, and hydroxychloroquine along with steroid, that can be an option. Biologicals can be used, but what is recommended that if the patient, not for arthralgia, if the patient has frank synovitis, if there is swelling, then only we should go for biologicals. That there are only case reports. So we have to be careful about using biological. So it is always the most important thing before investigating a patient of fever with joint pain is the clinical examination. Like this patient, she is a 26-year-old female. She presented with progressive weight loss for last 4 months. She has fever, she has arthralgias, she has ischemic ulcers, she has normocytic normochemic anemia, high acute phase reactants with ESR of 82, and her urine shows 15 to 20 RBCs. So when we see such a patient, we think, should I order ANA, ANCA in this patient? So main stress should be on the clinical examination. So this patient has splenomegaly and she had a planned systolic murmur. So we did an echo and echo was showing vegetation and blood culture was showing staphoria. So she was having endocarditis. So endocarditis is a great mimicker of all the rheumatological disorders. Septic arthritis, that is a rheumatological emergency. Most of the septic arthritis in 80% of the patients are monoarticular. That represents monoarthritis actually represents most important cause of non-traumatic monoarthritis septic. Mostly affects the large joints. Most of the cases actually occurs in case of adults are knees, but no joint is immune for septic arthritis. Mostly affect the children or the elderly unless patient has some predisposing conditions. And in case of Sindel, most common joint involved is hip joints. There are many risk factors. Usually, adults who does not have risk factor, they don't suffer from septic arthritis. Risk factors can be many things like systemic disorders, rheumatoid arthritis or diabetes or liver disease, alcoholism, chronic renal failure, or local factors like a local trauma or arthroscopy or arthritis or prosthetic joint, elderly or newborn, social factors like occupational exposure to animals or brucellosis or low social income for tuberculosis. Acute monoarthritis, always we should rule out septic arthritis first. Patient will have fever, the joint will be swollen, there will be local rise of temperature, there will be tenderness, erythema, and limitation of movement. And when we see a monoarthritis, we should look for the predisposing conditions that we have discussed. So in case of monoarthritis, first is radiograph to rule out any underlying abnormality in the joint. But we should not go, we should focus on the joint. First thing is synovial fluid analysis, gram stain, then total count, culture, and usually if it is chronic, we send for fungus as well as tuberculosis. If the synovial fluid analysis does not give the diagnosis, then we go for synovial biopsy. There is blood tests are actually not that helpful in diagnosing monoarticular joint pain. So what are the red flags? When it is an emergency, when patient present with fever and joint pain, when the joint is red, hot, and swollen, if there is significant trauma, if there is malignancy, because malignancy can present with fever and joint pain, a joint which is locked, that is an emergency, then constitutional symptoms like fever, chills, sweating, if a patient has fever and chill, usually we don't think about rheumatological disorder. Most of the rheumatological disorder, when they have fever, that is not associated with chill and rigor. Then if there is sweating, there is a loss of appetite, nausea and vomiting. If there is significant weight loss, severe unrelating pain, nocturnal pain, usually that indicates malignancy, then significant weakness. So these are the conditions where usually patients need admission. Reactive arthritis can present with fever and joint pain, and that mostly clinical examination actually cleans the diagnosis. Like this patient has dactylitis, the whole digit appears like swollen. There can be swollen joints. It can be present with, or mostly it is oligoarticular involving the lower limb joints. There can be enthesitis like retrocanalicular bursitis or plantar fasciitis. There can be conjunctivitis or uveitis, or there can be skin manifestations like keratoderma blenorizica. Now, let us come to another patient. This was a 40-year-old man. He has 10 days history of fever, sore throat, fatigue, and subjective weakness, and muscle and joint pain. And first, we thought that this patient probably has tonsillopharyngitis. But he was febrile, and wrist joints were swollen and tender, and there is limitation of movement of the shoulder and hip joints. But when we look at his investigations, there was TLC was very high. Uh, it was neutrophilic, procalcitonin was normal, ESR and CRP was elevated. And at this point, with so much of ESR and CRP, when wrist joints are already swollen, we thought it is not actually pure pharyngitis. So we did a ferritin also that was very high. So what he was having was still disease. We have to remember that still disease is the pharyngitis is a criterion for classification criteria for still disease. So pharyngitis is common in adult onset still disease also. So I won't go into the details. So nowadays, that adult onset is still disease and what we call instilled and systemic onset juvenile idiopathic arthritis, they are actually clubbed together. They are nowadays named that, propose that we should call them as still disease. And when we diagnose still disease, we should always remember about macrophage activation syndrome and lung problems with still disease. IL-18 because ferritin can increase in infections also. IL-18 also increases in infections as well as adult onset disease, but it is so high in adult onset that this can be a discriminating factor to diagnose adult onset still disease. So I won't go into vasculitis because Dr. Oman is here, so the master of vasculitis is here. So last patient I will discuss, it is already time. So how to differentiate? It's a patient of rheumatoid arthritis coming with fever. Usually we think about infection. When a patient of SLE comes with fever, we have to differentiate from infection versus disease activity. So the important point is fever and arthritis. First, we have to rule out infections. Ferritin is useful but non-specific. Endocrine can mimic rheumatic diseases. Viral arthritis are often self-limiting. But most important is structure evaluation to avoid misdiagnosis. Thank you. Thank you for your patient hearing.
Thank you, Dr. Sharma. Yes, approaching very nicely in an unholy nexus between the joint pain and the fever. So, as we are very strict about time, so only 2 questions are allowed from the audience.
What a very nice presentation. Just one point. In our clinic, we used to get a lot of diabetic patients with locked and painful shoulder joints. So what is your, and it's very difficult to treat those patients.
Yeah.
Would you like to say something on that? Of course, they are not they are not a febrile joint pain, but the problem is a very chronic. It is very difficult to treat.
Yeah, thank you. So actually, yeah, most common when a patient, diabetic patient come with shoulder pain, first we think about is frozen shoulder. But we have to remember that shoulder pain is actually not only always because of frozen shoulder. Sometimes that is the first manifestation of rheumatoid arthritis. Many patients actually we have picked up that patient actually first shoulder joint pain. Actually, and when we looked at that, he does not complain of pain in the fingers because his more problem is in the shoulder. Sometimes patient present with rheumatoid arthritis and polymyalgia rheumatica also like picture. So, but frozen shoulder, actually, yeah, that as you have told that sometimes it is frustrating to treat. But usually we do advise them exercise. Usually we inject the joint after doing exercise, X-ray that there is no anatomical abnormality. But exercise definitely helps. Ultimately, with time, they improves.
If there is no question, any question? So we can conclude then. Thank you.
Thank you for that insightful presentation. I would like to request our chairperson and the speaker, sir, to kindly proceed to the felicitation area.
At least two minutes.
Moving forwards, it gives me great pleasure to introduce the chairpersons for this next session. Professor Dr. Sanjeev Kakoti, sir, Principal, Assam Medical College and Hospital. Dr. Shantanu Bodhakur, Dr. Arup Sharma, and Dr. Gautam Medhi. I request you to kindly chair the proceedings. I'm also very delighted to introduce our guest speaker, Dr. Vishal Sharma, Additional Professor, Department of Gastroenterology, PGI Chandigarh, who will speak on the topic gastrointestinal tuberculosis, how to improve the diagnosis. Dr. Sharma has made significant contributions to the field of GITB and IBD. I'm confident that this session will be highly enlightening and beneficial for all of us. Let's give it a big round of applause.
Thank you. It's a great pleasure to be in this beautiful state, and I'm grateful to the API Nagaon branch and Dr. Arup for the kind invitation. Arup has been a student with us, and it's a great pleasure to know that he's uh, treating the GI diseases here. He has provided access to endoscopy and ERCP, and it's a great pleasure as a teacher to note all that he's doing here. The task that we have today is to go over gastrointestinal tuberculosis and how we are trying to improve the diagnosis of this entity. So we'll very briefly cover the spectrum of GI tuberculosis. We'll have an overview of the performance of various diagnostics as are available today. We'll enumerate the challenges in the diagnosis of GI TB and then talk about the concept of diagnostic ceiling, that how all the wonderful diagnostic armamentarium that we have cannot go beyond a particular cutoff. And then we will look at the strategies that are in work to break this diagnostic ceiling. So, GI TB overall has four broad types. Probably the most common and the one which the physicians will handle easily and comfortably is the peritoneal tuberculosis. And then there has been a classification of peritoneal tuberculosis, typically into a wet type, which is ascites dominant and probably constitutes around 90% of the cases. And then there is a dry type. Again, people have subcategorized dry type into a dry plastic type and a fibrotic fixed type. The other one, which is the luminal tuberculosis, is the one which typically involves the GI tract. Now, the problem with this one is that the diagnosis typically will need some kind of endoscopy. And therefore, this is prone to misdiagnosis and mistreatment, especially in regions where endoscopy services may not be easily available. And then, of course, we know the lymph nodal, which can involve the abdominal lymph nodes, typically the mesenteric lymph nodes. And these sometimes may be more difficult to treat than the other two variants. And then, of course, the least common of these is the visceral tuberculosis, where you may have involvement of different organs like the liver, pancreas, spleen, etc. Now, most of this talk will be focused on intestinal tuberculosis, and we'll also discuss a bit about the peritoneal tuberculosis. If we talk about the clinical features, I think all of us are aware, and just for the sake of repetition, it is pain, abdomen, and fever, which are the most dominant manifestations, along with weight loss and loss of appetite. Some of the patients, especially if they develop strictures in the lumen, they may also develop intestinal obstruction and constipation. Diarrhea, and if you look at the Hippocratic description of tuberculosis, Hippocrates actually described diarrhea in tuberculosis, but this is not very common. And in fact, when you have extensive ulceration, only then you have diarrhea. Now, how do we approach these patients? And if you are sitting in a clinic, typically people who have GI complaints, you would ask typically for an ultrasound abdomen. Now, radiologists have told us, and I will say with confidence that probably erroneously that ultrasound is not a good technique for the bowel. We have been told this n number of times because of the air. Ultrasound obviously can pick up lymph nodes, it can pick up peritoneal involvement, nodules, or mental involvement, sometimes fat changes, but very importantly, it's a very good tool to pick up lesions in the bowel. And in fact, in the field of IBD, now there is an entire new concept of using a bowel ultrasound to pick up disease activity and even monitoring disease activity. And therefore, in fact, the air that you see in the lumen is the guide that this is the lumen, and you can actually pick up bowel wall thickening very nicely. And this is images of one of the patients that we saw. And you can very nicely see that this is the thickened bowel, some amount of vascularity here. You can see some fluid, and then you can also see a lymph node. And you see that such a simple tool, you can pick up so many findings. But of course, what we typically bank upon is the CT, and this was a systematic review of which I was a part. And if you look at intestinal TB, the most important mimic is Crohn's disease. And this was a comparison between TB and Crohn's disease. And if you have a hypodense center in the lymph node, which is a necrotic lymph node, then that is specific for GITB. Ileocecal involvement can occur in both, probably more suggestive of TB. But other findings like comb signs, skip lesions mean different part of the bowel involved at the same time with a normal intervening area, asymmetric thickening, involvement of the fat, changes in the fat, the mesenteric fat, long segment, that is typically more than 3 centimeter of involvement, would go with Crohn's disease. So these are some of the images. Earlier, lot of barium was used, barium meal follow through, but this has now gone out of fashion. So I'll just focus on the CT images, and you can see here, this is symmetric, fairly symmetric bowel thickening in the ileocecal region. There's a very nice image. You can see these lymph nodes peripherally enhancing, and then there is a necrosis in the center. So these are the necrotic lymph nodes that you will see in GITB. Again, thickening of the cecum, hair, and sometimes you will find findings which are out of the bowel, and you can see adrenal involvement here and the vertebral involvement in this patient. So these are images you may pick up in patients with tuberculosis. What do you see in Crohn's disease? And as against, you see this is a pretty symmetric kind of involvement. In TB, you see this one. So this is the mesenteric side, and you can see that this part is thickened, but this is relatively normal. So the mesenteric involvement is suggestive of Crohn's disease. And then you can see that some amount of stricture here, and then there is a pseudo circulation, classical of Crohn's disease. And then you can see this vascular, these are the vasa recta which have become engorged and prominent, and this is the comb sign that you see. And then of course you can see some amount of mural stratification, that each of the layers of bowel can be separately visualized. If you look closely, you can see the enhancing mucosa, and then there is a black part there, and then again enhancement. So this is that because of the bowel edema, these layers appear to be separate, and then you can see a stricture here. So these are some of the findings you can probably see in Crohn's disease. Now, once you have seen involvement of the colon or the ileocecal area, you will go ahead with a colonoscopy. And these are some of the classical images one would see in GI tuberculosis. So you have relatively transversely placed. So these are perpendicular to the direction of the bowel lumen. And you can see classical transverse ulceration here, some amount of pseudopolyp formation and distortion of the cecum, lot of pseudopolyps and almost a complete obstruction here. And this is a very, very distorted cecum and a gaping ileocecal valve. You can see that this is virtually open, and sometimes, of course, it can be strictured also. And these are findings that you will see in GI-TB. On the other hand, in Crohn's disease, you are more likely to see these kind of small aphthous-like ulcers, this kind of diffuse involvement of the ileum. Now, these are relatively deep ulcers, and I would say to some extent these are linear. These are in the direction of the bowel lumen. And then you can see cobbler stone appearance. And this is the classical tram tract kind of ulcers that you will see in Crohn's disease. Once you've taken biopsies, then obviously you would send it for microbiology and for histology. Now, histology, if you see a granuloma, a well-formed granulomas, multiple granulomas, large granulomas, granulomas which are coalescing together, it is TB. On the other hand, if you hardly see any granuloma or a microgranuloma, sparse granulomas, then more likely Crohn's disease. If you have an ulcer which is lined by a lot of histiocytes, probably tuberculosis. If you have lot of very, very deep ulcers going through the bowel wall, then probably we are dealing with Crohn's disease. Then what about the culture? So typically the ICMR guidelines, of which I was a part, suggested that we should have at least 6 biopsies being sent over so that we improve the mycobacterial yield of the culture. The standard culture performs less well than the MJIT, which we now typically use. But even when you use such a strict way of taking biopsies and multiple biopsies, the yield is just 52%. 4 biopsies and a MJIT culture, the yield is 52%. And if you look at most of the studies, the yield is actually less than 50%. This is again a systematic review which our team performed. And you would note that the gene expert, which has become very important in the tool in diagnosis of pulmonary TB, it will just pick up 1 out of the 4 cases of GI TB because it's a posse mycobacterial disease. So to summarize the diagnostic yield, and you will see the problem here, AFP stain less than 5%, expert 23%, the MTB PCR, which has its own problems of false positivity, 47%, cultures typically less than 50%, histology less than 40%. So none of these actually give us a yield of more than 40%. And therefore, the traditional Postian criteria, which are very difficult to fulfill, have gone out of fashion. And what we had was a Logan's modification. Logan actually suggested that not only can we diagnose TB using definitive criteria like a mycobacterial positivity, which is not very frequent, but you could also use a response to therapy. And how do you define a response to therapy? So the problem is that if you give ATT in patients with Crohn's disease, the CRP declines, they feel better, the diarrhea improves, the pain improves, the weight also increases. So a clinical response to anti-tubercular therapy is not valid as a satisfactory criteria to define response. And this was a work by All India Institute of Medical Sciences, which looked at doing colonoscopies again. And you can see very nicely, although symptomatic response is there in both Crohn's and tuberculosis, but the healing of the ulcers at the end of therapy is only in TB and not in Crohn's disease. The problem is giving therapy for 6 months when you're not sure whether this is TB. So we started doing it, and this was what we published. We started doing colonoscopies at 2 months. And actually, you can see the same kind of healing. And you can see this was the initial picture, and then this is healing at 2 months with some amount of stricture formation. So if the healing happens at 2 months, you're dealing with TB. If it does not, probably it's a drug-resistant TB, but more frequently it is Crohn's disease. And the misdiagnosis is common. And this is outside of India, where TB is not much of a problem. Almost 10 to 18% of misdiagnosis is there. And the problem is if you start treating GI TB as Crohn's disease and start giving immunosuppression, then obviously there's going to be a flare of TB. On the other hand, what about giving ATT to patients with Crohn's disease? And one would think that this is relatively okay, but no. This results in increased formation of strictures, and this is again data from AIMS, which showed that people who had an inflammatory, that is largely ulcerating phenotype of Crohn's disease, when they were started on ATT, and you look them at follow-up, most of them started developing GI strictures. And obviously, this diagnostic delay in Crohn's disease also results in adverse outcomes. ATT is obviously not innocuous. So what we now want is that we can achieve a diagnosis on day 1. even before we give a therapeutic trial or a diagnostic trial of antitubercular therapy. The problem is that we have this kind of a glass ceiling at around 50%. And almost all the diagnostic armamentarium that we talked about do not cross this glass ceiling. They do not break this glass ceiling. So how do we go forwards from here and break this? So what are the approaches? One is you better target the ulcers, you take more biopsies, you try to use multiple techniques rather than a single technique to achieve a diagnosis. You improve the tools, you do a better expert, you do a better bacterial test, or you target you target using artificial intelligence based approaches. These are the approaches, and some of these actually have been tested, and they are the hope for the future. So this is, if you use gene expert, you have one primer, RPO. If you use the standard TB PCR, you have IS6110. And therefore, you have a limited sensitivity with each of these primers. But what you can probably do is use a multiplex PCR. And this, in fact, this is the work which has been done at PGI by Professor Kushum Sharma, who has shown that these multiplex PCRs actually show a very, very high sensitivity. Gene Expert, you have the advanced version, the Gene Expert Ultra. It also uses the same principle. You have 3 primers rather than 1, and you try to improve the diagnostic yield. You have the Indian point of care diagnostics, which is the TrueNat, and then again you have TrueNat Plus, which again uses more primers rather than a single primer in the hope of improving the sensitivity. And this is again the data which I was talking about. This multiplex PCR seems to do better than Gene Expert MTBA in diagnosis of intestinal TB. And this is unpublished data from our center on Gene Expert Ultra. And you can see that the sensitivity, which was 23% with Gene Expert, improved to 65% with Gene Expert Ultra. But it comes at a cost of some reduction in specificity of diagnosis, which was almost 100% with Gene Expert, but is 83% with Gene Expert Ultra. Now, this is probably going to be a game changer. Tissue NGS, and this is a Chinese study. They had patients with TB or Crohn's disease where there was a diagnostic dilemma. And apart from doing the PCRs, they also started doing tissue NGS. And just look at the performance. 83% diagnostic sensitivity. This is unmatched till now by any other diagnostic tool. And in fact, the cost in India in the private labs is around 8 to 10,000 rupees for this test. So not very costly, and hopefully there is a chance that the WHO is going to roll this out, and this might in future become a very important tool for diagnosis of GI tuberculosis. Again, this is a multi-parameter model. So this is a tool which one colleague from Thailand, Julajak, developed. And this is actually taking into account all the data you have. So you have an underlying prevalence, you have put the data about the clinical features, serology, endoscopic findings, histology, and then you get a probability. And this is one of the best performing multi-parameter model, the LIMS-free model, which is available online for use. So this is one systematic review which we did where we looked at artificial intelligence based approaches. And in fact, now we are working on using colonoscopic images, using transformal VIT based model to pick up whether we can, based on colonoscopy, discriminate tuberculosis and Crohn's disease. So these are some of the additional relatively recent work which has been done, but the problem is that this needs to be validated. So CT findings, lot of fat involvement is suggestive of Crohn's and not TB. T regulatory cells, especially FOXP3 positive Tregs, if they're more than 31%, then they're more suggestive of TB, but this is very difficult to do these tests. And then there is a unpublished data from Professor Vineet Ahuja's group where they've tried to create a machine learning model, and there are n number of parameters that you can input, and you get again a probability of the underlying diagnosis. So now I'll briefly talk about peritoneal TB. If I have time, I don't know. So if you look at peritoneal TB, you can have ascites, which is the dominant presentation. But then you could have peritoneal involvement, mesenteric involvement, and then of course you have all the differential diagnosis of ascites as a possible mimicker. Like in intestinal TB, the most important mimicker was Crohn's disease, but in peritoneal TB, it is the peritoneal carcinomatosis, which is the most important mimic. So how do we move forward? So this is, I've already talked about this. So here you have a lot of ascites, and you can see that this is different from cirrhotic ascites. Even on a CT, you can actually get a clue that this is not totally black. So ascites in chronic liver disease is very black. Here you will see some kind of, HU which is slightly higher than the ascites in cirrhosis. And then here you can see a lot of omental involvement, almost a cake formation. And this is again peritoneal involvement with some tubercles. So the differences in presentation, you have fever and distension, which is more important in wet type. It is pain and obstruction, which dominates in the dry type. And just look here. This is that table which I showed you earlier. And this is now for the peritoneal TB. Very poor performance of AFB, 30% for gene expert. Culture, again, low positivity. But just look, there's one tool that we have. Ascitic adenosine deaminase, excellent performance, very good sensitivity. The problem is that it can have false negatives like in a cirrhosis, low protein ascites, or in loculated ascites, especially if there are a lot of locules and you may not get a very high ADA. But there could also be false positive like in lymphomatous and if there is pus or bacterial peritonitis. So what are the newer tools? So people have started using this PET CT, and you can see the difference. On this side, you have TB, a very, very diffuse kind of involvement and a string of beads kind of situation. And here you have clustered uptake, especially in the subdiaphragmatic area and the pelvis. And this is largely the pattern that you will see in peritoneal carcinomatosis as against TB peritonitis. Again, it's fairly sensitive, but not very specific. People have used CA125, CEA, CA724 levels. I can assure you that none of these achieve a very good diagnostic performance. And in fact, CA125 levels can actually be elevated even in ascites of virtually any cause. And eventually, if you don't find a diagnosis, you move forward with the peritonioscopy, where visual impression itself can give you a diagnosis in more than 90% patients. But you also get a chance to take the samples for all the mycobacterial tests that you can do on peritoneal biopsies. So, ladies and gentlemen, to summarize, GITB is a situation where low mycobacterial yield of the tissue is the Achilles heel of TB diagnosis. The diagnostic ceiling threshold, which hovers at around 40 to 50%, needs to be overcome. There is now availability of better mycobacterial diagnostic tests, which hopefully will be rolled out through the RNTCP program. We are looking forward to using AI-based approaches which use original data rather than just textual information to differentiate TB from its close mimics. And these innovative approaches also combine use of multiple parameters to combine information to provide a diagnostic probability. Thank you for your attention.
Thank you, Professor Sharma, for an excellent deliberation on a subject which was a problem, which is a problem, going to be a problem. And particularly from your deliberation, one thing becomes very clear to all of us. Number one, Crohn's disease is not uncommon in Northeast. This is my experience to you. Earlier in our days, when we were a student, we have been told Crohn's disease is not a problem in Northeast. You go for tuberculosis, anti-tubercular treatment. But now, as the age passed off, I have found that there are a lot of number of Crohn's coexisting with or without tuberculosis, number one. One thing he has mentioned, therapeutic trial is not holding good. And this is a practice, it is still a practice to give a ATT and see the response. And he has mentioned very clearly that this can happen both the way, and endoscopic intervention or endoscopic evaluation is better way of assessing it, not going by simply physical improvement and CRP and ESR. So these are important points he has taken, and multimodal approach is a best way to solve the problem, but the problem will remain. Similarly, in case of the tuberculosis peritonitis is really a problem. In my career, I have made mistakes, so many cases. Treated young girls coming with ascites, exudative ascites, ADA high, ultrasound didn't detect anything in the ovaries, but later on come with a big ovarian mass after giving ATT. This is happening. I think many of the senior physicians present here, you get it. We can take a couple of questions on that very important topic.
So sir, just to add to what you said, in fact, I would request if it is possible to just download a very nice ICMR summary which is available, and I'll just highlight 2 points from that. That for GITB, when you don't have a secure diagnosis, even ICMR now mentions that you should do a repeat colonoscopy at 2 months. So this is ICMR guidelines. I'm not talking about data. And in fact, this is now also included in the European Crohn's colitis organization guidelines for IBD management in our setting. Second, that if you are making for a diagnosis of peritoneal TB only on the basis of ADA, I mean ascitic ADA, then the ICMR guidelines suggest that at least thrice it should be sent for cytological evaluation for malignant cells. So I'm just picking up some of the things which are there in the guidelines, which can become very important clinical practice takeaways from this talk.
Few questions from the audience.
DVT is not a common in case of tuberculosis, and then retrospectively we diagnosed both the cases to be Crohn's disease, and later on we found that Crohn's disease is mostly associated with IBD is associated with DVT. So any patient with abdominal suspect tuberculosis, if there is DVT, you should have strong suspicion of Crohn's disease.
I think this is a very important comment. DVT is very well recognized to be a problem with active IBD and even with use of steroids. And you would note that many of these patients have hypoalbuminemia, which itself predisposes. So three predisposing factors: hypoalbuminemia, disease activity, and use of steroids actually also encourages DVT.
Sir, your lecture is very nice for our clinician. Recently, one patient came from Apollo Hospital, Chennai, and he was diagnosed TB from gastric level study. So I think this was not mentioned here. Is there any need of gastric level study for diagnosing abdominal tuberculosis?
So which study, sorry?
Gastric level study in tuberculosis.
So this typically has been okay. So this has been used for diagnosis of pulmonary TB in children. I'm not aware of similar data for GI TB, but there is one data which has used stool collected from patients with GI TB and done PCR, actually gene expert, for the diagnosis of TB. But I'm not aware of lavage-based studies for GI TB diagnosis.
Thank you.
Due to paucity of time, we conclude the session.
Sometimes, as already sir says, unequivocal ADA, we found it very difficult. We usually start empirical ATT. Sir, in that case, the role of peritoneal biopsy, sir, what is your take on this?
The problem is that you will find it very difficult to get a surgeon who agrees to do a peritoneal biopsy. That's the biggest problem. So I think if you have a ADA which is suggestive, and you have done a cytological evaluation at least thrice to rule out malignant cells, then in a clinical setting which is okay, you probably should start ATT. And if you get a surgeon who is ready to do a peritoneal biopsy, wonderful.
Thank you, sir.
Thank you, sir.
You review your diagnosis. Now I get to meet the surgeon. When will you say that? 3 weeks, 4 weeks, 8 weeks? When?
So I'll just actually, for the lack of time, I did not show that study which we had done. And this had patients both with intestinal TB and peritoneal TB. And if you do ultrasound at 2 months, almost always there will be a massive reduction in the amount of ascites. In fact, most of the patients will have a disappearance of ascites. The omental and the peritoneal findings would have disappeared. And I think 2 months, as of whatever evidence we have today, is a reasonable time to reevaluate.
For your elaborative and nice talk, we conclude the session now.
Thank you so much. Thank you for that clinically relevant and highly valuable session. Now I would like to request our chairpersons and speakers, sir, to kindly move forward for the felicitation area. Moving on to our next session. It is my honor to introduce our chairpersons for this session. Dr. Aditya Langthasa, Dr. Sarat Hazarika, Dr. Anuradha Deori, and Dr. Krishnakshu Das. I request respective faculties to kindly chair the proceedings. Our speaker for this session is Dr. Bhupen Verman, a distinguished expert in his field. Sir will be speaking on the topic why amyloidosis is often missed, a silent masquerader. Sir, we warmly welcome you to the stage.
Thank you, sir. Thank you, Chairperson. Uh, Good morning, my respected teacher, senior faculty members. First of all, I would like to thank Goswami sir and all Nagaon team for giving me this opportunity to speak on not a very common topic, that is amyloidosis. So in next 12 minutes, I'll give a brief review on when to suspect amyloidosis and what are the diagnostic criteria and treatment options. So what is amyloid? So amyloid it's a protein. It's a protein which is structure or arrangement is in the with beta platelet. Normally, protein structure is in the alpha helix. Any protein which is beta platelet is called amyloid. Okay, so amyloidosis is a group of disorder where there is deposition of abnormal protein, that is beta platelet protein, and this beta platelet protein the deposited extracellularly in some of the organs, mostly in the heart, kidney, liver, or nervous system, causing organ damage and functional compromisation. The gold standard for diagnosis for amyloidosis is the Congo rate by polarized light. We start with a case report. Recently, we had this case. He was a 62-year-old male, non-hypertensive, presented with generalized anasarca, reduced urine output, and features of heart failure. He also complains of low back pain for last 4 to 5 years, arthralgia, IG fatigability for last 3 months. On examination, he had petting edema. There's macroglacia, papules on the forehead, hypotensive hypoxia, and on chest examination, there was bilateral basal crepitations. So this is the picture of the patient. He had his elderly male, he had macroglacia. And if you see, there is that soldier joint, it is like more prominent, that is known as soldier pet sign. So the clinical clue is the macroglacia, papules in the forehead, soldier pet sign with heart failure, and there are some sort of proteinuria. So all those things goes in favor of amyloidosis. His blood parameters revealed anemia, high ESR, mild renal dysfunction. Echocardiography revealed biatrial enlargement with global longitudinal stent. This was not original echo report. Later on, when we came to know that this is amyloidosis, we asked them repeat the echocardiography, and they found that there is bilateral atrial enlargement. On CT, there was suggestive of pleural effusion and pulmonary edema. We did the serum protein electrophoresis, which suggests monoclonal gammopathy. Although PET biopsy came out to be negative, but renal biopsy showed lambda light chain amyloidosis. So we ultimately confirmed diagnosis with primary systemic amyloidosis with involvement of the kidneys and heart, and started the treatment and referred the patients for in the Guwahati Medical College for further treatment in the hematology department. So that this is the amyloidosis. So it's a, as I have said, it's a misfolded protein, which is a beta pleated sheets, and then there is cross connection between the side chains that causes depositions. There are three most common type of amyloidosis. One is called AL amyloidosis, second one is ATTR amyloidosis, and third one is AA amyloidosis. I think most of us, we have read all this terminology during our postgraduate time, and yes, we are not seeing the patients commonly, or we are just, it is just recapitulations. So there are three types of amyloidosis: AL, ATTR, and AA. So AL is that most common one. This one is primary systemic amyloidosis, and AA1 is previously called as secondary amyloidosis. In our time, we studied the primary and secondary. AL is the primary, A is the secondary, and ATTR is the hereditary. In simple way to classify. There are some local amyloidosis, that is known as A beta 2 microglobulin, that is found in patient with chronic dialysis, chronic renal failure on dialysis, and that is called A beta protein, which is deposited in patient with Alzheimer's disease. So these are the common types of Alzheimer's disease, amyloidosis, and the classification also like same. In the systemic, we have three types: AL, ATTR, or AA. AL is mostly found in the multiple myeloma and all. ATTR is the hereditary one or aging populations, and AA is found in case of chronic inflammatory disease with rheumatoid arthritis, Crohn's disease, or any infections. Hereditary amyloidosis is mostly found with the familial Mediterranean fever, and some sort of local amyloidosis is there, is known as senile cerebral or isolated atrial amyloidosis. So this is the Congo red staining. It's difficult to get, but this is a very classical pictures of Congo red stained seen under polarized microscope. So if we go to the pathogenesis, what happens actually? There are two types of pathogenic mechanisms. One is that abnormal protein someone acquired hereditarily, genetically, so that gives rise to genetic amyloidosis, also known as ATTR variant amyloidosis. This is a genetic form which is not very common. The acquired form is that normal protein misfolded because of some stimulus, maybe B cell in case of plasma cell dyscrasia, maybe some hepatic stimulant, or maybe some inflammatory stimulant in case of autoinflammatory disorder. Because of those stimulus, our normal protein got translated into beta pleated, and that because of stimulation, this beta pleated protein got accumulated extracellularly in some organs, giving rise to amyloidosis. So there is one form is hereditary, that is normal number of protein but variant. Other one is abnormal secretions of normal protein which got translated into abnormal protein. So diagnosis depends on the high degree of suspicion. As the index case, patient is having heart failure, macroglossia, and some soldier PET sign. Then when you have suspicion, you have to confirm your diagnosis, ideally by biopsy, or nowadays we can go for some immunohistochemistry test. Once you diagnose, you have to stage the patient and then accordingly go for the treatment. So when to suspect amyloidosis? What to remember is if patient has undiagnosed heart failure, undiagnosed neuropathy, and undiagnosed nephrotic syndrome. These are the three classical symptoms where you should have suspicion of amyloidosis. Okay, so undiagnosed, untreated heart failure because of restrictive cardiomyopathy, undiagnosed, untreated polyneuropathy, and undiagnosed, untreated nephrotic syndrome with large kidney size. We have only three causes of large kidney size: type 2 diabetes, HIV, and amyloidosis. So patient is having nephrotic syndrome with enlarged kidney, you can easily rule out diabetes and HIV. Third diagnosis, always you should rule out amyloidosis. So patient will have hepatosplenomegaly, cardiac disease, malabsorption. So in nephrotic syndrome, it's not very difficult. Nephrotic syndrome with enlarged kidney is very straightforward. Rule out diabetes, rule out HIV. Third cause, if it is enlarged, should be amyloidosis. And peripheral neuropathy, especially patient having carpal tunnel syndrome, entraped neuropathy, you should have suspicion of amyloidosis. Cardiomyopathy, mostly in case of restrictive cardiomyopathy, with if you get bilateral atrial enlargement with normal ventricles, you should have suspicion for amyloidosis. Best one is cardiac MRI, but most of the institute we don't have much facility to, and difficult is that to read the MRI cardiac MRI. It's very difficult to read the cardiac MRI. So from echocardiography, biatrial enlargement with normal LV, that is the hallmark. And then other reflex signs are unexplained polyneuropathy and carpal tunnel syndrome. Once you have suspicion of amyloidosis, next one is confirmation. How to confirm? You took the biopsy. If it is easily accessible like renal, you can go. In case of heart, it's very difficult, then you can go for the fat PET biopsy. And if you can do, it's very difficult, not available in most of the cities, that congruent staining. If you can do the congruent staining, then you get the apple green birefringence. And once you have the suspicion or once you are having biopsy proven, then you have to see the which amyloid is there. It's L, A, or ATT. Once you have diagnosed, then you do the risk stratification. It's very simple. Just what you need. One is troponin T, proBNP, and third one is that serum light chain. So if you have these three molecules, it's not very difficult. If you do the electrophoresis, you will get the light chain. Troponin T you can do easily, and proBNP you can do. And based on this marker, you can stage it stage 1, stage 2, or stage 3 disease. And the renal amyloidosis is easy. Based on EGFR or proteinuria, you can divide in stage 1, stage 2, stage 3. And based on staging, you can have the different treatment. Why we missed amyloidosis? One is that symptoms are non-specific, as I have said, but if you are having that strong clinical suspicion, unexplained proteinuria, unexplained heart failure, unexplained neuropathy, then definitely you should have, and at least you can go for the next step of the investigation. Once you are confirm the diagnosis, then comes the treatment. So treatment, it differs in three different groups. The most common is AL amyloidosis. The treatment protocol for AL amyloidosis is go for the standard one is high dose IV melphalan followed by autologous stem cell transplantation, which can give a response to almost 50% of cases. If patient is transplant ineligible, then we can best one is that the next one is cyclophosphamide, bortezomib, and dexamethasone, if available with daratumumab. Supportive care for nephrotic syndrome, you can give diuretics. For heart failure, what we should not give in case of amyloidosis or avoid. One is digitalis, second one is beta blocker, third one is calcium channel blocker. So these three drugs, like especially calcium channel blocker and beta blocker, we give in heart failure patients. So if patient is having restrictive cardiomyopathy or having suspicion of amyloidosis, you should avoid giving digitalis, beta blocker, or calcium channel blocker. These are not for the heart failure. In arrhythmia, amiodarone is a drug of choice, and if it is complete heart block, definitely pacemaker. In case of localized AL amyloidosis, then we can go for low dose radiation therapy because systemic therapy has lots of side effects. If it is localized amyloidosis, then we can directly go for low dose radiation therapy. In case of AA amyloidosis, the treatment is the primary cause. Suppose is AA amyloidosis due to rheumatoid arthritis, then you can treat the rheumatoid arthritis. If it is due to Cohen syndrome, you treat the Cohen syndrome. For familial Mediterranean fever, drug of choice is the colchicine. But remember, colchicine does not work in other AA amyloidosis. It works only against familial Mediterranean fever. And then other molecule like TNF alpha inhibitor, interleukin 1 and interleukin 6 antagonist, it might work in like patient with autoimmune related amyloidosis. Treatment of ATTR amyloidosis is difficult, and then it's mostly the genetic level, and most of them they are still under clinical trial. One is called tafamidis, that is FDA approved recently, which stabilized the TTR tetramer. The next one still under trial is the acoramidis, Then there are some called gene slicing therapies. One is patisiran and other one is inotescent. And third molecule is the fibril disruptor, because we know that there is ultimately the accumulation of fibrin. So if we can disrupt those fibril, there is a chance that is called eprodicere, and like CRISPR molecule, and maybe the combination therapy. So for AL amyloidosis, treatment is the stem cell transplantations. A amyloidosis, treatment of the primary cause. A TTR amyloidosis, the targeted gene therapy. So my take home is very simple, because it's very difficult to go for each and every type of amyloidosis. So when to suspect amyloidosis, one is unexplained nephrotic range proteinuria with enlarged kidney. You should rule out. Other, ruling out diabetes and HIV. Restrictive cardiomyopathy with biatrial enlargement, peripheral or autonomic neuropathy, and if we get pathognomonic soft tissue sign like macroglycia and periorbital purpura like reconcile. Once you have suspicion, confirm the diagnosis by congruent and staining. Once you diagnose, you go for the amyloid typing by immunohistochemistry. Then treat based on what is your suspicion. If it is AL, go for transplantation or chemotherapy. If it is AA, treatment the primary cause. ATTR, then targeted therapies. Manage organ complications. If it is heart, don't give beta blocker, digoxin, and calcium channel blocker. Give diuretics. In case of nephrotic range proteinuria, give diuretics. In case of arrhythmia, go for pacemaker. Early recognition and targeted therapy can stabilize disease, improve organ function and quality of life, and meaningfully extend the survival. Thank you. Thank you for patient hearing.
Thank you, Professor Bormon. It was an excellent talk. As you rightly said, amyloidosis is usually a suspicion. When we highly suspect, then only we diagnose. Usually, when we're doing a differential diagnosis, first diagnosis, we never go for amyloidosis. And when there's a polyneuropathy, as you've said, proteinuria not responding, when we have other carpal tunnel syndromes and all, then only we think, in third line only we think that it might be a case of amyloidosis. Thank you. Thank you once again. And I think we can take questions or comments from the audience.
Sir, very nicely explained. Sorry, you explained that the enlarged kidney with nephrotic range proteinuria, we should always rule out amyloidosis. It is not, yeah. But even in diabetes patient also, if you sudden...
No, there are three causes of enlarged kidney: diabetes, HIV, and amyloidosis.
I'm coming to the questions. You're absolutely correct in your mind. Even in diabetic patient also, if patient present to you with sudden onset of massive nephrotic range proteinuria, then again you should also rule out all this amyloidosis part also. Always we think that in diabetic patient having nephrotic range proteinuria, we should think that it is a diabetic nephropathy. But if the appearance is sudden, massive, then always you should again go through this, and you should always do biopsy of the kidney.
Like my index case, how I suspected, Pradipda asked me to write a chapter on amyloidosis. And when I was going through the amyloidosis, then that patient, I suspected that this patient may be a case of amyloidosis. And then we did all the things, cardiac MRI and all. Then we diagnosed the patient as amyloidosis. So until and unless you have suspicion, otherwise this patient don't get complicated with heart failure and nephrotic syndrome. So until and unless you have suspicion, you cannot diagnose this.
Thank you. Thank you very much. One question. How many, in Assam, how many people or a pathological laboratory will do an abdominal fat aspiration and look for amyloidosis?
So abdominal fat, if you can ask, they can do, but only problem is you don't have congruent staining, sir.
Yes. So beyond that, is there any other screening procedure you'll say that, look, because it's an invasive procedure after all. So you are just getting, like he says, do a kidney biopsy. It's a nephrotic syndrome. It's a, you may be able to do a thing the patient will accept. But peripheral neuropathy, doing a abdominal fat aspiration, I would see, I think so in this hall only, I don't know how many, 5 or 10 will probably have done that and have a pathology. So anything else screening before that?
Sir, it's organ specific, but if you do that electrophoresis, serum electrophoresis, probably we can get that light chain, especially in AL cases.
Okay, so basically before that we can do a electrophoresis screening and also,
electrophoresis.
Can we also look at the serum light chain estimation
Yes,
in the serum?
Yes, sir.
That's the easier test.
Yes.
These two, if they are there screening, then you should
Yes.
But I thought pickup was better in a duodenal biopsy, percentage-wise.
I don't say.
Achha, okay.
Only electrophoresis will pick up the AL type of amyloidosis. What about the A type of amyloidosis? What is the diagnostic method?
This is
Biopsy only out there.
no, sir.
No other way to confirm.
No, sir.
Because electrophoresis will confirm the AL type only.
Not confirmed. Not confirmed.
Not confirm also.
Screening is suspicious. Will not.
So we can take the help like in cardiac, we can go for MRI and echo, if bilateral enlargement and relative that strain is there. So
Many a time in our practice, the radiologist, they give us the feedback after seeing the CT and all. So it is the clinically it's very challenging to diagnose amyloidosis. There's a high index of suspicion that will lead to that. Anyway, very nice talk, Dr. Burman. So
Thank you, Bhupin. We can conclude this session.
thank you.
Thank you for that valuable session. I would like to request our chairpersons and the speaker, sir, to kindly proceed to the felicitation area. Next in the program, we have one of the most valuable and esteemed API oration session. And for this session, only Hall Kolong will be operational for the next 30 minutes. So I would like to request everyone to gather in Hall Kolong. Moving forwards, I would like to invite our chairpersons for this session. Okay. I would like to request Dr. Anupam Datta sir to kindly take over and conduct the session.
Thank you. So now is the time for the revered API oration. First of all, I would like to invite Professor A.K. Pegu sir, President of API Dibrugarh to come to the dais, and Dr. Rakhi Shyam, Honorary Secretary API Dibrugarh, to come to the dais for the oration. I would also like to invite our chairpersons, Professor R.P. Medhi sir, Professor Anup Kumar Das sir, and Professor Prakhanto Dihingia sir, to kindly come to the dais as chairperson. And I would also request our chairpersons to kindly introduce the orators and Professor Prakhanto Dihingia sir to talk briefly on the API oration. Sir, kindly come to the Medhi sir. Medhi sir.
Chairperson એટલે બહુ છે.
Chairperson ever. So I would request our chairpersons to introduce our orator, and I would also request Professor Prakhanto Dihingia to briefly talk about API oration.
It's my pleasure today to be chairing this prestigious oration dedicated to the name of our one of the doyen of medicine, Professor H.P. Burua sir. And today this oration, like every year, we have this oration to be delivered by one of our own members of the Fraternity of Medicine in Assam. And this time, Dr. Atul Hoikia will be delivering this oration. He is an alumni of Assam Medical College, Dibrugarh, and who passed out in, I think, in early 80s. He has been the past president of API Assam chapter, and he's based in Tezpur, and he will be delivering this oration today. And I invite Dr. Atul Sachish to be here to the dais.
I would request Professor Prakhanto Dihingia sir to briefly talk about API oration in a short way.
Thank you, Dr. Anupam. I'll say about how this API oration starts. Uh, I'll briefly say about this in Assamese language. So this API oration is a very prestigious oration for the senior most physicians who is dedicated to this API from the very grassroots level. 2003 চনত অসম API ডিব্ৰুগড়ত পতা হৈছিল। এই API খনৰ সভাপতি আছিল লেট প্ৰফেচাৰ মুনীন দত্ত ছাৰ আৰু ইয়াৰ কাৰ্যকৰী সভাপতি আছিল লেট প্ৰফেচাৰ বিনাপানী দলে মাদাম আৰু ইয়াৰ সাংগঠনিক সম্পাদক অৰ্গেনাইজিং সেক্ৰেটাৰী আছিল প্ৰফেচাৰ গ্ৰীণ গগৈ ছাৰ আমাৰ সন্মুখত তেখেত বহি আছে আৰু এই যিটো আমাৰ API 2003 চনত হৈছিল এইটো বৰ উলহ মালহেৰে খুব সুচাৰুভাৱে পালন কৰা হৈছিল য'ত 7ৰ পৰা 8,000 মানুহে খাদ্য গ্ৰহণ কৰিছিল দুপৰীয়াৰ 2 নম্বৰ দিনা য'ত অসম মেডিকেল কলেজৰ প্ৰত্যেকজন ছাত্ৰই এই API ভাগ লৈছিল আৰু প্ৰত্যেকগৰাকী আণ্ডাৰ গ্ৰেজুৱেট ষ্টুডেণ্টে এই API দুপৰীয়াৰ আহাৰ গ্ৰহণ কৰিছিল তাত আমাৰ 7ৰ পৰা 8,000 ষ্টুডেণ্টৰ পৰা আদি কৰি API মেম্বাৰসকল আছিল আৰু এই API সম্পূৰ্ণ হোৱাৰ পিছত ডিব্ৰুগড় API এটা ডিচিশ্যন লৈছিল যে অসম API এখন জাৰ্নেলৰ ব্যৱস্থা কৰিব লাগে দ্বিতীয়তে অসম API যিজন আটাইতকৈ জ্যেষ্ঠ চিকিৎসক যি একেধাৰে অসম API লগত জড়িত তেখেতক এটা টক দিব লাগে গতিকে সেই ডিচিশ্যনৰ ওপৰত ভিত্তি কৰি আজি আমাৰ 2008 চনৰ পৰা এই API অৰেশ্যন হৈ আছে যদিও 2003 চনত ইয়াক সিদ্ধান্ত লোৱা হৈছিল তাক কাৰ্যকৰী হোৱা নাছিল কাৰণ 2004 চনত API হোৱা নাছিল 2005 চনত ডিগবৈত আৰু 2006 চনত তেজপুৰত API পতা হৈছিল তাতো এইটো কাৰ্যকৰী হোৱা নাছিল কিন্তু তাৰ সিদ্ধান্ত লোৱা হৈছিল কিন্তু 2007 চনৰ এক্সিকিউটিভ বডি গুৱাহাটীত ইয়াক কৰিবৰ কাৰণে সম্পূৰ্ণ সিদ্ধান্ত ল'লে আৰু 2008 চনৰ পৰা ইয়াক কাৰ্যকৰী কৰা হ'ল ইয়াক গোলাঘাট API য'ত প্ৰফেচাৰ প্ৰভাস ভট্টাচাৰ্য ছাৰে প্ৰথম ইয়াৰ বক্তব্য প্ৰদান কৰিছিল তেতিয়াৰ পৰা একেধাৰে আজিলৈকে এই API অৰেশ্যন হৈ আছে ইয়াত আমাৰ স্বনামধন্য প্ৰফেচাৰ দুলাল বৰকটকী ছাৰ প্ৰফেচাৰ গ্ৰীণ গগৈ ছাৰ অমৃত ভট্টাচাৰ্য ছাৰ ভৱানী চক্ৰৱৰ্তী ছাৰ গিৰিধাৰী কৰ ছাৰ উপাধ্যায় ছাৰ তেখেতসকলে বক্তব্য প্ৰদান কৰি আহিছে আজি এই 2003 চনত হোৱা এই কাৰ্যটো আমাৰ সম্পূৰ্ণ ৰূপায়িত হৈছে আৰু এইটো এটা 2003 চনৰ পিছত অসম API এটা নতুন সৃষ্টি হৈছে এখন হৈছে জাৰ্নেল হৈছে য'ত এই জাৰ্নেলখনত অসমৰ বহু সহকাৰী অধ্যাপক সহযোগী অধ্যাপক আৰু অধ্যাপকলৈ উন্নীত হৈছে এই জাৰ্নেলৰ পৰা অকল হেই নহয় অসম APIৰ সকলোখিনি মেম্বাৰে তেখেতসকলৰ জ্ঞানৰ ভাণ্ডাৰ এই জাৰ্নেলখনৰ দ্বাৰা প্ৰতিষ্ঠিত কৰিছে ইয়াৰ পিছত 2019 চনত 2018 চনত এটা সিদ্ধান্ত লোৱা হৈছিল য'ত প্ৰফেচাৰ সঞ্জীৱ কাকতি ছাৰ সভাপতি হৈছিল তাত এটা দিয়া হৈছিল যে প্ৰেচিডেন্সিয়েল অৰেশ্যন গতিকে অহা প্ৰেচিডেন্সিয়েল অৰেশ্যন কাইলৈ প্ৰফেচাৰ অনুপ দাস ছাৰে প্ৰদান কৰিব গতিকে তিনিটা ডিচিশ্যন বা তিনিটা সিদ্ধান্ত 2003 চনৰ পৰা 1 নম্বৰ আছাম জাৰ্নেল ইণ্টাৰনেল মেডিচিন Number 2, API oration for the senior physicians who is dedicated to the API. And third one is API presidential oration. So this is a very three important decision after 2023. So I request all the members for today that you take another one decisions which will be fruitful for API from now onwards. Thank you. Dhanyabad hokololoi.
Thank you, sir, for going us through the history of API oration. Now is the time for felicitation, and I would request the first Professor A.K. Pegu, President API Dibrugarh, to felicitate our orator Dr. Atul Soikia sir with a Fulan Gamusa. I would request Professor R.P. Medhi sir to felicitate our orator with a Sarai. I would also request Professor A.K. Das sir to felicitate with a Seleng Sador. I would also request our senior members of API Dibrugarh, Sanjeev Kakuti sir and Girin Gogoi sir to come to the dais during the time of oration, during the time of felicitation. I would also request Prokhanto Dihingia sir to felicitate with a jacket. I would request Professor Subhalakshmi Das madam to present madam with a Eri Sador shawl. And I would request Professor S.M. Borua to read the citation in Assamese, followed by Professor Dr. Rakhi Shyam to read the English citation. Sir.
Felicitation to Bruno. Farino. ভাৰতীয় কায় চিকিৎসা সংস্থা ডিব্ৰুগড় শাখা ডাক্তৰ অতুল চন্দ্ৰ শইকীয়া দেৱলৈ সম্বৰ্ধনা পত্ৰ তমসু মা ছদ গময় তমসু মা জ্যোতি গময় মৃত্যু মা অমিতং গময় ওম শান্তি ওম শান্তি ওম শান্তি যোৱা কেইবাটাও দশক জুৰি অসম তথা উত্তৰ পূৰ্বাঞ্চলৰ চিকিৎসা সেৱা ক্ষেত্ৰখনলৈ আপুনি যি অৰিহণা যোগাই আহিছে সি অনস্বীকাৰ্য বৈজ্ঞানিক দৃষ্টিভংগী আৰু মানৱীয়তাৰ সুসমাহাৰেৰে জনতাৰ সেৱাত বৰ্তি আপোনাৰ সুদীৰ্ঘ সাধনাক আমি কৃতজ্ঞতাৰে সোঁৱৰিছো ভাৰতীয় কায় চিকিৎসক সংস্থাৰ অসম শাখাৰ সভাপতি হিচাপে আপোনাৰ অৱদান আমাৰ পাথেয় হৈ ৰব আজি পৰ্যন্ত আপুনি অনুষ্ঠানটি যিদৰে গুৰি ধৰি আহিছে তাৰ বাবে আমি আপোনাৰ ওচৰত কৃতজ্ঞ অনাগত দিনবোৰত আপোনাৰ লগতে আপোনাৰ পৰিয়ালৰ সুস্বাস্থ্য তথা অধিক কৰ্মময় জীৱন কামনা কৰিলো ইতি ডাক্তৰ অজিত কুমাৰ পেগু সভাপতি ডাক্তৰ ৰাখি শ্যাম সম্পাদিকা ভাৰতীয় কায় চিকিৎসা সংস্থা ডিব্ৰুগড় শাখা দিনাংক 13 ডিচেম্বৰ 2025
It is our proud privilege to acknowledge and honor Dr. Atul Chandra Saikia for delivering the prestigious API Assam oration at APICON Assam 2025 held in Borgos Resort Kaziranga on 12th, 13th and 14th of December 2025. We extend our deepest reverence and heartfelt gratitude for your unparalleled contributions to the field of medical science and healthcare in Assam and the Northeast, spanning several decades. Your unwavering commitment to serving the underprivileged, combined with your scientific expertise and compassionate care, has profoundly impacted countless lives. As a distinguished medical visionary, your dedication and hard work in the field of internal medicine has set an example to one and all. We are deeply grateful for your visionary leadership and contribution for the Association of Physicians of India, Assam State Chapter. We wish you and your family enduring health, happiness, and fulfillment in the years ahead. Professor Ajit Kumar Pegu, President, Dr. Rakhi Shyam, Honorary General Secretary, Association of Physicians of India, Dibrugarh Branch. Thank you.
Thank you, madam. And with this, I would request our chairpersons to conduct this session of oration and we'd request the others to leave the dais.
Now, on behalf of my co-chairpersons, I invite Dr. Saikia to deliver his talk, this oration.
Honorable chairpersons, respected guests, my seniors, friends, and my dear ones. Today, I am very happy and privileged to offer my heartiest thanks and gratitude to API, Assam State Chapter, Dibrugarh branch and Nagaon branch, to giving me the honor to deliver the API Assam State Chapter lessons. I feel also honored and remembering all my life. In next 20 minutes, the next 25 minutes, I shall say only 3 points. What is the dignified life? What is relations between lifestyle medicine and dignified life? And what are the steps to be taken to live a dignified life in elderly groups? Let us see one small video. Sound, please, sound.
যদি এন্টিচিপেটৰি বেল লৈ পেলাই বাচিব পাৰি মই ল'ম বুজিছা আজিকালি ওলাইছে ন তুমি ষ্ট'ৰ কৰি এন্টিচিপেটৰি বেল লোৱা বুজিছা উকিল টুকিল ধৰি থাকি যাব পাৰে মৰণ মই আটাইতকৈ বেয়া পাওঁ জীৱনটো মোৰ কাৰণে ধুনীয়া বুজিছা মই জীৱন উপভোগ কৰিব খোজো হাঁহিব খোজো নাচিব খোজো শ্ৰীকৃষ্ণই গীতাত কৈছে যে তোমালোকে আনন্দ কৰা সামবেদত থাকা তোমালোক ঋগবেদত থাকিব নালাগে সামবেদত কি আছে অৰ্জুনে সুধিলে বোলে নাচ আছে গান আছে অস্ত্ৰা আছে গন্ধৰ্ব আছে তুমি অৰ্জুন ইমান ধুনীয়া মানুহটো হয় ঋগবেদৰ কথা ভাবিছা সেইবিলাক ঋষি মুনিয়ে ভাবিব হাবিৰ মাজত বুজিছা আমি কিয় ভাবিম শ্ৰীকৃষ্ণ সংস্কৃতি আনন্দ জীৱন আনন্দৰ কাৰণে জীৱন মানে যৌৱন যৌৱন মানে আনন্দ মই সেইকাৰণে বয়স কিমান হল নহয় বন্ধু কিমান হল জীৱন জুখিবা হাঁহিৰে চকুলোৰে নহয় বুজিছা বয়স জুখিবা বন্ধুৰে বছৰৰে নহয়
Thank you. Yes, আমি সকলোৱে দেখিলো আমাৰ অতি শ্ৰদ্ধাৰ বিশিষ্ট সাহিত্যিক লক্ষধৰ চৌধুৰীয়ে কৈছে যে আমি জীয়াই থাকিব বিচাৰো মৰিব নিবিচাৰো যদি দৰকাৰ হয় ভগৱানৰ ওচৰত এন্টিচিপেটৰি বেল আবেদন কৰিম কিন্তু আমি কাৰোবাৰ পুতৰ পাত্ৰ হৈ কাৰোবাৰ নিৰ্ভৰ কৰি আমি জীয়াই থাকিব নিবিচাৰো আমি বিচাৰো আমি যেন সসন্মানে চবেই মানে নিজৰ ওপৰত নিৰ্ভৰ কৰি জীয়াই থাকিব বিচাৰো Yes, we want to live, not to die. If at all needed, we will apply for the anticipatory bail to the supreme power. Each one of us comes with a quiet wish to live long, to see more, to experience a full life, experience life in its fullest colors. It is not just adding years to our lives, but it is about adding lives to our years. Bhagavan Sri Krishna also said that we should live in Samved, Hamved, not in the Rigbed, and enjoy our life with dignity. This is the Bhagavan Sri Krishna Sanskriti. Now let us see whether the government of Assam has taken any step to uplift the dignity of the citizens of India. Yes, advanced medicines, healthcare, technology, and more have enabled people to live longer than ever before. But this also raises important questions. Are the additional years truly enjoyable and enriching? How about aging well? We have seen that more than 2 lakhs population in India are centurions, they live more than 100 years. And more than 6% is about 748 million in 2025, and this trend is rising gradually. With this trend, the importance of understanding how to live with dignity is most important. Aging is not just a demographic trend. It is a call to build inclusive, resilient societies where older peoples are valued, supported, empowered. All of us love our President Drupadi Murmu. Under her guidance, India is in the process of bringing out a new policy for senior citizens. On May 2, 2025, the President of India, Srimati Drupadi Murmu, graced an event, Aging with Dignity, initiative for the welfare of the senior citizens at Rashtrapati Bhavan Cultural Centers. And they take the decision that with the advancements of science and medical science, longevity of the lifespan is increasing, but longevity, aging well, and living with a dignity
become very important. So it is highlighted the voice of seniors across India who now wanted to focus on aging well than simply on how long they live is very important. So we have to live, all of us want to live with dignity. Now, what is meant by living with dignity? It means living a life with respect oneself's worth, values, and human rights, regardless of circumstances. It involves having access to the basic necessities of lives, bringing treated with respect for others, maintaining self-respect, and in turn making choices that all the wants, morals, and ethical principles. Living with dignity is the ability to live a fulfilled, independent, and respectful lives, where one's physical, emotional, and social needs are acknowledged and viewed. Let us see some importance of living a life with dignity. What is there? Dignity gives us self-respect. When we live with dignity, we value ourselves. It helps us feeling confident, independent, and worthy as a human being. Dignity improves mental and emotional health. When we feel respected and valued, stress decreases and our inner space increases. It should build a resilience during difficult situations. Dignity guides our action and decision. It helps us to choose honesty, kindness, responsibility, and discipline in our lives. It's act like a navigator that keeps us on the right path. Dignity protects our human rights. Even persons deserves to be treated with fairness, equality, and respect. And living with dignity means standing up of those rights. Next, dignity is essentially illness, old age, and hardships. Even when we face challenges like diseases, disability, poverty, and aging, dignity helps us to maintain hope, courage, and self-values. And lastly, dignity strengthens our relationships. Respecting ourselves and others leads to better family, social, and public relationships. Let us see some important points to be considered with dignified lives. What are they? Living with self-respect and independence, maintaining quality of lives, not just living long, ability to make own choice and live meaningfully, balance of physical, mental, and social well-being, and it is about living with respect, fulfillment, and humanity, not just living long. Some of the key social aspects to lead a dignified lives are respect and equality, basic needs, agencies and choices, self-esteem and identity, privacy and boundaries, and composure and appearance. Let us see few considerations. All of us needs autonomy and control. That means ability to make lives in own choice. We expect physically, we expect and we try to be physically healthy, absence of disability and less dependence. We deserve mental well-being, less stress, good mood, good thinking, and laughing a while. We expect better relationship with social groups and good family supports. Always we deserve self-respect and sense of worth. To get all these things, conscious lifestyle is the important part. Now, what is the values of dignified lives? Dignified lives can be seen as one of the highest aim of life. It gives us a meaning to life. It integrates moral, emotional, and social well-beings. It enhances quality of lives. It links mainly philosophy and faith, and it is sustainable and universal, cannot be taken away. There are some few factors, some is modifiable, some is non-modifiable factors that can influence the living with a dignity. But I am not going all details. I am just focusing mainly on the lifestyle modifications. Then what is lifestyle modifications? It is a change in long-term habits like diet, exercise, sleep, and stress management to improve our overall health and prevent diseases. Then what are the relations between lifestyle modification and living with a dignity? The positive changes in daily habits to improve health and well-being is the lifestyle modifications. But on the other hand, living a life with self-respect, independence, and sense of human values is what is meant by the living with a dignity. So both are closely related. A healthy, balanced lifestyle form the base for a dignified and independent life. Now, another more important relationships are physical health and independence. Healthy lifestyle prevents chronic diseases. It promotes strength, mobility, and independence. And independence is the essence of maintaining dignity. Mental and emotional well-being. Balanced diets, exercise, and rest enhance mental clarity. Reduce stress, induce emotional balance. We deserve self-esteem and self-respect. Social respect and productivity. A disciplined life improves relationships and works performances. It encourages respect from others and supports a social dignified life. Ethical and responsible living by avoiding addiction and harmful habits, promoting moral dignity and responsible citizenships, and reflects respect for self and the community. And lastly, aging gracefully, like healthy habits delay age-related declines and maintain self-dependence and personal dignity in older age. Then what are the components of lifestyle modifications? I come to the second part. The healthy diet, regular physical exercise, weight management, stress management, adequate sleeps, avoiding harmful activities, and positive mental and social health. Let us go for the first one. That is regular physical activities. It is the key component of the dignified lives. It helps to prevent and manage chronic diseases, promote physical, mental, and social well-being, improve cardiovascular and mental health, reduce risks of obesity, diabetes, and hypertension, and enhance mental health and longevity. These are different types of exercise. Aerobic exercise should be done at least 115 minutes per week. Strength training exercise, that is 2 to 3 times per week. Flexibility and balance exercise, that is very, very important for the elder persons. Mind-body exercise for reduce stress and involves focus. But most important one is the incorporating exercise in daily life. That means use stairs instead of lift, walk or use bicycle for short distances, regular breaks from sitting during work, and join community fitness program. Next is the diet. Second part is diet is just a cornerstone of the lifestyle modifications. It plays a key role in the prevention, manage, and reverse many chronic diseases, and such as diabetes, obesity, hypertension, and cardiovascular disease. It provides essential nutrients for growth, repair, and energy, and it affects metabolic health, immune function, and mental well-being, and helps in maintaining ideal body weight and hormonal balance. That all improve the quality of life. There are different types of diet. There's diet for hypertension. I'll not go in details. Median diet for the metabolic disorders. Plain diet to improve control BP and weights, and low carb diets for the control of diabetes. But diet modification is the lifelong commitment, not a temporary change. Proper nutrition supports pillars for the lifestyle modifications. Third one is the sleep. The importance of sleeps are it consolidates new memories, it restores the body and brain, promotes growth, bones and muscles, regenerates tissues, supports your immune systems, reserves energy, and promotes your cell growth. There are a few tips which improve our sleeps, like routine bedtime, evening walk, comfortable bed, cool and dark room, bedtime rituals, and take a bath just going to bed. And these are some adverse effects like heavy food, blue light, alcohol, smoking, caffeine, heart trainings, and stress. Then weight management. Another important part is weight management. Weight management is the crucial aspect of lifestyle modifications. Healthy body weight can be achieved through balanced diet, physical activity, and behavioral changes. It prevents obesity and metabolic disorders. It improves hypertension, heart disease, and diabetes, and promotes overall well-being. The best way to manage the weight are balanced diet, physical activities, sleeps, and stress control. Most of the departments depends on BMI, but BMI tells you what your current weight status is. And on the other hand, weight management tell you how to improve or maintain the status through healthy living. Then harmful habits. Another important harmful habit, elimination of harmful habits is the key component of lifestyle modifications. These habits reduce this interferes with diet and exercise approach. They contribute to poor mental and physical outcomes, and many harmful habits are linked to stress, anxiety, and depressions. These are the common harmful habits. I don't go to. Then interventions are proper counseling and therapy for addictions. We should attend that immunity awareness programs, regular follow-up and family supports, and if at all needed, took some medication with proper guidance. Then stress management. Stress is a natural response to the challenges arising from the work pressure, public dissatisfaction, family, financial problems, poor time management, social isolation, conflict, and unhealthy lifestyles. These are all physical, mental, and behavioral problems. How to manage it? Like physically, regular exercise, deep breathing, adequate sleeps, and balanced nutrition. Psychologically, take meditations, positive thinkings, and time management prioritizations. And a social aspect is share your feelings and seek help. Build support relationships and do not share everything to the social media. This is very, very important. And lastly, the positive mental and social health are feelings, calm and confidence, having good relations with society and family members. Remedy for mental and social health is reduce exercise, reduces stress, fatigue, and makes one happy. Good sleep keeps the mind fresh and active. Healthy food helps the brain to work better. Spending time with family and friends improve mood. And group activities improve communications, and social supports makes you feel safe and confident. Then we come to the last part. This is a very important part for our senior groups. How to live a dignified life at the later age. First, maintain physical independence. Stay physically active with appropriate exercise. Use assistive devices like hearing aids, glasses, walking aids without any shame. Manage chronic illness with regular medical checkup. Ensure safe home environment like grab bars, good lighting, and clutter-free rooms. And the moralist independence is the strongest pillar of dignity. Now, preserve emotional and mental well-being. Stay connected with family, friends, and community. Engage in hobbies like reading, gardening, singing, and teaching when possible. Practice mindfully meditations and spiritual routines, and seek help for loneliness, anxiety, and depressions without hesitations. Then third is continue having a sense of purpose. Join senior groups, social clubs, and volunteers in a program. Continue to family discussion and decision. Always try to take part in family discussion and decisions, and mentor younger people when needed. Promote respectful relationship with, expect and ask for respectful treatments from family, society, and the caregivers. Communicates needs clearly and assertively, and set healthy boundaries if someone is disrespectful. The moral is respect from the others, reinforce personal dignity. Next is ensure financial security and control. Plan finances early, but also maintain a control in it in old age wherever possible. Keep important documents organized so that you can get easily, and avoid financial dependence, and seek assistance only and when necessary. The moral financial autonomy supports confidence and self-respect. Then maintain personal appearance and hygiene. Dress comfortably and neatly. I can say proudly that all our doctor friends are really dressed neatly and very nicely and very comfortably. Grooms regularly hair, skin, and nail, and takes time for self-care. The moral is good self-care boosts confidence. Next is accept aging as a grace. Understand that physical changes is necessary. Focus on ability, not on limitations. You change your mindset that replace I am old and useless with I am experienced, and more valuable. A positive mindset protects dignity. Make your own choice on medical decision, daily routines, living arrangements, and social preferences. Choices are controlled to dignity. 9 is build social safety networks. Maintain strong family bonds. Stay connected with a phone, social media, community as and when needed. Seek support services when needed, like home nursing, social workers, and senior groups. And lastly, protects legal rights. Understand it properly with the following things: elder abuse, healthcare decisions, property ownerships, and lastly, pension benefits. Knowing a rights prevents exploitation and preserves dignity. Dear friends, all these things about, let us come to the conclusions. In conclusions, respect yourselves through healthy choice, honesty, and self-care. Treat others with compassion and care, uplifting mutual dignity. Live by your values, not by pressures, fears, and circumstances. Lifestyle medicine is the key point of living with dignity. And like dignified lives, we need to be prepared for a dignified end also. Thank you. Thank you so much for patience. Thank you.
Thank you, Dr. Tulsiga, for a nice presentation of the oration. It is a great pleasure that I am sharing the one of my best students of AMC. Now it is a very nice lecture. Thank you very much.
Thank you, sir, for this valuable lessons, I may say, for us of living a meaningful life. A bit philosophical, but very important, and we just overlook it. But being an oration appropriate for this occasion. Thank you, sir, so much.
Thank you.
I hand over the mic to the organizers. Thank you.
Thank you so much. Now I would like to request our chairpersons and speakers, sir, to kindly move for the felicitation in.
Thank you, respected speaker, respected chairpersons, and also president and other office bearers of FTI Dibrugarh branch. I, on behalf of the organizing committee, in the capacity as chairman, would like to inform you that simultaneously in both the halls, scientific programs are going on here in Kolong as well as in Kopili. The next program will be simultaneously going on in both the halls. And the program, for your kind information, the program that will be organized in the hall Kopili, that is hall B, is will be delivered. The lecture will be delivered by Professor Priyam Goswami from Tinsukia Medical College. She will deliver a lecture on dyslipidemia trends in India, pharmacological therapy beyond statins. So, audience is hereby requested to draw their conclusion. Whoever prefers to be there, I think it is an important topic also. So we must participate and listen and also do acquire knowledge from that talk or the lecture. Thank you all.
Moving forwards, I would like to invite our chairpersons for this next session, Dr. Aminul Islam, Dr. Pritam Kurmi, and Dr. Alka Sharma. I would like you to request, please grace the dais. Our chairpersons for this session is Dr. Aminul Islam, Dr. Pritam Kurmi, and Dr. Alka Sharma. Please kindly grace the dais. Our speaker for this session is Dr. Nilakhi Deka, who will speak on the topic Stepping Up Towards Transformative Health-Centric Approach to Obesity Care. I would like to request ma'am to please conduct the lecture.
You can start. A very good afternoon, everyone, and it gives me great pleasure and honor to be a part of this scientific session, this scientific event here organized by API State Chapter. The topic that I've been, the Nagaon chapter, Nagaon branch. Thanks for the correction. So, the topic that I'm going to deliberate upon for the next 20 minutes is on obesity care, which is one of the hot topics in these recent times. As you must have observed, that there has been a recent change in the topic of discussion from diabetes care to mostly the scientific events across the globe focus on obesity care. And we will discuss on stepping up towards a transformative health centric approach in obesity care. These are my financial disclosures. So, what is obesity? Obesity is defined as a chronic, relapsing, progressive disease process which is characterized by abnormal or excessive adiposity that impairs health activity. It is often acknowledged as a disease, though there was a long debate as to whether obesity should be considered as a condition, a state, or a disease. It is now acknowledged as a disease and a health issue according to the numerous global guidelines. Now, if you see this slide, what is more alarming and disturbing is the fact that almost 1 billion people are affected by obesity. And the most disturbing part is that almost 71 million children suffer from obesity. 86 million adolescents suffer from obesity, along with 764 million adults. Now, obesity in children and adolescents is more dangerous because early obesity during childhood years, during these formative years, could eventually lead to a more aggressive form of non alcoholic fatty liver disease, which is commonly known as metabolic dysfunction associated steatotic liver disease or MASLD of recent times, which could lead to early onset cirrhosis and shorten the lifespan of these children with obesity by close to 20-25 years. So, obesity is of concern to each and every one of us. In India, the picture is not better than the global stage. And though we Indians may appear to be thin, we are actually the thin fat Indians. If you see, there are 254 million people in India who are adults with generalized obesity. But if you focus on this figure, 351, this is adults who have abdominal obesity. So most of these individuals are normal BMI individuals who have an increased waist circumference or central obesity, and which is the more dangerous form of obesity that could be prevalent in a country like ours with poor resources. Now, only around 30% of the patients they acknowledge that they have obesity. The rest 70% are in a stage of denial that it is okay, this has been recent, this is healthy, I don't feel any difference, there are no symptoms of obesity. So almost 33% patients with obesity are in a state of denial of their condition, only around 40% of them have a formal diagnosis of obesity given by a physician. What is important is that in spite of this denial by the patient, the complications of obesity, they embrace these patients. So, in spite of their denial, these patients with obesity go on to have more frequently stroke, congestive heart failure, ischemic heart disease, PCOS, major depression, diabetes, myocardial infarction, MASLD, gastroesophageal reflux disorders, obstructive sleep apneas, hypertension, and musculoskeletal disorders like knee osteoarthritis. Hence, obesity is of concern not only to the physician but to multiple other specialties. Almost 230 plus complications have been attributed to obesity. So, obesity is the root, with all these complications, the offshoots of obesity. So, having known the fact that most people are ignorant, yet complications of obesity embrace these ignorant people, one of the simple measures to get rid of these complications or to stay at bay from these complications is weight loss. And weight loss, even as low as 5%, can have its benefit. So, if you see in this chart, weight loss as low as 5%, so to an 100 kg individual, becoming 95 may not be a very significant or impressive figure. Yet, even getting from 100 to 95 kg can actually go on a long way to improve the liver insulin sensitivity, the muscle insulin sensitivity, improve the beta cell function, improve the abdominal adipose tissue inflammation, improve the inflammatory markers. And weight loss of up to 15% can accelerate or accentuate the benefits which come out of weight loss. So, even 5% weight loss, if we can achieve in an individual, that goes a long way to improve the metabolic profile of the individual. And achieving weight loss as much as 15% can almost lead to reversal or remission of many of these complications, like the gene expression in adipose tissue, the myocardial infarction rates, and a reversal of liver fibrosis to a certain extent. Now, whenever a patient with obesity comes to us, it is very hard for us to convince the patient in the first instance that you have obesity. So once you somehow try hard, spend a lot of time counseling, telling the individual that he has obesity, which is a disease, and he has to deal with it. So at that current moment, the patient may not be having those complications of obesity which can occur in the later run, like diabetes, hypertension, myocardial diseases, and all. So the patient will not accept the fact that he has obesity as a disease. He would consider that as healthy weight gain. So we can use terms like more weight than your height, more weight than which is healthy for your body. And the measures which we suggest are measures like increased physical activity, so less calorie intake, increasing the calorie expenditure, that is physical activity, and also cognitive behavior therapy helps in many ways, like psychological interventions. So these measures of lifestyle interventions can lead to a fair weight reduction of around 3 to 5%, whereas on the other hand, the surgeons have an edge over physicians, because what physician tells, the surgeon does, and the weight loss which comes with bariatric surgery is close to 30%, 35%. So which is huge, with regression in the cardiac complications, with regression in the stroke complications, with regression in the metabolic liver profile complications. However, one of the offsets of bariatric surgery is the fact that it is not widely available and it is not acceptable by the patients also, because it's a irreversible, it's a mutilating process, and so a patient may not embrace the idea of bariatric surgery very warmly. In between this lifestyle modification and bariatric surgery, there is something which is new in the pharmacotherapy area, or in the treatment area, in the treatment domain, that is pharmacotherapy for obesity, which could lead up to 5 to 25% weight loss without going under the knife. Now, when an individual loses weight by decreasing the calorie intake, by increasing the physical activity, there's a constant tussle between the factors which decrease the resting energy expenditure. There would be increase in the hunger hormones, there would be decrease in the satiety hormones. So when a patient loses weight, the body fights back to gain the weight which is lost. So that's why it is difficult for a patient to maintain a particular weight. So the patient may lose weight initially by causing excess calorie restriction and by increasing the physical activity. However, it becomes difficult for the patient to maintain that weight for a prolonged period of time, because as he loses weight, suppose the patient loses from 90 to 80, the resting energy expenditure in this individual would go down, so that his weight loss is no longer facilitated by his basal metabolic rate. There'd be an increase in ghrelin, which is a hunger hormone, and a decrease in the satiety hormones. Hence, the various studies, the various RCTs, randomized control trials, like even the look ahead trial, it showed that it may be possible for an individual to lose weight, but very, very difficult for an individual to maintain the lost weight. Hence, the role of pharmacotherapy in these patients. So, because of the metabolic changes which fights back weight loss, pharmacotherapy can help an individual to maintain the weight which is lost in an individual who is obese. So, we have this molecule Wegovy, which is a GLP-1 receptor agonist. It is semaglutide and it's a human GLP-1 analog. It acts on the hypothalamus to cause decreased appetite. So we have three forms of eating. One is the homeostatic eating. So when you're hungry, you eat. The other is hedonic eating. So you're not hungry exactly, but you eat because of the pleasure of eating. Suppose you've had your meal, then you have your dessert. So the dessert is the part of hedonic eating. And the final call is taken by the cortex. So the cortex tells that you are full, you don't eat. So the cortex can control both the homeostatic eating, that is eating out of hunger. So sometimes you may be hungry but you don't have access to food, and then the cortex says keep your hunger feeling at the background and go on working. So the cortex takes the final call, and that can take care of both homeostatic eating and hedonic eating. So cortex is again control. We can cause weight loss through measures like cognitive behavior therapy or psychological counseling or lifestyle modification. If a patient gets into that, then he can have a cortical inhibition of hedonic eating, which could as well lead to weight loss and weight maintenance. But these pharmacotherapeutic agents like GLP-1 receptor agonists, they work on these two forms of eating, that is the homeostatic eating and hedonic eating to a certain extent. More of the hedonic eating pleasure is controlled by other drugs like topiramate, phentermine, which, however, are out of use in the country because of their other side effects, like psychiatric side effects which come. So, we have GLP-1 receptor agonist, Wegovy, which is currently available with us. It's semaglutide, which works in the key areas of brain to help control hunger as well as the cravings. It is available up to 2.4 mg. That is the maximum dose of GLP-1 receptor agonist of semaglutide that you can give once weekly, and it increases satiety, makes your patients feel less hungry. It also acts on hedonic regulation of appetite. It reduces the food cravings and preferences for certain calorie dense, less nutritious food. So there have been a number of phase 3 programs with semaglutide, which are the step trials. So we have step 1, 2, 3, 4, 5, 6, up to 11, and then you have Wegovy in heart failure with preserved ejection fraction without diabetes, heart failure in preserved ejection fraction with diabetes, select trial, which is a CVOT trial with Wegovy, and the Essence trial in metabolic dysfunction associated steatohepatitis. So, Wegovy has a role in weight loss primarily, and that would also go a long way in decreasing the HbA1c and improving the liver fibrosis in those individuals who have MASH or MASLD. The weight loss that is caused by Wegovy, so we saw 3 to 5% can be achieved with lifestyle modification, 35% with bariatric surgery, and semaglutide Wegovy up to a dose of 2.4 milligram has been able to achieve weight loss of almost close to 20% or sometimes 20% and more in 1 out of 3% patients who use Wegovy. Almost most of the patients, more than 9 out of 10, they achieve around 5% weight loss, and this weight loss is sustained over a period of 4 years. So there has been a transformative weight loss of up to 18% across the various STREP trials that were conducted in different groups of patients. So they could be obesity, they could be obesity with diabetes, they could be obesity without diabetes, it could be Asian phenotype in China, in Chinese people, which was done. So in these different trials, they saw that there was a mean weight loss of around 18%. Participants achieving 5%, 10%, 15%, and 20% weight loss where like 5% 9 out of 10 and 20% 1 out of 3 achieved. So more than 20% weight loss, as we see from these figures, is achieved in 1 out of every 3% patients. And so most of us will argue that when you have weight loss, you tend to also have muscle loss, which leads to sarcopenia and which can affect your aesthetic appearance, which can also lead to more number of falls, more fractures, and thus increase the morbidity. But in these trials, so they did a DEXA, which is one of the gold standards, to see what percentage of fat, what percentage of muscle they have, what percentage of bone. And it was seen that in an individual, say the patient was 40 kg, he has now achieved 30 kg. So this is just a hypothetical figure. It was seen that from 40 kg to 30 kg, that decrease in body weight is mostly fat and less of muscle. So there is invariably some amount of muscle loss, but this muscle loss is much lesser compared to the weight loss. So that when you do a DEXA of that 30 kg individual, it appears that the muscle mass is actually increased. Why? Because the 30 kg weight is contributed more by the muscle mass than the fat mass. So the fat mass has shrunk and the muscle mass appears to increase, though that is a statistical gimmick. Yet what the slide wants to prove is that you do have muscle loss along with fat loss, but the proportion of fat lost is much more than the muscle loss which occurs with the use of Wegovy. In fact, they found plus 4.5 kg improvement in the hand grip strength with Wegovy, which means that the muscle strength, muscle mass, muscle volume is maintained. So beyond weight loss, now we talk a lot of these pleiotropic effects of medications now after 2015 when the first SGLT2 inhibitor empagliflozin came into the market. So until then we were only evaluating glycemic reduction, and glycemic reduction. That is, we were having a glucocentric view. After we got a taste of what empagliflozin or SGLT2 inhibitors could give, we now talk about pleiotropic benefits. So other than weight loss, what else do you have to offer? So similarly, when we talk about Wegovy, apart from weight loss, there's a minus 16 centimeter waist circumference reduction. So what is the significance of this waist circumference reduction? So if you remember the slide, the second or the third slide which I had presented, that in India there are more number of individuals who have almost a kind of normal BMI, but they still come in the category of central obesity. So Wegovy, even in these individuals who do not appear to be obese by the BMI scale, but if they have central obesity, it can go a long way to reduce the central obesity because it decreases the waist circumference to the extent of minus 16 centimeter. It could also bring about, as an accessory, around 2% reduction in HbA1c, decrease in inflammatory markers like CRP, close to 63%, 10 millimeter reduction in systolic blood pressure, 5 millimeter reduction in diastolic blood pressure, and also an improvement in triglycerides, which is a marker of insulin resistance. So decrease in triglyceride would be a surrogate marker to know that there is an improvement in insulin sensitivity or a decrease in insulin resistance, which is one of the key components of MASLD. So these are the pleiotropic effects of Wegovy. Now, you remember the patient, how difficult it is to convince him that he has obesity as a condition. Then you have the ordeal of convincing the patient that there are medications for obesity and you can try. So, first, 30% of the patients will deny they have obesity. Out of the rest 70% who will accept that they have obesity, a small fraction will accept the idea, but a majority will refuse because they would say, no, doctor, there are a lot of side effects I have seen in social media. It keeps coming. So and so faces, Karan Johar faces, and so many other things that would come in lay media, which the patients are scared of. And I feel, in a way, though this negative publicity has made people a bit scared, but it has also percolated the idea amongst the masses that you have something for the treatment of obesity which could lead to weight loss and wrinkling of the skin, which is a secondary thing. So unless we know that there are no side effects of Wegovy or GLP-1, we will not be able to convince the patients. So these various CVOT trials done with GLP-1 receptor agonists have found that one of the bottom line with the use of this incretin-based injectable agents GLP-1 is that they could lead to GI intolerance. So you expect that the patient will have nausea, vomiting, bloating, decreased appetite, a sense of unwellness at times because the patient is on GLP-1. So apart from that, there are no major side effects. Maybe in a patient who has idiopathic pancreatitis, you should refrain from using GLP-1. Apart from this, the very small fraction, which maybe my senior MP Borwa sir must have seen a number of, but in my career I have seen around 2 medullary thyroid carcinoma. So in those group of patients, one should be wary of the use of GLP-1 receptor agonists because they have a remote probability of increasing the chances of medullary thyroid carcinoma prevalence in those who have a family history of medullary thyroid carcinoma or a past history of medullary thyroid carcinoma. So apart from GI intolerance, which is there with all GLP-1, apart from pancreatitis, which is rare, but suppose the patient has idiopathic pancreatitis, you don't know the cause, then you should refrain from using. So pregnancy is another issue. And then in patients who have family history of medullary thyroid carcinoma. So in this, now there was a concern with exacerbation of non-arteritic ischemic optic neuropathy, NAON, which was called. So semaglutide has a focused trial which is selectively dedicated to study the effect of semaglutide on retinopathy. The reports are not yet out. However, whatever data they have said that there is no increased risk of diabetic retinopathy in patients with obesity without type 2 diabetes. In patients with type 2 diabetes who have established retinopathy, if you bring down the HbA1c or the glucose reduction very fast, any medication would lead to an exacerbation of retinopathy, and that was also seen with liraglutide in the leader trial, and then it is also seen with any GLP-1 or any modality of treatment. So that is there, and we await the trials from the focus trial, which is a dedicated trial to see the effects of semaglutide on diabetic retinopathy. So semaglutide has almost 60,000 people who have been studied in these various STEP, sustain and pioneer clinical trial programs. So almost data from, these are very critical, crucial and minute data from almost 60,000 patients who have been followed up for a period of 3 years to 5 years in these patients. So we see that this molecule is safe. It's a known devil, does not have any effects like which we are not aware of as of now. It's been around 10 15 years of use of GLP-1 receptor agonist. So the only side effects that have been known are GI intolerance, pancreatitis, medullary thyroid carcinoma, no other risks which are unique to this class of agents. So to summarize this discussion, we know that there's a growing burden of overweight and obesity, and we are talking more of overweight and obesity now in current times, and we were not speaking of this in the past because now we have pharmacotherapy to take care. So earlier it was diet, exercise, which fails in most of the patients, and then you had to ask the patient to go for bariatric surgery, but the patients would refuse. So if you're advising 10 people to take GLP-1 receptor agonist, 3 will agree. But if you're advising 100 people to undergo bariatric surgery, maybe one will go for bariatric surgery. So you now have something more tangible, which is something more which is accessible and available, more acceptable to the people to accept as a form of therapy for obesity. So um, we are talking of obesity and overweight now more often because we have more tools to address obesity. Semaglutide, which is a GLP-1 receptor agonist, Wegovy, which is available from strengths of 0.25 to 2.4, given once weekly, offers comprehensive cardiometabolic benefits. So it not only reduces weight, it also reduces BP, it also improves the lipid profile, it also improves the liver fibrosis part or non-alcoholic steatotic liver disease part. It also leads to a weight reduction. It also leads to waist circumference reduction, decrease in the inflammatory markers like CRP, and has been found to cause a 20% reduction in the MACE outcomes in the CVOT trial, which was there with the SELECT trial and Wegovy. The safety profile of semaglutide is consistent with GLP-1 receptor agonist as a class, and there is no red flag to its credit. I mean, it does not have anything which is away from other GLP-1 receptor agonists as side effect. With that note, I thank you for the patient hearing.
Thank you, ma'am. That was a great talk. I think it applies to all of us. Being parents of young kids, I think the constant struggle of keeping the children away from screen and the junk food. So adolescent obesity once was considered mainly a Western phenomena, but it's right there in our homes. So and it increases the risk of CVD, cardiovascular events at a young age. So we all need to be prepared for the adolescent obesity for management. One more thing is GLP-1 RA, as you said, they have GI side effects. So the idea is to titrate slowly with the smallest possible dose, which can be tolerated by the patients. So it was a very great talk.
Thank you, ma'am. Ma'am, I want to ask you a question. Ma'am, what is the starting dose of Wegovy and what is the duration of treatment?
Go with 0.25 once weekly, say for 4 weeks. Then you up titrate to 0.5, then 1, and then 2.4 is the next Wegovy dose. So Wegovy and Ozempic, what they call, they are the same molecule, semaglutide. But Wegovy is for patients with obesity, even without diabetes. So we know for causing glycemic reduction or glucose reduction, you need a lesser dose of GLP. But to cause weight reduction, you need a little bit of supraphysiological dose of GLP-1, which would cross the blood-brain barrier and would affect the hypothalamus. So for that weight reducing effect, the appetite reducing effect, you need a higher dose. So that is the idea why Wegovy is available up to 2.4, whereas Ozempic, which is also semaglutide, the same molecule, the highest strength is 1 mg. So you go from 0.5, 0.25 once weekly for 1 month, then you up titrate to 0.5 once weekly for 1 month, then you go accordingly higher up to 1 milligram dose. So at any point of time, if the patient is not tolerating the higher dose, then you can again go back to the lower dose.
But I hope, rather I am afraid or worried that it is expensive and costly, which is not just, let's be complete, but which is not affordable by the common masses. Because nowadays this is a pandemic, this obesity. That is one point. Second point, how long the effect will remain after the course or the doses are over. Once he completes or she completes the course, suppose he restores his old habits, so will he again regain the weight?
yes, they will again regain the weight. So there is this trial which was done with the dual agonist tirzepatide, where they saw they had given tirzepatide for a period of 82 weeks, and then they stopped, followed up the patients for another 56 weeks. So they saw that patients came down, say, from the said weight to 24% weight reduction. Then again, they went back to 19% after stopping the medication, which was still less than the baseline weight which they had. So these are temporary measures, but how we can counsel the patient is that so this may be a learning time for the patient. Like that is how I explain to the patient that this 6 months when you are on GLP-1, you follow the same routine of food which you follow in these 6 months for the rest of your time. And there is also something called maintenance dose. So you go up to the higher dose of, say, Wegovy, you achieve weight loss, then you can step down to a lower dose and maintain it for a longer period of time, because a lower dose would also mean lower cost. Higher the dose, greater the cost.
So, would you
we have to.
just
Excuse me,
only. So,
I have questions. Thank you, madam, for your nice presentation. Before starting whatever GLP analogs, we have to counsel the patients, because 5% of the patients will not lose any weight. Even in your slide also, you have seen that only 9 out of 10 will achieve. And we have to be frank about that you may not lose weight. And another thing, the diabetics patient, they will not lose weight as much as the other patient. These are facts we have to tell them. And second thing, the right from the head, you have to prepare the patients that initial period, besides the gastric symptoms, you have hair loss, you have loose skin, that Ozempic phase may occur. So we have to appropriately give them the nutrition that requires for the hairs. And sarcopenia, though it is a aesthetical gimmick, sarcopenia muscle loss is a reality. It is a real fact. So you have to supplement adequate protein along with that. And as you have rightly mentioned, those who have got medullary carcinoma, we have to, at least before starting, to save ourselves, though it is incidence is less. And we have to screen for medullary carcinoma at least by doing an ultrasonography, or if possible, by calcitonin level of calcitonin. At the same time, we have to in the eyes, diabetic retinopathy, yes, maybe because of the rapid reductions of the glucose sugars, semaglutide or may not be responsible for that. But non-arteritic the NIN is a fact, and it is maybe, though it is, you cannot absolutely say that it is not because of that. You cannot rule out. So we have to do a thorough eye examination in all patients whom you are going to prescribe it. And second, in the abdomen, those patients who may have got some microlithiasis, there is always a chance, because of the excess weight loss, these patients may suffer from gallstones also. So it is our duty to exclude any gallstone, and those who have history of pancreatitis, idiopathic pancreatitis, even these patients already they have got hyperglycemia. That is another reasons for pancreatitis. We have to exclude all these things before prescribing. And once you start this, you have to continue. Otherwise, he or she may regain weight. Unless and until he maintain the lifestyle modification with both with the diet as well as the exercise. Thank you, ma'am. Thank you, ma'am.
Thank you, sir.
For your
Just
excellent.
one point that I would like to say. In none of these CVOT trials, they actually did a serum calcitonin and excluded medullary thyroid carcinoma, because the prevalence of medullary thyroid carcinoma in the general prevalence is deemed to be extremely low. And there is no guideline recommendation to actually screen for serum calcitonin or do an ultrasound. But if a patient has a family history, because it could be a part of MEN, so one has to be cautious in those patients who gives a florid history, family history of medullary thyroid carcinoma. In that subgroup, we have to be cautious. But otherwise, routine screening.
Since the patient is going to spend 25,000 rupees, if the question of litigation come, because it is the established cost, no? You have, if you do calcitonin level, that will not cost him much. To protect ourselves, someday some patient may come into the court.
But litigation is also not there, sir, because it is because if we go by the medical recommendations, there is no guideline recommendation to suggest that. Like we have for pancreatitis, if a patient has idiopathic pancreatitis and we are still initiating with GLP-1, we may be at the at the other end of being unethical. But sometimes a patient having gallstone pancreatitis had just one episode of pancreatitis, we may at times be in a kind of dilemma or in a gray zone that he just had one episode of gallstone pancreatitis. So in those cases, sometimes we, because we have a soft corner for the patient, at times to prevent cardiovascular or say decrease in the renal function, we may at times initiate. But yes, there are chances of legal litigations are there in those patients who have had a pancreatitis, but not in those if we do not do a serum calcitonin, no, we are not at the other end of the law.
So, at the end of the day, in view of all these hullabaloo, will you advocate that bariatric surgery is the ultimate?
No, sir. I will not. Yes, but it would prevent the recurring cost of the patient. So it would just be a cost of around 4 to 5 lakhs
Yes.
at one time. But how many of us would be ready to undergo that?
Yes.
To have a permanent, irreversible, mutilating surgery. So many of us would be scared. And we also tend to have weight gain even after bariatric surgery, though the chances are very less. Yet bariatric surgery is not 100% weight reduction even at the end of say 5 years or 10 years. So after some years, patient may gain back the original weight. So that still remains.
Thank you.
Thank you, ma'am, for your beautiful presentation. Apart from GLP-1, is there other drugs for management of obesity which are easily available and affordable to the patients?
So there is uh, orlistat, which is there, but which causes a weight loss of up to 2 to 3 kgs in certain patients at the end of 6 months. But that will work only if the patient has a visible fat in their meal. Suppose the patient takes boiled carbohydrates or takes sweets for all his meals or junk for all his meals, junk not in the form of like salted things, like not pizza and all, which have a high this thing. But if they have a high carbohydrate content, which is increasing, contributing to their fat, it will not work. But only if they're having a curry which has a lot of oil in it, it will lead to that loss of fat in the stool. It will cause steatorrhea and loss of calories, and thereby it will cause weight loss. But it would not be effective in patients who are not consuming too much of oil or fats in their diet. So the maximum dose of orlistat that we can give is 120 mg thrice a day with 3 meals which have visible fat in them. So in that case, it would work, but that would also increase the cost of therapy to 300 rupees per day, or close to 200 to 300. So that would also be in a way expensive only.
So, thank you. Chairpersons, please wind up.
Okay, we conclude the session.
Yeah,
Thank you
thank
so
you.
much, ma'am.
Thank you.
Right.
Thank you, ma'am, for that insightful session. Chairpersons and speaker, ma'am, kindly step forward for the facilitation area. Moving forward to our next session, it gives me great pleasure to introduce the chairpersons for this session. Dr. Noni Gopal Singha, Dr. Nripendra Nath Datta, Dr. Bithika Burman. I request you kindly chair the proceedings. I'm also very delighted to introduce our guest speaker, Professor Dr. Aman Sharma, Department of Rheumatology, PGI Chandigarh, who will speak on the topic, the rash, the nerve, and the kidneys, a classical clinical clue to vasculitis. Given Dr. Sharma's substantial work in rheumatology, we look forward to an informative and clinically relevant session. We kindly invite sir to begin the talk.
Good afternoon. At the outset, I would like to thank the scientific committee, especially Dr. Arup, for this very kind invitation. So the title that he has given me is The Rash, Nerves and the Kidneys, a Classical Clue to Vasculitis. Taking this opportunity, I would actually give you a snippets or the case-based examples actually as to when to think about vasculitis. When as a term vasculitis is used, many of us think that, well, it's not a common disease. Why should we bother to know about different forms of vasculitis? But I'll show you that whatever your specialty, at the end of the day, you will realize that almost all of us would have seen many of the different varieties of that the vasculitis that we're going to talk about. In rheumatology, whenever we talk about vasculitis, basically vasculitis is, as the name suggests, for the residents is inflammation of the blood vessel. So what the inflamed blood vessel can do is either it can result in occlusion of the vessel, which causes ischemia or infarction of the organs, or it can cause the weakening of the vessel wall, which further ruptures and causes hemorrhage. So there are various classification nomenclature systems. The one that I've chosen to give various examples is the Chapel Hill nomenclature system, wherein the different clinical subtypes are divided based upon the vessel size. For example, aorta and its major branches cause if they are involved, there is large vessel vasculitis. If the medium-sized vessel which go into the organs are involved, there is medium vessel vasculitis. There can be small vessel vasculitis. There can be vasculitis which is variable etiology, which means either any of the larger, medium, or smaller size vessels can be involved. It can infect only a single organ. It can be associated with various rheumatic diseases, part of which Pradeep very beautifully talked about this morning when we talked about rash and joint disease. And it can be associated with probable etiology like Hep B and Hep C, drugs, and cancer. So moving on to the large vessel vasculitis. So if you see an elderly who comes to you with a recent onset headache where the character of the headache has changed, it is severe, it is new, and then you should always consider giant cell arteritis as one of the possibilities. So what we should do is you put your hand on the temporal area, see whether there is tenderness in the temporal artery area, and then if it is there, get an ESR and CRP done, and ask about the visual impairment or blurring of vision. There can be history of jaw claudication or if the pain in the head while somebody is chewing. If these are there, you need to start treating. Actually, the one investigation that you can do is if you have an ultrasonist who can do the temporal artery ultrasound and show you halo sign, then the diagnosis is nearly established. ESR and CRP will be high. And if a biopsy of the temporal artery is done, it will show the break in the internal elastic lamina, and these are the giant cells. So it was always talked about as we were talking this morning about Crohn's disease, that giant cell arteritis doesn't really occur in this country. That also is far from true, as was the untruth about the Crohn's disease and sarcoidosis. So this does occur in this country. Almost 15 years ago, we had collected around 17 patients, half of them from the ophthalmology department, because the sinister manifestation is vision loss. So if an elderly comes to you with headache and a vision loss, you must definitely consider giant cell arteritis. And besides the scalp area, the other area that you must always palpate is the carotids and see for carotid artery tenderness. The other time when you should consider giant cell arteritis is when an elderly comes to you as a physician as with pyrexia of unknown origin. The fever is not going away and all the investigations have been done and it is not picked up. And nothing actually is contributing, and patient has been going on with high grade fever. The SR is elevated and the CRP is elevated. At that time, the imaging would come into the picture. The most important imaging is PET scan, but even CT scan can pick up the thickening of the vessels, especially if the headache is not there. We saw a patient a couple of days ago in PGI where the patient is having fever for 2 months, ESR is more than 100, CRP is elevated, but none of the investigations is contributory. The only thing which is there is the aortic thickness and uptake in the aorta. So that is what you call as extracranial giant cell arteritis. That's what I was trying to allude to. So it is not only the giant cell arteritis is always with headache. It can present only with pyrexia of unknown origin and headache may not really be there. So this was a patient admitted under neurology of PGI, where a dementia was responsive to corticosteroids, and we would be surprised that even reversible dementia has been reported with giant cell arteritis. And this was a patient who just had a very mild headache, predominantly was presented with fever and abdominal aneurysm. And Orgo Chattopadhyay, who is there in Calcutta now, was our student. He took me and said this could be Behçet's disease, because every aneurysm, aortic aneurysm, thought Behçet's has aneurysms which are more common, but this patient didn't have Behçet's. What this patient had was extracranial giant cell arteritis. So there was definitely an abdominal aortic aneurysm, but there was thickening of the temporal artery, there was thickening of brachiocephalic artery with FDG uptake, common carotid arteries, and this was extracranial GCA. So again, for all of you, whenever there is giant cell arteritis, the new kid on the block is, all of us as physicians have, what we do is pattern recognition. So if it is headache and vision loss and high ESR and high CRP and temporal artery, thickening or uptake, giant cell arteritis, that actually had a paradigm shift in an NEJM publication in 2020, wherein it was shown by the NIH group, our friends and collaborators, Peter Grayson's group. They showed that whether it is giant cell arteritis or relapsing polychondritis or sweet syndrome, if there are cytopenias, mind it, there are generally leukocytosis, thrombocytosis in inflammatory rheumatic diseases. But if you have cytopenias, and more importantly, if you have macrocytosis with MCV more than 100, think about a new disease entity, which is Vexus syndrome. So there is a ubiquitin gene mutation, UBA1 gene mutation. So, and this is vacuoles, E enzymes, X-linked autoinflammatory with somatic mutations. So these are not germline mutations. These are somatic mutations. So inflammatory diseases with cytopenias, elderly onset males with high MCV should be when you should suspect Vexus syndrome. At the same time, what the NIH group, actually they sent us an email that if you have a patient suspected, we will help you in working up this patient. At the same time, we had one elderly male who had a lupus phenotype, had come with fever, was being worked up in Delhi, then came to us. And if you can see here, the MCVs was 107, 104, 109, and there were steroid responsive cytopenias, and there was ANA positivity, and there was hypocomplementemia. We thought, could this be Vexus syndrome? And then we sent this sample to David Beck at the NIH, and this was the first patient of Vexus syndrome diagnosed anytime, anywhere outside the NIH cohort. So we added to the phenotype described by the NIH, and now this has been further expanded. We now have around more than 15 patients of Vexus syndrome, some of them presenting with gout, some of them presenting with other manifestations, and even relapsing polychondritis. UBA, and our Kolkata group had seen spondyloarthropathy as a manifestation. I think Parashar had one patient wherein the ubiquitin gene mutation was positive. So the only thing is you should be knowing that these things are there, and the facilities to diagnose are readily available. If you think about a patient, you can send the sample to PGI. We'll be more than happy to get this workup done. Coming to medium vessel vasculitis, the most important is polyarteritis nodosa. This is one diagnosis you will never be able to make unless you are thinking about it. So none of the tests is going to be positive. The patient might present to you with fever, weight loss, hypertension, some renal insufficiency. They might have abdominal pain because of abdominal ischemia. There can be CNS and peripheral nervous system involvements. There can be monoitis multiplex, skin manifestations, and 10%, around 10% mortality. One thing which will, the ANAs, the ANCAs, the rheumatoid factors, all those tests are going to be negative. One investigation which can help you is CT angiogram, which can show you microaneurysms or which can show you organ infarcts like the renal infarct shown here, and even the splenic infarctions. And on top of that, there can be monoitis multiplex, and you can do a nerve biopsy to show vasculitis. So that's the only place where you can prove that there is a medium vessel vasculitis. So there is a monogenic variant of ADA2, which is called DADA2, where if you have medium vessel vasculitis, which is early onset, which is familial, which presents with stroke, cytopenias, and if there is extensive skin rash or there is a bone marrow failure, think about that deficiency of ADA2, or this is because of ADA2 gene mutation. And one thing very important for all of you to note is that this is reported in from the Agarwal or the Jain Bania community, because it's a monogenic disease and it's very common most of the places. We have patients from Northeast, we have patients from Kolkata also, besides patients from North India. So this was the first largest cohort from India, which we published in Arthritis and Dermatology with our help from our Harvard colleagues. What we showed the world was that this disease, previous to our description, it was thought to be disease of the childhood, but we had seen, this was our previous old paper, that this disease does occur well into the adulthood. And if you have somebody who presents with recurrent strokes and is from Agarwal Jain community, has a rash, think about DADA2. Because if you think about it, get the ADA2 gene mutation, start anti-TNFs, the strokes won't recur. So that's the importance of knowing that this entity exists. Now we have a much larger cohort that we presented at the Washington ACR meeting last year. The oldest patient that we've seen is 58 years of age. So don't think that this would be a disease of the childhood. And this number is only expanding. We have a family from Bardhaman. I mean, there are 6 patients from Bardhaman district who's following up with us. So they present generally with a skin rash. And I think Vishal Sharma sitting in the audience was my co-conspirator when we initially thought about, when we used to walk from home to PGI, and could the first patient that we diagnosed, could it be DADA2? Because at that time, the adult onset disease was not really known. But now it is history, and we see many patients well into adulthood. The dominant brunt is by the CNS, so the neurologist actually need to know. There can be constitutional symptoms, there can be very bad GI involvement, and actually which contributes to mortality in these patients. The diagnosis can be established either by doing ADA2 enzyme levels. The levels can be done at PGI. The levels are also done at various private hospitals now. Or you can do an ADA2 gene mutation, which is again available in the private labs and also available at various institutions. They can present with ischemic strokes. You can see here, you can see the vessel wall imaging on the MR angiogram. You can see the vessel narrowing. There can be subtle hemorrhages. This is a superior cerebral artery microaneurysm. There is a ophthalmic artery microaneurysm. This is a posterior reversible encephalopathy kind of a presentation. There can be organ infarcts. There can be peripheral vascular aneurysms, peripheral arterial narrowing, like even ulnar artery narrowing and a gangrene. And there can be focal nodular hyperplasia. So you keep these pictures in mind. There is a pancreatic microaneurysm. There are renal infarct. So if you see organ infarcts in somebody with multisystem disease, think about medium vessel vasculitis. And if they happen to be from the familial clustering or Agarwal Jain community, then think about DADA2. So we've seen this is exsanguinating GI bleed in one of our patients. These are all microaneurysms studied all over. So you can see microaneurysms in the intercostal vessels. You can see microaneurysms in the various branches of the abdominal aorta all over. And if they rupture, they cause hemoperitoneum. This is one of the patients who presented during COVID with a rupture there is a perforation at the antemesenteric border. We've seen diffuse alveolar hemorrhage. If you do various biopsies, you can see both vasculitis and vasculopathy. So if you get a vasculopathy on a biopsy, it doesn't really exclude vasculitis. So we've seen vasculitis in skin, in colon, and this is our own data. Not only the strokes, which was the NIH cohort outcome, but most of the other manifestations that we've shown also improve when you expose these patients to anti-TNFs. So the major contributors to mortality are strokes and a very bad GI involvement. Actually, a GI involvement is much more sinister. They can have mesenteric ischemia, they can have gut infarction. So these are contributors to mortality. The other important subgroup is small vessel vasculitis. And so this is what actually Arup would have, the skin, the nerves, and the lung. So if these 3 clusters are there, then you must always think about ANCA vasculitis. So the 3 types are GPA, or which was previously known as vaginous granulomatosis, or EGPA, which was previously known as Churg-Strauss syndrome, or MPA. So in GPA, there is nasal crusting, nasal bleed, nasal obstruction. These sinus symptoms are not there in microscopic cholangitis. In EGPA, there is history of asthma and there is eosinophilia, which is there in the name itself. So there can be ANCA positivity in up to 90% of the patients with GPA and MPA and almost half of the patients of EGPA. So sinus disease in EGPA can be just, beside asthma, can be some allergic rhinitis. And there is a granuloma on histopathology in both GPA and EGPA. So these patients can present with episcleritis. They can present with very bad globe-threatening scleritis. They can present with proptosis. These patients can have very large abscess ulcerations. So these are the ulcers these abscess ulcers are not garden variety of abscess ulcers. This is as if a pound of flesh has been taken away. So if a systemic disease patient presents with some gums which look like strawberry, then think about GPA. If there is a collapse of the nasal bridge, or if there's a nasal septal perforation, or if there is a recurrent sinusitis with an inner multisystem disease, or if there are cavitating nodules, large cavitating nodules, or even century, there's a air bronchogram kind of, this is also GPA. All air bronchograms are not pneumonias. So air bronchogram could just be GPA also. Or there are angiocentric nodules, there can be diffuse alveolar hemorrhage. This was a patient who presented to the gynae labor room in third trimester, late stage of labor, had these cannonball opacities. But these cannonball opacities was because of GPA. And these three of our patients presented in the labor room in labor, but had GPA simultaneously. So this is the image which is published in the Lancet. You can have pseudotumor kind of presentation, proptosis. You can have pachymeningitis with cranial neuropathies. So this is also, you can see the meningeal enhancement. So this is a pachymeningeal involvement. You can have very skin manifestations like skin nodules, cutaneous infarctions. Again, a hole was formed here at the canthus, around near the canthus. There is a pyoderma gangrenosum and a red eye in somebody who was labeled as rheumatoid arthritis, but eventually turned out to be GPA. There can be hemorrhagic blisters. There can be large pyoderma gangrenosum kind of lesions. So if you think about it, we are talking about our own guidelines. So these are evidence-based, economically consideration given guidelines published in a journal which has around 10 impact factor, autoimmunity reviews. These are Indian Rheumatology Association guidelines for management of ANCA vasculitis. These take into consideration the economic considerations also. So it's time that we should develop. We have the president of API sitting here, and I think he started a very good venture of crosstalk between various societies. So I think we need to move forward and develop our own evidence-based guidelines and publish in top-of-the-line journals so that there is an international recognition that whatever we're doing is as per the best in science. So these are the summary of recommendations. The other small vessel vasculitis is what is now known as IgA vasculitis, what was previously known as Hinox-Schönlein purpura. This was again thought to be disease of the childhood with ankle arthritis, purpura, and abdominal pain, but the adults can also have it. And once the adults have it, they have it very bad. So these are patients who presented with severe mesenteric involvement, and they can also have very bad renal involvement at times. If they have, then you should treat aggressively. Variable vessel vasculitis, that one we must know is Behçet's disease. They present with oral ulcerations and genital ulcerations and very bad eye involvement. They can have panuveitis, they can have anterior hypopyon, they can have vitritis. This is posterior hypopyon. Again, we have people from Kolkata, our student from Kolkata, I asked him to collect our arterial, the patients with arterial involvement in Behçet's. We have seen at PGI the aortic aneurysms. We have seen a femoral artery aneurysm. We have seen drossalis pedis artery aneurysm with Behçet's disease and published. These are percutaneous interventions, surgical interventions in these patients. They do occur very well, and we just need to consider about these because if you don't treat, the mortality is very high in these patients. There can be single organ vasculitis. So this is isolated granulomatous GI vasculitis. I don't know whether Vishal is sitting here. This was initially labeled as inflammatory bowel disease. But all that this patient had was isolated granulomatous GI vasculitis and not really inflammatory bowel disease. You can have primary angiitis of the CNS, which can be diagnosed either on the angiogram with beaded appearance or a brain biopsy from the non-dominant temporal lobe. There can be vasculitis is associated with various diseases. Pradeep did talk about lupus, and I'm happy that he said that everybody now diagnoses lupus in big numbers. We had one paper presented of 60 patients of SLE, how to differentiate infection versus disease activity. That's very good. There is increasing awareness about rheumatological diseases. It's very heartening for somebody from rheumatology fraternity to know all these rheumatological diseases can be associated with vasculitis. So we had an MLA from Haryana who presented with blindness. But this blindness, because the patient had one record of high blood pressure, was initially thought to be malignant hypertension. But this was not actually malignant hypertension, but this was sarcoidosis presenting with optic granulomas, inflammatory disc edema, and this is what they call as macular star. You see this around the macula, and we treated it. The patient had complete restoration of vision. So this was sarcoidosis presenting with optic disc edema as a cause and not a malignant hypertension in a diabetic and a hypertensive. So every swollen disc with hemorrhage in a diabetic and hypertensive is not malignant hypertension. You can have very different treatable causes of disc edema even in those patients. This is a disease which is again where me and my NIH collaborators have been working on. This is relapsing polychondritis, which presents with red ears and the nose tenderness, but the sinister thing is aortic inflammation. So these are all root of aorta involvement, main bronchi, and the airway involvement. And work that we've done and published in Rheumatology Oxford made its way through to the uptodate.com, because previously we were looking at echocardiographic aortic regurgitation, but that aortic regurgitation we have to prevent. And the only way you can pick up is by doing the PET scan. When you see the aortic root which is involved, thickened, and increased uptake on the PET. So once we've treated our own patients, and one of our residents had it, and we could prevent development of aortic regurgitation over a period of time. So Hep B associated polyarteritis nodosa, again, Pradeep talked about it this morning. This is an immune complex mediated disease, can cause microaneurysms and cause ischemia. HCV associated cryoglobulinemia vasculitis, generally mild, presents only with some skin rash and neuropathy, but at times can present with life-threatening manifestations like GI vasculitis, and that is when you need to either do plex or maybe give rituximab to those patients, even in the presence of HCV, to salvage those patients. Towards the end, these diseases don't really read the books. At times, they might present with presentations which are almost unheard of. That is also what we published. This patient's presenting with tumor-like mass in the thigh. This patient was coming from Bombay with a label of rheumatoid arthritis and some nasal crusting. But all that she had was a thigh tumor-like mass. And then we had a prostatic obstruction and obstructive uropathy and advanced renal failure, a biopsy showing a granuloma. We had a very bad GI involvement. So, ladies and gentlemen, I'll wish to conclude by saying that the most important consideration while making a diagnosis, it actually you think about. I've shown you enough real life example that we've ourselves seen. If you see any of these combinations, or a skin or lung and nerve, keep vasculitis in your differential diagnosis. Vasculitic syndromes can have various diverse manifestations and way beyond what the time permitted me to show you. There can be even more diverse than what I've shared with you, and pattern recognition still holds the key. Although I've talked about Vexus syndrome, that should also consider in your consideration. And this is the second textbook of vasculitis. I'll be happy to present a book to any of the teaching institutions free of cost, to the any medical institutions. They can refer to this. This is a 50-chapter book on systemic vasculitis. This is the second edition. The first was reasonably well received. Thank you very much for your patient hearing. This is my institute, PJ Chandigarh. I'll be happy to answer any questions.
Sir, as is very nice and very illuminating, and a complete coverage on the topic of vasculitis. So, like the audience also, we have to know that DADA 2 is very important, and we got to think in the vasculitis. You usually do not think of DADA 2, and especially in the people, what we have learned that people coming, young people with stroke, and it should be the one of the DD is the DADA 2.
Yes.
So I have a question, but before that, I like to go to the house for take a 1 or 2 questions, sir.
Sure.
Or any comment?
Many often we find patients in the ICU presenting with fever, shock, and multi-organ dysfunction or failure. So how do you come to know in the bedside whether it is an infection-mediated
Excellent
sepsis
question.
or immune-mediated vasculitis? How do you define it?
Excellent question. When you have multi-system presentation and we label as sepsis, so if there is, so the common scenario can be what probably Arup gave me. So if there is a renal dysfunction, if there is a lung shadow, and the patient is in the ICU with a respiratory failure, so you will never get a thrombocytosis and leukocytosis in somebody with sepsis. What sepsis generally does is thrombocytopenia, leukopenia. If you have leukopenia and thrombocytopenia, it is not going to be vasculitis. Unless it is infection associated vasculitis or a lupus associated vasculitis or a malignancy associated vasculitis. So one clue can be if you have leukopenia and thrombocytopenia, then think about infection. The second thing is coagulopathy. Generally, you don't have coagulopathy in patients with vasculitis. So if you have coagulopathy and thrombocytopenia, you're definitely looking at infection. But if you do not have any of those, your cultures are all sterile, your procal is normal, you have a rash, you have any of the symptoms that I've talked about, you have a lung shadow which looked like an air bronchogram, but the kidney, the urine analysis is showing active sediments, and when you look for dysmorphic RBCs, they are there, you think about a glomerular pathology, then you must think of ANCA vasculitis and not sepsis. Many times if these are we have to bring on physician's hat and think about alternatives also. But one thing which helps you in small nutshell is if there is no coagulopathy, no thrombocytopenia, it is, and the cultures are sterile, it may not be infection. Think about the alternative diagnosis. And on top of that, if you ask history of nasal crusting in the past, nasal bleed in the past, the kind of abscess ulcer that I showed you, if a pound of flesh has been taken away and there is a large deep bore ulcer in the oral cavity, you should ask a question, could it be vasculitis? Send a PR3. By the evening, you will have a PR3 report. And on top of that, if you have the other clue, many times what I have seen is if there is a neuropathy, which of the infections, barring leprosy and all that, we generally don't lead patients into the ICU, would cause a monoitis multiplex. If you have a monoitis multiplex in a multi-organ involvement, it's highly unlikely to be because of infection and sepsis.
Well, sir, like one common queries. One of the criteria in the DADA, you said the macrocytosis, macrocytic picture.
That's for
megaloblastic.
That's for Vexus. Vexus syndrome.
Vexus
Not for DADA 2.
Okay.
For Vexus, elderly onset patients with any, you're thinking about an inflammatory disease,
right.
Like there is leukocytosis, there is, high ESR, there is high CRP, and the patient is elderly. Think about giant cell arteritis, and then there is thrombocytopenia or leukopenia sets in, and then you have MCV, which is persistently more than 100. So because then just send a ubiquitin gene mutation, you will be in for a surprise that this could be a Vexus syndrome. And if you do a biopsy in those patients, many of them will have an MDS profile. But the MDS panel, which the hematologists do, is non-contributory. And then you ask your hematologist to look at the marrow more critically, they will see that the vacuoles are there in both myeloid and the erythroid precursors. Even in our patient, which we diagnosed around the time when Vexus was described in the NEJM, initially the vacuoles were missed actually. And all patients may not have vacuoles also.
Thank you.
Thank you so much, sir, for the excellent deliberation. So if we don't have any more questions from the house, we can conclude this session.
Thank you very much.
Thank you, sir, for that highly valuable and clinically relevant presentation. I would like to request our chairpersons and speakers, sir, to kindly step towards the felicitation area.
So it is high time that we break for our math series lunch. Yes, there is a round of applause, of course, for the lunch, I think. Listen, wait, please. There are two menus for the lunch. There's, of course, the same menu will be served. For the convenience of the delegates, you can go downstairs in the restaurant in this very building near the reception counter. Just your nose touches the reception counter when you descend downstairs. So there and in the left side, if you turn left side in the field also, the lunch is being arranged. So we will assemble here sharp at 2 for the afternoon session. And that afternoon session, I would like to request the speakers and the chairpersons to get ready. The first speaker will be Dr. Pranjal Kumar Dotto. I think he is here very much, and Dr. Triveni Sharma. So after this academic phase, of course, it is the time for the stomach. Thank you.
জীবন খোঁজো এন্ধার হবনো আরো মুসি জীবন খোঁজো পাখি মেলা অতীত চিরালো মনে হাতে রে ঝুঁকিনু বাজনরেস পাখি লিখো ফোনে কাগজ সিলে জীবন সংবাদ সত্যি আকা খলিলি বাটে সেই মন আজি যেন লিজ হোনা তৃষা কিদরে পামরুম and heart তোমার মুসি জীবন খোঁজো পাখি মেলা কি দরে পাবো পাগল চোখ কিরণ না জানি যদিও সুবাহু আছো বেবি সঁচা বিচাৰ সমাজত সাঁতোৰ যদি খেদি খেদি সপোনে মিঠা চুমা যাছে এই মন আজি যেন পোহৰ প্ৰাণ পোৱা তৃষা কিদৰে এন্ধাৰ হ'ব নোৱাৰো মুচি দিবনো খোজো এন্ধাৰ হ'ব নোৱাৰো মুচি দিবনো খোজো পাখি মেলা উদিত কিদৰে পাহৰো এন্ধাৰ এন্ধাৰ এন্ধাৰ
Welcome back, ladies and gentlemen. We shall now resume the scientific proceedings as per the scheduled program. Let me take this opportunity to introduce the chairpersons for this next session. Dr. Prince Bey, Dr. Rajani Kantadeka, Dr. Bablu Banik, and Dr. Norima Kalita. I request respective faculties to kindly chair the proceedings. Our speaker for this session is Dr. Pranjal Kumar Datta. Sir will be speaking on the topic Advances in the Management of Resistant Hypertension. We warmly welcome you to begin the session, sir.
মোৰটো আছে না ইয়াৰ পিছত ষ্টিফেন শৰ্মা হ'ব মই আগতে
Good afternoon, respected chairpersons, the distinguished faculties of API, the delegates present here, and my students friends. It is really very difficult to say something in immediate post-lunch session. It is difficult for me as a speaker and also for the audience like you. but I'll try my best to give and try my best to awake you. And I thank the team Nagaon to give me the opportunity to say something in front of you. This topic is very important. That is the resistant hypertension. And this resistant hypertension, that too the recent advances in the management. And we are getting lot of cases. We know hypertension since our childhood. And now, obviously, we know it in a very scientific way. And we also know this is the leading cause of cardiac involvement, both in mortality and morbidity. And it is the predominant driver of cardiac diseases. If you see this slide, the lot of types of hypertension, from white coat hypertension, marks hypertension to the resistant hypertension. Obviously, the patient with resistant hypertension are particularly for the high risks of cardiovascular complications. Many confuse with the resistant hypertension with the uncontrolled hypertensions, but the resistant hypertension has the definite criteria, that is the BP should be maintained with maximum 3 or more drugs, and one drug should be diuretics. Remember, one drug should be diuretics, and it is we have to fulfill, and there is many pathological mechanisms for development of resistant hypertension. But most important, if you see in this slide, is increased sympathetic outflow is the fundamental in abnormality in most of the cases. That's why we have to think and we have to use 3 drugs regimes, and these regimes based on the fact that these drugs agent on the different putative mechanisms in management of resistant hypertension. So in brief, what do we mean by resistant hypertension? We all know that's just a recapitulation. And in a compliant patient, compliance means patient is on lifestyle modifications, good diet controls, following our common doctor's advice, with good lifestyle, optimal lifestyle changes, with 3 optimal drugs with optimal doses. Even then, if the BP is not controlled, that is called resistant hypertension. Obviously, there are many other causes. If you see, only with this criteria it's not fulfilled. There are many other causes. Maybe defect in the measurement, maybe problem in the cuff, maybe there is secondary hypertension in the pipeline. Definitely, we have to exclude each and everything by extensive investigation. And also, we have to think about the other risk factors like older age, male, person with chronic hypertension, alcohol abuse. These are the other factors we have to see. Now come to the proper. In short, the management of resistant hypertension is based on 3 principles. Number 1, the lifestyle modification. Number 2, the medical therapy. And obviously, the number 3 is interventional strategies, which is coming in a very big way nowadays. This is the algorithm. If you see, first and foremost thing, as I already mentioned, we have to prove that this particular patient has resistant hypertension. By this step 1, that is, we have to exclude the other causes of hypertension, including secondary. We have to ensure that patient is following proper lifestyle guidelines, diet management, and this patient is on optimum 3 drugs regime is optimum dose, which has no side effects. The side effect we have to consider, I mean to say the drug side effects. So we have to observe this for 6 months, 3 to 6 months. Even then, if the BP is not controlled, we have to go for the second step. That is, the substitute the optimal dose thiazide like diuretics in the form of chlorothalidone or indapamide. And if we have to wait for 4 to 6 weeks again. And if the BP is not controlled, we have to go to the step 3. That is mineralocorticoid receptor antagonist in the form of spironolactone or aplerenone. Even then, the BP is not controlled. Then we have to go for step 4, 5, and 6. These 4, 5, and 6 are very individualized. It depends on patient to patient. Is very personalized, and we have to see for the pulse rate. If it is more than 70, then we can eat beta blockers or alpha beta blockers or the alpha agonists accordingly, according to the patient need and according to the patient other comorbid conditions. If the patient BP is not still controlled, then what we have to do, we can add hydralazine. We can build up the dose from the lower dose to the maximum dose. And we, even a cardiac compromised patient, definitely we have to take care of the cardiac part also. If the BP is still not controlled, then definitely we have to substitute this hydrolyzine with mixocidil, that is 2.5 milligram. We have uptitrated the dose accordingly. And even then, if the BP is not controlled, we can put that particular patient on the experimental studies, or we need some research work on that particular patient. This is the standard guideline still date in the management of resistant hypertension. I'm talking about the diuretics because diuretics in the form is that it is already proved by different journals, including JAMA in 2014, that the diuretic use is associated with improved blood pressure control. It is also proved that chlorothalidone has a cardiac benefit, so we have to consider chlorothalidone as an important first-line treatment. Mineralocorticoid receptor antagonist, again, it is showed that the pathway 2 study and also Spiran EX3 study clearly proved that mineralocorticoid receptor antagonist in the form of spironolactone is really helpful. But definitely we have to look at the potassium level of that particular patient. We can consider amiloride because in particular, because we know the side effect of spironolactone, including the breast tenderness. In that particular case, we can consider amiloride as an alternative to the spironolactone. Arterial vasodilators, obviously, is a medical therapy nowadays if the patient is not responding to the initial management. Minoxidil, Durasantan, this is the new drugs, obviously. It is not available in each and every country, but we can consider these drugs also. So if we formulate the principles, these are 6 important principles. First is that we have to drugs of different classes, of different mode of actions. Long duration action drugs should be preferred, not the short duration action. We have to titrate the drugs to the maximum level. But remember one thing, the side effect we have to see, that means a patient tolerable maximum doses. Diuretics is mandatory in the drug combinations. Once patient's compliance is good and patients can be controlled with this medication, then we can consider for combined pills. Combined pills will be helpful, particularly the patient like India, the compliance is always good. Always we should remember aldosterone receptor agonists, antagonists, beta blockers should be used if it is not contraindicated. One thing we should know, drug adherence is a major factor in management of hypertension. Many patients used to stop medicines, so we have to take care of this. There's a 2 methods. One is the indirect, one is the direct. Direct is the obviously gold standard. You have to observe, just like directly observed therapy in a patient with treatment of pulmonary tuberculosis. Different guidelines, if you see the recent guidelines. So 2023 European Society of Hypertension guidelines, it is clearly mentioned what I have mentioned already. Also, it is mentioned and clearly, and I am showing this in the brief way in the chart. So these 3 drugs, it is divided into CKD stage 1 and 2, 3, and another group CKD 4 to 5. 4 and 5. So in stage 1 to 3, we can add spironolactone, beta blocker or alpha 1 blockers, or centrally acting agents. In other group, definitely in stage 4, 5, we can consider chlorothalidone instead of spironolactone, and others remain same. These European guidelines, both Association of Hypertension and the Society, recommended renal denervations as an important modalities of treatment in a patient who failed to medical therapy. So the same thing, the European Society of Cardiology guideline in 2024. Interestingly, the American Society of Cardiology guidelines or heart association guidelines, they are stick to the same management, though the criteria for diagnosis of hypertension is a bit different between these two, but the diagnosis treatment part is remain same. So they both recommended that renal innervation is an important guidelines in management of resistant hypertension, those who are not responding to medical therapy. So these are emerging therapy. This is called device-based therapies. So device-based therapies obviously recommended by maximum all guidelines, particularly renal sympathetic denervation. Baroreceptor activation therapies also recommended by many. So these are proof by the different studies that this is really beneficial, and the blood pressure reduction is 5 to 10% in management of blood pressure control. The baroreceptor activation therapy again is not recommended by each and every country, but it's available in Europe. USA is under research. Definitely will come within the years or two about these indications in this. Digital advancements is again, you see nowadays the era of digitalization. So the different modalities, the ambulatory blood pressure monitoring is very, very important nowadays in management of blood pressure, both in diagnosis and management. I want to stress the digital parameters is also well. Digital watch is also helpful. AI is coming in a very big way. AI always help us in managing the patient with resistant hypertension. The fews are in the pipeline. These are the drugs which are fews in the line like endothelin 1 receptors. So these drugs are really helpful as per trial of precision trial. And another drug is aprocitentan. Then this is also useful, particularly in CKD patient. Anup Burman sir is here. He knows this drugs is coming in a very big way, and they prove that in stage 3 and stage 4 hypertension, this is really effective. Prevustat is another new drugs. This uses the generation of angiotensin 3 in the brain. So it is in the research work. Obviously, we'll get the information in near future. So let me conclude. We have to follow the rule of 7 in management of resistant hypertension. We should not say the patient to be a case of resistant hypertension unless we exclude the other causes of hypertension, including secondary hypertension. Our measurement should be perfect. Ambulatory blood pressure monitoring is mandatory. Those patient is only hypertension, but this is not required in patient with target organ involvement. Rule of secondary causes, that is, we have to rule it out. Triple trap therapy we should remember, including diuretics. Spironolactone we can consider the fourth line of treatment. We can add beta blocker or alpha blocker according to the patient's priority, according to the patient's state and comorbidities. Definitely, the device-based therapy is coming in a very big way. Many institutions in this country has these facilities available, and digitalization obviously is the pivotal, maybe in near future, in management of resistant hypertension. Thank you so much. Long live API, long live API Assam.
Thank you very much, Dr. Dotto. You have nicely covered the modern aspects of treatment of resistant hypertension. Yes, indeed, it is very difficult to treat this resistant hypertension. It is very stubborn. Now, the subject is open for discussion.
Since you have told about the new version and newer drugs, probably one of the upcoming single in RNA interference therapy, and that is the gelabisiran and injection, which actually prevents the generations of your angiotensin and in the liver, and it has to be given one injection per 6 monthly.
Definitely, Nitada. That is actually there is another few drugs in the pipelines. Because of the time constant, I have reduced this. But these drugs are already recommended in few countries. Not maybe not be available in India, but these are on use in some European countries. That's why I highlighted this particular medicine. But that medicine is really, and maybe is a very good drugs in your future.
Pranjal, nice talk. Does nocturnal dipping occurs in patients with resistant hypertension?
Yeah.
If so, is there any increased risk of stroke in these dippers? I don't have much of an idea because in normal hypertension, you have dippers, and it has been seen that with dipping also, there is increased chance of stroke. Is there any dipping in resistant hypertension?
Yeah, actually, that's why it is clearly mentioned that ambulatory blood pressure monitoring is very, very important to know the status of the blood pressure. Many time And that's why, and different guidelines. If you see the American Cardiology Society or European, they have the different and they have the categorized accordingly. And the range of the blood pressure is different in the two conditions, in the daytime and also the nighttime. And for that reasons, the ambulatory blood pressure monitoring is those who have the target organ involvement is different, but those who have no target organ damage, we have to see and monitor. And in that way, we can prevent that, particularly the unwanted risks like stroke or unwanted events in the brain. That's why, and the criteria is a bit that BP level is a bit lower in the night time if you see the that chart in the guidelines. But I have not covered this because of this, sir.
If you want to add a spironolactone,
Yeah.
then when will you add? Morning or night or evening?
No, no. Spironolactone, you see, few drugs like alpha blockers we have to give in this particular night because of the dizziness or other drug side effects, postural hypertension. But spironolactone definitely we can give in the morning time. But only thing is that the spironolactone, if you go on increasing the dose, it rather invite the toxicities than the benefit because the cardiac blood pressure lowering efficacy of the spironolactone is to some extent. That's why it is level as a fourth line, and it is not force or stress that we should go on increasing the dose of spironolactone to the maximum level in case of hypertension management, particularly resistant hypertension. But obviously, it is in the morning time.
Thank you, Franjala, for your excellent and lucid presentation. Just, it is not a question or this one, just a suggestion and a comment on your presentation. Even most of the cases of resistant hypertension are because of chronic kidney disease. Across the whole age group, if you see the causes of resistant hypertension, only number one is your chronic kidney disease. So in that case, sometimes you can do creation of heavy fistula in the large arteries. That can also sometimes in an interventional part that can reduce the BP because it reduces the systemic resistance. Peripheral vascular resistance will be reduced by creating a large vessels heavy fistula, arteriovenous fistula. That is one. And sometimes even you can do in the where the cause of your hypertension is because of ischemic renal disease, then you can go for auto renal transplantation is also another option. This is not done here, but in Western countries in developed it is also going on.
Definitely. Thank you for your suggestion. But resistant hypertension, one thing we should be very clear during the investigation period in the approach, we have to exclude the secondary causes of hypertension. By excluding other causes, definitely that other according treatment that is I already mentioned step 4 to step 6 is individualized. It depends on the patient's condition and the other comorbidities. Yeah, Amalla. Yeah. Yeah.
Then you suggest that the fourth drug will be a spironolactone.
Yes.
So there will be two diuretics as such.
Yes.
Thank.
Yeah.
Time once in this group of patient, you use CCB that develops pediledema.
Yes.
If you use diuretic, it leads to hyponatremia. If you use ACE inhibitor, it leads to hyperkalemia. Many patients. So that time becomes
very difficult. That's why this from step 4, step 3 up to that level is fine. Step 4, from that point of reading spinal electron and etc., the complication of the disease and also complication of the treatment go side by side. Very difficult to balance this.
And
really challenging.
Many a time in this group of patient, maybe the renal artery stenosis because of atherosclerosis or fibromuscular dysplasia is one, and OSC is one of the important factor probably.
OSC, yes, I have mentioned these things. Very important and very upcoming also.
As time is over, I have one comment on that issue. Nicely mentioned about the management.
Yeah.
Still gold standard is a ESS 2023 is a still gold standard.
Still gold
Even in ACA 2025 stick to the same
same.
But as a Pradeep rightly mentioned about the CKD group of patients are a major chunk of resistant type of hypertension. And most of the time, we ignore that part that many of our patients are getting erythropoietins, right? So I think this is a slow withdrawal of the erythropoietin will be justified in such patients in a resistant type of hypertension. And then only he will go for another is a renovascular hypertension. It is a secondary hypertension. Then of course he can go for a nephrectomy, then an autologous transplantation. That these are the some. And in case of a renal transplant recipient, even if they are also hypertensive, resistant type of hypertensive, then of course sometimes we may have to go for a native nephrectomy. So these are some of the points to be noted in case of a chronic kidney disease populations.
Thank you, sir.
Conclude.
Yes, Manada.
Hello. Thank you very much for your lucid presentation, Pranjal. There is one genuine study in top spins trial.
Yeah.
Sponsored by this chronic disease control center from UK. In that, this trial, there are three different groups: indapamide, then amlodipine, then indapamide, then perindopril, and indapamide, then amlodipine. Okay, so that they have given maximum importance to this indapamide. That is a very important diuretic. So regarding indapamide, you did not mention anything. So what do you say, this indapamide as a diuretic?
Yeah, actually, that top spin trial, this is particularly the India and the Southeast India. India is one, and interestingly, the one center out of 36 centers, Assam Medical College and Hospital is also one. They have, because of less number of cases and the supply of medicine, they discontinued, most probably, the recent update. And that study is not for the resistant hypertension. This is for that patient, and they compared the three group of patients, indapamide, amlodipine, then AC inhibitors, and they had a fixed dose regimes of the three drugs, and they follow up the patients every 3 months, 3 months, 6 months, and a 9 month, and they want to see the result. And there, this is not include the resistant hypertension as a whole hypertension of this particular belt, Southeast Asia.
Understand, but this is not about, I'm not telling about resistant hypertension, but people starting any medication as a diuretic, and instead of this other diuretic, can we go for this indapamide?
That is lot of confusion regarding the aid of the medicines. That's why in some centers discontinued and away from the trial, because indapamide or other drugs are not that common, and they are not as available in this government institution, including the government colleges like us.
As we are running short of time, I conclude this session.
Thank you, sir, for your insightful presentation. I'd like to request our chairpersons and speakers, sir, to kindly move towards the felicitation area. Moving forward to our next session, it gives me great pleasure to introduce the chairpersons for this session, Dr. N.N. Deka, Dr. Satyabrata Guhai Borua, Dr. Karan Dole, and Dr. Pranab Borua. I request you to kindly grace the dais. The chairpersons for the next session, Dr. N.N. Deka, Dr. Satyabrata Guhai Borua, Dr. Karan Dole, and Dr. Pranab Borua. Kindly grace the dais. I'm also delighted to introduce our speaker, Dr. Triveni Sharma, who will speak on the topic corticosteroids in TB, when, why, and how. We kindly invite ma'am to begin the talk.
Good afternoon, respected chairperson, my teachers, my colleagues, friends. So today, thank you API Guwahati for giving me this opportunity to speak. So the topic today is corticosteroids in tuberculosis, when, why, and how. And I have here very senior teachers and stalwarts of medicine and everyone out here, I know you all have an enormous experience in tuberculosis and using steroids there. So I'll try to finish my talk as early as possible so that you all can share your experiences. So the objectives will be understanding the rationale behind the corticosteroid use in tuberculosis, identify the specific indications, learning timing, doses, and duration, evaluate the evidence and risk, and summarize the WHO international recommendations. So India carries 27% of global tuberculosis burden. And as we all know, like the Mycobacterium tuberculosis, it causes the granuloma formation, and there lies the cytokine storm, which results in necrosis, fibrosis, and tissue edema. And that is why corticosteroids, by suppressing the immune overactivation, reducing the inflammation, and improves the recovery. So this is where corticosteroids can be helpful in tuberculosis. But the main point is corticosteroids cannot be a treatment for tuberculosis. For tuberculosis, we have the antitubercular therapy. It can be only an adjunctive therapy together simultaneously with antitubercular medication. And we have the glucocorticoids. They are the synthetic analogs of cortisol, like dexamethasone and prednisolone. So when do we use corticosteroids? So one is we have a very strong evidence, WHO recommendation, strong evidence for CNS tuberculosis, like tubercular meningitis. And then we have a conditional evidence, that is tubercular pericarditis, tuberculosis associated iris in HIV, and then a very limited evidence with severe pulmonary tuberculosis with ARDS or miliary tuberculosis with respiratory failure. Tuberculosis involving the pleura, again, a very limited and decision on the clinician because we do not have any WHO or international recommendation for use in tuberculosis involving the pleura. And adrenal insufficiency due to tuberculosis, here corticosteroids is not the adjunctive treatment, it is the replacement therapy. It is a replacement therapy in adrenal tuberculosis. And another one, we have the abdominal tuberculosis, and we'll come to subsequent slides where we can use corticosteroids there. So tubercular meningitis or CNS tuberculosis. So here, what does tuberculosis? As we all know, it reduces the meningeal irritation, inflammation, reduces intracranial pressure and vasculitis, and prevents obstructive hydrocephalus. And that is how it decreases the long-term neurological deficits. And that is the rationale behind using corticosteroids. And it is strongly recommended, and we use it simultaneously. And the dosing is usually with dexamethasone. We start it with 4.4 milligram per kg per day, and then we gradually taper it off within 6 to 8 weeks. Even ICMR recommends tapering off within 6 to 8 weeks. And then we have the tuberculous pericarditis. Here also we have conditional evidence because, as we all know, the inflammation in the pericardium, it will ultimately cause adhesion and constrictive pericarditis. So this inflammatory part we can stop with the corticosteroids to prevent the constrictive pericarditis. Again, we can use prednisolone here for 4 weeks, and again the same, taper within 6 to 8 weeks. So here we come to tuberculosis involving the pleural tuberculosis. Initially, when we were students, we used to see our teachers regularly using corticosteroids in pleural effusions, and the outcome was also not bad. And then the pleural effusion it decreases fast. However, corticosteroids do not prevent pleural thickening. So here, like, there is no international recommendation for using corticosteroids in pleural effusion due to tuberculosis. Whether it is the effusion is due to a hypersensitive reaction of the tuberculin protein, or it is because of the bacilli itself. But still, the recommendation is not there. And here, senior physicians and all of you all are treating tuberculosis right, left, and center. And maybe you all will have, a lot of experience of treating pleural tuberculosis, pleural effusion. So you all can comment later. And then this is another recommendation here. Yes, it is recommended in tuberculosis with iris in HIV. It is to control the exaggerated immune reaction alter after the ART initiation, and prednisolone 1.5 milligram per kg per day oral for 2 weeks, followed by 0.75 milligram per kg for 2 weeks or equivalent doses. And tuberculosis with airway obstruction. Now, here again, it is not recommended, but physicians are using it when there is endobronchial tuberculosis. It reduces, if there is obstruction, if there is symptoms of obstruction, to reduce the edema and to improve airflow. So, in certain instances, yes, in endobronchial tuberculosis or excessive airway inflammation, leading to signs of obstruction, a very short course of inhalation corticosteroids can be given. In ARDS or diffuse miliary spread, corticosteroids improve oxygenation and survival. Yes, and there is very limited data, but there are literatures and studies where it has been used with ARDS to improve corticosteroids in miliary tuberculosis. Now, this is again very, very controversial. Tuberculosis associated with massive hemoptysis. I have never used steroids there. I have also not seen people using steroids, but I have gone through literatures and certain studies where they have said that corticosteroids in massive hemoptysis with tuberculosis, they have treated and they have found results. Because this is controversial, because we all know that the hemoptysis is due to vascular erosion or Rasmussen's aneurysm or bronchiectasis. So there is no rationale behind using corticosteroids, but I've just mentioned this because it is, I think, open for discussion. And then, as we have said, that the miliary tuberculosis and tubercular iris, it is used. Now, coming to steroids in abdominal tuberculosis. So I had discussed this with gastroenterologists. They said no, corticosteroids, no use. But then it is not routinely used. But if the inflammation of the bowel, if it causes obstruction, if there are symptoms of obstruction due to bowel inflammation, or peritoneal tuberculosis with ascites with peritoneal inflammation, or mesenteric or retroperitoneal lymph node inflammation, then their steroids, the rationale behind using corticosteroids in these cases is that steroids will reduce the edema of the bowel, inflammation, and it can delay surgical complications. However, one has to be very careful that if there is perforation of the bowel, the corticosteroids will cause a havoc. Like, it cannot be used. It will be very dangerous. So there are studies on all the use of steroids in abdominal tuberculosis. And then we come to adrenal tuberculosis. Here, yes, corticosteroids are a must, not only because as an adjunctive therapy, but it is due to a replacement therapy where we can use we have to use corticosteroids in adrenal tuberculosis. Hydrocortisone is used, and together with that, fludrocortisone are also used. So glucocorticoid replacement with hydrocortisone at a dose of 15 to 30 milligram per day in 2 to 3 divided doses, typically 10 milligram in the morning, 5 in the noon, and 5 to 10 in late afternoon, and mineralocorticoid replacement with fludrocortisone if hypotension or electrolyte imbalance is present. So there is justification of using corticosteroids in adrenal tuberculosis. And together, simultaneously, we have to continue antitubercular therapy. So that, and then side effects of steroids, I don't want to go here because we all are aware of the side effects of steroids when we have to be careful. with all these hyperglycemia and gastric ulcers. And then we should also, steroids should be tapered gradually, especially in adrenal insufficiency. So that ends my talk, and I leave a few minutes before completion, because I want the, respected teachers and seniors and all the physicians sitting here, you all can share some of your experiences where you have used corticosteroids. And very short course of corticosteroids we can use post bronchoscopy or post procedure, just to reduce the inflammation, that is inhalation corticosteroids. I think these are the indications or instances where we can use corticosteroids in tuberculosis. Thank you so much.
Thank you so much for your lucid presentation. Actually, I would like to invite your attention. Whenever we are treating a patient with antitubercular, there may be sometimes paradoxical reaction, which is actually tubercle bacilli we do not see, but new symptoms or former symptoms become aggravated. And when it involves a vital organ, in those cases, we can actually we have to use steroid. This is another indication, I think, paradoxical reaction.
Yes, sir.
Then it is over to my co-chairs.
So now this session is open for discussion. So we'll invite one or two questions from this distinguished guest.
I want to stress that only 4 conditions where we unconditionally used steroids, like your meningitis. One is meningitis. Second is pericarditis. Third is if there is adrenal insufficiency, you have to use it. And fourth is iris. These are the 4 conditions we have to use. Others, it depends on the condition, depends on at the risks, and if you risk benefit ratio you have to. Otherwise, these are the 4 conditions.
Absolutely. These are the 4 conditions where we have strong evidence, even by WHO and international recommendations. These are the 4 conditions. Absolutely correct, sir.
Thank you, madam, for very beautiful presentation covering all the area. I just wanted to know whether there is any indication of steroid in renal tuberculosis.
In
renal tuberculosis.
In renal tuberculosis. In renal tuberculosis, we have nephrologists here who will guide us better. But then there are, as I went through all the studies and literature, there are no indication for corticosteroids in renal tuberculosis.
So, if I'm not wrong, I searched earlier literature, and it has been said that the urethral strictures and other things are very common. So it is, I think, it's preferred to use steroid in patients.
Together with ETT?
Yes.
Thank you. Yes.
My teacher was there and another teacher were there. Whenever we got the pleural effusion patient, we give a ATT along with one triamcinolone injection is available at that time. 2 cc we used to put inside the pleural cavity.
Yes,
and interestingly, very nicely
the outcome was good.
Yeah, outcome was very nice.
Yes.
But I don't know now what is the present situation.
Now we are not. I don't think so. We are using it, and they have said that it will not prevent pleural thickening, but the effusion will decrease. But pleural thickening.
And what about the dose? I read in some edition of Harrison, it was written 20 milligram prednisolone, 15 milligram for 15 days, and 15 milligram 15 days. In a old Harrison, Davidson, yeah.
Davidson.
What was written?
Okay.
What about it? Your comment?
Like in the 21st edition of Harrison, this is not there anymore. In a latest edition of 24.
Just I want to give one comment, because you have focused the very point regarding massive hemoptysis.
Yes.
We will give the steroid because you tell that should be for open discussion, no?
Yes, sir.
So in massive hemoptysis, when there is organic granulomatous or any vasculitis, in that region we should give, otherwise there is no benefit.
In massive hemoptysis,
Massive hemoptysis, yes.
So,
in vasculitis. Second thing regarding tuber kidney, and endobronchial tuberculosis even. Sometimes we should use to prevent the bronchial stenosis because that is a permanent condition.
That is endobronchial
Yes,
tuberculosis?
yes, to prevent the stenosis. Otherwise, no.
Yes,
Third
endobronchial
point thing
tuberculosis
is that
sometimes.
in case of pre-revision, actually we don't use so much.
Actually,
but sometimes think
these
that
are
to
the conditions where we are using
not not commonly,
not commonly.
not till today one patient also by me, but sometimes to prevent second pura, sometimes we may use, but no value so much. Already what happens, it is happening. Third thing is that endobronchial tuberculosis you mentioned, no, that is also to prevent this one. Otherwise, no need of giving. And iris is always indications of it is there. Pericardial effusion also, if there is mild, moderate, no such indication. But to prevent constricted pericarditis, some people are advocated to give the. Regarding intestinal tuberculosis, also same thing. Otherwise, we should not give. That is the.
Yes, just to prevent like.
Just a thing. Thank you, Dr. Tobeni, for a beautiful presentation. But what I feel and what the bottom line is, thing is this bottom line is, whenever a vital tissue is involved in tuberculosis, be it brain, be it kidney, be it heart or pericardium, where scarring and inflammation is not warranted, where the scarring will do more harm than good. In those situations, apart from those four conditions that Sir has mentioned, the administration of corticosteroid along with ATT is very well justified, and this is very well given in the literature also.
But before doing this, always do the Sevina test. If it is negative, then you give.
Yes.
Otherwise, if Sevina is positive, if you give the steroid, then there is chance of again you should see the drug resistant tuberculosis. That is always important. It will be flare up. One important point, this one.
Yes.
Second thing, in case of adhesive arachnitis also, if there is spinal tuberculosis, to prevent this one also, sometimes we should use steroid to prevent adhesive arachnitis.
Madam, are you going to use steroids in a case of severe miliary tuberculosis with ARDS in the ICU?
Yes, like that I had shown it in my slide. So severe in miliary tuberculosis with ARDS, yes, steroids are being used, but they're in international recommendation. The doses of steroid, what to be used, it is like it is depends on the particular clinician because there are no recommendation or guidelines like in ARDS with tuberculosis, with severe tuberculosis or miliary tuberculosis. There are no specific guidelines about the dose, but then it has been mentioned in studies and literature, and even in the ICUs, it has been seen that we use steroids. We do use steroids, but the specific doses and duration, like there is no specific guidelines like how much to use and.
Thank you, madam. We close the session.
Thank you so much.
Thank you, ma'am, for your enriching, valuable talk. Please proceed to the felicitation area. Moving on, I'm delighted to introduce our chairpersons for this next session. Dr. Mitali Borua, Dr. Gayatri Pegu, and Dr. Vijay Debnath. I request respective faculties to kindly chair the proceedings. I would also like to extend a warm welcome to our esteemed panel moderator, Professor Dr. Anup Kumar Burman, DM Nephrology, Vice Chancellor, Srimanta Sankardev University of Health and Science. And I'd like to invite the panelists for this session, Dr. Pradeep Kumar Dole, Dr. Soeb Borfukon, Dr. T.A. Chaudhary, Dr. Niranjan Gogoi, and Dr. Bhayolina Bora. We warmly welcome you to take the stage.
Panelists on my left side. introduce করে আপনি করে দেন ফর্মালি ইন্টিগ্রেট করে দিন
Afternoon, good afternoon, everybody. It's my pleasure and honor to invite you for this session. We have got Dr. none other than Dr. Anup Burman sir to moderate the session. And then we have got a enriched panelist over here, Dr. Pradeep Kumar Dole. He's the HOD, Nephrology Department, Guwahati Medical College. Dr. Swajib Borfukar, he is the Professor of Nephrology, Assam Medical College. And Dr. T.A. Chaudhary, he is the Consultant Nephrologist of Dispur Hospital. Dr. Niranjan Gogoi, Associate Professor, Department of Nephrology, Jorhat Medical College, and Dr. Vailina Bora, Consultant Nephrologist in Dispur Hospital. I'd like to welcome all. We are going to have a very enriching talk with Dr. Burman sir as the moderator. I ask sir to start the session.
Thank you. Good afternoon to one and all present, my esteemed chairpersons, my panelists, my teacher, and colleague and students and friends. At the very outset, I must thank the API Assam chapter for giving a wonderful chance to us to talk about a very important disease. And they have given us a 40 minutes. Thank you that they have given enough time for us. So we'll try to do justice. On the left side, there are 5 panelists. All are very distinguished, all nephrologists in private as well as in public sectors. So without wasting time, I just started regarding the progression of a chronic kidney disease. First, let's see. Please, no. Shift. Okay. The diagnosis. I mean, how do you define the chronic kidney disease? We all know that it's a recap only. That it has changed now. That there are some markers. Based on the markers, we can diagnose the chronic kidney disease. So these are the markers you all know. We are not discuss details about how we diagnose the chronic kidney disease. Then this is a very frequently asked question that can the chronic kidney disease be repaired or can be repaired? Can it be cured? The answer is it cannot be cured. It cannot repair. It is not reversible disease. It involves a gradual permanent damage. There is a scarring of the cell and cell death, structural loss, and eventually there is a chronic kidney disease. So this is not a reversible disease. So having said that, we must know these are some natural progressions, right? There is a natural progression. Even without disease, there are after 40 years of that, there is a natural slow declining of our GFR. It starts after 40 years, and declining GFR is around 1 ml per minute per year. And there is an increased proteinuria is the first sign of natural progression. And the serum creatine gradually increase or creatine clearance gradually declining after 1 year of the proteinuria. And urine sediment is always unremarkable. So these are the very vital points while you're discussing about the progression of the chronic kidney disease. Now, it's a major public health issue as on date. Even India and the subcontinent also is even in Assam also is a very high prevalence. And kidney disease prevalence is increasing all over the globe, as you will know. And there is a consensus meeting. It was held by the American Society of Nephrology, European Renal Association, and International Society of Nephrology. And interestingly, Vivek Jha, he was a professor and head of Department of PGI Chandigarh. He was also one of the panelists on that meeting. And it was concluded that early detection is a key strategy to prevent the kidney disease. And its progression and related complications show that awareness of kidney disease in the population is low. And therefore, increasing knowledge and implementing sustainable solutions for early detection of kidney disease are the public health priorities. And economic and epidemiological data underscore why kidney disease should be placed in a global public health agenda. So with this, I just have tried to show you some of the causes of the chronic kidney disease. As you all know, the diabetes is a major etiological factor than hypertension and some other glomerular disease. Now, look at the global prevalence of the disease. CKD affect almost 10% of the general population over the globe, and sometimes is ranging from the 8 to 16%. And prevalence is little bit higher in women, but is more or less same. And geographical disparities in low and middle income countries bear a significant proportion of chronic kidney disease burden, and higher is standardized prevalence in this region compared to high income countries. And risk factors are all the diabetes, hypertension, and other etiological factors. Now, in India, in 2025 review found that there is a prevalence of 13.24, quite a high. And even in ICMR study sponsored by, this is a National Task Force on Security in Indian population, Indian urban region. I was one of the PI from the northeastern state, and it was a multi-centric trial that was conducted in 2012 to 2015, where the professor and head of Department of AIMS New Delhi was the principal investigator. That is revealed that there are 9.2% in urban Indian populations. So it's quite high. And Europe also equally high. So contributing factors in the talk about the disease burden, CKD prevalence has increasing nearly over 30% since 1990 and is a leading cause of morbidity and mortality. And key drivers are all diabetic, hypertension, and other diseases. Now, look at this slide. You can easily appreciate from this slide here that you can predict that by 2040, then we will have a very high number of prevalence of disease. And look at this slide. Whereas in certain disease like in heart disease and a stroke, it's gradually in declining. So it can we can predict now by 2040, the stroke and heart disease will be lower. But whereas in CKD, you can see there is an increasing pattern. So by 2040, the prevalence of CKD will more. So these are the very risk factors, as we know. These are the susceptibility factors like old age, family history of chronic kidney disease, reduced mass, low birth weight, a low income group. Then these are the insulting factors or initiation factors like diabetes, high blood pressure, systemic infections, urinary stones, lower urinary tract infections, drug and drug toxicity. And these are the progressive factor like high proteinuria is progressive type of hypertension, uncontrolled hypertension, and poor glycemic state and smoking. So with this, I want to open my panel discussion. I have some queries for my panel and they will answer your query, this question. And if you have one query answer in between, you can ask, but should be very brief. So first question to my Professor Sajib Borphukan. He is a professor and head of the Department of Nephrology, Assam Medical College. How often you get the early stage CKD patient in your day-to-day practice?
Good afternoon, sir, and thank you so much for the question. I get in early CKD patients, I get a very few number. I would say around 2 to 5% only. The majority of patients who attend my clinic have already GFR of less than 40, 30 or so. And this is the data from my own analysis.
So you are getting a less number of patients, but so don't you think it is because of the late diagnosis?
Sir, yes, I would say decreased awareness among the patients.
So, ladies and gentlemen, you see the majority of the patients of CKD population, they start having the symptoms of uremia or symptoms of chronic kidney disease appear very late. So, by the time they appear symptoms of chronic kidney disease, it's a very late stage. So, therefore, the early detection in this such patients is very, very difficult. So, this may be. I think I absolutely agree with your point that because of their symptoms are appeared in the very late, so they come later on. So my next question to the Dr. Gogoi, he is an assistant professor of nephrology at Jorhat Medical College. How do you follow up your CKD patient and what investigation do you advise to monitor the progression of chronic kidney disease?
Thank you, sir. Sir, the follow up the CKD patients depends on the different stages of the CKD. If there's around in the early stages, we follow around 3 to 6 monthly. If the stage 4 and 5, we can more frequently we should assess the and follow the patients, and like 2 to 3 months. And if the patient goes to the end stage kidney disease and with very high risks of other cardiovascular susceptibility, then we should also monthly we can should follow up. And the second question regarding investigation, what to monitor in the progression of CKD. Before 2001, only the journey of the patient, we only follow the serum creatinine. Then 2001 to 2012 come the GFR, eGFR. Then after 2012, there comes the urine albumin to creatinine ratio. The three criteria, creatinine, GFR, then ACR, combining all these CGA criteria, we should follow these three parameters.
Okay. So for diagnosis of the chronic kidney disease, we don't need much with a higher investigation, very sophisticated investigation, right? If you have only the STEMI biochemistry and also routine urine examinations, and even each every corner of the state it is available, so you can diagnose in even very PHA level also you can diagnose a chronic kidney disease. Of course, you subsequently you need to substantiate your diagnosis by doing some sonology or radiological investigations. So my next question is Dr. Dole, Pradeep Kumar Dole. He is a professor and head of Department of Nephrology, Guwahati Medical College. And what are the most cost-effective screening tools for a resource-limited settings in our resource-limited settings?
Okay, thank you, sir. So topic has already been covered by previous speaker, but still I want to insist on that. There are no sophisticated investigation, as sir already mentioned that it is not need to diagnose a CKD patient. Only two simple tests, basic tests. It is done each and every nuke and corner of Assam, not only in Assam, all peripheries. So urea and creatinine and urine protein. Because the CKD diagnosis is based on EGFR and the proteinuria, presence of proteinuria. So then again, the EGFR can be done. Also, that can be extrapolated from the creatinine value. So creatinine and urinary is enough to say that patient whether having some sort of kidney problem or not.
Should you routinely investigate all the hypertensive and diabetic patients?
Yes,
irrespective of
obviously.
their
So
symptoms?
because if you see the etiological profile of CKD, the number cause of CKD is always diabetes. So more than 40-50% of the overall CKD population is because of diabetes, and next obviously it is the hypertension. So these two are a very, very important risk factor. So because of that, all patients, whether they are having any symptoms related to kidney or not, each and every patient should be routinely, just like you do RBS, you do a routine blood examination. So like that also you should always give at least the creatinine level so that you will make a early diagnosis, because CKD is symptomless. It is a silent killer disease. Until and unless you do the screening for a high risk group, it is very difficult to diagnose the patient at early stages. Even stage 3, after the stage 3, usually it is seen by the physicians, and when we do get the patient, basically they are in stage 4. So more than 80% is stage 3 and
Right.
seen by the peripheral physicians only.
So he's rightly mentioned that it is mandatorily each and every patient of hypertension and diabetic and the first diagnosis on the day of the first diagnosis, I think it is better to investigate the patients for having kidney diseases. So it is not very high, standards of you need any investigation. You can simply diagnose. So better to investigate each and every patient of diabetic and hypertension on the very first day. Like we are doing a ECG for every hypertensive patient, same also you can go for a routine creatinine examination, creatinine clearance estimation, and a routine urine examination. And if you have a facility, then you can go for a sonography of the patients. So yes. So my next question is to Dr. Bhalina. Bhalina is a student and she is the nephrologist and practicing in Guwahati. Dr. Bhalina, just I have one question to you. What are the risk factors for the stress migration of chronic kidney disease patients?
Thank you, sir. As already Bourbon sir has mentioned the various risk factors for CKD, the two most important modifiable risk factor for CKD stage migration is blood pressure and diabetes. Poor blood pressure control and poor glycemic control both leads to rapid progression of CKD. Then other important factors like use of various nephrotoxic agents like NSAID, then certain antibiotics like aminoglycoside, these are also causes rapid migration in CKD stage. Then the certain lifestyle factors like high salt and protein intake also causes CKD stage migration.
Okay. So what advice you give to your patient in prevalence of asthmatic disease?
The advice is just to control the risk factor, that is optimal control of blood pressure and diabetes, along with low salt intake and dietary modification. So these are the main advice to my patients.
Okay. So it's very clear that the risk factors should be assessed first. Risk stratification is very, very important for such patients. And you have to find out what are the insulting factors and minimize or limit the insulting factors here. That is a very, prerequisite for retard of the disease, retardation of the chronic kidney disease. Now, Dr. Tahidul Alam Chaudhary, he is a very senior nephrologist in Guwahati practicing. Dr. Chaudhary, what is the role of lifestyle modification in a chronic kidney disease progression?
Thank you, sir. Thank you, the organizer, for giving the opportunity. Say, living a healthy lifestyle improves quality of the life, survival, prevent and manage the CKD patients. But it is too difficult to prove that the lifestyle modification prevents CKD progression. Because of heterogeneity in the population, variation in the studies, there is no RCTs, it's difficult to measure the parameters. That's all. Anyhow, there are whatever commonly adopted physical activity, avoidance smoking, avoidance tobacco, weight reduction, management target weight, salt, diet, protein, phosphorus, calcium, etc. intake is there. We see one regarding physical activity, whatever standard recommendations like 30 minutes or 150 minutes in a week of vigorous or moderate activity, that not the sedentary activity. So, in a study by in USA in 2014, around 285 patients that leisure activity they have taken, those who didn't have leisure physical activity has a progression of CKD as compared to those who didn't have. But this is not seen in when advanced renal failure means CKD less than 30. Whatever observed was in CKD stage 1 to 3. Next. In additional 60 minutes walk, they have found that the incidence of ESKD was reduced, those who having the activity group. But other research trials have taught that this physical activity never involved in reducing with rapid GFR. You cannot culminate for rapid fall of GFR that is more than 3 ml per minute per year by the physical inactivity. Number one, incidence of ESKD is also not attributable to this that physical inactivity causing the ESKD incidence also less. Similarly, if you took then other like weight management, that ideal when weight in CKD patients is said to be in 18 to 25. There is J-shaped curve of BMI with progression of CKD. That means more the lower BMI having the higher progression. Again, higher BMI, again there is a risk of progression of CKD. But again, in stage GFR below 30 or 34 have shown that even higher BMI, they don't even have that progression as in the other groups. And main common finding in all these weight reduction policies is that if you have more obese, means more than 35 PMI, or you are doing the bariatric surgery, you have definitely reduction of proteinuria, definitely reduction of progression of CKD. So, and our target as far as 18 to 25, most optimal BMI for our patients 18 to 25 should be there. And regarding the smoking, and definitely smoking has a role in progression of CKD, but in the early studies they have shown that again GFR more than above 30, they means 60 or whatever, the evidence is more prominent, but less 30 is not evident. Number one. Number two, those who had former smoking or past smoker, they have lower rate of progression as compared to those who have current smokers. Number one. Again, the pack of smoking is the more than 5 packers have higher risk than compared to less than 5 pack years per year. Again, with the intervention, the progression retardation by smoking cessation has also not documented in RCT, one of the RCT. So, smoking definitely need to be stopped to prevent the progression of CKD, and salt intake, which is difficult to identify how much salt this patient is taking, dietary recall, and one of the best is 24-hour urine sodium. So, more the salt intake, there is increased chance of proteinuria, there is increased chance of progression of the CKD. So, salt intake reduction is a crucial part to reduce the progression. And in case sometimes potassium intake also, higher potassium is a controversial in different few only studies showed that 24 high potassium may have
Okay, that part will come later on when we have another two or question on based on that. So now the thing is that too much of protein restriction is not mandatory actually. So we are stick to Indian diets already deficient of proteins, And if you restrict on top of that, too much of protein restriction sometimes you can give a body catabolisms, right? So negative nitrogen balance. So eventually may cause and certain more progression of the disease. Yes, Dr. Burman has a one question probably. Yes, please. You take your microphone, please. Yeah.
Rather than obesity, we are seeing most of the patients they are sarcopenic. They're having lean body mass, they're thin. So how to manage those patients? There are more of a sarcopenia, and sarcopenia is an inflammatory one step.
Yes, do you have an answer?
Yes, yes. See, elderly patients, protein restriction as per recent 2 or 3 major trial is there. Elderly patients, protein intake is not to be restricted. So said that who was taking 1.3 gram per kg as compared to taking 0.8 or 0.6 gram per kg are doing better quality of life, greater survival and progression of CKD is not there. So number one, those already sarcopenic or they you should not restrict the protein. If you are restrict the protein, you are doing harm to the patient, not benefit. Malnutrition is more dangerous
Yes.
than the CKD progression. A patient with CKD can live more than 10 years, 20 years, not with malnutrition.
Absolutely. So malnutrited
It
patient
should
may
be
die.
individualized, in my
I
opinion.
agree. That's point. Yes. So my next question would be to Dr. Sajib again. How often you encounter hypertension in early stage chronic kidney disease patients?
Thank you, sir. It's around 80 to 90% of patient of early stage CKD have hypertension. Around 80 to 90%, sir.
Okay. Then what antihypertensive you would like to initiate in such patients? As is already mentioned in last probably. Or
Yes, sir. So this is regarding the first line of treatment would be ACE inhibitors, renin-angiotensin system. I mean, I would say RAS blockers, renin-angiotensin system blockers.
Correct.
And if we see the level of blood pressure control is not optimum, we can add a thiazide diuretic or a thiazide-like diuretic.
What is your target of blood pressure in such patient and patients?
So in CKD patients, I would like to keep my the target around less than 130/80 millimeter mercury. The latest 2024 and the ESH guidelines have mentioned also 130/80, but ideally 120 systolic. There is no mention in the KDIGO guidelines. They have not mentioned about the diastolic, but it's trying to achieve a 120. We should try to achieve a systolic BP target of 120, but if you keep at 130/80 also, it's sufficient enough to control the complications. Mainly, we are concerned with the cardiovascular complications, cardiovascular disease, coronary artery disease, and others.
Right. In this, here, one question might come sometimes, when you start a AC or ARB, AC inhibitor or ARB, what precaution you should take initially first?
Yes, sir. So first, we would like to, when we start a patient with, depends on the EGFR. If the EGFR is more than 30, then when we start an AC inhibitors ARBs, we should check the potassium level and the EGFR at least 2 to 4 weeks after starting the AC inhibitors ARBs, if the EGFR is above 30. And if the potassium level is less than 5, and if there is not more than 30% decline in the EGFR from the baseline, starting from when we started the ACE inhibitors or the ARBs, then we can still continue using them. But if there is a significant decline in more than 30% from the 30% from the EGFR, then we should cut down the dose of ACE inhibitors, ARBs, but we should not stop them. However, if the EGFR is less than 30, then we can still start using these agents, but we should check the potassium level and the creatinine level, I mean the EGFR, at least 1 week, maximum 2 weeks of starting. And if we see that there is no significant decline in the EGFR, I mean more than 30%, and if the potassium is less than 5, we can still continue using these agents.
Okay.
But we should check them. The main problem is the monitoring of potassium and
Right,
EGFR.
right.
So our patients do not come for checkup. So we are not able to monitor.
Absolutely agree with point here. Next. So Dr. Gogoi, Niranjan, when to start an RAS blocker? Already he said that when to start and till what stage of the chronic kidney disease you will continue. Your answer is the second part.
Yeah.
Till what stage you will continue to RAS blockade in such patients?
Ideally, sir already answered the first question. Second question answer is previously it was told that we should be contraindicate before 30 GFR, but now is consensus came that we should continue CKD even if the GFR is less than 30, if the patient is under close supervision and under strict monitoring,
Correct.
provided potassium is monitored. And also, we should. It is not that this RAS is given only for the progression of the chronic kidney disease. If the CKD patient having concomitant disease with heart failure or other diseases, then also it's had benefit in the other cardiorenal protection.
Absolutely.
Yes, sir.
So the reason is that then when the majority of our CKD population
Also, proteinuric patient, we should continue.
Yeah,
if the
the-
patient is severely proteinuric.
right. So majority of our CKD population artificially succumb to coronary events. It is 90% of the CKD population eventually they succumb to coronary events, and this is a drug ACI or ARB is a drug. We have ample of evidence that they can heart attack can be reduced by instituting these drugs. So that is so we should not discontinue the drugs to get the benefit from their coronary events. That is one of the things. Even in the patient with a higher range of potassium, then we can give even a potassium binding mixers, potassium binding regime also you can start
Yes,
nowadays.
sir.
It is started to get the benefit of the AC or ARB. Now, Dr. Dole, Pradeep Kumar Dole, as we all are aware, diabetes is a modern day epidemic and most common etiology of chronic kidney disease over the globe. What is the role of diabetes control here?
Okay, so it's a diabetic control, diabetic status, especially glycemic status control is very, very difficult in patient of CKD. So patient may went into hypoglycemia, sometimes patient may go into hyperglycemia also. So it is very difficult to balance the euglycemic status in CKD patient. And even if you see the monitoring parameter, so based on what you will monitor the glycemic status, it is not the FBS, it is not the PPBS, because these two are again difficult and it is very, very variable fluctuating in case of CKD. So because of that, you can choose the HbA1c. So you should target the HbA1c, especially in CKD patient. Again, depend upon what is the stage of CKD. So it should be range from 6.5 to 8 in a CKD patient, and it should be also based on the what is the stage of CKD and what is the age of the patient. If you try to strict control of glycemic status, then there are lots of problems are there. So usually elderly patient, it should be kept above 7 or around 8.
But the interpretation of A1C in a chronic kidney disease is little different. I think there some endocrinologists will here, Nilaksi or the Manas are here probably. Has it there? No.
So even it is also not a
Gunasan. Samiran is also here. Can you comment on that? And what's the A1C level in a such patient, in a chronic kidney disease patient? How do you predict, how do you assess such patients?
Hello, sir. Sir, basically HbA1c target is always subjective. So if the patient is very sick, if the CKD patient is sick, we cannot maintain a universal target of 7 in that patient. So it depends upon patient to patient. If the patient is taking orally, if he is compliant to treatment, then we can target a HbA1c of less than 7. But what we see in our clinical practice, maintaining a target HbA1c of 7.4 is sometimes also good for patients' glycemic control.
Correct.
However, only maintaining HbA1c but not looking into glycemic variability will be a problem in these patients, because what is problematic in our patient is glycemic variability, not always HbA1c, because average may be something which will be peaks and troughs in average. So we have to maintain the good glycemic variability. Without variability, 24 hours is
So it's
full body.
clear that you don't need to have a less than 7 in such patient also in chronic kidney disease patients sometimes. Dr. Dahidul, when to start an SGLT inhibitors in such patients?
A GLT-2 inhibitor type 2 diabetes mellitus, EGFR above 20, proteinuria that is 30 milligram per gram, that means micro or macro albuminuria, and these are typical indications as GLT-2 inhibitors. Again, the heart failure, presence of heart failure should be or preventive should be there.
So in both even type 1 also, is it?
And type 1 diabetes, there is a recent trend towards use of SGLT2 inhibitors. As you know, type 1 is autoimmune phenomenon or whatever, but still, as SGLT2 is used, different now using to reduce the glycemic variability, also reduces the HbA1c. Along with there is trial is there, they are as reducing the proteinuria as seen in type 2 diabetes mellitus. EMA European Medical Association recommended with patient type 1 diabetes BMI more or equal 27, more than that with glycemic variety, this SGLT2 is indicated. But later on, they have put on the recommendations in FDA and others now is still
Right.
considering to use
Right.
SGLT2 inhibitor type 1 diabetes mellitus.
So general consensus is that then up to 30 ml, below 30 ml, once the GFR is declining below 30 ml, probably this molecule will not be effective because these drugs acts on the tubules. And the tubules already get started. Yes. If the tubules started fibrosing and then probably this drug will not be effective. Like in thiazide diuretics. Although we are using indipamide, although we are using thiazide like diuretics after 30 ml of GFR, but these drugs require a little high dose because they'll not be very effective. Yes, Dr. Das, you have any queries in mind?
Yes, ADA does not recommend SGLT2 inhibitor in type 1 diabetes with the fear that it may cause euglycemic ketoacidosis.
That's
And the cases has been reported. Now, is it recommended in CKD then in type 1?
Not recommendation.
Not recommendation.
This is not recommendation. This is the studies that are coming, and that's few is there that it
Now,
reduces the protein.
the message should go to the house that
Yeah.
type 1 diabetes mellitus CKD. Should we prefer to use SGLT2 inhibitor?
As of today, I will try to use.
Hardly to see type 1 diabetic CKD nowadays.
As of today, I will try to use.
Anyway,
Whatever
type
I will use.
It's a type 2. Yeah.
One or two trials are there, like delivered trials. They are using SGLT2 in type 1 DM. This SGLT2 is not used for glycemic control, but to prevent the CKD. It's mainly control the tubulo-glomerular feedback, which reduce the hyperfiltration.
Yes.
So,
Yes.
Yeah, there's a side effect is there.
Yeah,
But that is very, very minimal, and that euglycemic ketoacidosis, diabetic ketoacidosis is very, very less in use of this one SGLT2
Dr. Gayatri,
inhibitors.
you have any comments on that?
So just two things about SGLT2 inhibitors. No doubt it was initially used in diabetic CKD patients, but now we are even using in non-diabetic CKD patients for prevention of the progression of CKD.
Correct.
Firstly, we are using it only in proteinuria patient initially, but now you are using it even in non-proteinuric patient where the benefit has been seen. Earlier, GFR was 30. Now you are using even in those patients who are on dialysis. Sir has said that about the role of tubulo-glomerular feedback. No doubt that is the main mechanism which is responsible for causing preventing the progression of CKD. But we have seen new studies are coming. Even we are using where we have seen that these have been continued using in patients who are on dialysis, off-label use you can say. But we have seen that while using this medicine, the incidence of heart failure, which is very common in CKD patients who are on dialysis, that incidence has reduced to a much extent.
Absolutely.
So probably that's why you are using SGLT2 inhibitors, mainly dapagliflozin. Now EMPA is also coming. But these are the two SGLT2 inhibitors which we are using in CKD, non-diabetic patient also. But I will say this. This is what I am saying. But the thing is that we have to be, it's not that right and left we can use. We have to choose our patients very carefully and selective.
We have
Like
only
the panelists to give
we have only 9 minutes. Please
Okay,
be touch to your.
So just I
queries.
want to say add on this. So SGLT2 on a dialysis population, because SGLT2 per se molecule is acted only on the kidney. So if your kidney is not there, so even the beneficial effect will be not there.
Right.
But there are trials that is something different. Otherwise, the everything is done by the kidney only. If the kidney is no more functioning, so use of that drug is not
Correct.
effective.
Okay, Dr. Bhalina, the next your question: does proteinuria reduce the related to delaying the progression of chronic kidney disease? How we can achieve it? Yes, please.
Reduction in proteinuria has been strongly and consistently seen to slower progression of CKD, and various trials already has shown that proteinuria reduction is beneficial, and we can achieve it. The first cornerstone is the RAS blockade by either AC inhibitor or ARB in maximally tolerated doses. Then second game changer is SGLT2 inhibitor. Already we have discussed the various landmark trials like Credence, EMPA kidney, DAPA CKD trials has already shown that reduction in proteinuria is beneficial. Then third pillar is the newer drug, the non-steroidal mineralocorticoid receptor antagonist, that is Finrenone, which we are using in both diabetic CKD, and now trials has been coming that we can use it in non-diabetic CKD and type 1 CKD also.
Okay, thank you. So next is your Dr. Borfukon. What is the role of he says Finrenone? Just tell about, she has already spoken, and just to tell about and pros and cons of finerenone in such
Yes, sir.
patient.
So from a practical standpoint, I would like first to check the EGFR. If the EGFR is 60 and above, and if the potassium is less than, I would say, 5 or 4.8, then we can start finerenone. But finerenone not as a first-line therapy. The first-line therapy is always RAS inhibitors. The maximum tolerated RAS inhibitor the patient has to take. Then only on top of that we can add finerenone. Because finerenone we are not adding as an antihypertensive agent as such. We are adding for renal protection and cardiac protection. It reduces the kidney composite endpoints and reduces the cardiac endpoints, as is shown by the three major trials: the Fidelio DKD, the Figaro DKD, and the Fidelity pooled analysis of the previous two trials.
Right. So it's a very proven drugs, anti-fibrotic drugs now. It's a very proven drugs, so it can be used, but provided you have to follow all the guidelines. Now, Dr. Gogoi, what is the concept of gut dysbiosis now? He's just coming up now.
It's ideally it's a very long topic, but in the short,
In a
in gut, where the good bacteria is there, there's bad bacteria is there. What happened in the CKD that the intestinal milieu which change, it become acidic due to GI gut motility or low fiber intake. This the bad bacteria get increases. So we generally use these pre and probiotics. Like prebiotics are generally fermentable fibers which increase the gut bulk and decrease the bad bacteria and increase then help in the promotion of with addition of probiotics in the good bacteria, which leads to the decreased gut barrier transformation of the lipopolysaccharides in systemic inflammation and progression of CKD.
Like
This
this
is
drugs,
the effect is modest, but still not.
these drugs are
Yes, sir.
commercially available now.
Yes, sir.
Many of nephrologists are using these drugs, but these are all probably, I would say, these are all like additional pill burden to the
Yes,
patient,
it's adjunctive.
and also taxation. But however, there are some benefit also. The next question is to Dr. Dole. What is the role of beta analogs in an acetylcysteine? So that's a very commonly asked question, probably.
Okay, probably for all physicians, this medicine is a game changer for CKD management, but it is not like that. So if you see the management of CKD patients, just like diabetes, we do have a 4-pillar based management. So one is the SC and ARB, second is the SGLT2 inhibitors, third is the what finerenone, and fourth is nowadays semaglutide is coming up in the as a fourth filler. But this medicine is not find any place in that filler based treatment. But of course there are certain benefits are there. Bhupen Burman sir was asking one question. So most of the patients are sarcopenic. All CKD patients are sarcopenic because if you see the patient, any stage of CKD patient, they will give one diet chart. So that whatever diet chart is given, it is usually for those who are in stage 5 or CKD 5. But even in the stage 1 or 2 patient, will start following that chart. So become more and more sarcopenic. So this is just a nutritional supplement to those sort of patients who are having
Absolutely. So
sarcopenia. This is basically build up the
supplement.
muscle bulk.
Correct.
Also, there are some benefits are there
Absolutely.
as a low protein diet. As you know, low protein diet is a renoprotective.
In a later course, as I'm telling you, if you do not prescribe beta analogs, and the patient will change your doctor. She'll go to the other doctors, because doctor is not prescribing my kidney disease, a kidney medicine here.
It's a very high cost, and the volume is very, very high.
So next is Dr. Chaudhary, role of bicarbonate and phosphate lowering agent in such patient for prevention of retardation of the chronic kidney disease.
Yeah, thank you. See, metabolic acidosis is a crucial part that reduces bone density, that reduces the muscle strength, muscle wasting. It starts in GFR below 30.
Yes.
Must question. So when GFR is 60, 80, 70, why would prescribe these things usually? So my personal opinion. It starts below 30. And this replacement of bicarbonate in 2009 JSN journal, there's a trial, the RCT, around 382 patients is there. They're shown that bicarbonate replacement has reduced the fall of EGFR around 1.8 in control group and 2.2 in the control group and 1.8 in patient group. There's a reduction in the, but no incidence of ESKD was reduced in this trial. No incidence of doubling of serum creatinine, whatever take initiation of KRT is not clear. And thereafter, what is the target? Initially, it was target that bicarbonate was 22. You replacement till bicarbonate 22 means better rate.
Right.
Now the trial is coming that a higher target 26 to 28 also have some beneficial effect, but there is some negative effect like acceleration of hypertension, heart failure, increased sodium load. Again, increased sodium load may, as already told, may again increase the proteinuria also.
I understand. Just you just simply tell the audience that at what level you should start and when you to continue.
Below 22, target is 24 at my as of date.
The reason is why we should start our because after GFR declining to 30 ml, there started acidotic patients, and acidosis will again then cause an deterioration of the bone diseases, and also ongoing acidosis can cause a further progression of the disease. So therefore, the control of the acidosis is very, very important in such patients. So once the GFR is reaching 30 ml per ml, probably you have to start the bicarbonate level here, or bicarbonate tablet. So, Bhalina, when to treat the hyperuricemia? Do you need to treat on each and every patient of hyperuricemia in such patient, chronic kidney disease?
No, actually, guideline has recommended that only symptomatic gout, patient with uric acid stone and very high level of uric acid, more than 9 to 10 milligram per DL, should be treated with anti-hyperuricemic agents.
Correct. Any other recommendation? Then no. Dr. Sajeev, what is the role of multidisciplinary CKD clinics in delaying the progression of the disease?
Yes, sir. So it's a pertinent question. So actually, by a multidisciplinary CKD clinic, there will be a nephrologist. There will be now a diabetologist or a medicine specialist, a cardiologist. I'm trying to involve the cardiologist also, as per the latest KDIGO guidelines, and a renal dietitian, a nurse, a social worker, a counselor.
Absolutely.
Also, I'm involving the physicians also, if they don't mind, because glycemic control, every nephrologist might not have so much time to maintain the glycemic control.
Absolutely, I agree. No
So
one is chief consultant.
and
Everyone
I'll
is
need a cardiologist and a diabetologist to help me out with my CKD patients.
Absolutely, absolutely. Thank you. Dr. Alam, as a new drugs in CKD, I think we'll not have a discussion. These are little high because the paucity of the time. I think we can stop the rapid fire round. These are some important one. What is the game changer drugs in the chronic kidney disease progression?
Already the GLP-2 inhibitors. It is no more a diabetes drug.
Anybody
It is
in
a
favor
CKD
of
diet.
Findenot?
CKD drugs.
Anybody in favor of Findenot? Yes, I also. What common practice we should abandon? What common practice we should abandon now in treating such patient?
You should avoid NSAID, frequent avoid the over-the-counter drug. NSAIDs.
NSAID prevention. Any more important?
Sir,
discontinuation of the AC or ARB unless there is hyperkalemia or right. This is a very important. Even you can continue the AC or ARB, then end-stage renal disease on dialysis also to get at least the cardiac benefit in such patient. Thank you very much for your patience, Yari. And if you have any queries in your mind, please.
I have a comment on this also.
Time is out already.
Yeah, no, I have a simple comment on this.
Yes.
If you,
Nita is there.
Because CKD you diagnosed with EGFR, serum creatinine, and UACR. If you based on this, you will be bombarded with a lot of patients. Nephrologists will not be able to handle.
Absolutely.
So my take is that from this forum, we should not label CKD unless and until we exclude other causes which can cause, because there may be infections, there may be other causes also which will be reversible. We have to look for the reversible causes before labeling.
No, that is clear. We go by definition of the CKD. Our diagnosis is CKD based on our definition. So AKI is a different chapter. We are not discussing.
But
here,
we have
right?
to exclude before labeling.
Definitely. Every patient of CKD should be suspected. Is there an underlying AKI?
Yeah, underlying AKI. That's my point.
Always. When before developing CKD, you should be stroke. This patient is AKI.
Yes. Even you can go for biopsy also, not to see. I think. Yes, please.
Okay, there are a lot of questions, I understand, but time constraint is there. But I will allow a few questions. Yeah, just one question. One question. Yeah.
Madam, role of vaccination in CKD. Because most of the stage transition happens because of intercurrent infection.
What did you just briefly mention about it? Yes,
Vaccination should not be discussed here in this patient, so we can go with each and every vaccination. There is no contraindication per se, except the live
Dr.
vaccination in
Bipul
terms of your.
Sir was thinking of a question. You wanted to ask one question.
Kolta.
the ARB and SC inhibitor in CKD, at what level we should proceed, we should treat it. That question was above 30. Now, what is your comment? The message should go to the house.
No,
as a
ARB
physician,
SC inhibitors, there is no cutoff.
as a physician,
Cutoff
sir,
GFR level, sir. You
No,
can
no,
go
no.
up to 0
Now
GFR.
we don't go by the cutoff.
No,
No,
sir,
we don't
no.
have any cutoff now.
Any GFR level, you can start
Any GFR level
ASARB.
you can go.
You
But
have
you
to
go with the
monitor for
simulation.
potassium. That is the only reason. Even patient on CKD, if the potassium is, you can control, continue with ASN inhibitor.
But under close supervision,
Yes.
under your follow-up.
And yeah.
And what the second drugs we use, because ARB and SE, I have seen that never control the BP to their target level.
As per guideline, you say then calcium channel blocker.
Yes.
Then other even beta blocker or centrally acting drugs you can add on.
No.
So I think we can close as it is the time is.
Even the SGLT2 also antihypertensive drugs nowadays because it exceeded the creatine level.
Due to
Okay.
paucity
Yeah.
of, we should close this session. Actually, we wanted to hear more, but there is time constraint, so we should close the session.
Thank you, ma'am. Thank you. Thank you.
Thank you, ladies and gentlemen. Please step towards the felicitation area.
There is a saying that the night is dark and I have my miles and miles to go. But these words I will not say. The hall is bright and beautiful, but we have lots and lots of topics yet in this particular day to talk about. Now, next in the line is there's another panel discussion. Yes, and after that, prestigious HP Bora Horizon is there, guest lecture is there, and another lecture is also by I think another guest, Professor Nandini Chatterjee. So many lectures are there. This schedule is jam packed. So please bear with us, with the organizing committee. Quick.
We shall now proceed to the symposium session. I'm delighted to introduce our chairpersons for this session, Dr. Nayanjyoti Kakoti, Dr. Somnath Roy, and Dr. Bhaskar Debnath. I request respective faculties to kindly grace the dais. The chairpersons for this session is Dr. Nayanjyoti Kakoti, Dr. Somnath Roy, and Dr. Bhaskar Debnath. Now I take great pleasure to introduce the esteemed members of today's symposium, Dr. Suresh Sharma, Dr. Manas Jyoti Saikia, and Dr. Nirvan Baisha. We warmly welcome you to the stage. I'd like to invite Dr. Suresh Sharma, sir, to take over the mic, please.
So, good evening, everyone, respected chairperson, seniors, and colleagues. So I think we have to be in the Rajdhani mode now. Shatabdi, yes, sir. Vande Bharat may also do. So this symposium roughly will cover about the assessment as well as management of COPD, and we'll discuss few case-based scenarios in the clinical day-to-day practice. And we'll mainly focus on the about this the latest 2025 goal guideline. So we all know COPD is a heterogeneous lung disease characterized by chronic respiratory symptoms and is mainly due to the abnormalities in the airway or in the alveoli, and this is mainly characterized by airflow limitation, which is usually persistent and progressive. So it's a very common disorder, most commonly seen in elderly people more than 40 years of age who are smokers, and more common in males. And the global prevalence of COPD is 10.3%, which is very alarming. So in 2011, COPD was the third leading cause of death. And globally, it is found that almost 3 million people die every year because of COPD or its complication. So roughly the pathogenesis, new term coming up is a getonomics, which is GET. G is the gene when the person has some susceptibility either in the form of deficiency of alpha-1 antitrypsin or other genetic factors. E is the environment, most important, either in the form of smoking, indoor or outdoor air pollution or certain infection. And lastly, T, which signifies type. That means over a period of time, once these all three tangles, they lead to the pathogenesis of COPD. So this is a new proposed taxonomy of COPD. So nowadays COPD has various taxonomy. So the most common which I am telling you is the COPD G, which is that means genetically predetermined either in the form of alpha-1 antitrypsin deficiency, etc., or other enzymes. Then COPD D, which is because of abnormal lung involvement development, commonly seen in low birth weight babies or underdeveloped person. Then we have environmental COPD, the most common which we encountered, which can again be type C, which is because of smoking or cigarette, or P, which is again recently coming up very highly because of the increase in environmental pollution. Then we have COPD due to infection, COPD-I. In our setup, more common is tuberculosis, then HIV and other infection may cause. Then COPD asthma overlap. And lastly, we have COPD of unknown causes. Sometimes we may not find any precipitating cause, then we may label him as a COPD-U. So in the diagnosis and assessment, our target is to find out individuals who have chronic respiratory symptoms, diagnose them with the help of a spirometry, and put them under some assessment test so that what pharmacotherapy or other interventions are usually required in the individual, and we have to individualize the treatment. So it's not so we have to make the treatment tailor-made for each and every individual. So a diagnosis of COPD should be considered once there is a typical clinical history of chronic breathing difficulty associated with cough and or sputum production in a person who has certain risk factors of exposure, either in the form of smoking or environmental or external air pollution. And this is followed by a spirometry. So if the post bronchodilator FEV1 by FVC is less than 0.7, which usually confirms the diagnosis of COPD. So there are certain clinical indicators of COPD. So in whom we should suspect. So dyspnea is the most common presenting symptom for us, especially in the tertiary care hospital. So the dyspnea is typically progressive, persistent, and it usually progresses over a period of time. And it usually worsens with exercise. And it may be associated with wheezing. Chronic cough, initially it may be intermittent, mainly during seasonal change or during winter, but as the disease progresses, the cough becomes persistent and is associated with usually recurrent respiratory tract infection. And there may be history of the risk factor, either in the form of history of smoking or exposure to chula smoke in case of indoor air pollution or outdoor air pollution. Then other associated features may be present sometimes if the patient is bedridden, may not give typical history of breathlessness. So fatigue is again a very important symptom, commonly missed also. Along with this, since it's a systemic disease, patient may present with features of weight loss, muscle mass loss, anorexia, and sometimes in late stage, patient may present with signs of cor pulmonale in the form of ankle edema, etc. So once these symptoms come, so there are certain disease which may mimic similar symptoms. So for most common is asthma. It's always we find most of the patient with asthma are level as COPD and COPD patient are level as asthma. So this should be differentiated because they have a different natural course. COPD is a progressive disease. But in case of asthma, if we treat it well, it's not progressive. We can hasten the progression of lung function deterioration. So asthma is typically seen in young age, maybe seen in elderly also, but the symptoms are usually episodic. There's a history of remission in between. If we treat well, definitely there may not be progression in deterioration of lung function. See, congestive heart failure again a very common, and sometimes both of them may coexist also. So we have to differentiate. So unlike COPD, congestive heart failure may not present with features of obstruction in the spirometry, and once we do X-ray, etc., we can get curly B lines, etc., cardiomegaly. Patient may history of orthopnea, PND. Bronchiectasis again very important because symptoms may be similar and sometimes severe COPD may be complicated by bronchiectasis, which can be confirmed from history of cough with copious sputum production, and this can be confirmed with the help of a HRCT thorax. TB in again Indian setup very common, but it can be seen in all age group. We have a typical TB symptom, chest X-ray shows infiltrates, and if you go for sputum microscopy or CB-NAT, which we may get detection of Mycobacterium tuberculosis. And these two, though mentioned in the guideline, but not much common. Diffuse bronchiolitis, mainly seen in Asian, Japanese people, not common in Indian setup. So spirometry. So we should make sure each and every patient of chronic breathlessness or cough production should be subjected to spirometry because it is the gold standard for diagnosis of COPD. Whatever test we make do to level him as a case of COPD, unless it is spirometry proven, we cannot call it as a case of COPD. So the hallmark is post-bronchodilator FEV1 by FVC ratio of less than 0.7. It's not pre-bronchodilator. The role of pre-bronchodilator spirometry is that if it comes out to be normal, we can exclude COPD. But ideally, we should go for post-bronchodilator FEV1 by FVC ratio. If it's less than 0.7, then we can label him as a case of COPD. So the role of COPD, number one, definitely in diagnosis. Then assessment of severity of airflow obstruction. So with the help of spirometry, we can grade the level of obstruction into grade 1, 2, 3, and 4, which I will talk later on. Then again for follow-up assessment, mainly in the therapeutic decision, because this may help in selecting drugs, number one. Then we can have to, sometimes we have to consider alternate diagnosis if the patient's symptoms are disproportionate to the level of obstruction which we are getting in spirometry. And sometimes we may require some form of intervention in severe COPD patient where spirometry may play a role. And lastly, identification of rapid decline, because these patients are have more morbidity as well as morbidity compared to person where the lung function decline is less. So initial assessment, once we have made a diagnosis by doing a spirometry, now we have to go for initial assessment. So first we have to look for severity of airflow obstruction, followed by nature and magnitude of current symptoms. How much severe the symptoms of the patient is, previous history of moderate or severe exacerbation, and lastly presence and type of other disease or comorbidity. So all these four play an important role in choosing the type of treatment, either pharmacotherapy or sometimes other than pharmacotherapy in the form of some surgical intervention. So first, the severity. So once we have confirmed our diagnosis of obstruction by going for spirometry and FE1 by FVC ratio less than 0.7 post bronchodilator, then we have to look at the values of FEV1. If it is more than 80%, it is mild. Between 50 to 79 is moderate. From 30 to 49 is severe, and anything less than 30 is very severe. So this slide should be kept in mind because this will be, once we talk about the treatment, so this will play important role in choosing the type of pharmacotherapy. Second, the nature and magnitude of current symptoms. So here we have certain things we have to go for the guideline recommends. So the most common questionnaire which we are using is CAT, COPD assessment test. Even St. George respiratory questionnaire may be used. But this CAT test is important in this assessment. So usually it has 8 questions, 5 maximum up to 5 points for each question, and we have to label. So anything 10 or more becomes significant. So we can quantify into CAT score more than 10 or more than 10, or anything CAT score less than 10. So if the CAT score is 10 or more, the patient is more symptomatic. If the CAT score is less than 10, it is less symptomatic. Thirdly, the more commonly used one, MMRC. Previously we used to use MRC, but now it's MMRC. So we have 5 grading from 0 to 4. So 0 means the patient is breathless even only on strenuous activity. Grade 1 is when the patient is breathless while hurrying or walking uphill. Grade 2, when the patient walks slower than the contemporary age group. Grade 3 is once he has to stop for less than 100 meters. And lastly, grade 4, where he has problem in doing normal day-to-day activity. Again, we have to quantify this patient. And lastly, exacerbation risk we have to know, because the most important predictor of future exacerbation is a past history of exacerbation. Also, the most important indicator of mortality as well as morbidity in a CO patient is the previous exacerbation or the rate of exacerbation. So we have to quantify how many exacerbation he was having in the last year. And lastly, comorbidity. Now, COPD is considered as a systemic disease. So it's thought that the main pathology is in the lung, but there is a spillover of the inflammatory markers in other parts of the body. That's why there is increased prevalence of cardiovascular disease, metabolic syndrome, osteoporosis, depression, anxiety, and many others. But these are the common ones. So, and lastly, once we come on, we have done everything. Now we have to come to the assessment tool, which nowadays is called ABE. So gold ABE assessment tool. So previously we had ABCD, now we have ABE. So how do we proceed? So we have done a spirometry to confirm our diagnosis. Okay, the ratio is less than 0.7. Now we have to go for assessment of airway obstruction. There are 4 grades which I have told you. Grade gold 1, 2, 3, 4, mild, moderate, severe, and very severe. Once this is done, now this we have to categorize into group A, B, E. Now I will simplify this one because it looks more complicated. A means less symptoms, less risk of exacerbation. B means more symptoms, less risk of exacerbation. E means high risk of exacerbation. So group A, so that means less symptoms. That means the MMRC grade is less than or 0 or 1 and the CAT score is less than 10. But there is no exacerbation, moderate or severe in the past 1 year. It's 0. Previously, we considered as 0 to 1, but now there should not be any exacerbation in the last 1 year. And the patient has a CAT score of less than 10, MMRC of 0 to 1. This means they have more mild symptoms and less exacerbation. Second, we have B, where the symptoms are more, but exacerbation risk is less. That means the MMRC is 2 or more, CAT score is 10 or more, but there is no exacerbation in the last 1 year, moderate to severe. And then we have a group E. So previously we have C and D, but now only V, because any exacerbation, moderate to severe, is significant, irrespective of symptoms. That's why we quantify into A, B, and E. Now this A, B, E will be used further once we go in the treatment part. That's why this chart is important. Then additional investigation we have to go for mainly DLCO lung volume, and these are done once the patient has symptoms which are disproportionate to the airway obstruction, or we are suspecting a other comorbid condition. In that case, we have to go for this test. Again, X-ray and radiology commonly done. So chest X-ray is done just to confirm as a supplemental tool. We can get findings of hyperinflation, flattened diaphragm, low lying, along with tubular heart, and any other comorbidity, infection, and bronchiectasis sometimes may be picked up. And CT scan. So there is a use of CT scan in stable COPD in certain conditions. First, in differential diagnosis, or if the patient is more symptomatic, is having recurrent infection, has large amount of sputum production, or once we are suspecting some atypical infections such as non-tubercular mycobacteria, etc., then there is a role of CT scan. Second, if we are planning some lung volume reduction surgery procedure, either in the form of some valve or LVRS, then again there is a role of spirometry, CT scan. And lastly, lung cancer screening now is coming up by doing a low dose CT every year in a susceptible group of population of 50 to 80 years who are heavy smokers, smoking around 20 pack years and has not quit within the last 15 years. So ideally they should be subjected to low dose CT beyond. So because this patient that we can pick up malignancy in an early stage and especially in a curative stage. Then certain tests in special conditions should be done, mainly alpha-1 antitrypsin. If you are getting a young patient less than 45 years, history very much suggestive of COPD, no issue of smoking, and once we do a CT showing panlobular emphysema, then this patient should be subjected to alpha-1 antitrypsin deficiency testing. And lastly, blood eosinophil count is again coming up very much because the role of steroid in stable COPD is coming up in a big way, and the most important indicator is nowadays considered to be the blood eosinophil count. So anything more than 300, they have a higher chances of exacerbation, and these are the people who are a good candidate for inhaled corticosteroid. Okay, thank you. So now from further on, so how we manage from this assessment will continue pharmacotherapy as well as other surgical modalities. So Dr. Manas will questions we'll take on the last once it's over.
Good evening, and first of all, I like to thank the organizing committee for giving me this opportunity to speak in such a grand platform. I'll be speaking on the treatment updates on the both pharmacological and non-pharmacological treatment update on COPD as per the goal 2026. Coming to the briefly history about the gold, as we all know that till 1998, there was no consensus guideline to guide us for treatment of COPD worldwide. Every country has their own guideline. In 1998, basically World Health Organization and the National Heart Lung Institute, they come together to form the first guideline in 1998. And since then, we are having a guideline update in every year. From 1998 to 2011, they have guided us to give the treatment of COPD based on the FEV1 grading, basically FEV1 80, 70 like that. But in 2011, they have introduced the ABCD assessment protocol, but still there was confusion, the guiding which to FEV1 to use when and the ABCD approach to use when. In the next major update, that was in 2017, where they have completely separated the FEV1 grading from ABCD and advised that treatment should be based on ABCD only. This was based based on the all evidences supporting the ABCD approach. And FEV1 now from 2017 should be used for COPD prognostication to the patient and for non-pharmacological management only. In 2023, they have revised this ABCD approach to ABE, and in 2026, another major review. Recently, they have changed the ABE, some of the revision in the exacerbation protocol, and also they have introduced the biologicals in the 2026 guidelines. Coming to some of the facts, though smoking is the main cause of COPD, only 50% of heavy smokers suffer from COPD. Overall, incidence of COPD in smoker is 20 to 22%, and in never smoker is 3 to 11%. And in the never smoker, the air pollution is the leading cause of COPD, with 50% attributable risk. The goals of COPD management is to reduce symptoms and the reduce risk, as we all know. Coming to this is the recent sense. Here, if you see the y-axis, the below part, the zero, compared to last year, it was they have allowed till last year one moderate to severe exacerbation, but in 2026 they have changed. They have not considered any exacerbation, and if one exacerbation, so we will consider it as a group E. And the treatment in Group A will give a bronchodilator, preferably a long-acting muscarinic antagonist. In Group B, will combine LABA plus LAMA. And in Group E, will LABA plus LAMA. And depending on the eosinophil count and patient criteria, we'll go for triple therapy. And after that, we'll have to divide the group in two groups. That is, which is the predominant characteristic, is dyspnea predominant or the exacerbation predominant. In the dyspnea predominant group, as we all know, if the patient is getting only a single agent, we will combine the both agent and one new agent in the third line. This is not very clear. The ensifentrine is a new drug. There is a PDE3 and PDE4 inhibitor. This ensifentrine is the newly introduced in this dyspnea predominant group. And coming to the exacerbation predominant group, we will mainly look for your blood eosinophil count. If it is more than 300, we will directly go to triple therapy, single inhaler. And if it is 100 to 300, we can give a trial of single inhaler triple therapy, LABA, LAMA, and ICS. And if it is less than 100, we can try with loflumilast, that is a PDE4 inhibitor. And in chronic smoker, we can try with azithromycin. Here in the right side, if we can see, uh, the square one, the biological therapy, that is dupilumab and mepolizumab. This is given in order of their FDA approval. Dupilumab is a IL-4 alpha subunit analog, and the mepolizumab both are recently been approved, and it is introduced in the newer guideline. This is the trials that allow us to give this two new medicines in the COPD management. For dupilumab, the main two trial was the Boras trial and Notas trial, and mepolizumab, Metrio trial and Matrix trial. The mepolizumab dose is 4 weekly 100 milligram dose. It is same as the asthma dose what you were using, but in case of dupilumab, the dose is little bit different. It is 300 milligram twice weekly. In case of asthma, we used to give initially 400 milligram, then every 2 weekly we used to give 100 milligram only. But here in COPD, we will be giving 300 mg 2 weekly. And other pharmacological treatment like alpha-1 antitrypsin deficiency, if the patient is having alpha-1 antitrypsin deficiency, other agents like antitussive vasodilators and the pulmonary and PAH drugs, these are not indicated. This I want to highlight about the antitussives. We have a common practice of using the anti-cough syrups. As per guideline, from last 4 or 5 years only, they have found no evidence supporting the use of antitussives in case of COPD. Coming to the exacerbations, what we mean by exacerbation, by definition, it was changed last year to they have given a definite duration now. It is defined as acute worsening of symptoms that within last 14 days. And it is divided to mild, moderate, and severe. Basically, moderate and severe difference we need to know, because moderate and severe they keep on coming on the guidelines. Moderate and severe basic difference is that all the respiratory rate and heart rate parameters are same. But in ABC, in the severe group, we will give hypercapnia also, and in the PaO2, in case of severe group, will be less than 60, and in the moderate group, it will be more than 60. It will be less than 90, but more than 60. Coming in the exacerbation room, we may have to use the NIV. There was a big trial going between NIV and invasive mechanical ventilation, and it was established that the NIV is much superior in case of COPD. Unlike asthma, in asthma the mechanical ventilation is more superior. And the criteria of NIV, we all know, P is less than 7.35 and PCO2 more than 45. And along with the other criteria, if the person is having dyspnea and muscle fatigue, excessive use of muscle, and that hypoxia persistent in spite of using high flow oxygen therapy. Coming to non-pharmacological therapy, in the A, B, and E group, the essential in everyone is smoking cessation, as we all know, and smoking cessation should be addressed with pharmacological management and assist in that 5A step. And in B and E group, along with the smoking cessation, the pulmonary rehabilitation takes the main role. Other recommendation is the physical activity, and depending on local guidelines, we will be using the vaccinations. The vaccination guideline, the goal guideline is adopted from the CDC only. The vaccination, the below part, if we see, and the lower part, that between 19 to 49 years age group, if the chronic heart and lung disease like COPD, will give one dose of PCV 20 or 21, and option 2 is we will give PCV 13 and followed by PCV 23 1 year after. Here in our we don't have PCV 15, we have PCV 13 here. We use PCV 13, and 1 year after we can give PCV 23. Same in the case of more than 50 years also. And non-pharmacological follow-up management in the dyspnea phenomenon group, basically we'll try to teach the patient for self-management, and we'll give some breathlessness exercise, energy conservation techniques, etc. And in the exacerbation phenomenon group, we'll mainly go for the aggravating the trigger to take out the trigger. And other therapy in the COPD is the oxygen therapy. In oxygen therapy, we should not give oxygen therapy to all resting hypoxic patient. The long-term administration of oxygen increases the survival in patient with severe resting hypoxia only. And the other exercise-induced hypoxia or moderate resting hypoxia, it has no role. And the criteria of LTOT is PO2 in ABG less than 55 or PO2 less than 60 to 55 with pulmonary hypertension, congestive heart failure, or erythrocytosis, that is hematocrit more than 55%. The important point here is that we have to recheck it in 60 to 90 days. If it is now improved, then we have to stop the oxygen therapy. Otherwise, it again lead to CO2 retention only. The restacking part we usually forget. The pulmonary rehabilitation, what it defined as a comprehensive multidisciplinary patient-centered intervention that include patient assessment, exercise training, self and management education, and psychosocial support. The indications are all chronic lung diseases. Outcomes compared to PIVA, it increases the exercise tolerance, reduces dyspnea and anxiety. Important point is that though positive outcome associated with pulmonary rehab are realized without improvement in the lung function, we may not find a parametric improvement in the lung function, but the patient overall feels much better with pulmonary rehab. Essential components are patient selection, assessment, and mainly is the main part exercise training. In the exercise training, we can do in outpatient or inpatient setting also. In outpatient, we do it 2 to 3 days in a week, inpatient 5 days in a week. The exercise, mainly lower extremity exercise like walking, treadmill, stationary bicycle, stair climbing, and sit and stand. Upper limb exercises like arm cycle ergometry, unsupported arm lifting, and lifting of weights. This is the guideline how to you do it. Basically, we do it 3 to 4 days in a week. Two type of exercise training is there: continuous and interval training. In continuous, we give continuously for the exercise, and in interval training, we give 30-minute exercise, then 30-second rest, then 20, or another approach is to give 20-second exercise and 40 seconds of rest. Other pulmonary rehab components are neuromuscular electrical stimulation, whole body vibration, breathing exercise, etc. This is the vibration technique, and this is all we know: partially breathing and expiratory muscle testing. We can use a device also that create a PEEP. And diaphragmatic breathing is the while exhalation we have to take the belly in, and half cuff technique while expiration we can cuff the extra out. Other management, non-pharmacological management comes if it is not managed with the pharmacological management. We can see if there is CT scan, if there is large bulla, then we can directly go for a bulectomy. And if there otherwise, if there is a emphysema, we can differentiate heterogeneous or homogeneous. In both the side, the management is almost same. Basically, we have to see if there is a collateral circulation that we measure by a Cortis method. And if there is collateral circulation, if we use a valve from the side, again there will be accumulation of air. So only if there is positive collateral circulation, we cannot use the valve. Other management are same only. Other management including lung volume reduction surgery, bronchoscopy lung volume reduction like reduction coil and vapor ablation. And in the last option, there is always one option of lung transplantation. Coming up in 2026, two, three other options in COPD. It is cryo spray, rheoplasty, and targeted lung denervation. In cryo spray, bronchoscopically, we use some cryogens in the most affected emphysematous lung that makes that part collapse, causing that lung volume reduction. In the rheoplasty, is like that only on the volume reduction method. And in the targeted lung denervation, basically, as we all know, the bronchoconstriction mediated by vagus nerve. If we selectively uh, give high temperature and then suddenly low temperature to a targeted nerve, it causes the denervation of that nerve area, causing that mass improvement in the overall lung function. Lastly, take-home messages. The target, as we all seen that ABE new approach, the exacerbation they have reduced to 0 in the y-axis. So target exacerbation prevention with upfront patient-guided approach. And then ensifentrine in dyspnea predominant group. Ensifentrine is nowadays in the pipeline coming to India. It is given in a dose of nebulization dose in 3 mg twice daily like that. And biologicals have established role now, dupilumab and mepolizumab, and pulmonary rehab to all group B and group E patients. Thank you.
Good evening, everyone. So my time duration is very less, so I would try to keep it short. I would like to go through the slides as fast as possible. So for the first time, I'm seeing my teachers in the opposite side. I would request them to bless me, and then I would like to continue with my slides. So this is the first case. This is a 65-year-old male who is a smoker, who has who is already on treatment with theophylline 150 mg and inhaled corticosteroids of beclomethasone, and he has MMRC grade 4 dyspnea. He also has clubbing, and he also has hyperinflation, and there is coarse crackles in his lungs. And so this is his X-ray. So we see hyperinflation. We see a lot of reticular opacities in the lung as well. So this is the theme of this year, is that if you're short of breath, think of COPD. So are you people thinking of COPD in this case? Or are you thinking of something else? Can we keep it interactive? Yes, no? Yes? No? So these are my options. So what will you do further? Will you go ahead with treatment with LAMA? Will you go ahead with a LABA-LAMA combination, or will you evaluate further? Evaluate further. So what will you do, sir? HRCT thorax? Okay, sir. So in this case, because there were some atypical findings of there was sinusitis in this patient, as well as there was coarse crackles, as well as there was lung clubbing. Clubbing is very atypical in a case of COPD. So in this case, we went ahead with the HRCT of the chest, and where you can see that there is a lot of signet ring appearance in the chest, and there as well. So we did a transbronchial lung biopsy, and then this is what we can see. There is a bronchioles, and there is a lot of neutrophilic inflammation. So this is actually a case of diffuse pen bronchiolitis. We have published this case in Indian Journal of TB and Chest Diseases. So this is a very rare case of respiratory bronchiolitis. Sorry, it's a case of diffuse pen bronchiolitis, and this patient was on treated with long-term antibiotics of anti-pseudomonal antibiotics for 6 months. So colistin was used, and patient improved. So everything that looks like COPD is not COPD. This is what I wanted to highlight. So going to the next case is a COPD, is a 66-year-old male who has a 47 pack year history, and he is cachectic and is in moderate respiratory distress, and he has a barrel chest, and there is scant edema. So this is a case of COPD. So there is on previous history, he had an episode of increased breathlessness, and which he received in oral antibiotics and steroids. His CBC shows TLC of 9,500. So eosinophil count, absolute count comes around 475. So what would you start on this patient, A or B? Fast, can you anyone say A or B? Would you start an inhaled corticosteroid, or would you not in this case? B.
So both options are correct. So actually, this is what Suresh sir had said, that if in the previous guidelines the B option was correct, in 2025 guidelines the LABA LAMA combination with one moderate exacerbation. This is from 2025 COPD goal guidelines. But if we go ahead to 2026 guidelines, so even one moderate exacerbation comes as category in which LABA LAMA inhaled corticosteroid is to be used. So this is what I wanted to highlight. In both my previous speakers have done an excellent job discussing it. So this is the basic study in which they had seen that even one moderate exacerbation has 60 to 70% increased risk of next exacerbation in the next year. So even if when a moderate exacerbation patients come to you with breathlessness, in those also ICS can be considered. So we followed up the patient for a year on LABA LAMA ICS, and he had 2 exacerbations later, even while he was on inhaled corticosteroids. So what are the options available? So basically, this was already discussed in my previous speaker. So roflumilast, azithromycin, and biological therapies are the drugs which can be used. So so in this patient, actually, the eosinophil counts remain more than 300. So in my residency, we started the patient on mepolizumab, and the patient is doing well. So he is in under follow-up. So should I continue or should I conclude? So I have 2 more cases. If you can say, I will conclude. I will continue. So I will continue. Okay. So this I would summarize the case. Here is a case of dyspnea, and so I would like to go to the next slide. So this was the CT which we done. So we can see that there is a lot of emphysema, and the emphysema is heterogeneous. So we can see that it is in the predominant in the lower lobes, and then the middle lobe is almost collapsed. So in this patient, this is a Chartis method in which we saw how much was the lung ventilation, collateral ventilation in the lung. So the valves was used in this patient. So we put a valve in the lower lobe, and then we can see the improvement. So valves have been improved in India since the last September, this September. So Zephyr valves have been approved, and we can use it in patients. So if you see patients with heterogeneous involvement, so we can try using in these patients. So this is the last case. So now I am discussing a case in which there is high symptoms. He has poor exercise tolerance. He has cachexia. His BMI is very low. So even the FEV1 is also less than 15%. So what next? So anyone? Sorry, sir. Sorry, sir. So this is the case in which patient had all the criteria for board index. He had FEV1 FEV1 was less than 12%. His distance walk was less than 150 meters. MMRC was less than 4. So patient had all the criteria of board index. So patient had fulfilled the criteria of lung transplant. So lung transplant is being done in India now. So in my residency period, I had seen 2 lung transplant for COPD patients. So we can keep an eye on it and try on it if we can get COPD patients for lung transplant. Thank you. Any questions?
Thank you, all the speakers, for an excellent presentation. We heard about the ICS LABA LAMA, but I want to ask you one question for one of the speakers. Is there any role of SABA or SAMA in management of COPD? And the next question is regarding the use of ventilation. Are you going to use HFNC or BiPAP ventilation?
Sir, a very pertinent topic question to this topic. First, Saba Sama mostly we are mostly commonly using in exacerbation state, not when the patient is stable. So if the levosalbutamol and ipratropium generally we use in exacerbation, not in a stable state. So the benefit of using LABA is that we can use it in 12-hourly dosing. Now ultra long acting LABA like indacaterol has come, so which act at 36 hours. So OD dosing can be used in this patient. So the benefit of that is that we can use in a single dosing, which is more important. Single inhaler triple therapy is the new go-to, so which we commonly use now. So, and the second question is that there is always a risk of with HFNC and ventilation. So both can be used. We had done a trial in AIMS where we had used HFNC in COPD patients. If the patient has normal sensoria, patient is not tachypneic, or patient has no increased work of breathing, in those patients also HFNC have been tried, and we are in the pipeline of publishing this data. It's in RCT form, so we will be publishing it. Thank you, sir.
Any questions from the audience?
Sir, role of systemic steroid or any steroid during exacerbation of COPD.
Definitely there is a role. There is a during the exacerbation, we generally use prednisolone 40 mg for 5 days if the patient can take orally. But if the patient cannot, then we use 100 mg IV hydrocortisone, 100 mg BD dose.
Sir, is
We are in paucity of time. I declare the session closed.
Thank you.
Yes, sir. Yes, this is very discussing of the diet. Thank you very much for your kind over.
Now let's proceed to our next session. It's my privilege to introduce our chairpersons for this session, Dr. Bhaskar Kantinath, Dr. Suranjit Borua, Dr. Nitin Bhartia, and Dr. Haider Mohammed. I request you to kindly preside over the session. And now may I invite our esteemed guest lecturer, gold medalist, Dr. Pratik Poddar, DM Gastroenterology, to deliver his talk on the approach to functional constipation. We warmly welcome you to the stage.
Thank you so much.
Please go ahead with your presentation, sir.
Thank you so much for inviting me here. It's wonderful to be back in my roots. My mom is from Guwahati, so I'm very happy to be here again to speak on this very important topic, which is constipation. Well, we see it very often in our clinics, but the approach to constipation has to be very scientific if we need to treat it. So often we get patients who keep having constipation. They don't improve. You're giving laxatives, you're increasing the laxative dose, but they keep having symptoms. So in the country, whenever we talk about importance, I think there is cinema and then there is politics. The two things which are always talked about in the country. So whenever cinema talks about something, it becomes relevant. So we had NHL, lymphoma sarcoma of the intestine, which was relevant because of Anand. And then, of course, we had constipation, which was made relevant by a very important movie. And of course, we spoke about it very often. So we'll talk about the ease of doing business and the approach to functional constipation. Now, about defining constipation, it's very important that it is a symptomatic definition. It's not about the number of stools. It's not about the main thing is the patient symptoms, what the patient feels. So difficult, infrequent passage, hardness of the stool, and the feeling of incomplete evacuation. Even if the patient is passing stools multiple times, the feeling is actually very important, either in isolation or secondary. If you look at the prevalence, there's a huge number of patients we have of constipation all over the country, almost 20% of adults overall. And the moment we are aging, we find that this number keeps on increasing. So this number is what we are targeting because there's a female predominance, and most of the patients, 2/3, do not seek any advice. They keep taking OTCs, they do not respond, and they keep increasing the drug and the dose. What is peculiar to the constipation that we have in India? The first thing is the stool frequency is higher. So we get very patients often in our clinic. The patient is saying, sir, I'm passing motions 3 times a day, 4 times a day, but I still feel it's not clear. So this increased frequency, yet having constipation, is peculiar to India. And the stool is also softer. So when we talk about the constipation Bristol stool chart, I'll show the chart. We talk about stool 1 and 2. In India, actually even 3 is considered to be constipation. So this is very important that we have a slightly different characterization of constipation, because the stool weight that we have measured, and this has been done in population studies, the stool weight is higher in India. Our fiber intake is higher. So still we are having constipation because of even in spite of that. So if you see, a lot of patients keep on telling us of self-medicated diarrhea, alternating constipation. So this peculiarity is very common in our country. And if you look at the stool chart, which I show to all my patients, it's very important to have this chart when you're treating constipation. And remember, it's not just type 1 and 2, up to 3 is also considered to be constipation in our country. Now, like I mentioned this, also when we talk about pain and other symptoms, we talk about IBS. Because the main difference between IBS and functional constipation is the discomfort or the pain. Now, in the Rome criteria, which we use for diagnosis of constipation and basically for research, you'll find the newer Rome criteria removing abdominal discomfort, making it pain. But actually, we follow the older Rome 3 criteria because in our country, we still consider it as discomfort. So if the patient is not talking about pain, there is discomfort, still consider it as IBS. But we have more of functional constipation, less of IBS. This dichotomy is important because when you are treating the patient of constipation, the symptomatic treatment is also very important. Just treating the patient's stool frequency is not going to help you. That is why I'm saying that the stool frequency may be higher. So this pain symptom must be targeted properly for the IBS patients, otherwise they will not improve. So antispasmodics have a big role to play in these patients. Now, the risk factors including age, female gender, poor socioeconomic status, lack of physical activity, stressful events, and this is very important. So many females come to us with constipation issues, and there is history of abuse, sexual abuse, so many other issues which are underlying, and they need to be targeted before we can treat constipation properly. Of course, dehydration is an important part of it. And like I mentioned, the important difference between IBS and constipation is the pain symptom or the discomfort symptom, which needs to be looked at in all our patients. Now, what are the red flags? Why red flags? Because these patients who come with specific red flags need to undergo a colonoscopy and imaging test at the earliest. So, new onset constipation in any elderly patient, unexplained anemia, and we'll tell you very small amounts of anemia can be helpful, any bleeding, occult blood test positivity, a family history of bowel cancer, IBD, tenesmus, and a weight loss. All are very significant. These patients require immediate evaluation with a colonoscopy or with an imaging test at the earliest. So, a few interesting cases I've come across, and we'll be sharing that. A 48-year-old male, recent constipation, incomplete evacuation, and a 2 kg weight loss over the last 3 months. So, relatively young in all respects. The USG abdomen was normal, a hemoglobin of 10.2 gram percent. So, any patient who's a male patient coming with an anemia has to be evaluated for that, and the patient was found to have an iron deficiency anemia, and this patient by guidelines must undergo a colonoscopy, and we found a sigmoid mass in this patient. So a very subtle sign of a subtle weight loss and a subtle anemia is significant enough to help us diagnose constipation and diagnose a rectal or a rectosigmoid mass in these patients. This classification is extremely important. A constipation can be functional, that is primary constipation, and secondary to some drugs or some other diseases. This primary constipation mainly of 3 varieties, and this is the reason we classify it, because the treatment will depend on it. If the patient can have normal transit, can have a slow transit constipation, and actually can be having evacuation disorders, and these 3 differentiations are so important to plan further therapy and to find the underlying root cause in these patients. I'll discuss how it works. So if we talk about constipation, very important to see for hypothyroidism and diabetes, 2 very common issues in our country and 2 important things which we miss. Uncontrolled diabetes is a very, very important cause of constipation which needs to be treated. Underlying underlying undiagnosed Parkinson's disease, very important, dementia, very important, can be a very important cause of constipation, can contribute to it. So these need to be treated. We also must need to spend time on the medication. I have seen so many patients now who are simply on calcium channel blockers, who are on simple drugs like ondansetron, which can actually aggravate constipation significantly. So whenever these patients are on it, you need to realize if the patient is actually having a drug-induced constipation, simply removing the drug may actually improve the patient's constipation significantly, and we do not need to actually add on to other laxatives too much. Now, the most common variety we talk about is a normal transit constipation. It's the most common. Stool travels along the colon at a normal rate. It is the patient's misperception of the bowel frequency and the discomfort which the patient feels, which is actually the cause of constipation. And these patients, even with a small rectocele or a small rectal prolapse, can actually have severe constipation, will not respond to standard therapy and standard drugs. And in the functional difficulty disorder, you will find there is incoordination, hypersensitivity, there's abnormal rectal compliance, and the propulsive force also may be poor. And these patients do not respond simple laxatives. What history will they give you? And in constipation, only the listening part can be enough for you to identify a lot of issues. So the patient will say, stool movement is infrequent, there is excessive straining, and they are telling you they'll use the finger to evacuate the stool. So history of finger evacuation is very classical in these patients of evacuation disorders. So it's very important to identify these. Now, whenever we talk about examining, we also do a physical exam. Now, abdominal distension, palpable masses are very important, but the most important part is a digital rectal exam. which we seldom do, but is very, very important. Because in dysenergic defecation, almost 80% of patients can be picked up if you are doing a proper DRE exam. And of course, not always necessary in children, but adults, it is a mandatory criteria in the Rome criteria to do a DRE exam for all our patients who are coming with constipation. We look at the perineal descent, we look at the sphincter tone, we look at the tenderness, and you might just be having an anal fissure and the patient may be having tender anal canal, which is causing excessive contraction of the sphincter. And this is maybe enough for us to diagnose this problem. And of course, problem is the DRE is difficult for the patient, it's difficult for us doctors as well, and the data shows it, because hardly any, if it's seen by data, 15 to 20% is the only number of doctors who do a DRE in the clinic because of a patient who comes to constipation. So what does the Rome say about treating these patients and diagnostic tests? The important thing is not all patients require diagnostic blood tests or scans or colonoscopies. First, a laxative trial should be given after a proper examination and DRE. Once it fails, only then we go for further investigation. What is required? So the bare minimum, a blood count, a thyroid test, a sugar test, and electrolytes. That's all you need, and you have to include a calcium in that. The number of patients I've found with hypercalcemia who've been diagnosed to have constipation, and this is very important to pick up early in our clinical course. What about a colonoscopy? Unfortunately, gastroenterologists are vilified for doing too many colonoscopies, and really, if you talk to me about it, a patient with a chronic constipation for 20 years, 25 years, 15 years, what are we going to find in a colonoscopy? So the colonoscopy is indicated only for the red flags or when therapies are failing and you are suspecting something in the patient. A colonoscopy should not be a first go-to test for a constipation, because I will not be able to diagnose and treat the patient accordingly. We do use radiographs. We use something called a transit time. I'll discuss that. We use balloon expulsion test. So a transit time is actually very interesting, where we give radio opaque markers. The patient swallows it. We do X-rays serially, and we find if it's being passing in the motions. And we do something called a manometry, and I do it in my clinic very often to find out if there's a coordination defect, and that helps us. So gas shadows in the rectum, in the CTs, can help us. But the most important test, which is the first line of the investigation, is an anorectal manometry. You basically insert a catheter in the rectum and anal canal, and the patient is asked, it's a water perfused catheter, now we have solid state as well. It measures the pressure in the rectum and anal canal. The patient is asked to defecate. It tells us what is the pressure being generated in the rectum and the anal canal, and it gives us somewhat like a distant kind of graph. And you see the sphincter is a higher pressure zone, and when the patient is passing motion, this is the balloon there, it gives us the complete graph as to how the patient is passing motions. If you see the type 1, type 2, the anal sphincter canal pressure is much higher when the patient is actually defecating. This is causing the anal sphincter to contract and the patient is unable to pass motion. Just look at this. This is the normal on the left side. If you look at this, when the patient is defecating, the rectal pressure is increasing, the anal sphincter is becoming relaxed. In the second one, where there is dysenergic defecation, the anal sphincter is becoming tighter. How will you treat this patient with only laxatives? Because the sphincter is not improving and you are ending up with a problem. Second case, a 42-year-old male, known cirrhotic CTP7, recurrent hepatic encephalopathy. No other precipitating factor, having recurrent constipation. So we have evaluated the patient from all ends. We've done the scans, we've done if there's any shunts, nothing is there, but the patient is only having recurrent constipation. Lactulose is failing in the patient is having a lot of bloating. So we evaluated the constipation, a manometry was done. Something which we do is called a recto-anal inhibitory reflex. This reflex is a natural reflex present in a patient. You inflate the rectal balloon, the anal sphincter will relax in this patient and you'll get a graph. But in this patient, actually the anal sphincter was not relaxing. This was a case of ultra short Hirschsprungs diagnosed, and we reported this case. This patient had ultra short Hirschsprungs at 42 years of age, and the patient had a full thickness biopsy. So this is the anal sphincter relaxation which was absent in this patient, and we had this. What we do also during the manometry is a balloon expulsion test. A balloon is inflated. The patient is asked to evacuate the balloon, and it lets us know how the balloon is being evacuated. If it is not, that means the patient has a significant evacuation disorder. And of course, we have different cutoffs for finding out if the patient's evacuation is significant or not. And there are multiple ways by which we are modifying this now. We are using solid state catheters. We are asking the patient to do it when the patient is sitting. Of course, there's a very important defecography which we do. The MR defecography is something which we have to use often, especially for cases which are on the border. We are not able to diagnose the cause, and there we find some cases of rectoceles, we find some cases of descending perineum syndrome and enteroceles interception, which may have been missed on the initial evaluation. And all these patients are picked up very well with the MR defecography. And of course, barium we don't use anymore. I mentioned the colon transit study, very simple test. I use it in my clinic very often. We have radiopaque markers. We give the patient to eat those markers, just swallow the markers, and we do serial x-rays, and we see where the markers have progressed over this time. And we see where it's accumulated. It also gives us an idea, general idea of where it is getting accumulated. So it can be either accumulated throughout the gut, or we get certain cases like dysenergification where the accumulation is in the rectum and the sigmoid colon. So this can help us. Other tests are available, scintigraphy, motility tests, wireless motility capsule, but unfortunately these are not easily available in the clinics. Only these 3 tests that I spoke about is rather sufficient to help us diagnose most of our patients of constipation in these patients. A third case, very interesting, 28-year-old female, severe constipation complaint. She's coming to the clinic, she's changing clinics, she's changing doctors, she's changing drugs, but nothing is working. She passes stools once a week. There are no red flags. Evaluated, manometry was performed, manometry was found to be normal, but still saying I'm passing motion once a week. So in that patient, ultimately we ended up with a colon transit study. So the expectation for this patient after the x-ray should have been this, but it was like this. There was not a single marker in the patient the next day. So the patient actually was passing all the markers in the stool, and basically it was a case of Munchausen syndrome. And the patient was actually malingering her symptoms and changing doctors. So this very objective finding we can get of colon transit and let us know. And we've found this in even children. I had a patient who was a young chap. He's saying, I'm not passing motions. The parents are very concerned. They're saying he's going to the washroom and he's flushing, but the poor child is not passing motions. The patient actually had Munchausen, and the patient we could actually diagnose on the colon transit. He was passing all the markers in the next day. So a very important tool in our clinic to find out if the patient is having proper motions. Of course, we have endoscopic ultrasonography, EUS, also for diagnosing the sphincter and their alarms and the things. So if you look at the flow of diagnosis of constipation, the first and foremost, history and examination. Importantly, is the DRE. Very important. Do a digital rectal exam for all your patients. If there are alarm signs, please do a colonoscopy at the earliest or an imaging test. Increase the fiber intake. Now, this is a simple thing which you need to understand, that in India, our fiber intake is already adequate. So increasing fiber may actually increase the bloating and severity of bloating and discomfort. So here we prefer to use PEG, and of course sometimes even lactulose. But again, lactulose, remember, too much of lactulose can cause a lot of bloating and discomfort. This is also a problem. In these patients, the next line is an inorectal manometry and a balloon expulsion which is done with it. If it is normal, is we do a colon transit study like in the young girl. And in these patients, we can either diagnose slow transit or normal transit constipation, which you treat as IBS. And if those patients are having an evacuation disorder, it's abnormal, the patient requires biofeedback therapy, where we retrain the patient to pass motions properly, and the patient will not improve only with a laxative because the patient will not evacuate. For patients who are in the borderline, we do a MR difficography to find out anything. So to take home, keep in mind the red flags, because the moment your patient has even a single small red flag, please send the patient for a colonoscopy or imaging. The drug history is very important to take in all our patients. You may be missing simple drugs like ondansetron or amlodipine, which is causing constipation. The correct therapy should be given at the correct dose before declaring it a failure of therapy. Appropriate stepwise investigation is the most important step, because they may harbor a sinister pathology or even a treatable condition. And put the finger in. A DRE should not be kind of skipped in our clinics. And inorectal manometry, balloon expulsion, and colon transit time is very important. In my clinics, we see so many patients who come with all sorts of therapies. So we have patient taking shank prachalan, enemas, this, that. I mean, I've seen everything in my clinic. But ultimately, there's always light at the end of the tunnel if we go by the right technique and the right examination of the patient. Thank you so much.
Thank you, sir. Thank you for your lucid presentations. So one question's come to my mind. Is there any role of prucalopride, or nowadays Biximot is coming?
Yes. So the newer drugs are excellent. So prucalopride I've been having for the last at least 5 years now. Prucalopride is a good drug, but you need to use the drug at the right place and the right time. So for patients who are actually having the slow transit constipation, prucalopride is a wonder drug for them. I mean, we have patients who are taking 1 mg or even 2 mg. They're having absolutely normal motions. They don't have any other symptoms. They don't require any other drug. But remember, prucalopride also has its own trade-offs. So we have discussed this. There are certain depressive issues, certain neurological symptoms, issues with prucalopride, and some patients have severe headache. They have patients of vertigo, patients who have had vasovagal symptoms with prucalopride. Especially elderly population, we should be very careful in using prucalopride. The newer drugs, linaclotide, plecanatide, Ilobixibate, wonderful drugs. So the response and the kind of evaluation we have done and the usage that we have done, we are seeing good response with all the drugs, especially Ilobixibate. I would say I have had a very good response with Ilobixibate to all my patients in this care subgroup.
The session is open for discussion. Anybody has got any query or question? What is the best approach or best treatment to go for the diabetic gastroparesis, constipation due to?
So this is actually a difficult topic because in diabetic gastroparesis, we do not usually only have a evacuation disorder. They also are having a lot of nausea issues, bloating issues, because there is a pan-gastric, pan-intestinal gastroparesis and intestinoparesis. So the first important thing there is evaluation is tough because in the evaluation studies, scintigraphies are not easily available. You don't have the swallow studies easily available. What I do in my clinic, whenever I suspect this patient to be a high diabetic having a kind of gastroparesis, I call them immediately at 8 hours from fasting. So if I do the endoscopy and I find that the patient is having food in the endoscopy, I immediately think that they might be having gastroparesis. And they improve significantly with a prokinetic, either prucalopride or even with other prokinetics like etopride. Now, the important thing is, again, when you talk about laxatives, just adding on simple lactulose will actually worsen them because they will have more of bloating. So remember that those patients may require addition of a prokinetic. And again, they will tell you that after consumption of these laxatives, they'll have a lot of bloating. Importantly, sugar control is the most important part of it. When they are having HbA1cs of 8, 9, 10, I tell them when you get the sugar under control, it will still take 3 to 6 months for you to see the response because the response is not immediate. So sugar control and addition of a prokinetic is the most important part of this evaluation in these patients. And I use the colon transit study for these, and I find that they're abnormal, so they improve.
Very good evening to sir. Can you please shed some light on whether there is any association of constipation with cannabis use disorder? I recently went through an article.
Absolutely. So I get these patients, I would say, once in a month in my clinic as well. So cannabis use disorder definitely has a significant constipation predominance and unfortunately very difficult to treat. So unless we are going for a proper de-addiction, proper therapy, these patients do not improve. Yes, for them, we do have to use strong prokinetic agents, mainly prucalopride and other drugs in combination. Otherwise, they don't show any response.
Yeah, with this, we can conclude the session. Thank you.
Thank you, sir, for that well-articulated talk. I now kindly request our chairpersons and speaker, sir, to step towards the felicitation area. Moving forward, we now proceed to the HP Borua oration, for which I would like to invite Dr. Sarat Keot, Organizing Secretary, Assam APICON 2025, to kindly conduct this session.
So now it is time for prestigious Dr. S.P. Bor audition. So to conduct this session, I would like to invite Dr. Sahid Ali sir, Dr. Girindranath Gogoi sir, Dr. Deva Goswami sir, and Dr. Kollol Bhattacharya sir to share this session. Now I would like to request Dr. Simanta Madhav Borua to speak few lines about late Dr. H.P. Borua sir. Please come.
Thank you, sir. Late Dr. S.P. Borua. Dr. S.P. Borua was an eminent physician, legendary teacher, a beloved mentor, and distinguished medical administrator of the region. He was born in Dibrugarh on 15 November 1936. Dr. Borua had a brilliant academic career. He completed matriculation from Government Boys School, Dibrugarh in 1951 and ISC from Cotton College, Guwahati, 1953 with first division results before joining Assam Medical College to pursue MBBS course. He graduated with flying color in 1958
and served for a couple of years as a registrar in the Department of Medicine, AMC, before proceeding to England for higher studies. Upon his return to India, he joined as Assistant Professor of Medicine at Guwahati Medical College in 1964. He joined the Department of Medicine, Assam Medical College in 1976 as a professor and became the departmental head in 1986. He assumed charge of the post of principal cum chief superintendent of Assam Medical College and Hospital Dibrugarh in 1988 and also served in the same post later at Guwahati Medical College Hospital, Guwahati. Dr. Borua held several leadership roles in medical fraternity. He was the founder fellow of Indian Academy of Medical Specialties 1983. He was the founder chairman of Association of Physicians of India, Assam State Chapter 1989 and was the chairman of IMA Academy of Medical Specialties, Assam 1993. He also served as a member of Medical Council of India and as Dean of Faculty of Medicine at both Dibrugarh and Guwahati universities during his administrative tenure. He passed away under tragic circumstances on 24th November 1994 in Dibrugarh, leaving a everlasting void in the sphere of medical education in the state and region. His legacy continues to be fondly cherished by his colleagues and students across the globe and serve as a beacon of inspiration for generations to come. Thank you.
Thank you. Thank you, Simanta Maravda. Now I'd like to request to deliver the oration. Now I would like to request Dr. Ranjit Kumar Nath, Director, Professor, and Head, Department of Cardiology, RML Hospital, New Delhi. Please come to the dais, sir. Now, I would like to request our organizing committee members to come to felicitate Dr. Ranjit Kumar Nath, sir. Now, I would like to read a brief citation about Dr. Ranjit Kumar Nath, sir. 34th Assam Apicon Nagaon 2025 API Assam State Chapter, organized by Nagaon branch. Date 12, 13, 14 December 2025. Venue Borgos Resort, Kaziranga, Assam. Dr. Ranjit Kumar Nath, MD, DM, FACC, FESC, FSCAI, FCSI. He is honored for his exemplary contribution to cardiovascular medicine, reflected through an outstanding academic journey and decades of dedicated service. A university rank holder from Assam Medical College, MBBS third position in 1992 after his schooling from Sipazar and a recipient of the Best Research Paper Award at APICON 1998 during his MD at Guwahati Medical College. He completed his DM in cardiology from AIIMS New Delhi in 2005, establishing the foundation of a distinguished career. Selected for the UPSC, Dr. Nath joined Dr. Ram Mohan Lohia Hospital in 2007 and has served with exceptional distinction as Director, Professor, and Head of Cardiology since 2018. His academic legacy includes over 80 scientific publications, 20 textbooks and update chapters, and mentorship of around 25 postgraduate theses. He has been a leading contributor and principal investigator in several landmark international trials and national registries, and has played pivotal roles in major guideline writing committees, heart transplantation for DCHS, recipient of prestigious recognition such as the India Life Most Challenging Interventional Award 2014 and the Best Mentor Award 2023. Dr. Nath is celebrated for his clinical excellence, academic leadership, and enduring impact on the advancement of cardiology in India. He will always be remembered with reverence by the medical fraternity of Northeast India. May his life journey be blessed with sound health and happiness. Dr. Mihir Kumar Goswami, President API Nagaon Branch and Organizing Chairperson, Assam APICON 2025. Dr. Horat Keout, Organizing Secretary, Assam APICON 2025. Dr. Orup Chaudhary, Secretary API Assam Nagaon Branch and Chairperson Scientific Committee, Assam APICON 2025. Thank you. So it is time for the Ranjit Kumar Nath sir to deliver the oration. Thank you, sir.
Before I deliver, I pay my sincere respect to the chairpersons. All are very senior and very seasoned professors, my teachers. So I respect all gatherings. All of you are very close to me because I am from Assam and I want to remain rooted in Assam only. Again, I decided to do medicine only because of one person, that is H.P. Barua, because I was interested in surgery. So while studying, I was more tuned to surgery. I was always thought that I will be a surgeon. Then I met him from a very close counter, because on the day of his demise also I was taking the round with him, because I took the round with him, and Dr. Kanak Barua sir and Dimbeswar Barua sir was waiting in the eye and medicine corridor, and we took round, and last patient was in a nursing home. He left. I came back to the canteen while having the tea. Somebody shouted that somebody has shoot someone. There was firing sounds, and we rushed, and I was amongst the few to reach there when blood was coming out from here, blood was coming from here, and that scene will never go from my mind, because I was there before even police, before anybody came. 3-4 people of us was the first responder, but we rushed him to casualty, but there was no more. 3 close encounters. First MBBS, I probably had a 7th rank, and my senior Nilaksi Mahanta was topper in MBBS. So I wanted to shift it to Guwahati Medical College because I am from Sipazar and I am from a very rural background. And I thought that let me go to Guwahati, because I did not get a seat in Guwahati in MBBS, because my parents wanted I should shift. So I went there. Nilaksi Baido said, sir, I want to do internship in Guwahati Medical College because of some issues. Sir agreed politely. Then I said, sir, I want to shift. He rebuked me like anything. So you have to continue here only. That was my first impression with sir. That was not a very good impression, but I continued, and I felt lucky to continue in Assam Medical College, because I learned more clinical medicine here. Probably shifting would have led me some lay-downs. Second encounter was when we had a student movement and in discretionary quota time. I had a very close encounter with him, and where we had very close fights and rebukes just 5 months before my MBBS final. But I got very good mark in medicine. I was thinking that I may fail once, but I got highest rather in practical, 72% of marks. Then I decided to shift to medicine. Totally, I said no, surgery is not my subject, because the surgical side I did best mark in theory, but I scored only 51% in practical. Then I shifted to medicine. This is my journey with sir. So he's the person who has shifted me and shaped my medicine thinking. I have never seen a person
There will be more, but I never had a close encounter of a person of medicine who knows so much. Even if he doesn't know, then also seeing him looks like as if he knows the whole Harrison, whole British medical, everything. So that the aura he used to carry with him. So we are very fortunate to have attended his clinics, his rounds. So that's how it is. So I thank Apicon Assam, Apicon Nagaon branch especially, and Saurabh in specific, because I have been here because of your request, and I never say no to all these approaches. Initially, I was said I need to say about HOCM. I said even I see very rare cases of HOCM. So why to speak on HOCM where physicians will not benefit that much, because very rare patients. So I thought let's speak on the topic which we encounter very commonly, that is chest pain. You see, chest pain is one of the most common reasons for which patients seek medical attention in emergency or OPDs. But only 15 to 20% of acute chest pain actually have acute coronary syndrome. Remaining 75 to 85% are non-cardiac or non-anginal. So actually can be managed without seeking a cardiologist intervention. So all physicians can actually treat around 80% of chest pain. So but the problem is that once a chest pain comes into the emergency or into the ward, we all start thinking that it is cardiac. It's cardiac. So there is a delay also in treatment, and unnecessary patient expense also involves. Even in ACS patients, majority can be managed, and if we follow a proper algorithmic management route that we can manage with medicines, except two situations, that if you got a ST elevated MI patient and you got a cath lab also in the hospital or cardiologist, that patient should be managed by a cardiologist, because primary angioplasty is said to be better than thrombolysis even today. Second is that if it is an non-ST elevated MI, but he is very high risk. I'll just show one slide how to assess high risk. If high risk, then intervention will help him. Otherwise, all patients can be managed medically. Remember, medications we jump immediately to give, that actually can be counterproductive, because if you give aspirin to a patient who has developed an aortic rupture or aortic dissection, can be counterproductive. If you have a pleurisy, some effusion, you give high dose aspirin and copitugal, he may convert to hemorrhagic effusion actually. So, or you've got a gastroesophageal reflux disease, you give 325 milligram aspirin, and you end up having this patient in gastroenterology referral, endoscopy, and everything. So, initial assessment of chest pain is so important. Remember, this is a very important paper published by Faudgard et al. More than 10,000 emergency visits they seen, and they saw that there is commonest cause. You can see gastrointestinal is the commonest cause, 42%. Ischemic heart disease, second common, 31%. These are all adult patients, more than 50 years. Chest wall syndromes like Treat syndrome or costochondritis, pericarditis, 4%, pleuritis, pulmonary embolism, lung cancer, aortic aneurysm, aortic stenosis, and herpes zoster. These are the patients coming to emergency with chest pain. Remember, these are more than 1%, and less than 1% includes aortic dissection and other conditions. So the list itself says that all chest pain are not coronary. So what is the chest pain of concern? So if there is a substernal chest pressure or tightness, it may radiate to jaw, neck, or left arm or back, often described as heaviness or squeezing. This pain, if these things are produced by the patient, we need to think that it may be an ischemic chest pain. These pains, acutely if they come, it can be cardiac or non-cardiac. Chronic chest pain or chronic stable angina are effort angina. They are actually a same pattern every time. He will say that I go for the morning walk. After around 100 meter, I need to slow down or I need to sit for some time. Then I can continue 5 kilometers. This is classical of an angina. It is the same pattern every day it will happen, and it is reproducible. Remember, if you don't take care of the acute chest pain, 15% of patient will again come up within next 3 months that I am having again an attack. So that is a second window. Sometimes we get around 15% of patients. Chest pain, if it is associated with dyspnea, patient says that I am feeling breathless, their saturation is low, or it is hypotension. These three are the red flags. So these three things we need to look for, that either it's an acute MI with pulmonary edema, or it's a pulmonary embolism. That we have to remember that all chest pain not MI. It's a pulmonary embolism that we commonly miss, even cardiologists also miss. acute aortic dissection with severe AR. This severe AR leads to pulmonary edema because the left ventricular end diastolic pressure is very low. In that patient, when acute AR comes, they are not tolerated, so they are pushed out into the pulmonary veins. That leads to pulmonary edema. And last is a fulminant myocarditis. If a patient gives a history of prodromal fever, he was feeling not good, he or she, or a case of SLE already on steroid, now comes with acute chest pain and you have got a hypotension, desaturation, this is fulminant myocarditis. These four red flags has to be known, and if it is not there, then we can proceed. If it is substernal, as I already have described, these three factors has been given, and if all three are there, then we call it nowadays typical chest pain. Remember, the angina term has been removed from last year. All angina term has been taken into chest pain. So we don't call it nowadays angina, it is called the chest pain. So if it is all three characters are there, then it is called classical or typical chest pain. If two of three is there, then we call atypical chest pain. Still, they can be cardiac. But if less than two, only one of these three is present, that it is mostly non-cardiac. So if you got if you follow this, actually 85% of a patient can be excluded from a classical angina physiology. Causes of ischemic pain. This need to be remembered. Remember, CAD or atherosclerotic plaque obstructing coronary, this is the atherosclerotic CAD, that is the number one cause. There is some non-atherosclerotic cause of chest pain, which are situational, like a coronary vasospasm or squeeze metal angina. You get an ECG, SC elevation, diffuse, you call resident, this is an MI. Now, next moment you do an ECG, patient says, my chest pain gone, my chest pain is no more. You do a ECG, find normal. So this is metal angina. Problem is, if we give a beta blocker thinking that this is chest pain of coronary or MI, this metal angina will prolong, it will not relieve because this is contraindicated. That's why situational, and we have to diagnose properly so that we can treat properly. Second is microvascular dysfunction. That leads to a lot of chest pain, but you do a lot of tests and you find it negative. So that is one of the important factors. I have enumerated causes according to according to preponderance. Spontaneous coronary dissection, that is non-atherosclerotic. It specifically happens in postpartum women. They develop severe chest pain and ECG elevation. That is because of a coronary artery dissection, which is spontaneous. They are also common in fibromyalgia, fibromyalgia dysplasia patients also. Coronary artery anomalies. So if a boy or a girl comes every day after heavy exertion or playing something like tennis or football and says that I get chest pain, that is because at a higher level of exercise, the coronary artery, which is arising from opposite side or anomalous, like left anterior coronary arising from right side and goes in between aorta and pulmonary artery, they get compressed because of a heavy level of exercise when BP is high, pulmonary pressure is high. That sort of situation needs important evaluation because that is coronary artery anomaly, it can be. Coronary embolism in atrial fibrillation or LV thrombus situation. There is a condition called Takotsubo cardiomyopathy, that is stress-induced acute acute ischemia that leads to an aneurysmal LV apex. Myocardial oxygen supply demand mismatch. This term need to be remembered because this is called type 2 MI. Then arrhythmias leads to some chest pain, and aortic stenosis and HOCM. These two are structural disease that causes classical chest pain. So these are the causes of ischemic chest pain. Now the important slide is the non-ischemic chest pain. If we go to this, most of you know I have just summarized. Most common is the pleuritic chest pain, which are sharp, stabbing, worsens with breathing, found in pleurisy, pulmonary anemia, or pericarditis. Esophageal GERD, gastroesophageal reflux disease, they happens most commonly after meal and with recumbency or at sleep. If you lie down, there'll be more problem. Relief with nitrates, that is the most common problem. That's why, because patient comes to emergency, we subscribe gives to nitrate or NTG drip, they get relief. Then we think that it may be coronary artery disease, but even GERD also gets relief with nitrate. Aortic dissection. So aortic dissection is the disease where even I can't treat because I have seen a patient who has come with aortic dissection. I asked him to get admitted in CCU. Before a bed could be vacant, he died. So aortic dissection is sometimes very difficult to manage. So that's why we have to remember that this is not the patient to be managed. But if we can diagnose properly, that can give a window of opportunity for proper treatment like surgery. It's a sudden onset severe tearing chest pain. Often radiates to back, abdomen, or neck. may get cardiac tamponade or acute severe AR quickly. So these two conditions actually worsens very quickly, either cardiac tamponade or acute AR. Risk factors are present, mostly elderly, hypertensive, or they have got a fibromuscular dysplasia or Ehlers-Danlos like connective tissue disorders. Those are the risk factors. And if you examine properly, then you may get a pulse deficit. One hand pulse is there, other hand pulse is not there. There can be a differential BP. One hand BP is high, other hand BP is low. There may be a new murmur of short diastolic murmur of aortic regurgitation, and there can be focal neurologic disease. If that dissection involves one carotid artery, suddenly there may be focal neurological deficit. If you remember these four factors, then sometimes we can clinically diagnose aortic dissection and we may save a patient. Next comes pericarditis. These are sharp pleuritic chest pains, improves with bending forward. That leads to improvement and worsens with lying down, lying supine or deep inspiration that can lead to worsening. They may reduce to trapezoid ridge and actually preceded by a viral prodrome. So European Cardiology Society has given guidelines. They say that if four factors are there, like this classical chest pain, if there is a friction rub, there is some effusion, and if there is in ECG, you see a widespread ST elevation with PR segment depression. Any two out of these four factors, pericarditis diagnosis is nearly 90% sure. So that's also a clinical diagnosis. So an ECG will help us if it is, or an echocardiography possible will help us if pericarditis is there. Pulmonary hypertension sometimes comes with acute chest pain, but they will have dyspnea, fatigue, syncope, edema, loud P2, banging P2. All these things are there associated, so diagnosis should not be a big problem. As I said, myocarditis, they will have febrile prodrome, they will have dyspnea, they will have dull pain, and it will be a constant pain. Pneumothorax is another cause. Pneumonia is another cause. And last most important is the costochondritis. There is sharp reproducible pain localized to second to fifth costochondral junction. Females, mostly 40 to 50 years are common. People who exercise or recent trauma, microtrauma, all those are patients who can develop this syndrome. So coming to how to differentiate acute pericarditis, because as acute pericarditis leads to ST elevation, and we are more concerned with ST elevated MI. So how to differentiate acute pericarditis versus STEMI? So three questions should be asked. Is there ST depression in lead 1 other than AVR or V1? If yes, then it's just MI. So if you go by 2 ECG, this is a case of MI, this is case of pericarditis. Now, first question is there an ST depression any lead other than AVR and V1? Now you see lead 3, there is a significant ST depression. There is some ST depression 1 millimeter in AVF also. In reciprocal changes, these are called reciprocal changes of ST elevation in anterior leads. So reciprocal leads will have ST elevation, reciprocal lead will have ST depression. If both are present, then it is an MI. But in the second ECG, there is no ST depression. So there is no ST depression. So pericarditis diagnosis goes to the favor. Second question to be asked is there convex up or horizontal ST elevation? If yes, then answer is STEMI. Convex up means like this ST segment. Concavity upward will be pericarditis. So if you see second ECG, this is pointer is not working intermittently. It is concavity upward with ST elevation. So this is pericarditis. But here you can see convexity also, concavity also there, but convexity also there. So it is a case of STEMI. Third is there ST elevation in lead 3 greater than ST elevation in lead 2? If the answer is yes, then it is acute MI or STEMI. If it is not there, then you can consider for other algorithm. Then we go for this criteria ECG finding. ECG is diagnostic in pericarditis. First is called absence of spodioc sign. Spodioc sign is ST depression from T to P. Classical T to P ST depression is spodioc sign. You see, nothing is occurring in clinical medicine. So it is not absolutely, but 95% of patients you will not get there, but you will get there in pericarditis frequently, spodioc sign. As I said, convex ST elevation. As I said, check mark ST elevation. This check mark happens because one of the common cause of QT shortening is acute MI. This QT shortening happens because cardiac myocyte lysed, so calcium comes out from intramyocardium to the circulation. So local hypercalcemia leads to QT shortening. That leads to this as not touching descending limb of R not touching even baseline starts ST elevation. So that is called check mark sign. This is classical of an ST elevated MI. ST segment depression. You see, this is ST segment depression, which is you will find more commonly in MI. You will not get in acute pericarditis. ST elevation in lead 3 already I said, and absence of PR depression. If in pericarditis, next point to see is that if the PR segment is depressed, then isoelectric line. Isoelectric line, if you draw middle of the T to middle of the T, you'll see that PR segment is down. So these are the few classical signs by which we can diagnose pericarditis in emergency department itself on a single ECG. So if we follow this algorithm, you can diagnose definitely pericarditis and you can treat accordingly. And need not to give aspirin because aspirin can cause hemorrhagic pericarditis. Another important emergency visit of chest pain is pulmonary embolism. Now this ECG, both the ECGs, if a come with a 50-year-old lady who otherwise was normal, from 1 or 2 days she says that she's sick, you'll think this must be MI, there is some ST elevation, there is so much of tachycardia. Do you have a better pointer? So you see the classical diagnosis of a pulmonary embolism is there will be disproportionate tachycardia. So both the ECG, you can see this is a severe form of pulmonary embolism. This is a moderate form of pulmonary embolism. Here you see severe form of tachycardia is going on. Then there is a sign called S3. S wave is deep, and Q3. Q wave is present in lead 3. So S3 Q3. Otherwise, you don't see any other Q. If you get this ECG, that S wave is there only in lead 1, nowhere in such deep S1, and Q wave is there in lead 3, then you think that this is pulmonary embolism rather. And severity, if there is RBBB, right bundle branch block, because in pulmonary embolism, all of a sudden RB pressure goes up. So this high pressure leads to neurotomesis of right bundle, because right bundle is very small and very superficial. That pressure causes neurotomesis or neuropexia, whatever you say, in long term. That leads to right bundle branch block. And last is pressure overload leads to ST depression in your chest leads. This ST depression is because of pressure overload in the RV. Now, if you see this is classical pulmonary embolism. You have to look after, you need not to do any other echo even, you have to do a CT angiography to think whether to thrombolize or whether to not. Because unless they are having hypotension significant or cardiogenic shock, thrombolysis is not needed, only heparin is sufficient. Antiplatelet and heparin is sufficient. Now, this is easy. You see again S. Here it is wide and deep. Here it is C. You get a S, and you get a Q again 3. But here RBBP is not there because it's a moderate form of the whole pulmonary artery, probably not marked with a thrombus. Still, there is not so much of high pressure that it has led to RBBP. That's why that is moderate variety of. Even ECG will say whether it's a massive pulmonary embolism or a moderate variety of pulmonary embolism, we can diagnose with this. So we need to go for chest pain again. That's why I say if you get the chest pain with this side of qualities, central pressure, squeezing, gripping, having, they are more commonly towards coronary artery disease. But if you go towards the opposite side, the sharp, flitting, shifting, pleural, positional, most likely not. So that algorithm given by ACCH is very useful. MI has been classified newly, not very new, but 2021 MI has been reclassified. So if it is a spontaneous plaque rupture leading to coronary occlusion, we call it type 1 MI. If it is secondary to an ischemic imbalance, means oxygen is required by myocardium, but supply is less. There is no obstruction as such. This is called type 2 MI. And type 3 MI is, there is a patient, there is a situation that he was sitting here waiting for a bus, he collapsed, he died. We don't have any evidence. We call it type 3 MI. This is for medical purpose, it is important. Otherwise, type 1, type 2 is our concern. So again, definition, when we were students, even when I was doing DM, the definition was classical chest pain central, and that causes diaphoresis and all these things will be your MI, but that is not there. Nowadays, it is the rise and fall of cardiac troponin. No CPK, no CPKMB. You have to do cardiac troponin because you have to be specific nowadays. At medicine at advanced, so you have to be very specific. Rise and fall of cardiac troponin, along with symptom of myocardial ischemia, that is chest pain, new ECG changes, or developmental Q wave or invasive, invasively you can, or echo you showed that there is some segment of heart is not contracting, or angiography showed that there is a thrombus. These are the things, any one of these along with rise and fall. See, all these are not required. Any one of the slight symptom of myocardial ischemia is there, but troponin elevated, then it is an MI. So new definition of type 1 MI is this. Type 2 MI is more important actually, because majority of MI is type 2. That is, they have got another disease, like they got admitted in the hospital ICU for fever. Now the ECG developed, patient is saying chest pain, ECG developed, changes, ST depression, troponin is positive. Problem is there is no obstruction, but the tachycardia, the inflammatory milieu, all these things has caused requirement of oxygen more, but supply is getting less because patient is infected, lung is gone, oxygen supply is not proper. So all these things. So this is called type 2 MI. So most of the patients you attend for chest pain in your ICUs are actually basically type 2 MIs. And here what happens if you go for an angiography or a CT angiography in this situation, the chance that we may lose the patient chance is more, because that will lead to further organ dysfunction like renal failure or other things. That's why we have to understand that this is not type 1 MI, it is type 2 MI. It needs stabilization, it needs antiplatelet, it needs heparin or claxin, but it doesn't need further. It doesn't need high dose statin of 80 milligram. It doesn't need a CT angiography. That point should be remembered. How to diagnose ST elevated MI or ST depression? So again, these things are newly defined in our societies. In absence of a left ventricular hypertrophy or LVVB, you have got a more than 1 millimeter ST elevation in all leads except V2 and V3. V2 and V3 has been given more weightage in present ECG. So in V2, V3, more than equal to 2 millimeter in man more than 40, and more than 2.5 millimeter in less than 40 years, and 1.5 in case of women of any, regardless of any age. So 1 millimeter, all are less than V2, V3, according to age and gender that has been defined by all our societies. And ST depression, same, if it is more than 0.5, ST depression is sufficient. So as I already said, that you have to, you know that there is QT shortening. That's why your descending limb of R has not touched baseline before ST elevation happens. That's why it is a correct mark sign we say. In clinic, if we remember in emergency, what are the other causes of ST elevation that will help us? Because quick check will lead to 50% of patients to be excluded as ST elevated MI, which is most dangerous, like prismatal angina, I already said. These are brief ST elevation that normalizes quickly. Pericarditis, early repolarization syndrome. Young patients, short QT with an early ST elevation, that is called early repolarization syndrome. Raised intracranial pressure, LV aneurysm or Brugada. In Brugada, you get V1 to V3 ST elevation that leads to sudden cardiac death because of ventricular fibrillation at night. So these are the causes of ST elevation. ST depression, you know, LV, hypertrophy, strain pattern, hypertension, hypertrophic cardiomyopathy, digoxin, or hypokalemia. These are the commonest cause of ST segment elevation or depression. If you remember those, most of the time will lead to not diagnosing them as MI, because alternate diagnosis will be available with you. So in an ST elevated MI, ECG is normal. Sequence of things happens. There will be hyperacute T waves. This sense happens because when says, remember, V1, V2, V3, AVR, these leads are called limb leads. They are bipolar. So micro voltage sense in anything is not detected. It is a plus minus ultimate voltage sense that will be picked up in the limb leads. In the SES leads, it's a unipolar leads. You put exactly over the heart. So they will show you the things that are happening just beneath the electrode. So that's what happens whenever there is an acute MI. I already said that there is calcium release that leads to hyperkalemia transient, that leads to your shortened QT. There is potassium release from cell that leads to localized hyperkalemia. That's why T wave is like hyperkalemic T wave. Localized hyperkalemia that leads to T wave. Most important, ischemic. If you want to know that how to differentiate ischemic T wave. Actually, normal T wave, upstroke is slow, downstroke is fast. Upstroke is low, downstroke is fast. But in MI, it is upstroke and downstroke is equal. So that is the equally upstroke and downstroke is equal. You've got a hyperacute T, you think of MI. Classically, this is an MI. then you can see that there is ST depression, 1 AVL reciprocal changes, 2, 3 AVF. This is ST elevation, or this is an inferior wall ST elevated MI. So these are the things that we commonly see in our emergencies. One topic that is STEMI equivalent, ST elevated MI equivalent. They are not diagnosed in emergency, but they are actually, what are those? They are called De Winter's T-wave, Whelan syndrome, posterior MI, left main coronary occlusion, Garbus's criteria in presence of LBBB, and isolated RVMI. These are the things that we call nowadays STEMI equivalence. Whelan syndrome is one where angiographically it was found that LAD is 100% occluded, but they were not diagnosed as XT elevated MI. But although there are two types, Whelan's 1 and 2, 75% patients like this, there is no ST elevated 2 millimeter V2, V3, but deep T, symmetrical T inversion. These are, and Whelan's 2 is a biphasic T wave. These are also nowadays classified as STEMI equivalents. There is another called De Winter ECG. There is depression of ST, then quickly ST elevation. You see the ECG 12 lead. You see there's some depression of ST, then quickly ST elevation. These are called De Winter ECG. This is also an ST elevated MI. I will say about this ECG, which is very important, that how to diagnose STEMI in presence of left bundle branch block or pace rhythm. So here what happens that if you see there the point system is given, this is where Sarboza's criteria. They have given concordant ST elevation 1 millimeter. If the RS wave is this side and same side 1 millimeter ST elevation, they have given highest point of 5 points. Discordant ST depression more than 1 millimeter. ST depression more than 1 V2, V3. Any ST depression in V2, V1 to V3, 1 millimeter, they have given 3 points. And discordant ST elevation. Discordant means R is this side, ST elevation is this side. If it is more than 5, they have given 2 points. So total of 8 points. But Smith has modified these 5 points. So Smith said that this discordant ST elevation should be 25% of this R wave or S wave. If it is more than 25, then so these things helps us in LBBB diagnosis. Now in emergency, if a patient comes with chest pain, how to proceed? ECG is non-diagnostic, but patient has got chest pain. ECG is normal because 25% of patients with acute MI may have a normal ECG other than ST elevated MI. So then we have to take the help of troponin. So troponin concept is, it is the defection of rise and fall. So you see this is called level of baseline. So here some troponin is released, but you cannot detect it because some myocardial cells are dying because of apoptosis, because of injury, inflammation, some is dying. So some troponin is released, but it is level of baseline. Level of detection. Now the point crosses, then you start detecting, but all detection may not be MI. Then comes level of quantification. Here you can quantify how much is detected. This concept has come because as this patient is MI, his MI started here, and in MI or any ischemia, time is muscle. So that's why we want to detect this patient earliest so that we can intervene, not to wait till the peak comes. That's why this concept has come. So how to do this? Because you can see these levels are so much different that at different timeline a patient can have different levels. So how to do diagnose? So if a patient comes with chest pain, you do a troponin. If it is negative, then you have two options. Either you are clinically so sound and you can send him home because you are sure it is Treat syndrome, you are sure it is pericarditis, well and good. But if you are not sure, then there should be second troponin done. If you are doing a troponin qualitative or strip test, that it should be done after 6 hours. If that ECG, that troponin also negative, then you can discharge the patient from emergency. But 6 hours sometimes in emergency, bad issues comes. That's why what we do nowadays, we do a 0 and 1 hour algorithm. We do 0 hour and we level the troponin. At 1 hour, again, we do a troponin. If the delta is more than 5 nanogram, then we say it is ischemic. If delta is less than 5, so this increase in 1 hour is called delta. If it is more than 20, this is definite of MI. If it is more than 5, so this number says that if delta was less than 5, that was 3, they discharged it and nobody actually turned up to be MI in the next 24 hours. They observed intermediate, and if delta was more than 5, majority of them has diagnosed subsequently to be MI. So if you have bad trance, you cannot keep all patients of suspense 6-8 hours. This concept is better, that you do a baseline troponin and you do a 1 hour or 2 hours. ESC says that you can do 1 hour is good if you have got a bad crunch. If you not that much of bread crunch, you can do a 2 hour. And if you see the delta is 20, in 2 hours it is definitely 20. In 1 hour it is 5. Really. If you say the delta is 20 nanogram per ml elevation, you have to think that this is MI. You can start the treatment. So time is muscle, so you can save more lives. Then you can do additional tests, CT angiography, TMT, everything. If it is non-diagnostic, you don't want to say. Additional test depends upon the concept of pre-test probability. If a person, 30-year-old girl comes to me and says chest pain, and you do a TMT, TMT comes positive. So that is pre-test probability. You are thinking that it will come as negative. So negative will be confirmatory for that lady. But if it comes positive, so it will be false positive. In a high probability situation, you know a 60-year diabetic has come with chest pain with ECG changes. Now your TMT comes as negative, so it will be a false negative. So these two extremes, other tests are not helpful. So only in intermediate region where pretest probability is intermediate, not that strong, not that weak, their additional test will be helpful. Most pretest probability, if it is less than 5% pretest probability, there is no compelling reason to go for any other test. If it is less than 15%, only 1% turns out to be cardiovascular events in next 6 months. So pretest probability is the most important thing. So pretest probability after lakhs of patients, this is the chart given by ESC, that if the pretest probability is very low, you can manage OPD basis, you can call for a regular TMT. You need not to go for emergency procedures. That's why this pretest probability has been given to us, and we follow these pretest probabilities. Remember, CT angiography, if it is available in emergency, can be helpful. So CT angiography sometimes is very helpful. There are a lot of studies has been done where it is seen that CT angiography in non-diagnostic chest pain helps in reducing hospital stay, helps in discharging early discharge from emergency. As I said, I'll say only one slide about non-STEMI. If we have got some features like presentation, clip, blood pressure, heart rate, age of the patient, and creatinine level, if these things are there, then we classify them as low risk, intermediate risk, or high risk. High risk patient, I said that an intervention cardiologist need is there. Otherwise, in low intermediate, medicines are sufficient to treat non-ST-elevated MIs. Same is another is the TIMI score. It is total clinical. There is no need for any only known CKD patient. Same, but we follow more of the nowadays the gray score. But still, then this is another score whereby you can see whether it's a high risk or low risk, and you can basic common management. If it is a cardiac chest pain, now I come to basic cardiac chest pain. It is a cardiac chest pain, acute chest pain. You can give morphine injection for pain killing. Oxygen should not be given if the saturation is not less than 90%. There's been 2 trials conducted international, AVOID trial and detox AMI trial. Both trials says that if you give oxygen to all patients who has got saturation more than 90, it's harmful. Rather, infarct size in MRI has been found to be larger, whom oxygen was given for 2-3 days. So oxygen is not needed if it is saturation is not less than 90%. Morphine is needed, nitrate is needed, aspirin can be given once you establish that this is coronary chest pain. Aspirin can be given, and the P2Y12 should be given to all patients. Then we should give statin. What are the anti-P2Y12 inhibitor given? So you have 3. You know it that clopidogrel, prasugrel, and ticagrelor. But only clopidogrel should be given in few situations. That should be remembered. Rest of the things is not needed to be remembered. That if you are planning to thrombolize the patient in a STEMI, then you don't give any other drug, give clopidogrel. If your patient is very high risk for bleeding, like CRF, today it was discussed a lot of CRF, CKD. If they're very bleeding high risk, a frail lady, elderly, so you don't give other, you give clopidogrel single tablet 75 milligram. If they are prior IC bleed, if the patient is already on NOACs or oral anticoagulant because of an atrial fibrillation or other issues, only give clopidogrel. If patient has any prosthetic valve in heart, and if you are planning for medical management only for that particular patient, it is better to give clopidogrel. It is safe. So this is about the antiplatelet drugs. You always should give other things like heparin or claxin. I am not going to go this. Other drug is most important, lipid lowering. You know the targets AC or ARB if the BP is high. and beta blocker as you know, or mineralocorticoid receptor antagonist. A proton pump inhibitor should be, once a dual antiplatelet is started, a PPI most safe is propanol, pantoprazole should be started. So drug therapies, I am not going to say about thrombolysis. Most of the things are known. I will say only chronic stable angina, a few words. Chronic stable angina was that person who goes to the field, equal amount of exercise, he bots in some chest pain, he takes rest, it goes up. These patients, what it is says that lifestyle measures and guideline directed medical therapy is sufficient and first line drug for all chronic stable angina. So they don't need a cardiologist intervention at all. What are ZDMT? It includes antiplatelet, aspirin only, aspirin mostly. Clopidogrel if the aspirin is contraindicated, like any aspirin allergy, or like the patient has got a gastric ulcer or something, or you had a history like that. So in that case, you can give clopidogrel. Otherwise, aspirin only should be given. Beta blocker or non-dihydropiron calcium channel blocker like diltiazem should be given. Along with that, ivabradine, if you are not being able to bring heart rate below 70. Remember, it should be resting heart rate should be below 70 in chronic stable angina. So if beta blocker or diltiazem is not bringing in, then add ivabradine. Dihydropyridine calcium, that is amlodipine or that group, and AC inhibitor ARB should be given pressure optimal level. Optimal is 120 to 130 systolic, 70 to 80 diastolic. Statin to keep lipid in target, and anti-anginal drugs should be started if angina is still not going in your first visit. Fifth drug should be added, or anti-anginal should be in the second visit. First visit, majority of the patient, 70% of the patient will get relief of angina. Anti-anginal should be given, nitrate first line, and you can use nicorandil, ranolazine, or triamcinolone as second line of drug. So these are the things that can be done, and all chronic stable angina patient, majority will. Now, why we do intervention? We do intervention to reduce the burden of angina. If a patient is going to hospital repeatedly for angina, we do intervention. Otherwise, it is not needed, not indicated. Why not indicated? Because these are the bombastic trials that has been conducted, whether medicine is better or angioplasty or CVG is better. So, Courage trial, Bari 2D method diabetic trial, FAME2 trial, Orbita trial. In fact, Orbita trial is the most challenging trial where even medicine patients also was brought to cath lab, was put some wires so that patient cannot, or other people, it is double-blinded trial. So this is called SAM control trial. So, and last is the ischemia trial, which is a nail in the coffin sort of trial, where I was also PI and I recruited third highest patients from India. So we saw this algorithm and we found that all patients on medicine, guideline directed medical therapy group, fared much better, less death, less acute MI. So that's why I am saying with conviction that all chronic stable angina doesn't require or angiography or angioplasty or CVG at all. So this, as ischemia, I said I was part of the study. It's the largest trial of coronary intervention where we have analyzed the data. What happens to the patients when we send for angioplasty or bypass? You'll be surprised to see that even anatomically controlled group may only 43% actually had complete revascularization. So actually, cardiologist or surgeon is not doing the great job because they are putting grafts of stent only where he or she can. But rest of the things are not done. So angina is produced by myocardium. If one segment you don't do revascularization, that will still come with angina. Maybe burden will go down, but still will come. So fractional flow reserve mediated assessment also showed that it is only 58% was getting revascularization, others not. So that's why I'm saying you are sending patients to a surgeon or cardiologist, whether they are doing a fair job is not known. So that led to increased problem also. Ischemia burden after a year of revascularization did not go up. Medicine fared much better. That's why I'm saying that medicine can use to treat. So to conclude, chest pain needs proper evaluation in emergency room, keeping in mind that 75 to 80% of the chest pains are non-cardiac or non-coronary. ECG and quantitative troponin, as I said, 1 hour or 2 hour algorithm is the mainstay of early diagnosis of CAD. Subsequent tests, if needed, depends upon pre-test probability. You can do a pre-test probability check. If you still find that patient is at high risk, you can go for a subsequent test. Coronary CT angiography, if you have in the selective patients, will help you to early discharge and need to be careful early medication. As I already said, patient is aortic dissection, you are giving aspirin. So that can be counterproductive sometimes. So that's why we have to be very carefully starting the early medications, otherwise it will be counterproductive. Thank you very much.
Thank you, Professor Nath, for your illuminating talk. That was a great deliberation for us all. We have learned many things from your deliberations. But as there is no scope of questioning to the guest lecturer, so that part is over almost. Now, we just can commend with a big applause. I propose to the House with you. So thank you, everybody. And I hand over the mic to the organizers.
Thank you. Thank you for that enlightening session. I would like to request our chairpersons and speaker sir to kindly move to the felicitation area. Moving forward to our next session, it gives me great pleasure to introduce the chairpersons for this next session, Dr. Deepak Chaudhary, Dr. Srimanta Madhav Borua, Dr. Anamika Chaliha, and Dr. Mukul Sharma. I kindly request you to grace the dais. I request Dr. Deepak Chaudhary, Dr. Srimanta Madhav Borua, Dr. Anamika Chaliha, and Dr. Mukul Sharma to kindly grace the dais. I'm also delighted to introduce our speaker, Dr. Dujain Das, who will talk about the approach to a case of pancytopenia. We kindly invite Sir to begin the talk.
Should I go ahead? Okay, thank you. Good evening. At the very outset, I'd like to thank the organizer for giving me the opportunity to stand before this August gathering. I've been allotted to talk on an approach to a case of pancytopenia. At the very outset, I've got a disclaimer that I don't have any conflict of interest in my presentation. So everything that we'll be presenting is from the review of literature only. At the very outset, what is pancytopenia? We all know the pancytopenia is basically characterized by three components. One is reduction in the hemoglobin less than 12 in female and less than 13 gram in males. Total count less than 4,000 per cubic milliliter, and the platelet count if it is less than 1.5 lakh per cubic milliliter. So pancytopenia is basically a manifestation of an underlying disease, but it is not a disease. The underlying disease may be a malignant or it may be a benign conditions. Now the pancytopenia can cause because of either decreased production or it may be because of increased destruction of the cell in the periphery. So a thorough evaluation may be necessary many a time to know what is the cause of pancytopenia. Now, if you come to the etiology, what are the common etiological factor of pancytopenia? The pancytopenia may be because of either impaired production of the cells in the bone marrow, or it may be because of increased peripheral destruction, or there can have a combination of both these. So if there is impaired production, what are the different causes you can think of? It may be because of aplastic anemia, which can be congenital or can be acquired, or it can be because of bone marrow infiltration like myelofibrosis, granulomatous disorder, or metabolic diseases, or maybe because of nutritional deficiency like vitamin B12, folic acid, and copper deficiency, or it may be because of myelodysplastic syndrome. In peripheral destruction, most of the time it's because of autoimmune hemolytic anemia, or it can also be seen because of the splenic sequestration. The conditions where there is involvement of both the pathway, decreased production and increased destruction, that can be seen because of the PNH, or it can be seen in autoimmune disorder like lupus, maybe because of some drugs, leukemia, and HLS or MAS, macrophage activation syndrome. It can also be seen because of transfusion associated graft versus host disease or many infective conditions. Now, if you go for the epidemiology of pancytopenia, it may have the bimodal presentation, which has got common one is the children, and in adulthood, it is commonly seen in third and the fourth decade. Males has got relatively more preponderance than of females. The common causes in India of pancytopenia are mostly hypersplenism, infection, and myelosuppression. This is a recent trial. Prior trial a few years back, megaloblastic anemia was found out to be the commonest cause of pancytopenia in Indian scenario. Now, what is the pathophysiology of pancytopenia? So it depends upon the underlying cause. The different cause may cause to different way of development of pancytopenia. Now, if it is because of drugs, say for example, methotrexate, anticonvulsant, or chemotherapeutic agents, they may cause direct cytotoxic effect on the bone marrow and may cause bone marrow suppression, which can lead to cytopenia. In aplastic anemia, these are mostly because of the immune-mediated T cell activation, which will cause destruction of the hematopoietic stem cells and may lead to cytopenia. Viral infection, they are responsible to cause bone marrow suppression in different way. Ultimately, they will be responsible to cause destruction of the hematopoietic stem cells and leads to cytopenia. Some disorder like myelodysplastic syndrome, they may cause ineffective erythropoiesis and may cause cytopenia. PNH may be responsible to cause complement mediated destruction of the hematopoietic stem cells and they may cause cytopenia. In sepsis, it may be because of the consumption coagulopathy or it may be because of hypersplenism. And sepsis, it directly may also cause suppression of the bone marrow and may lead to cytopenia. So in brief, these are the different mechanisms how the pancytopenia will develop. Now, if you come to the approach in a patient with an aplastic or pancytopenia, like in all other diseases, it includes three parts. You need to have a good clinical history, good meticulous physical examination, and some of the laboratory evaluation. History is the very important part in the evaluation of a patient with pancytopenia. Now, we always have to look for whether there is any feature of any underlying autoimmune disorder, any underlying malignancy, any features of infections, or if there is any history of intake of any chemotherapeutic agents or recent radiotherapy. Then we should also try to also know whether there is any family history of pancytopenia. Means there may have some familial hereditary condition which may cause aplastic anemia. Then maybe nutritional disorder, drug and malabsorption history is also very much important. Then many times these patients may be asymptomatic. The pancytopenia may be completely asymptomatic, but sometimes it may be symptomatic. The symptomatology will depend upon the type of the cells which has been reduced. Maybe features of anemia like you can get that fatigability, shortness of breath, palpitation, giddiness. There may be features of leukopenia in the form of there may be more chance of they are more prone to infection. They may have developed sore throat, may have recurrent oropharyngeal ulcers, and in features of thrombocytopenia in the form of petechiae, ecchymosis, bleeding like gum bleeding, epistaxis, or menorrhagia can be there. Now, we should, the other feature, like if there is any features of any underlying disease in the form of if the patient is having anorexia, nausea, lethargy, loss of muscle mass, or abdominal distension, you can think of the patient may suffer from chronic liver disease. If there is, dragging sensation or dragging pain in the left upper abdomen, you can think of there may have splenomegaly. If there is weight loss, lymphadenopathy, and anemia, hematological malignancies to be ruled out. Then if there is any evidence of joint pain, photosensitivity, oral ulcers, alopecia, you can always think about lupus. So physical examination, we'll have to go a thorough physical evaluation. So we'll all have to look for the pallor, petechiae, ulcers, or rashes. Then we should also search for whether there is any features of chronic liver disease, because this is one of the important cause of pancytopenia. We can get also evidence of splenomegaly. Now, if you're getting splenomegaly, this is an indirect evidence. Most of the time, we do say that probably this patient is not suffering from aplastic anemia. Same way, but if there is splenomegaly, we should always rule out to look for whether there is any hemolytic jaundice, or if the patient is having chronic liver disease with hypersplenism, or whether the patient is having leukemia. Then the patient can have lymphadenopathy. We should always try to rule out infection or any lymphomatous conditions. Then there can have sometime features of subacute combined degeneration, which is a features of vitamin B12 deficiency, which can manifest like ataxia, proprioceptive disorder, or there can have tingling sensation in the limbs. Now, in the lab evaluation, I'm just going in a brief and easy way how we can approach any patients with pancytopenia. Now, what is the basic evaluation you can go for? The peripheral smear is sufficient. So you can just have a look at the morphology of the RBC. We can get either microcytic RBCs, or we can get normocytic normogomic RBC, or can macrocytic. If it is microcytic RBC with pancytopenia, we'll have to think of them maybe thalassemia with hypersplenism, or may have Fanconi's anemia. Now, what we can do is you can just, if it is this, then you can just go for hemoglobin electrophoresis. You can pull out the thalassemia. Now, if it is the hemoglobin electrophoresis is normal, then you can think of the patient may have Fanconi's anemia. We'll have to evaluate according to the way. Now, suppose you are getting the patient is having normocytic normochemic anemia, then you can think of the patient may have aplastic anemia, PNH, hypersplenism, leukemia, lymphoma, or sepsis. Now here, if you are getting premature RBC, means the erythropoiesis is going on. That means we are not dealing with a case of aplastic anemia. Then if you are getting premature WBC, that may be a case of leukemia. Then if you are getting a leukoerythroblastoid reaction in the peripheral smear with toxic granules, means probably we are dealing with a case of sepsis. Now, again, if you're getting macrocytic anemia, means RBCs, then we'll have to look for the vitamin B12 or folic acid deficiency. Then you can think of megaloblastic anemia. Again, if the patient was having severe normocytic normochemic anemia, and the patient is also having splenomegaly, again, as I said, it's probably less likely to have a aplastic anemia. Then we'll have to look for the other causes of splenomegaly. Like these are the important factors like hypersplenism, CLD, leukemia. So we'll have to look for this. Now, if there is any feature of CLD, like there can be ascites, edema, loss of muscle mass, icterus, then you can think of the patient may have chronic liver disease. Now, if the patient is having history of joint pain, the finding of joint pain, you can think of either lupus or rheumatoid may be the factor. If there is, malar rash, alopecia, oral ulceration, photosensitivity, then you can think of lupus. So this is in the brief way. And again, if there is splenomegaly and we are getting high retics and indirect hyperbilirubinemia, high LDH, and abnormal RBCs in the form of spherocytes or elliptocytes, you can think of the patient may have hemolytic anemia with hypersplenism. So the other evaluation means it will have to look for the serum calcium parathyroid hormone, because hyperparathyroidism may also cause sometime pancytopenia. Hypothyroid may be also associated with pancytopenia. Then bone marrow aspiration, it gives around 75% cases of diagnosis, and biopsy is again very important evaluation. The other evaluation which can be done in certain scenario like genetic testing like FISH, or karyotyping of the bone marrow and the peripheral blood film, flow cytometry of the bone marrow as well as peripheral blood, molecular studies like mutation analysis, vitamin B12, folic acid, blood chemistries may be necessary only in certain scenario. Now, a little bit about the treatment approach. Now, it depends upon the underlying cause. Now, if there is any nutritional deficiency, we'll have to correct that underlying deficiency. If there is an offending drug which may be responsible to cause pancytopenia, we'll have to withdraw the drug. Well, if there is any evidence of infection, we'll treat the underlying infection. If there is any autoimmune disease, we'll have to treat that autoimmune disease. And if there is malignancy, treat the underlying malignancy. Aplastic anemia due to parvovirus, most of the time they recover spontaneously. So the other factor is, one of the important factor is aplastic anemia. If the patient is young, less than 40 years, then stem cell transplant is the best option. But if it is not possible, you can go for the immune suppression. ATG and cyclosporin is the preferred drug. And the other supportive care in the form of like blood transfusion, platelet transfusion, or L-thrombopac may be necessary because of thrombocytopenia. And the other control of infection is very important, which may need broad spectrum antibiotic, and sometimes antifungal is also necessary. So my tech clinic message in the brief presentation is that the manifestations, this is pancytopenia is a manifestations of underlying disease, which may be benign or malignant. The good history, physical examination, and minimal laboratory evaluation suffice to come to the diagnosis in most of the scenarios. Treatment depends upon the underlying cause, and aplastic anemia due to parvovirus, it recovers most of the time spontaneously. Thank you. Thank you very much for your question.
Thank you, Dr. Das, for your beautiful presentation. Within a very short time, you have covered a lot, and I think all doctors will be benefited. I request the other guests to ask not more than 2 questions.
I think Dr. Nijan is so clear that there is no question to ask.
Either not clear or not at all clear.
With this, we are concluding the session.
Thank you. Thank you very much.
I kindly request the chairperson and the speaker to kindly step forward the felicitation area. We shall now proceed to our next session. I am delighted to introduce our chairpersons for the next session, Dr. Yogesh Sharma, Dr. Giridhari Kar, and Dr. Anupam Datta. I request respective faculties to kindly grace the dais. I take great pleasure in introducing the esteemed guest speaker of this session, Dr. Jyotirmoy Pal, the Professor of Department of Medicine in College of Medicine and Sagar Datta Medical College, Kolkata. Also, the current President of API, who will gonna talk about the cardiovascular manifestation of tropical diseases. Sir, we warmly welcome you.
Serasu. So may I start? So, thank you for your introduction, and I am very much obliged to be invited in State Annual Conference of Assam Kaziranga. So, I am thankful to the scientific committee for not neglecting the neglected tropical disease. The tropical disease, the is bread and butter for the physician practicing in the tropical and subtropical zone. But we mostly know the tropical diseases causes fever, fever with other systemic manifestation, liver, brain, lungs, and kidney, and others. But we are less aware about the cardiovascular manifestation from the different tropical diseases. But this is relevant in some of the aspect. If we forget, if we ignore, you are not aware about the cardiovascular manifestation, outcome may not be good, rather may be catastrophic. Let us see few cases. So neglected tropical disease, what is? It is a diverse group of disease caused by the viruses, bacteria, parasites, fungi that primarily affect the people of the tropical and subtropical region. It is called neglected because it historically received less attention from the clinician, from the patient themselves, from the policymakers, from the government, and from the pharmaceutical industry. So research on on these diseases are less because the treatment, the drug, if it is invented, it is less profitable. So basically, these diseases are less understood, less discussed, and have a human impact havoc, but not properly discussed in different forums. It is estimated that neglected tropical disease affect more than 1 billion people worldwide, and mostly they have a vector borne. Mostly they have animal reservoirs and associated with complex life cycles. So entity basically differs. List of entity differ from continent to continent. Mostly it is found in Asia, Africa, Latin America. Some of the disease, such as Kalajar, it is an entity, but it is more prevalent in the Asia, particularly in India. But Chagas disease, it is more found in the Latin America. So list of the entity differs from continent to continent. So these are the diseases which is more prevalent in India. So India mostly we deal with these entities. So cardiovascular manifestation, today's point of discussion, basically two of the diseases, cardiac involvement is well defined. One is the rheumatic fever by the streptococcus, very much well defined because we learned from our MBBS day third year, the MS, MR, AS, AR, these are the primary cardiovascular diseases we are taught by our teachers from our third year medicine period. So it is well established. Chagas disease also causes the cardiomyopathy, but not common in India. It is more common in Latin America, causes very well established reason for the cardiomyopathy. But from the different bacteria, virus, fungi, or parasite or helminth that causes the more cardiovascular manifestation in this tropical region. There is the Asia. One is the virus. There is the dengue, Zika, chikungunya, protozoal malaria, leishmaniasis, helminth, echinococcosis, schistosomiasis, cystisarcosis, and bacteria. Though it is not an entity, but no discussion is complete in India unless you discuss something about tuberculosis. So there are sporadic case report. I told in the beginning that on the entity and cardiovascular manifestation, not much case series or vast of literature is present. Still, there are some sporadic case report. You will go if you go search through the journals, you will get the sporadic case report. That means it is happens, though will not well discussed. So this entity that affect the cardiovascular system through different ways, either by direct myocardial involvement. In case of dengue, it can directly involve the myocardium and cause the myocarditis and cardiac involvement, or immune mediated damages. When some infections happen, there is a more release of the cytokines, and this hypercytokinemia, this cytokine can damage the endocardium, myocardium, or pericardium, and causes the different manifestation of the cardiovascular diseases. Or in a long term, in the chronic stage, in acute stage, it can cause the myocarditis, but in chronic stage, it can cause the fibrosis of the pericardium conduction system, can cause the constrictive pericarditis or heart block, and so on and so. Secondary involvement, these are the primary involvements. Through secondary involvement, it can affect the heart through hypoxia, hypovolemia, or drug toxicity. So let us see a few of the cases that we encounter in day-to-day practice. Some of the cases we encounter very frequently, some of the rare cases. So first we are coming to the dengue. This series we published in 2018 in JIMA of the 6 series, or 2 cases I will mention here. One 21 years female, that time I was in Arjikar Medical College, that female was admitted in Department of Medicine with 4 days fever with precordial chest pain. Fever was associated with severe body ache, headache, macular rash, and it was in the period of post-monsoon period. Definitely we thought it can be a dengue. That period, the dengue, post-monsoon dengue incidence is very high. Pulse blood pressure was 106 pulse, BP was 110/76. Dengue, NS1 as usual, what we thought clinically, it came to be positive, malaria was negative, and troponin T was elevated. X-ray shows the normal, but ECG shows the sinus tachycardia. So case of dengue patient, troponin T was elevated, ECG shows the tachycardia. Echo was done because troponin T was elevated, so initially we thought it can be myocarditis. So echo shows the dilated cavity with low ejection fraction around 35%, and there is a tricuspid and mitral regurgitation. So basically, it was a case of dengue fever with pancarditis. So there is a aortic, tricuspid and mitral regurgitation. There is low ejection fraction, and there is also pericardial effusion. That means it is a pancarditis in a case of dengue fever. So 2 days after admission, patient that female, 14 years female, suddenly developed palpitation. Her pulse rate was very high, 150. ECG shows the revealed a non-sustained VT, and he was terminated by giving the bolus injection of amiodarone. After 2 to 3 days, patient became febrile, chest pain subsided, no further episode of palpitation or no episode of NSVT. On echocardiography, but ejection fraction not improved. Though patient was discharged in a stable condition, but initially the ejection fraction remains same between 30 to 40%. When these patient was followed up to 3 to 6 months, the ejection fraction gradually improved. The take-home message of this case is dengue we frequently treat, frequently admitted in the post-monsoon period. And this series was done by Professor C.K. Jana. Many of you know, it was published in 2004 in JIMA, where he mentioned that 20% cases of dengue have cardiac involvement that we do not search or we do not aware. So importance is because most of the cases there is a asymptomatic and there is a myocarditis and low ejection fraction. So we usually in dengue patient we are habituated to test for the PCV and platelet, not much about the echocardiogram, but myocarditis is found up to 20% cases. Importance is if we do not, without recognizing the myocarditis, if you give lot of fluid, that is the mainstay of therapy in dengue, patient can develop the heart failure, pulmonary edema, and their outcome may not be good, mortality may increase. So this is the importance of understanding or recognizing the cardiac involvement in a dengue patient. So another case, 30 years male, this patient admitted not in medicine, was admitted in the cardiology department of that Arjikot Medical College. 3 days fever with headache, body ache. Next day the rash appeared on the body, malaria was negative, and dengue was sent as it is a post-monsoon period, and dengue was found positive. The ECG showing the complete AV dissociation. This patient developed syncope of the 3 episode because of the complete AV dissociation. Temporary pacemaker implanted, and 9 the ECG again came back to the sinus rhythm. The temporary pacing was removed and patient discharged subsequently. This also can happen because sinus bradycardia we frequently see in the dengue patient, that is called temperature pulse dissociation. But complete heart block or 2:1 heart block not very common. But when we see the sinus bradycardia, we should watch the pulse every day very properly because this also can happen. And because the dengue virus directly can affect the AV node, that can cause the complete AV dissociation. Not only this case was recorded in Arjikot Medical College, in our college, also there are few case report from the Thailand, if you search the literature. So dengue involvement in the cardiac involvement dengue, we must recognize, otherwise our result may not be so good. There is another interesting case of chikungunya. Chikungunya, when the patient came with fever, with arthalgia, body ache, headache, we basically check for the malaria and dengue, not for the chikungunya, because chikungunya causes the disabling arthalgia, but mortality is not so high. It is more a morbidity. As mortality is not so high, we usually test for the dengue, but hardly test for the chikungunya. But this patient, there is also importance of diagnosing chikungunya, testing blood, because see this case, 36-year male came to emergency with 5 days fever, SOB, and 1 episode of seizure. Patient fever was associated with intense body ache and headache. He was admitted and tested malaria, dengue negative. That we usually do. Fever not subsided. Initially, chikungunya testing was not sent, and blood culture shows the growth of the multi-drug resistant Klebsiella. She was treated for the Klebsiella pneumonia, and soon after he suffered from cardiac arrest and succumbed to death. So in death certificate it was written that Klebsiella pneumonia sepsis due to Klebsiella pneumonia. But autopsy was performed. In the autopsy, it was revealed the florid myocarditis with hemorrhage in the heart and also in the kidney, lung, and liver, and also found the pulmonary arterial thrombi, edema, and hemorrhage. The PCR was positive for chikungunya. That means in chikungunya, cardiac involvement may not be so common, but it is recorded. So catastrophic outcome of chikungunya also possible. So that is why chikungunya awareness of the cardiac involvement also needed. One important thing is in chikungunya, sometimes they become the very disabling arthalgia. And this patient, if you follow up, can develop the rheumatoid arthritis. Similarly, the myocarditis that develop during the period of chikungunya infection, this myocarditis in dengue, there is a series that ejection fraction initially low but improve. But in chikungunya, this myocarditis, low ejection fraction can persist and finally can land up with a cardiomyopathy with low ejection fraction. So coming to the next, the protozoal infection. This is a case report. 10 years boy from the North Beard admitted in the AIMS with history of 10 days fever. Fever was associated with chill and rigor. And this boy has a SOB, tachypnea, tachycardia. Also have the raised JBP, fine capitation of the lung base, that means features of the failure, hepatosplenomegaly, and jaundice. His malaria slide and antigen was positive for the falciparum. Falciparum antigen and slide test was positive. X-ray show as usual features of heart failure. Echo shows the ejection fraction low, global hypokinesia with 40% EF. Cardiac enzyme was raised. So this patient has malaria with involvement of the heart, that is in the form of myocarditis. The malaria and heart involvement, there is very few limited publication, usually not common, usually heart involved due to hypoxia or circulatory failure. But in the severe malaria, if there is cardiac involvement, mortality is very high. If there is a myocarditis severe malaria, mortality will be very high. And also angina also possible in severe malaria, because in severe malaria, particularly in the falciparum, the cytoadherence increases. So in coronary artery, is there is more cytoadherence, there may be occlusion due to the RBC plaque, and that also can cause the acute chest pain or acute coronary syndrome like presentation. So these are the different series. If you go through the series, in malaria, cardiac involvement not common, but if there is involvement, death and mortality is very high. Now we are coming to the 2-3 very interesting cases of helminth infection, how it can involve the heart. So first cases we are coming, the 32 years female admitted with chest pain. ECG shows the sinus tachycardia. Troponin I and NT-proBNP was elevated. So thinking of the cardiac involvement with heart failure. Echo shows the marked hypokinesia. And there is a cystic mass, if you can see here, there is a if you can see cystic mass, you see a cystic mass here. So this patient also show the multiple cystic lesion in the liver. So as usual, there is a cystic lesion of the liver. We thought about the echinococcosis, and serology said that come to the positive for the echinococcosis. So it was thought this cystic lesion may be due to cardiac echinococcosis. This is not very common, but it was thought, and so patient was put on albendazole and then put on operation, and after the operation again put up the albendazole. Finally, 4 weeks after operation and putting the patient on albendazole, patient improved and discharged with a normal ejection fraction. Though in the case of cardiac involvement of the echinococcosis, though we know that echinococcosis mostly involve the liver and kidney, the cardiac involvement also possible. So echinococcosis basically it is due to the cardiac involvement less than 1% cases. It can cause the compressive syndrome. In these cases, it causes the compression, and that is why the features of heart failure develop. So another important case is cysticercosis. This is a 32 years male admitted with several episodes of seizure. Patient was alcoholic, used to take the beef and pork, and it was found the multiple cystic swelling in the bilateral arms and severe examination, ejection systolic murmur at the aortic area. So that means this patient has some obstruction in the aortic area and cystic swelling in the bilateral arms. This patient undergone the echo, and echo shows, see, these are the lesion, neurocysticercosis. Usually cysticercosis
happens the neurological presentation, neurocysticercosis. But cysticercosis involving the heart also found these cases. So this cystic lesion causes the obstruction of LV outlet, causing the ejection systolic murmur at the aortic area. Last case is coming the cystosomiasis. Cystosomiasis, this patient 40 years male came with cough and SOB and hemoptysis. He had the features of cirrhosis in the form of abdominal distension, hematomasis and melena. Patient have a history of bath in the local swimming pool. Patient have a dilated abdominal vein, hepatosplenomegaly. So it is the features of the liver cirrhosis. But in this patient, JBP was raised, P2 found loud, and left PSI was present. That means an RBS3 was there. That means patient have pulmonary hypertension with features of right heart failure. So in this patient, the investigation of the abdominal investigation shows the presence of liver cirrhosis. So, and the presence of liver cirrhosis there, the cystosoma antibody found to be positive. So it was thought that the cardiac involvement also there in this patient. So the cystosoma causes the egg deposition in the pulmonary artery. So if there is egg deposition, there is an inflammatory reaction in the pulmonary artery causing the obstruction of the pulmonary artery that causes the pulmonary hypertension and right ventricular failure. So this is another case. The tropical infection, cystosoma, not only affect the liver, can also affect the heart and can cause the pulmonary hypertension with right heart failure. And so lastly, no discussion in the tropics is complete unless we discuss something on tuberculosis, though TB is not a come under category of NTD. So this is the TB can affect the any organ of the body. So also in the heart, it affect the myocardium, endocardium, and also pericardium. But presentation of the pericardium is mostly common in the form of acute pericarditis, pericardial effusion, constrictive pericarditis. But here I will show a case that TB, how it involves the myocardium. So 25 years female came to emergency with features of heart failure. Patient has a SOB and low saturation of the room air. Patient has a history of low grade fever for 1 month, cough for 2 months, and weight loss. On investigation, the sputum found positive. LV was dilated with global hypokinesia. Patient put out anti-failure therapy and anti-tuberculosis therapy as sputum was positive. After 3 months, patient improved symptomatically and LV ejection fraction returned to normal. So initially there are the features of sputum positivity and dilated LV. After giving the anti-tuberculosis drug, after 3 months, the ejection fraction came to normal. That means this is the case of myocardial involvement of tuberculosis. Though pericardial involvement, we are more aware about the pericardial involvement of the TB, but myocardial involvement also possible. So in conclusion, CV involvement of neglected topical disease may not be very high, but there are enough case report and case series on cardiac involvement of tropical disease. These diseases not only get the less enough attention from the clinician, also from the researcher, industry, and government. So actual burden of the NTD and this cardiac involvement to determine. Till now, not decided. Thank you, scientific committee, for not neglected topical disease.
Thank you, Professor Dr. Pal, for your excellent, beautiful talk on the cardiovascular manifestation of the tropical disease. It is a very big chapter, and you are telling covering all the things in the limited time. And on the other hand, in any climate, a warm climate, or in humidity, the tropical diseases are more common, and they may be bacterial, viral, parasitic, or pathogen. So I thanks you. This is a very big topic. Actually, you are covering in a very limited time and in details.
Thank you.
So any question?
Well, there is pressure of time. So if anybody is very curious, can ask one question. Well, I don't think there is any question. So
Thank you, sir.
conclude this session here. Thank you, Dr. Pal.
Thank you, respected chairpersons and speakers, sir, for your valuable insight on this topic. I would like you to request to move towards the felicitation area. Moving on to our next session, I would like to invite Dr. Dimbeshwar Das, Dr. Prasanjit Roy, and Dr. Pratik Poddar to chair the next session. I would like to invite Dr. Manas Pratim Barua, who will talk on the topic tirzepatide versus semaglutide, evidence from head-to-head trials. We kindly invite Sir to take the stage.
Good evening. Thank you very much. Thank you, organizing committee, for giving me this opportunity, and I thank Eli Lilly for sponsoring this session. So, as a formality, I have to disclose this and put these disclaimers. So, to start with, we have already listened about GLP-1 receptor analog. Nice talk by Nilaksi. So that has made my job easy. But I'm also going to take up another interesting incretin molecule, so GIP. And you can call it GIP as a forgotten hormone. If I take you back to your Guyton days, first year, you have read about two hormones, secretin and cholecystokinin. In fact, just around 1900, secretin was discovered ahead of insulin, and after that, cholecystokinin came. So secretin, it increases the pH of the food matter, which goes to the proximal duodenum, so that bile can act for saponification, and pancreatic enzymes, they act in the basic media. And cholecystokinin, it reduces the gastric emptying. So they're basically related to the exocrine functions. Fine. But then there are two other hormones which are acting at tandem with either of them, and they are GIP and GLP. In fact, GIP was earlier, when we were students, was also that is GIP only, but it was gastric inhibitory peptide. They thought that GIP reduces gastric emptying. But later on, towards 1970s, they found that actually its main action is beta cell through beta cells. It's insulinotropic. That means GIP secretes insulin. So GIP was described somewhere around 1971, and its action as insulinotropic hormone was described in 1974. So that was before GLP-1, GLP-1, that is another hormone which came into being as a molecule for pharmaceutical uses much earlier than GIP. In fact, GLP-1 was discovered in 1984 only, but otherwise they have got certain things similar in their action. So GIP secreted by duodenal K cells, they are proximal in the proximal part of the intestine, and they are stimulated by lipid and glucose, and they are also having incretin activity. And GLP-1, which was discovered, as I said, in 1984, secreted by distal L cells and stimulated by glucose and only glucose. So if there is some glucose in the stomach, then it is going to send some signals to the distal L cell so that GLP-1 can be secreted. And it also reduces gastric emptying like cholecystokinin. But another action is again insulinotropic through the beta cell, and it also reduces glucagon. I'll again discuss the 2 points separately. So GLP-1 activity, GLP-1 like semaglutide, you can say it's an analog. It reduces food intake, increases satiety, central action, increases nausea also because the reduced gastric emptying. In the pancreas, it increases insulin secretion but reduces glucagon secretion from the alpha cells. So it's a kind of a balance. And in stomach, it delays gastric emptying. So GIP activity, which is a newer molecule, so it reduces food intake, decreases nausea. It decreases nausea. Interesting, see? And in pancreas, it increases insulin secretion, but it increases glucagon in a glucose dependent way. That means in high glucose level, it will suppress glucagon, but in a low glucose, hypoglycemic level, it will increase glucagon. So it has got certain basic or fundamental difference from GLP-1.
So in adipose tissue, which is where GLP-1 has got no action, in adipose tissue, it increases insulin sensitivity, which is beneficial for us, for metabolic system, because if your insulin is working through the adipocytes, it will reduce a lot of cytokines which are harmful and which actually finally cause cardiovascular disease and metabolic syndrome. So it increases lipid buffering activity, and actually it increases lipid as a source for calorie for a body and suppresses the usage of glucose and protein. So increased lipid utilization is another important function of GIP activity. And it as I said, it increases storage capacity of the peripheral adipocyte and reduces pro-inflammatory immune cell infiltration. There are certain fundamental differences amongst these two molecules, although they are being used together now. So that has to be known. So what is the unique action of GIP at pancreas? We have mentioned that GIP as well as GLP-1 both can cause insulin secretion from the pancreatic beta cell in a glucose-dependent manner. That is, glucose is high, there will be insulin secretion. Glucose is low, there will be no insulin secretion. So till now, we thought that GLP-1 is the only hormone which secretes insulin, but it is not so. Actually, in a normal person in a physiological state, the secretion of insulin is mostly through GIP, almost 44%, and 22% is only through GLP-1. Okay, the rest is through glucose. We know glucose is a good stimulator for insulin secretion through the hexokinase pathway. That's a natural secretion. That's a glucose, GIP, and GLP together can cause secretion of insulin from the beta cell. GIP is more important for that beta cell stimulation. So this is about the physiology, which is important to understand the action of these two molecules. Let us talk about clinical situations. So I'll discuss about this lady who is having obesity without type 2 diabetes mellitus. So as you can see, she has got probably BMI more than 34 or 35. So she has tried multiple times, as it is so for most of our patients, and has been unsuccessful in losing weight and maintaining her weight reduction over time. So she would lose and she will come back again, gaining more and more. So why should we consider tirzepatide? This is a dual agonist which acts through the GLP-1 as well as GIP pathway for these kind of patients, for different as a part of the different obesity management medication armamentarium. So I'll straightway hit the road by describing mentioning few trials where head-to-head comparisons between semaglutide, which is a GLP-1 receptor, a very good molecule, and dual agonists were compared. So this is a SARMON 5. All SARMON trials were done on obesity, and that's why I'm firstly taking up this. So it's a head-to-head trial. As you can see here, the flow of the trial, you can in the top, you have the tirzepatide, which the dosing is 2.5, 5, 7.5, 10 mg, 12.5, and 15 mg. Some people remained at 10 mg because many of them could not tolerate because of the GI side effects. So that is called the maximum tolerated dose. And some people achieved the could take the maximum dose, that is 15, which is a prescribed dose. And in case of semaglutide, as it is in practice, is 0.25 to up to 2.4, which is the maximum dose which is been prescribed for obesity control till now. Of course, we are having some trials where they are using more and more higher doses. That's a different story. So this is a randomized trial, but not blinded, because the pains were different, so you cannot blind and double blind them. So they were comparator trials, not unblinded. So what was the result? You can see here, semaglutide gave a fantastic reduction. That's 15.4%, and that was also mentioned by Dr. Nilaksi. Is almost touching the target which you set for bariatric surgery. But look at dual agonist. Reduction was 21.6%. Fabulous. So compared to this particular dose of semaglutide, the highest tolerated dose, or 15 milligram of tirzepatide, could reduce 21.6%. That means some people could achieve actually almost 30-35%, and some people could achieve less. And in a mean, you have the 21%. That is, again, it's fantastic, because if you achieve 21% reduction, your glycemic control gets better, your NASH or NAFLD gets reversed, obstructive sleep apnea gets reversed, and there are significant kidney benefits if their patient having a risk for chronic kidney cardiovascular benefit. And sometimes if the patient is destined to have diabetes in future, even that is reversed. So there are multiple benefits. So look at the comparison at different level of weight reduction, like more than 10%, 15%, 20%, 25%, all more people achieve the target with dual agonist compared to semaglutide. And participant taking Monjaro experienced superior reduction in waist circumference, which is very important because simply losing the body weight is not enough. You have to lose your central adiposity because that is pathognomic for metabolic syndrome and various cardiovascular outcome. So even that there was significant reduction compared to 14.7. It was 20 centimeter reduction. That was 7.9 inches mean. It's another patient. This patient is having type 2 diabetes, not as obvious as the other one. And this patient is concerned about the unsatisfactory A1C control and future implication of her excess weight. So there's a tendency of gaining weight at the same time, poor glycemic control. What is the future for her? So this answer comes from SURPASS 2 trial. All SURPASS trials were on type 2 diabetes. So this particular molecular striding, different combinations like compared to different agents like placebo, long-acting insulin, and semaglutide. And semaglutide as an anti-diabetic, like this has been launched, Ozempic, 1.0 is the dose. So that's why. And that time, semaglutide as an anti-diabetic was launched at 1.0 strength, and they compared their product against 1.0 semaglutide, and different doses were used: 2.5, 5, 7.5, and 10. So and what they try to look at overall A1C reduction and the change in body weight. So 1,879 patients were enrolled and different arms, so the different doses of tirzepatide and one dose of semaglutide injectable weekly. So compared to 1.0 milligram semaglutide, you just look at, we should actually compare the equivalent doses. 2.5 to 5 would be comparable to 1.0 semaglutide. Even they had better efficacy in glycemic control. Against 1.7% SVO reduction, 2.1 and 2.4, and with the higher doses, even it is higher. So it is a superior anti-hyperglycemic agent compared to semaglutide if you take 1.0. Of course, the results could be different if you use a higher dose of semaglutide, because it has been mentioned by Dr. Nilaksi in the morning, in the talk in the morning, that as you go up in the dose of semaglutide, A1C reduction also goes better. It can also cross 2.0. So both are good molecules for glycemic control, but probably dual agonists as of now have a certain advantage compared to semaglutide. And significantly more patients achieved the A1C target across all doses of tirzepatide, from lower doses to higher doses, and it was better than semaglutide 1.0 milligram. And what about the weight reduction amongst type 2 diabetic patient? It may not be as significant as obesity. It was mentioned nicely by one of my friends, Dr. Nita, that weight reduction has got certain resistance amongst type 2 diabetes mellitus patient compared to non-diabetic obese patient. Nevertheless, there was significant reduction, and it was dose dependent with semaglutide. Of course, we are comparing 1.0 milligram semaglutide with these different doses of tirzepatide, which is a bit unacceptable, because 1.0 semaglutide is not the anti-obesity agent. It's not expected to reduce the weight that significantly. Now I got higher doses. So neutrally speaking, probably that comparison would be little, can be criticized a little, but nevertheless, the certain trend, increase the dose, the weight loss will be more, and 12.4 kilogram body weight loss is again very significant for type 2 diabetic patient, because that can actually give you excellent control. It can reduce the insulin requirement, it can reduce the OAD requirements, etc. So more patients achieve the composite endpoint of less than 6.5% A1C weight loss of more than 10%, and without clinically significant or severe hyperglycemia with tirzepatide compared to semaglutide in this particular trial. So what about the adverse events? As expected, the GI adverse events are very common. You can say that nausea is almost 43.6% is a long list. So all expected GI side effects are there. No unexpected extra GI side effects are here. Most importantly, I want to mention here, discontinuation for the study from the study treatment due to adverse events is about 8% with semaglutide, about 6% with Monjaro, maximum tolerated dose. So it is almost about 6 to 8%. So that is what you expect when you give these molecules. And discontinuation from study treatment due to gastrointestinal side effects is again what we expect in case of GLP-1 receptor analog, about 4 to 5%. So that many patients would actually go out of treatment in your clinical practice also. Otherwise, you can counsel the patient and titrate the dose nicely so that you can maintain them in your clinical treatment program. I mean, if you are treating them for long term. So you don't expect that 50% of them will have GI side effect go away. That's not true, because no clinical trial has ever shown that that percentage is more than 10% or so. So, so this is what the most common is from Monjaro and semaglutide are GI related and mostly mild to moderate severity, not leading to discontinuation. Hypoglycemia again is negligible. One patient only in the Monjaro group, the tirzepatide group, showed hypoglycemia. That is again very interesting, very difficult to explain, but probably dietary issues were there. So in summary, in persons with obesity, tirzepatide demonstrated superior weight reduction versus semaglutide 2.4 and 1.7 milligram, that is 21.6% versus 15.4%. And patients with diabetes, it demonstrated superior SBNC reduction to 2.5% versus less than 2.5 or 1.7%. And in all three doses showed better result compared to semaglutide 1 milligram along with weight control. So just a few moments discussing about how to start. This is a start with 2.5 milligram starting dose that goes for 4 doses, 1 month, that's 4 weeks. Every week, every month you increase to another step, go to another step, that's increasing it to 5, then 7.5, then 10. Of course, we don't have this 12.5 and 15 here as of now. We have 2.5, 5, 7.5, and 10. The pre-filled pens are there. You just have to dial it to a marker. There, the particular pen will deliver that much. Even if it's a 5 milligram pen, 60 clicks, then there is a mark, and then it will be locked there. That's 1 dose, and then patient can inject. So full dose is going to go. So it's about just about 0.5 ml contains that much of dose. And what you can add, continue along with tirzepatide, and that is true for semaglutide also. Then metformin and SGLT2 can be continued. And in fact, there are a lot of good impact of SGLT2, the synergistic impact of SGLT2 with GLP-1 receptor analog. Of course, when you use drugs which can cause hypoglycemia, like sulfonylurea and insulin, you should be careful. I expect about 20% reduction of these particular drugs, and I actually initially only I start reducing the dose a little bit because suddenly the patient may have hypoglycemia. In special population, very important, no dose adjustment is needed: age, gender, race, ethnicity, or body weight. So higher body weight, lower body weight, you don't have to think about the body weight. And no dose adjustment is required in people with hepatic or renal impairment, because see, this is a polypeptide molecule. Once it is in the circulation, it will be broken down by the peptidase enzyme in the circulation. And all these broken down fragments are inactive. They are not having any biological activity. They will be finally eliminated by the kidney. So you can use it in the end-stage renal disease also, hepatic disease also. Of course, you have to be careful if the patients are very sick. Otherwise, there is no contraindication from the pharmacokinetic and pharmacodynamic point of view. In acute pancreatitis, you should stop it, or if the patient is having history of acute and chronic pancreatitis, should not use it. In advanced diabetic retinopathy or retinopathy requiring intervention, you should not start this molecule. Pregnancy, no data, so no. Lactating mother, safety has not been established, should avoid. So these are 4 important points for special population. And how we can counsel to avoid GI side effects is eating smaller molecule and not eating when you're not hungry, and staying hydrated, avoiding irritants, like a lot of irritants we use in our country, so that can add to it, and unnecessarily blaming the drug. So these are other issues which can be tackled, and probably that way you can actually continue to give these medicines because they're very beneficial in the long run, except for the price, but of course. And moderating intake of alcohol and fizzy drinks. In fact, people who love to drink a lot of huge quantity of alcohol or drinks, actually, it has been seen that is also reduced by this introduction of this molecule. Last slide. If a patient misses the dose on a particular day, suppose you are giving every Sunday, up to 3 days, the 10th day you can inject. But if he comes back on the 11th day, better to stop and go to the next scheduled date or day when you will get the next dose. So this is how you skip dose can be managed by up to 10 days you can give the scheduled dose, and that and again after this dose you can come back to the regular schedule, no problem. So that's all for now. Thank you very much.
Thank you, Dr. Manos. It was quite clear and crispy as always. As all of us know that obesity has been recognized as a disease now. It's not merely a cosmetic issue. And there's a lot of noise in the clinical practice about these two molecules. And listening to his talk, I think we are very clear how and when to use, selection of patient, and all other small details he has explained nicely. Regarding the question, is a request from the organizers that constraint of time, there are no question will be allowed. And anything anybody wants to know can meet him later, and I think that will be the most practical.
Manas, I have conclude the session here. Thank you. Manas, I have a point.
Okay, price factor of these two molecules.
Sir, Mike, please. Price.
Price factor of these two molecules. Tirzepatide.
Yeah, it is costly. But we talk to the patient.
How costly?
For the starting dose is somewhere around 14,000, and the last dose is somewhere around 20,000. Exact, I don't know. Somewhere around that per month.
Well,
4 injections.
See the reason why the people fall out. Price factor.
No, actually, at least for me, I have never started it without counseling. I have waited for 1 to 3 months, tell them, give them the picture. Then I said there are 3 classes of patients. One where it is medically indicated, but people still do not want to take. Price could be one factor. And second class, when counsel well, they take. And third class, like they're like not sure. So actually, it's a lot of counseling is required. But and a fourth class is interesting. People come and tell us, sir, what they dijiye. Say to Didier.
Manas,
I'll talk to you personally.
No, I have a point because this point is important and not for my personal health. It is for the because you have mentioned and that GIP being increases the insulin sensitivity. If you start GIP analogs, at that time there is hypertriglyceridemia. Initial period there is hypertriglyceridemia that induces more like because you are going to reduce because you are going to reduce the lipotoxicity in that patient to reduce not only the glucotoxicity by reducing the glucose, but the initial period there is always an increase in triglyceride while you start GIP analog.
Because there will be degradation of fatty acid release will be increased initially.
Initially,
that is to keep the energy balance because they want to provide the energy from the fatty acids.
That will not happen in the initial period. After using for quite a long time, that the lipotoxicity will go. Is it because of the alteration in the calcium in the sarcoplasm that causes lipotoxicity in the initial period, or any other explanation you have for that?
The sarcoplasm, calcium, and fatty acid. That I couldn't understand.
I think you can discuss it amongst yourself. We are running very much behind the schedule. Please don't mind Nita.
Thank you, Manasa. We'll conclude the session here.
Yeah.
Thank you, respected chairpersons and speakers, sir, for that insightful session. I request you to kindly proceed towards the felicitation area. Moving on to the moving on to the next session, I would like to invite our chairpersons, Dr. Dhiraj Das, Dr. Kartik Deka, and Dr. Devesh Kumar Singh, and Dr. Sadiqur Islam to chair the next session. Let's welcome our speaker, Dr. Nandini Chatterjee, who will talk about the topic newer anticoagulants. Points to ponder. Thank
It's not visible.
So, without losing any time, I request to Chatterjee to start the talk.
Okay, thank you very much. I'm standing between the inauguration and the last session. I'll be very brief. So, our topic today is newer anticoagulants, points to ponder. In the middle, I should, of course, thank the organizing committee who has quickly reorganized their busy schedules to include me here today. So, what are the newer anticoagulants? They are not new. They have been around since 2010 and they are better designated as the direct oral anticoagulants. So, they may be the direct inhibitors of thrombin like dabigatran, or they may be inhibitors of the activated factor 10, as you know, the apixaban, rivaroxaban, and edoxaban. They have been approved as newer anticoagulants since 2014. Now, there are many advantages of these DOACs. The new agents have single targets in the coagulation cascade. They have more predictable pharmacokinetics. They do not require routine monitoring. This is very, very important. And they have a less risk of intracranial bleeding. Also, they have very little interaction with food, which is a problem with the warfarin and can be prescribed in a fixed dose. They have rapid onset of action and a relatively short half-life, which means that they may not remain in the system for a long time, which is safer for the patient. And it has been found that they have anti-inflammatory and vasculoprotective effects too. If we compare them to our age-old drugs like warfarin, what is the problem? They have a slower onset of action. They have a very narrow therapeutic window, an unpredictable anticoagulant effect, many dietary interactions for which we have to take precautions, and very importantly, we have to monitor and adjust the dose according to the INR. When we have to start warfarin, we all know that we need a bridging therapy because they have a slow onset of action. We start with heparin, have a dual drug in the middle, and then send them home with the VKA. So, if these drugs have so many negatives and the newer ones have so many positives, why we have not chucked them out already? So, my today's talk is that there is relevance of the vitamin K antagonists in many situations, and we need to keep them in mind. We should not just think that apixaban is here and we just go on giving it to everybody. So let's have a case. A 35-year-old lady presents with sudden onset of right-sided weakness of upper and lower limbs with deviation of the mouth to the left side. She is normotensive and non-diabetic. She has a normal BP and pulse. When we examine, we find that she has right-sided hemiparesis. On further inquiry, we find that she has history of 2 pregnancy losses, one at 24 weeks, another at 28 weeks in the past. Investigations reveal that she has a left-sided capsuloganglionic infarction. And more importantly, she has a triple positive antiphospholipid antibody. So this is a young woman with stroke. And the etiology is the antiphospholipid syndrome. So, what is the management? What will be the anticoagulant of choice? We know that these patients are very prone to develop various types of thrombotic episodes. So, we need to give a drug, but what will it be? It will be warfarin. So, what are the indications that this patient should have warfarin? She has had an arterial thrombosis. Also, she is a very high risk patient with triple antibody positivity. In these scenarios, we usually will avoid the directly acting anticoagulants. Some indications in some trials have been put forward is that if your INR is not being achieved with a single drug, then you can add it. If there is a drug intolerance to the VKA, you can use it. If the patient has a single positive or dual positive, that is low risk category, then some trials are saying that you can use the directly acting oral anticoagulants, but for all other purposes, the drug of choice is the vitamin K antagonist. I will come up with another case, a 64-year-old diabetic male who develops sudden swelling and pain in the left lower limb postoperatively. The USG Doppler shows a thrombus in the popliteal vein. He has mild anemia. The blood sugars are within 127 fasting and 190 pp. What is very important, that his creatinine value is 2.9 milligram per DL and a creatinine clearance of only 23. So, this is a patient who has a diabetic kidney disease and has developed a DVT. So, what do? We give the patient unfractionated heparin for 7 days and we overlap with which drug? So I will come to the list of the thresholds by which the directly oral anticoagulants may or may not be used. So apixaban cannot be given if your patient has a creatinine clearance less than 25 and our patient has the value 23. Rivaroxaban can be given if the creatinine clearance is less than 15. So it is a little more the window in which you can give. Dabigatran, again, you cannot give if the creatinine clearance is less than 30. For greater GFR, you have to modify dose according to the other risk factors of the patient. So we put the patient on warfarin overlapping with heparin, closely monitoring the INR for 6 weeks. The DOACs seem to be non-inferior to VKs in terms of efficacy and might be superior in terms of safety if your patient has stage 3 or 4 CKD, but not for the patients who are having advanced chronic diseases of the kidney. Another case, a 40-year-old lady with exertional dyspnea and palpitations and pedal swelling. She was diagnosed to have a mitral valve disease along with atrial fibrillation and congestive cardiac failure. She was stabilized and underwent valve replacement. What is the anticoagulant of choice? So, anticoagulant of choice again is the older guard, is the vitamin K antagonist warfarin, and we have to maintain it between 2 to 3. The DOACs are not indicated in valvular AF, especially if the patient is having mitral valve disease and prosthetic valves. What are the other contraindications of DOACs? This is a big list, and you can find something common with contraindications of VK as well, like pregnancy, breastfeeding, mitral valve disease, renal impairment to a great degree, triple positivity of antiphospholipid antibodies, known hypersensitivity to active ingredients, and severe hepatic disease as well, and some of the common anti contraindicating factors like if there is an active bleeding, those patients, of course, you will not start. What are the other issues that you have to keep in mind when you start DOACs? DOAC dosing is complex and variable based on the DOAC indication and patient risk factors. Here, we have to keep in mind the age, the body weight, the comorbidities, drug interactions of the patient as a whole. So, age intrinsically influences anticoagulation response to DOACs, and this is because there is age related change in body mass and also decline in renal function, increase in comorbidities, and the patient may be having a number of drugs which may interact with this drug. Regarding body weight, dose adjustment is not required for extremes of body weight for all agents except apixaban. It is recommended that the reduced dose of apixaban be considered if the patient has a body weight less than 60. I will not repeat about the comorbidities of which I have already spoken, and about certain drug interactions we need to be careful. For anticonvulsant, antidepressant, and rifampicin, there will be a risk of thrombosis that is increased, whereas risk of bleeding can increase if you give antiplatelets, calcium channel blockers, and antifungal azoles along with the DOACs. I am skipping a few slides for want of time. So, what are the indications of the directly acting oral anticoagulants? The treatment and prevention of DVT or pulmonary embolism, stroke prevention in non valvular atrial fibrillation, prevention of major cardiovascular events with coronary artery disease and peripheral artery disease, prevention of venous thromboembolism after knee or hip arthroplasty. So, thank you.
Thank you, ma'am, for your excellent deliberation. And due to the time constraint, actually, we are not allowing any question from the audience.
Thank you for your enlightening and valuable talk. Now, I'd like to request respected chairpersons and speakers, ma'am, to kindly move towards the felicitation area.
Now we are moving towards another important program, that is the inauguration. The director of Kaziranga National Park, she is a celebrity in her own right. Sonali Ghosh, Dr. Sonali Ghosh, she is on the way. She will stay here for a few minutes. Just now she has communicated with me. So we are waiting for her, and in the meanwhile, let the podium be arranged. So I would ask you, I would like to request you, to stay here only to attend this particular important program.
Moving ahead, I would like to invite our esteemed guest, Dr. Preeti Sharma, ma'am, to take over the mic. Ma'am, please take the stage.
নমস্কাৰ উপস্থিত সকলোকে সম্ভাষণ জনাই আজিৰ এই বিশেষ অনুষ্ঠানলৈ সকলোকে উষ্ম আদৰণি জনাইছো Good evening, ladies and gentlemen. On behalf of the organizing committee, Assam APICON 2025, I welcome you all to the inauguration ceremony of the 34th Annual Conference of the Association of Physicians of India, Assam Chapter, organized by API Nagaon Branch. Our theme this year, Intelligent Healthcare for Better Outcome, reflects our determination to provide the best and most updated form of healthcare to our patients. Ladies and gentlemen, we begin this program by inviting our respected dignitaries to the dais. Professor Dr. Anup Kumar Bormon sir, the Honorable Vice Chancellor, Srimanto Shonkardev University of Health Sciences, we request you, sir, to please take your seat as the chief guest of this program. Dr. Jyotirmoy Pal sir, President, API, as the guest of honor. Dr. Anup Kumar Das, President, API Assam Chapter. Dr. Mihir Kumar Goswami, Organizing Chairman, Assam APICON 2025. Ladies and gentlemen, we are extremely fortunate to have amidst us distinguished IFS officer and director of Kaziranga National Park and Tiger Reserve, Dr. Shonali Ghosh. Madam, requesting you to please take your seat on the dais. Madam is the first Indian to win the prestigious Kenton Miller Award for Innovation in Protected Area Management in 2025. I request our special invitee for this evening, Dr. Bishnuram Das sir, Principal, Nagaon Medical College and Hospital, to please take his seat on the dais. Requesting Dr. Horot Keot, Organizing Secretary, Assam APICON 2025. Ladies and gentlemen, in a slight deviation to our scheduled program, I would initially start by requesting Madam Shonali Ghosh to please say a few words as she has to attend another meeting. So I request her to please speak a few words of encouragement to us.
Thank you so much, Madam, and good evening to all respected dignitaries on the dais. It's really indeed an honor for me to be here, and sincere apologies that I'm like breaking the tradition and speaking first. Actually, we have VIP duties, so there is a dignitary a state guest who is has reached, and I have to meet her. But having said that, I really I'm very grateful, especially to Dr. Mihir Goswami. I think a round of applause for all his philanthropic work that sir does for us. And I think all of you, as doctors, as eminent people, you are wonderful to the park because, as you all know, you are sitting close to the biodiversity hotspot. We have this world's largest population of the one-horned rhino, which is 70% of the world's population. We have the third highest density of tigers, 99% of the wild buffalo, the second largest population of Asian elephants in Northeast. And other than that, we have several other rich biodiversity. And to protect this rich biodiversity, we have over 2,000 forest frontline who they sort of give their heart and soul because they have to live in remote conditions. They have to work in difficult conditions. And every time we have reached out, if God forbid there is an accident, if there is a rhino attack or a animal injury, or for that matter any other ailment, it is doctors such as you all, such as Dr. Goswami, who have always helped us. So thank you so much for doing that. I would really appreciate that if all of you can, despite your busy schedules, and just enjoy nature, Mother Nature. She is at her best very close to this place. It's like just 5 minutes, and you will see rhinos and elephants very close to this place. And as we all talk about mental health or of physical well-being or mental well-being, I think the best place to sort of detox or to gain that back is parks and protected areas. So thank you so much, and I really wish all of you a great event. And also, please do visit Kaziranga, and get all your other friends and relatives to also visit Kaziranga. Thank you so much.
Thank you very much, ma'am. Moving on to back to our schedule, ma'am. Just a moment for us. We would like to felicitate our dignitaries on the stage by our senior and renowned physicians, Dr. Birinchi Kumar Bora sir and Dr. N.N. Deka sir. Thank you very much. Ladies and gentlemen, we now move on to lighting of the ceremonial lamp with a beautiful rendition of the Saraswati Bandana. I request all our dignitaries to please come forward for the lighting of the lamp.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगत्कापिनीं वीणापुस्तकधारिणीं
সকলোকে অশেষ ধন্যবাদ. We now move onwards towards the welcome address by the organizing chairperson Assam Apicon 2025, Dr. Mihir Kumar Goswami.
Respected dignitaries on the dais, Professor Anup Kumar Burman, Vice Chancellor of SSUHS, Professor Jyotirmoy Pal, National President of API, Professor Vishnuram Das, Principal, NMCS Nagaon, Dr. Sarat Keot, and the esteemed delegates who have gathered here from the nooks of a corner of entire state of Assam. It is with greatest degree of pride, pleasure, and privilege that I welcome you all in the capacity as the leader of the entire organizing team of Assam Apicon 2025. In every sector, there is leadership. It is a leadership that shapes the performance, the stacks, and also moreover, the leader must plan, implement, motivate, and guide the team operating for the cause or for the success of the Apicon Assam 2025. And it should be driven by demand, delivery, and uncompromising quality of standards. At the heart of this responsibility entails the devotional dedication. The responsibility none other than the prestige of the entire district of Nagaon, famous for the Nagaya Atitha. যে লুচি ভাজি, ফুলা লুচি ভাজি, ঘিউত ভজা ফুলা লুচি ভাজি, with আলুৰ দম নোখোৱালৈকে লাগিলে নিজে খালী পেটতে থাক কিন্তু অতিথি দেৱ ভৱ এই প্ৰিন্সিপলৰে পৰিচালিত হয় নগাঁৱীয়া জনসাধাৰণ গতিকে এই এণ্টায়াৰ টিমটোৰ ৰেছপনচিবিলিটি ইজ দ্য হস্পিটেলিটি অফ দ্য পিপুল who have gathered here. I hope the entire team Nagaon under my leadership is working for the success of this particular APICON Assam, and it will live up to the expectation of all the delegates. It is an historic event in the sense that for the first time, this APICON Assam is being hosted by the Nagaon branch of API, which was dormant till recently until the charge was taken over by myself. No doubt, the entire team is active now under my leadership. And this duration and the devotion and dedication towards their duty, kartabya, not only remarkable, it is exceptional. I will rather use the word. So, with this few words, I would like to welcome all the delegates with the words of the greatest bird of the Brahmaputra, Sudhakanta. Mur gitor hazar sota, tomak namaskar. Tumieto mur gitor khabar hola olonkar. All the delegates, you are welcome. You are the gem. You are the persons who have made this conference successful. In spite of this heavy, tight, jam-packed schedule of academics, যে ৰাতিপুৱা 9টা বজাৰ পৰা দৌৰা দৌৰি কৈ আহি প্ৰগ্ৰাম আমি আৰম্ভ কৰিছো এতিয়া সন্ধিয়া 7টা বজালৈকে একে লেঠাৰিয়ে যিটো প্ৰগ্ৰাম চলি আছে সকলোৱে আছে তাৰ কাৰণে মোৰ অশেষ ধন্যবাদ অন্তৰৰ আৰু কৃতজ্ঞতা ধন্যবাদ জনাইছো আপোনাসৱৰ উপস্থিতিয়ে আমাক ধন্য কৰিছে গতিকে এইখিনি কয়ে মোৰ আদৰণি ভাষণটো মই চমুকৈ সামৰিছো ধন্যবাদ
Dhanyabad, sir. Ladies and gentlemen, we take this opportunity to pay our respects to Professor Srimanta Madhav Borua, along with Associate Editor Dr. Anupam Doctor and Professor Dr. Bhupen Bormon, for their incredible role in the Assam Journal of Internal Medicine. We would like to felicitate them with a token of our respect to be done by Dr. Orup Chaudhary and Dr. Karan Kumar Dole. Thank you very much. We now move on to the speech by the chief guest of today's evening, the Honorable Vice Chancellor of Srimanta Honkodev University of Health Sciences, Professor Dr. Anup Kumar Borman, sir.
Good evening, ladies and gentlemen, distinguished guests in the dais, Professor Jyotirmoy Paul, President API National, Professor Anup Kumar Das, President API Assam Chapter, and Principal Nagaon Medical College, Professor B.R. Das, the organizing chair, Professor Mihir Goswami, and organizing secretary, Dr. Sarat Keot, my esteemed teacher present here, senior colleague, friends, my dear students, and ladies and gentlemen. At the very outset, I would like to thank the organizer for having me here today in this gathering. API APICON is our annual meet. I being a physician, I am actively attached to these organizations. Every year we are attending. This time we all are attending in Kaziranga, the world famous heritage. So here we meet not only to discuss the academics, as to showcase our other activities, and also it's a good get together amongst us, all the physicians, all the treating physicians, all the faculties of the medical colleges, and then primary treating physicians. Indeed, it's a very, very essential for us, and particularly in a place like in Kaziranga, where you can detox, as a madam told just now, you come to Kaziranga to detox. I would also support her. That's yes, absolutely. So I'll not take much time because uh, we all know that this the what the this is said. Yes, the theme of this conference is excellent one. There's an intelligent healthcare for a better outcome. So how we all doing justice to all this theme since morning, since probably yesterday. Very hectic schedule is going on right from the workshop, hands-on training, and then various topic discussions, and then updated with the updated. As you know, the medical science is very ever changing, very evolving. So we need a regular sitting to discuss the new upcoming that we can implement in our clinical practices. Only reading books may not help us unless we have a discussions in such forum. Then every pros and cons we can discuss in this forum for a practical approach to the patients by applying all this newer technique. I hope all the faculties and all the resource personalities, all the delegates will be immensely benefited from this sort of meeting in Epicon. I just simply witnessed since morning. I have attending. Yeah, that's excellent. I must congratulate already. Already 75% finished. So I must congratulate that you have done an excellent job. And yes, Professor Mihir Goswami, you know, so he's very active. And I could see him that he is maintaining time. That's a very important. How he maintained the time. That's why probably we could finish even with such a very busy, program. Even with this very busy program, he could finish on time. So that is another, his achievement. I must congratulate Dr. Goswami for your this achievement. So with this, once again, I hope that it will be a grand success, and all the faculties and all the staff, all the teachers, all the delegates will be immensely benefited from this conference. Thank you very much for your presence here.
Just I want to make an amendment of an inadvertent error. Actually, I apologize. He's my elder brother. My dearest elder brother. I forgot to mention his name in, in the list of the Professor Anup Das. He is the state president of API. So he is most welcome. He is our most beloved person. So let us give a big round of applause.
Thank you, sir. We now move on to inauguration of the souvenir, for which I request all our dignitaries, especially our chief guest, Dr. Anup Kumar Borman, sir, to please take the lead and unveil the souvenir. Ladies and gentlemen, a proud moment. A big round of applause for the souvenir. A proud moment. Thank you very much. I now request the guest of honor of today's evening, Dr. Jyotirmoy Pal sir, to please come forward and speak a few words of encouragement to us.
Respected Professor Anup Burman, Vice Chancellor, Professor Anup Das, Chairman API Assam State Chapter, Professor Mihir Goswami, dignitaries in the stage of the dais, my beloved juniors, seniors, ladies and gentlemen. It is really a pleasure to be in the inaugural dais of Assam API chapter. Why? Because as a president, I have moved till today at least 15 to 16 state conference. But Assam, presentation of Assam, when we discuss among ourselves informally, we always appreciate the zeal and capacity of Assam chapter. So this is not because I am here, you are here, so I am telling something. I am talking based of on the evidence, based of on the records. In India at present, there is a 4 index journal and 1 from the Assam. Among today, I am attending 16th state conference. No, I see every year you publish the medicine update. No state, central API release medicine update during APICON, but no state release, even my own state, West Bengal, never release such a beautiful medicine update what you release. Last day, I was in Kathmandu. Some Indian was there. We are discussing about the scenario of medical education in India. So one person asked me, you have taken exam in so many places. Where you find the best? I told it is Assam. Because when I first came to the Dibrugarh, Dr. Anup Das sir was that time HOD. During examination, sir has not uttered a single word. And when I am giving the final marks, I ask some, what do we do usually? Sir, what to do? Sir, bola, Jyotirmoy, whatever you like, you do. I will not say anything. You do. I have nothing to say. If you think 50% will fail, fail 50%. This is the ideal teacher. During examination, I have no mercy. 3 years, I'll do everything. But examination, no mercy. You have to pass on your own. That is why Assam is improving a lot. And today, you see so many persons from different parts of the states, all have gathered, around 400 delegates, what I heard, is present in the 2-hall program is going on. So I have, and I particularly have to mention about the Vice Chancellor. I think no Vice Chancellor and ex-DME, and last 4-5 years I see, sir, in state conference, sir stay almost from morning to evening and participate like a speaker, like a chairperson, like a delegate, and go on asking questions like a students. So I think sir is unique. And if sir is on the head of the state API, definitely API
of this state will grow. I am no doubt about it. But this is not the end. We have to miles to go, because API is growing okay academically, but many things we have to do. So what I have realized working as a dean, as a president-elect, as a president, we are doing very good in the academics, in CME, conference, teaching. We have a very good clinical teachers. But in one point, an area we are lacking, that is the research and publications. So research, medical India is ahead in many fields, IT field, in defense technology, in the space technology, but not so in medical field. That is why we Indian, we form any guideline. We are heavily dependent on the Western guideline. But we have to change the scenario. That is why we need the data. I was talking with Professor Prasun Chatterjee of AIMS New Delhi, as a HOD of geriatric medicine. We were discussing about why government not accepting the adult immunization in their schedule, like infant immunization. So Prasun told, I meet with the health minister. Health minister telling where there is a robust data, because we do not keep our data. We are not so much good in our research. So API has now a research wing, and we have also allocated the fund. 15% of the profit of the last year will be allocated for the research fund. This year I have allocated almost 1 crore of money from the API. This money, we have not so much money ICMR, but this money will be introduced or will be utilized for the increasing the awareness of the student. So first I request the teacher, you do the repeated workshop of the student to teach them the research technology, because if the technology is not perfect, whatever you will research, what will publish, it will be rejected by the good journal. So teach them the good technology, research perfect research technology, make them interested for the research, and at least take some small project. Sir, Vice Chancellor sir is there, sir will help you, and take the small project, low cost project. If you need some fund, Central API will give, and some project, maybe some epidemiological project, and take this project, teach the student how to proceed with the research and publish in a journal. Now you have an index journal. So basically India is a treasure of the case report, so much good cases nowhere in the world. So that is why we have a traditional journal JAPI. Now from this month, I think you got it, this is the e-journal. Later on, we'll do the print version. That is the API case report journal that we are doing exclusively for the case series, case discussion, case report, and pictorial CME. So I request all the teachers and students, you submit your case. That submit your the API case report journal. Our very idea is in the JAPI there will be more original article, but our original article is not of same level as of the Western countries. So because our infrastructure is poor, research, particularly from the research point of view. But case report, we have so many good case report. If we publish, whole world will learn. This is the very idea. That is why from this month, November, we started new journal, API Case Report Journal. So you go on the website www.apijcr, journalofcasereport.com, and submit your best cases. Whole world, a student, a doctor sitting in USA, Canada, Australia can see how the good cases you have diagnosed. So, so writing, research and writing should be our aims and objective, along with doing the academics and this. Another aspect I also highlight, that I have realized that whatever the good work we are doing in the academics, but the API is not so much recognized at the government level, whether the state government or the central government. Many of the bureaucrats, politicians, media thinks that our conference to some extent entertainment. They do not realize that we are teaching, we are updating our members about the new advance of the medicine. Because what is happening, so organization also have do something that involves the direct people involvement. That is why I have almost told all state branches, whatever profit you will do out of this conference, spend some money for the people's benevolent activity and do some visible work, not just simple health camp. Do some visible work. I know everybody from your state, they participate in hypertension day program. All the state, all the rail station, the video that was video, you played the video in the rail station in between the announcements. Such a beautiful such a work you do, that is very visible publicly, and that will come to the media. And suppose if there is a big fair, now this year we decided, then the Calcutta Book Fair is coming, we will give a API stall there to distribute the awareness papers, leaflets, and also do the screening of the visitors who come to the book fair. Also planning to have a health camp in the Ganga Sagar, because at least 10-12 lakhs people assemble in the day of 15 January, Makar Sankranti. So on behalf of API, I told Odisha API to do a health camp during the Puri Ratha Jatra. So here also in the Kamakha, Amavasya, Ambubachi, there is a big crowd. Do a API health camp to help the people who become sick during that gathering. That in that way, if you work, API will be more visible publicly. And also another dream API have, and I think you also do, you do a API clinic. API clinic, at least one clinic in per state. We've done one in West Bengal, one in Hyderabad. Third, we are going to with Ramakrishna Mission in Baidyanath Dham. So do a API clinic. That is a model clinic. May run 1 day or 2 day in a week, and in that clinic, free of cost, all the give the specialist care to the people, particularly in the small city or town. You do it in large city in Guwahati and Dibrugarh. So many facilities is there, but small city facility is less. In a small city, maybe in Tinshukia or other small city, do a API clinic, and your physicians and specialists in a rotational basis, he gives some service to the poor people, and that will be a model. The API not only for the doing conference in the five-star hotel, API for the people, API for the mankind, and that should be our future aims and objectives. So I hope, I am very much optimistic with the activity of our member in Assam. I hope you will grow and make a model in front of the national API. Jai Hind, Jai API.
Thank you, sir. API for people, that's a very beautiful initiative, and also the academic part. Ladies and gentlemen, and respected dignitaries, in a unique initiative to protect our environment, Assam Apicon 2025 has launched the medicine update in the e-version under the able leadership of Chief Editor Dr. Kalpana Chetia and Co-Editor Dr. Ajay Peter Topno. For the inauguration of the Medicine e-update, I request Dr. Jyotirmoy Pal sir to please come forward along all our other dignitaries. Ladies and gentlemen, the card round with the scanner below, you can scan it for accessing the Medicine e-update, and you can also go to the formal website for downloading it. Thank you. Thank you so much. Yes, sir. I have already mentioned you can access it through the scanner on the card round here, and you can also download it from the formal API website. Moving forward, we now come to the address by the President, API Assam Chapter, Dr. Anup Kumar Das, sir.
A very good evening to all present here, respected Chief Guest Dr. Anup Burman, Professor Jyotirmoy Pal of Central API, Dr. B.R. Das, Principal of Nagaon Medical College, Chairman Organizing Committee of 34th APICON, Dr. Mihir Goswami, Dr. Sharad Kaut, the untiring Organizing Secretary, and also in the audience, especially Dr. Arup, who is the scientific secretary. And it's a pleasure to be here. And we had a very great time from day before yesterday on the academic exercises that we have been having here. Just now, Dr. Pal, he said that his focus is on two aspects. Number one, to go to the public, be visible that you are doing something, actually doing something positive, and research. Because from research, data will come, as I said, and the government will have to take notice of the data, and that can change policies for the betterment of the public health. I'll just give you an example, small example. About 20 years back, um, one of my gurus, Dr. Premashishkar, he told me, what are the type of acute viral hepatitis you are getting in your state? I said, sir, I'm getting hepatitis A. But he said, hepatitis A is not supposed to be the cause of acute viral hepatitis in our country. I said, why? Because there is a new virus which has come out, that is hepatitis E, and everybody is reporting that there is hepatitis E is the commonest cause of acute viral hepatitis, followed by hepatitis B and so on. I said, no, sir, I'm getting. Then he said, no, you are mistaken. Repeat it. I repeated it in some cohorts. I got again hepatitis A. Again, I told him, Dr. Sarin was also there in 2009, I think. He said, it's not possible because epidemiologically, it's not possible. I said, sir, I'm getting it. Then he said, explain it. I said, I cannot explain it because I don't know why. Then after about 2-3 years, the ICMR, Dr. Harpreet Kaur, she's a deputy director. She was the deputy director of ICMR Delhi. And she read one of my articles, or she saw probably one of my presentations in Jaipur, specifying that hepatitis A is very common in our part. Then came an ICMR sponsored a very 9 crore rupees multi-state in the northeast, all the northeastern states project, where specifically looking into the acute viral hepatitis. It came out to be predominantly hepatitis A. So now it is accepted. So that is research. It will take decades, 2 decades for one research. I'm telling you. But when you do something that is validated and it can change the perspective of that particular disease, it makes a lot of difference. So that's just a small example. So I have seen that in my tenure in the last 2 years, the standard of APICON has improved tremendously because of the participation of the learned delegates, speakers like Dr. Anup Kumar Burman. I'm not praising him. I'm saying the truth. People like Dr. Anup Burman talks about small things that makes big difference. That is the most important thing in learning. And in the national level, Dr. Jyotirmoy Pal has told you about all the activities of the API and the new visions, new approaches to conduction, rather than being a picnic for 2-3 days in the year. And one lady, Dr. Nandini, is sitting in the front row, and she is equally energetic and has got huge contribution to the publication. I mean, coming out with that publication and good ideas. So without spending much time, I know all of you are tired now, but let me tell you, it has been a very good experience, and I have learned a lot of things today, attending different lectures, and I hope it will continue from the next tenure of the new API Assam State Chapter committees. And the last but not the least, for the first time, because of Dr. Nandini and Dr. Jyotirmoy, Assam is being represented in the national level in the API because of Dr. Jyotirmoy Pal's initiative. And one person has been from our college. One person has been nominated to the Indian College of Physicians. As you know, it's an exclusively academic higher body than API, and that is my beloved brother, Dr. Prashanto Dihinia, who is the HOD presently in the AMC. I request, I understand he needs recognition for this effort because he'll be taking our problems to the Central Committee ICP directly. May I request you, Dr. Arup, to kindly please felicitate him as a token of our love. But the thanks goes to Dr. Jyotirmoy Pal. Thank you so much.
Thank you, sir. Just as sir has mentioned, we would like to pay our regards to Professor Prashanto Kumar Dihinya, sir, for being elected recently as member of the prestigious Faculty Council of API for the first time from Northeast India. We are paying our respects with a Fulam Gamusa, a Seleng Sador, a beautiful jacket, and a citation.
I'm very much thankful, Professor Jyotirmoy Pal sir, Professor Anup Kumar Das sir, as because he helped a lot in this before the counting in this long period from the May 2025 to July and up to September. They cooperated and supported me every moment, every time. Nandini Madam also. I'm very much thankful to every members, ICP members of Assam, Northeast and Eastern Zone, especially the West Bengal, Sikkim, Tripura and Assam. And all the other members who have helped me and cooperated from these, the Jharkhand, Bihar and others also, but especially from the West Bengal and Northeast. Thank you all.
Dhanyabad, sir. Now we move forward to a few words by the Secretary API Assam chapter, Dr. Pritam Bothakur sir in absentia, to be read by Dr. Rontu Bormon, Joint Secretary API Assam.
Good evening to everyone. So, on behalf of our very respected and dynamic Secretary of API Assam Chapter, Dr. Pritam Bothakur, he is not able to attend the conference because of his health issues. So he conveys his thanks and send message to the August gathering. So I'll read it. Honorable President API Professor Jyotirmoy Pal sir, Chairman API Assam Professor Anup Kumar Das sir, respected Vice Chancellor SSUHS Professor Anup Kumar Bormon sir, Principal Nagaon Medical College Professor B.R. Das sir, Organizing Chairman Professor M.K. Goswami sir, Organizing Secretary Sarat Kaut, invited guests, ladies and gentlemen. It is my honor and privilege to welcome to ASSAM APICON 2025. I express my sincere thanks and gratitude to honorable members of Nagaon branch, especially Dr. Mihir Goswami sir, dear Sarat, and Dr. Arup for taking up the challenge and the huge responsibility of hosting the conference. All of them are working very hard to make it a grand success and to make your stay comfortable. As the tenure of our executive committee comes to an end and a new committee is going to be formed today, it is time to reflect on our activities and ponder about our achievement and failures in last 2 years. Our tenure had a very pleasant beginning with the receiving the Dean's Appreciation Award at National Conference 2024 at Delhi for excellent academic activities, the credit of which actually mostly goes to the previous executives. Our committee resolved to increase the public outreach activities, and accordingly, we conducted numerous public awareness programs all over the state in various colleges, schools, clubs, and collaborated with various organizations. All the district branches have cooperated, and I am thankful all the office bearers and members for their help and support. We discussed about reviving the dormant district branches and taken up steps at the very beginning of our tenure. We kept on encouraging members to get involved with API activities more and more. Now, through the WhatsApp group, we all know how active all those branches have become, and I am sure they will continue doing the good work. We conducted 2 midterm CME in 2024 and 2 more in 2025. All these midterm CMEs were very successful and well attended. For the successful conduction of the midterm CMEs, I would like to be specially thankful to Dr. Anupam Datta, Dr. Uttam Nath, Dr. Deepak Sharma, Dr. Dharam Singh Timu, Dr. Rantu Burman, Dr. Ranjan Bhatta, Dr. Kollolda, and Dr. Deepak Da from DIFU for their dynamic leadership in making our program successful. The last annual conference of Assam API, jointly organized with ASSAM at Guwahati with Dr. Siranjita Apicon as organizing secretary and Dr. Sangeet Datta as organizing president, was a huge success and crowning glory of our tenure. Unprecedented 800 delegates registered for the conference and also record number of postgraduates participated in the conference. The outside delegates and invited guests all opined that it was of the standard of national conference. Guwahati branch of API under the able leadership of Dr. Mitali Borua and Dr. Siranjita also has taken up some commendable job initiative via API heritage series, young API series, infectious disease concept, conclave, etc. Lot of activities are being conducted by our new branches like Dhubri, Bongaigaon, and Gwalpara. Tinsukia, Tezpur, Jorhat, Difu, Nalbari branches are also very active. I am sure the judges are having tough time in deciding the best 3 branches this time. It is also a matter of pride for me as the President's Place meeting of Central API Executive was held at our state at Kaziranga. Thank you, Mr. President, Professor Jyotirmoy Paul, for choosing our state as your own place. In this meeting, the Chairman and Secretary of API Assam was felicitated by National President for outstanding contribution to the cause of API. Lastly, I sincerely thank and express my gratitude to our honorable members for giving us the opportunity to serve you. Under the leadership of Professor Anup Kumar Das sir, we tried our best to serve you and to keep the API flag flying high. But despite our best effort, if we have failed to meet our expectation, I, on behalf of the entire executive committee, apologizes for any shortcomings. I thank all the executive body members, district and city branch office bearers, general body members for their help and support. Once again, I wish this conference a grand success. Long live API, long live API Assam. Dr. Pitam Kumar Borthakur, General Secretary, API Assam. Thank you.
Thank you, sir. Ladies and gentlemen, এইবাৰ আহিছো আমাৰ তিনিচুকীয়া APIৰ সদস্যসকলে খুব সুন্দৰকৈ এখনি চমু গ্ৰন্থ তেওঁলোকে সংকলন উলিয়াইছে সুৰা আৰু সুৰাজনিত ক্ষতি. I request members of the API Tinsukia branch to please come forward and present their collection alcohol and alcohol-induced harms to our dignitaries for the formal unveiling.
Very good job, Lata.
Thank you very much. I now request Dr. Bishnuram Das sir, Principal, Nagaon Medical College and Hospital, to please speak a few words.
Good evening to everybody. Honorable Vice Chancellor of Simanta Sankardev University of Health Sciences, Professor Anup Burman sir, National President of API, Professor Jyotimoy Pal, API Assam President, Professor Anup Kumar Das, Professor Mihir Goswami, Organizing Chairperson, Dr. Sarat Kev, the Organizing Secretary. This is really a proud privilege for me to be present here on this annual conference, 34th annual conference of Association of Physicians of India, Assam chapter. As we know, that API has been taking a very pivotal role in clinical excellence and guiding us in every part of medical care. And this time, the theme which has been selected, the intelligence, health, and better outcome. So when we say intelligence health, we specifically mean that artificial intelligence, application of artificial intelligence in healthcare. As we know Copilot, Gemini, then ChatGPTs and whatnot. All these things are included and facilitate us in developing algorithm, precision diagnosis, and providing healthcare services. But what I like to bring to the notice of all the dignitaries present in the dais, as well as of the dais, that human touch is very, very important. The healing touch, and that is missing in today's world. We know many things, we do many things, we are very high tech nowadays, but what is missing, that is the human touch. With the help of artificial intelligence, we can do better diagnosis, we can develop better algorithm. But if we miss the human touch, the touch healing, then it is really very pathetic and very painful to all of us. Moreover, if we say the healthcare delivery system, it is more urban oriented. The people who are residing in the rural area, the remote area, reaching to unreached is a very, very challenging for everybody. So keeping that in mind, we should remember that artificial intelligence is a very inspiring and very timely chosen theme for the API Assam chapter, which is organized by the Nagaon branch. And I think we'll work it on further. And in these days, many discussions have been taken place and everybody has been benefited. So I do not like to take much time giving more talk on this. So I thank organizer for inviting me to this occasion. I'm very grateful and thank you everybody. Thank you very much.
Thank you very much, sir. Ladies and gentlemen, we now move onward to the moment that we all have been waiting for, and that is the moment where we announce the awards for the best API branches within our state. Before that, I would like to make a small announcement that the late Dr. Dhirendas Memorial Award for the best paper presentation will be given off tomorrow. So without much ado, I would like to announce the awards for the third prize. This prize will be given away by the President API State Branch, Dr. Anup Kumar Das sir. And the award goes to DIFU API. DIFU, members of the DIFU API, please come forward. Thank you, sir. The second prize will be given away by the Honorable Vice Chancellor of Shimanta Shankardev University of Health Sciences, Professor Dr. Anup Burman sir. And the award goes to Guwahati API. Members from Guwahati, please do come forward. Guwahati branch, please do come forward. Guwahati branch, a proud moment for all of us. Thank you, sir. So any guesses for the best branch? The first prize will be given away by Professor Dr. Jyotirmoy Pal sir, and the award goes to Dibrugarh API. Members from Dibrugarh API, please do come forward. Thank you so much and congratulations to all our winners. We shall now move on towards the vote of thanks by Dr. Horot Keot.
So it is my time as an organizing secretary to offer vote of thanks. So respected chief guest, distinguished dignitaries on the dais, esteemed faculty members, honored delegates, and dear friends. It is my privilege and honor to propose the vote of thanks on this momentous occasion of inauguration of Assam APICON 2025. On behalf of the organizing committee, I extend our deepest gratitude to our chief guest, Dr. Anup Kumar Burman sir, Vice Chancellor, Shimanta Shankardev University of Health Science, for gracing the ceremony with his invaluable insight and for formally inaugurating the conference. Your presence has added immense dignity and inspiration to this conference. I offer our sincere thanks to our specially invited guest of honor, Dr. Srimay Pal sir, President API, for his encouraging words and support. I also offer thanks to Dr. Anup Kumar Das sir, President API Assam chapter, for giving us the opportunity to organize this conference and constantly guiding us from the beginning of our preparation till date today. I also offer sincere thanks to Dr. Pitambar Thakur, Secretary API Assam chapter, for his continuous support, although he is not present today because of his ill health issues. I also thank Sunali Ghosh Madam, for Director Kaziranga National Park, for being present here. I also thank Dr. Vishram Das sir, Principal Nagaon Medical College, for being present with us. I also extend heartfelt appreciation all the invited speakers and distinguished faculty members who have joined us from different parts of our state and different parts of India. Your enthusiastic participation is the true driving force of this event. My next sincere thanks goes to the member of our organizing committee headed by our dynamic leader, Dr. Mihir Kumar Goswami sir, and our scientific committee members and all the API members of Nagaon branch. Their tireless effort over the past few months have transformed this conference from an idea into a successful reality. We are also grateful to our academic partners for their generous support, which has helped us to organize this conference of this scale and quality. I also thank API BU team, especially Dr. Narottam Sunal and Dr. Uttam Kumar Nath, and all the members for their wholehearted participation in the BU program yesterday. Finally, I thank each one of you for your presence here, for your time, and for your goodwill and commitment to medical professions. Thank you all once again. Long live API, long live API Assam chapter. Thank you.
Thank you very much, sir. Ladies and gentlemen, we have now come to the end of the inauguration ceremony. Please take a few moments to stand for the national anthem.
जनगणमन अधिनायक जय भारत भाग्य विधायक पंचांग सिंधु गुजरात विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मागे आहि तब जय गाथा जन जय मंगल गात्री जय जय जय
The meeting is declared to be closed, but I request the esteemed delegates to be seated. This event is over, but the next event, another interesting event, Ahibo, is here. So I would like to request Professor Simanto Madhav Borua to assist me in the conduction of this particular event, open house debate. No, you have to assist me. Yes. No, basically, now we are ready to start discussion and debate and also arrive at a consensus at a particular topic, at a burning issue of the day. At a burning issue of the day, that is, it is open house debate. So I would like to request the esteemed delegates to take their seats. Please take your seats. And I would like first I would like to share with the house the topic of the debate. The topic is rapid integration of artificial intelligence into the healthcare poses greater ethical threat than clinical advantage. I repeat, rapid integration of artificial intelligence into the healthcare poses greater ethical threat than clinical advantage. Those who are interested to participate in the debate, it is an open house debate. So I would like to request the interested delegates to submit their names. Sabina, yes, our active member, Oyundoti. Dr. Oyundoti Bora is here. Yes. I think Srimanta Madhav Bora, you are also here. I hope Dr. Ripun Borbozari will also be here enthusiastically. So, yes. So, I would like to request Dr. Sorup Kumar Dey to be here to participate. So, let us start with this particular debate without any further delay, without any further delay. Sir.
Sir, আপোনাৰ প্ৰথমটো এইটো আছিলে ন এইটো এইটো মই শ্লাইড দুখনমান বনাইছো আৰু ইয়াত দি দিয়া শ্লাইডটো এইটো বেছি সময় নালাগে এইটো পিছতে জিভিএম কৰিলে ভাল নেকি জিভিএমৰ পিছত আপুনি চেয়াৰপাৰচন আসন লওক আকৌ মই
স্পীকাৰ দিয়া So, responding to my clarion call, Professor Srimanta Madhav Borua from Assam Medical College, Dibrugarh, he is already there on the dais. So, I would like to welcome him. I would like to welcome him for this particular debate. Initiation of the motion. Initiation of the motion. I would like to request him to. Yes.
Honorable Speaker, sir, and the House.
Yes.
Today is August House. I would like to propose a motion in the House. That motion is rapid integration of AI into healthcare possesses greater ethical threat than clinical advantages. Speaker, sir, I would like to forward my argument with a holy slok from Srimad Bhagavad Gita. That is from the chapter 6, slok number 5. Udherada atmano atmanang na atmano namo sayodeto atmevo atmenu bondhu atmavevo ripu atmano. Meaning, one should lift self by the self, not debase self. For the self is the friend of self, and self is the enemy of self. Yes, we have to uplift ourselves. We cannot allow to deterioration. But when we have to uplift ourselves, that upliftment should not be enemy of ourselves. In the language of Dr. Bhupen Hazarika, niyom bhongaro niyom ase. There is a rule to break rule. That my opposition might say that is there any rapid integration of AI? If rapid integration is there, will it matter? Yes, sir. There is definitely rapid integration of AI. AI has brought to the healthcare system without any clinical validation, without any staff training, without any code and conduct. And nobody can verify what AI has suggested. There is a word that AI hallucination. That out of 10 references given by AI, 2 may be wrong. And more importantly, no one is accountable. Speaker, sir, healthcare is not a technological system. It is a deeply human service built on trust, empathy, and accountability. A machine cannot replace empathy. Machine cannot replace the doctor-patient relationship. Machine cannot replace the affection of a teacher.
A machine cannot replace the respect of a student, nor a machine can replace the love of a mother. Speaker, sir. Ethics in the healthcare. The clinical ethics rest on 4 pillars. That is the autonomy and consent, beneficence, non-maleficence, and justice. Amplified by ATCOM training, which stress patient-centered care and informed consent. Nowadays, even NMC is giving more stress on ATCOM ethics in the healthcare. Autonomy and consent, the patient consent to care under assumption of their data and treatment decision are handled by trained clinician within agreed limit. Beneficence and non-maleficence means clinician must aim to help and avoid harm. Justice means fair distribution of benefit and burden. Rapid AI deployment flouts these obligations. It substitutes opaque algorithm advice for informed clinician judgment, uses patient data beyond original consent and love, and worst of all, can harm entire population group disproportionately. Speaker, sir, data consent hacking problem may be always there with AI. Patient's image, notes, genetics may be stored in cloud system or shared with vendor for model improvement, often with vague or absent consent. If these stored are hacked, sensitive medical details are exposed, including psychiatric history of the patient, HIV status of the patient, reproductive data of the patient, genetic information, etc. It is direct violation of patient consent and confidentiality. Speaker, sir, models are trained on limited data. Data bias is not uncommon in AI technology. Certain groups by skin, tone, region, sex, or age may be misdiagnosed more often than this, resulting in injustice. I am giving 2 examples. Robert Williams, 2 years back, he was arrested. That was a headline in newspaper because AI misdiagnosed his faces with a thief. Another example from Assam. Dr. X from Assam was not allowed to enter Hong Kong because of AI misinterpreting his face as that of the Tibetan faces during immigration process at airport. Same thing can happen with you. Same thing can happen with all the patients. The illusion of small sample success versus mass scale real life regional variability matters. AI may perform well on 10 curated cases in vendor demo, but when it has to be translated, that model to a nation of 1.4 billion, where the diseases prevalence, comorbidity, nutrition, skin tone, local pathogen, and device type vary widely, there will be performance collapse. An AI trained primarily on Western hospital data might diagnose a set of tropical or region-specific ailments poorly because its database has no idea what a region-specific outbreak looked like. The result? Systemic injustice and preventable harm. Speaker, sir, in conclusion, I would like to say that medicine is not a beta test. We cannot allow trial run to see if software learns. We need upliftment of technology. Yes, we need. But when AI introduced too quickly without a robust regulation, it will break ethics. Will outbreak validation, consent, data security, and justice. It will not be progress, rather ethical regression. Much like giving scalpel to a trainee who skipped anatomy. For the opposition, rapid integration of AI may be an innovation. But for me, Speaker, sir, it is experimentation without permission. Until AI integration is slow, regulated, ethical, and guided by robust local data, Till then, AI will pose greater ethical threat than clinical advantages. Thank you, sir. Thank you for patient hearing.
Thank you, Professor Shivan Damodar Borwa. Next, I would like to invite Dr. Nilakshi Deka. Okay, okay. Simultaneously, I would like to make an announcement that this particular general body meeting is already progressing in the other hall. If somebody is interested, they can attend.
So, my respected speaker has illustrated how AI can be a threat to healthcare field. Now, with the arguments which he has presented, it in fact he has made my job easy, because in today's time, AI can be, leave aside AI as a threat, that is an inconceivable proposition, but AI could be a great ally. Now we know change is the only constant, and there's a huge gap between not knowing and knowing. And sometimes when we don't know things, we should step back, take a moment to learn, unlearn what we have learned wrong, and then take a moment to acknowledge AI and then decide the indispensable role of AI in healthcare field. Resilience, continual learning, and adaptation. These are the key weapons which would help uplift doctors in this field, in this resource poor field, especially in a country like India. By leaning into the discomfort of learning and not rushing through it, we become more capable of mastering AI. Now, respected, learned speaker has already elaborated about medical ethics, and I did not go through those again. So, he means medical ethics are based on 4 pillars, which is autonomy, that is respecting patients' choices, acting good for the patients. Acting for the patient's good is the doctor's responsibility. That forms medical ethics. Doing no harm to the patient, and fairness in healthcare. I think in all these fields, when we look at these 4 points, these are the points where AI can be more helpful rather than human, where there is always a chance of error. There's a saying, to err is human. Now, what is the role of AI in healthcare? Now, AI in healthcare improves diagnostic accuracy. It is faster and more efficient than humans. It can give us personalized and precision medicine. So, we are progressing from a field of general medicine into a precision medicine, where once the patient comes, depending upon the data, the genetic data, the clinical data, the past history, we formulate an individualized, personalized treatment for the patient. That is known as precision medicine. And AI can help a lot, can go a long way in addressing this lacunae which is present in our current clinical medicine practice, or for that instant, current clinical practice. AI can lead to better outcomes in resource limited settings. It can also help establish continuous learning systems, cost reduction in the long term, support, not replace clinicians. Now, the story of artificial intelligence began by the IBM's Watson. And looking at the potential, the huge potential of artificial intelligence in healthcare, companies, tech giants like Apple, Amazon, these have developed, given huge resources to develop technologies which can revolutionize the healthcare sector. Now, how has AI impacted the health industry? We look at the lacunae or the threats of AI. Now, let us go through the benefits of AI in healthcare. Now, AI has the ability to process and analyze vast amounts of medical data far beyond humanly possible. It can make more faster, more accurate clinical diagnosis, improve treatment recommendations based on the diagnosis and screening, and also data driven decision making. So, here I would like to quote a case. One of my patients who had entered menopause was referred by me to a gynecologist who did a pap smear, and it was reported as metaplasia. So the patient was referred by the gynecologist to the oncologist. The oncologist asked for a cervical biopsy. The biopsy report came as specimen inadequate, so the patient was asked for a rebiopsy and an MRI. The entire process of patient going to the gynecologist, doing a pap smear, and coming to a conclusion that the patient does not have cervical cancer took a period of around 1 month with huge resources which the patient had to bear because of 2 OTs of cervical biopsy, the MRIs which were involved. So this was a case where the initial human error in reporting the pap smear as metaplasia led to the increased cost of hospitalization for the patient and also workout eventually. Now, there is Google's DeepMind Health project, which can pick up retinopathy far more accurately than humans without any variation or bias. And thereby, we can prognosticate the patient. Predictive analysis can take up patient's medical history and current health data to predict the potential health risk which he'll have in future. Like say if the patient has dyslipidemia, if the patient has hypertension beyond these levels, which might be difficult for us in the busy OPD to determine what is the level of LDL, what is the risk he poses. Like we have those risk 10-year risk scores. So AI can do it faster, much more accurately than humans in predicting health risk and thereby help us take preventive measures to prevent such episodes, such complication. AI also leads to thus proactive and preventive cure from scheduling appointments in our busy OPD to processing insurance claims, maintaining the patient data. AI reduces the burden on the healthcare professional, not only the doctors, but also the administrative staff. And here it can be of great use in preventing burnt out. So we heard Dr. Jyotirmoy Pal speaking about conducting clinics, about having our indigenous data or guidelines, because we rely hugely on Western guidelines for treating diseases in India. So I think in both these fields, like having a clinic in a huge religious congregation like Ambubasi or like Mahakumbh, where we have a very poor doctor to patient ratio, which will consume huge human resources to convey, to communicate to such crowds in such, I think AI can be of help in doing the early screening, which could then be supervised by a human doctor. So there AI can help penetration of doctors amongst masses, would also make API more visible to these huge religious congregations and maintaining data. There's no debate that machine AI can keep data, preserve data, analyze data, store data in the cloud much, much more better than humans, which could be utilized in formulating our own guidelines, having our own individualized treatment protocols rather than relying on Western. So Jyotirmoy Paul sir has actually made my job easy. Now, in cardiovascular diseases, there are now AI technologies which are involved in stethoscope, which with the use by a doctor in a remote village, he can pick up heart failure, he can pick up valvular diseases, ECG can be read, and you can also get an idea about the echo findings with the single stethoscope hearing, just putting the stethoscope to the chest. So you see how AI has transformed healthcare facilities, healthcare outcomes. Tools are also being developed to screen patients. X-rays, MRIs can actually be read to pick up cancers at a very early stage, like breast cancers, lung cancers, colon cancers, cervical cancer cases, as I mentioned, which can be picked up in very early stage before they even come for human recognition, to be picked up early and treated early in the course. Clinical documentation, administrative efficiency improvement, we have already talked. AI like Dragon Capilot can help draft referral letters in hospital, after visit summaries, and evidence-based clinical notes, which can go a long way in teaching our students how to evaluate a case. The mental health field is also being explored by AI, and there are now AI tools which can actually interact. So we are not talking about AI as just software tools which screen. So AI can be interactive and they can talk with the patient, they can interact with the patient to actually uh, offer therapies for mental health issues. There are AI models which can predict the onset of diseases like Alzheimer's, kidney disease much earlier than the patient develops the symptoms. In a country like India, the high-tech city, Hyderabad, it is piloting an AI-based cancer screening program where patients are screened with AI for oral, breast, and cervical cancer to address radiologist shortages and improve the early detection. So that is there in our country, speaker sir. So we are talking about AI, which is not confined to software tools, but expanding into interactive agentive systems. Collectively, these advances show that AI is rapidly becoming embedded across the entire health spectrum, from research labs to clinics and mental health services also. As adoption increases, as our understanding of AI increases, we should also try and make AI facilities available in rural areas, remote areas, so that the facilities of AI to the patient are also incorporated, or these are also received by people who cannot afford high end cities. Finally, just like there are rules for each procedure, so as speakers had said, that you don't have data privacy, there are data frauds. So haven't we had data frauds earlier? Don't we have banking frauds earlier also? So that does not refrain us from the ease of doing online banking or internet banking. Can anyone raise hands? How many of you have actually gone to the bank to deposit your banking draft or to transfer money to other individual? We all believe that we do it at the click of the computer. So that is how AI is indispensable in our day-to-day lives, and that is how AI is indispensable in healthcare system. As AI in healthcare becomes more powerful and pervasive, so we should not refrain or shy away or run away from using AI. Rather, we should come up with policies, we should come up with guidelines around data privacy, liability, validation, bias, and transparency to protect the patients while fostering innovation, while embracing innovation. So, innovation comes with personal care and guidelines. So, in short, we have seen from these slides that AI in healthcare holds tremendous potential. Through careful adoption, robust evidence generation, ethical oversight, ongoing education, learning, relearning, we can carefully harness AI's transformative power to improve lives of our patients at a lower cost, decrease the healthcare cost in a country like India, which is struggling in the healthcare sector because of the increased cost of hospitalization and patients paying out of their pockets because someone getting caught in a routine ultrasound that the patient might have breast cancer. So we may take preventive measures early rather than the patient having metastasis, increasing the cost and shortening the life. So AI can be used to improve lives, streamline clinical workflows, maintain data, formulate guidelines in our own country by maintaining guidelines, by maintaining the data in a huge country like India, and usher in a new future in healthcare by a patient-centered and a data-driven, clinical evidence-based system. So I would rather rest my arguments saying that AI would rather reinforce the concept of medical ethics, which is gradually being forgotten, into daily clinical practice across all geographic variations. So it would more sort of make it uniform. So with that note, I rest my arguments.
I would like to invite the next speaker, Dr. Rohindra Tebara. I hope that you will be brief, considering the time factor.
I'll be within, I think so, 5 minutes. I Jyoti, yeah. More Korean. Uh, Good evening, everyone. Respected speaker, sir, and audience. Well, I must say I'm after two good speakers, but Nilakshi Vaidya made my job very easy. You see, the point was rapid integration of artificial intelligence into healthcare system poses greater ethical threat than clinical advantage. We're talking about a threat. And I'm for the motion. Now, Nilaki Baidu said that there is like eco available, this available, that available, whatnot. But Dr. Valentin Fuster, who is the boss of JACC, he is one of the main brains behind everything that is happening in cardiology. He says technology is available, but the head must be also available. And I'm sorry to say that we are having a theme called intelligent healthcare for better outcome. Intelligence of what? Human beings or AI? So there was actually a paper, Nilakshi Baido, where it was written that the stethoscope is dead way back, I think so in 2018. And Dr. Fuster gave a rebuttal with 10 examples that the stethoscope is superior to the echocardiograph. It is available in the internet. And I would say AI is dulling our minds. It's dulling our minds. This is a recent Harvard paper, and this is a recent study. And they have seen the critical thinking of human beings is gone. This is a published study. Critical thinking, why it is gone? Everything is in ChatGPT. I went to ChatGPT and checked what it would say. And ChatGPT has become very clever these days. You see, I asked, is it true that this is going to be a problem? And then said, well, that is a valid concern. So it is showing some degree of sympathy for me, but it knows that I have become very clever. I'm giving this answer, so you be happy about it. What is happening in the world is very worrisome. This is a scientist named Cookley. He is in Google, and he has this program made which is called as AutoML. Now, AutoML is something which can develop AI programs which effectively will have zero input. Okay, so AI is evolving that much that it will develop its own programs that there will be zero input. And the classification of the AI autonomy levels, if you see, this is a published paper. You can see level 3 and 4. There is no decision by the human beings. It's worrisome. It is worrisome because we learned to stand up from a crouched position and we are crouching back. We have crouched back to the internet, to the laptops, but somebody is standing up. And this is seen because in hospitals, in large corporate hospitals, there is a virtual assistant who is giving all the answers that is being asked by the patient. It seems very helpful. If suppose there is a patient who is 90 years old and the feeding is that I have heart attack, and then the AI, if by mistake would say you need a CABG in a 90 years old patient, well, the AI is AI, it will follow. Because this preceding slide, which also showed that there is an autonomy that is being created by itself, it will say follow the guidelines. But here we are about ethics. Ethics is from the human brain. It is the moral quotient, it is the emotional quotient. It has so many things. We change our thoughts from here to there. God forbid if this takes over, there will be a very, very difficult time in managing things. Healthcare is always imbibed in two things, ethical and legal. Both are together, and we all spoke. Everybody spoke autonomy, beneficence. Baido spoke. What is autonomy? You ask this 90-year-old patient, would you like to undergo a CABG? And the AI says that you have to undergo CABG. Imagine the condition that will happen. Are we doing beneficence? Are we doing good for that patient? Absolutely not. This patient is not going to live for a very long time. And non-maleficence, no, I mean, said this is just wrong. There is no justice in it. It cannot be justified. And this I'm saying because AI is evolving and there may be something which can cause these guidelines to tweak. We never know. And where is the empathy of it? We have talked about guidelines speaking about empathy. So, will the AI have that empathy? Is it so? They will say, I'm a virtual assistant. Ask me anything. I'll say, you just cannot be, because we are moving back to something which is they want us to talk, to get our pulse, to get their pulse felt. Okay? Because if the virtual robot is taking up, then who will do this? And suppose there is a mistake, whom to blame? Can we say that, Speaker sir, can we say for sure that this is AI who is taking the decision or was supporting? Whom to blame? Well, there is a new Digital Misdiagnosis Act 2024. Do you know about it? Of course not. Because this is not there. This is created by the AI. This is what is happening. Why it happens, do you know? Because there is data leakage. What is data leakage? There is so many data that is fed up into the system. AI is nothing that you are feeding with so many data, 1, 2, 3, 4. Suppose it feels, I don't want number 3. I'll just feed with number 2. And this is what we end up. God forbid if you have a patient of an acute MI with an ST elevation and the treatment is not tenecteplase and something else. This will happen. Well, I'm here speaking today. So a photo of mine. I mean, say we are quite happy to meet each other. We are people. But then you never know. This might happen after a few years. There is no APICON. People are here. We will talk about ethical rules. Where? I raise my case, sir. There's nothing to debate about it.
Thank you, Dr. Arundhati Bora. I'd like to invite the next speaker. I think he's a very senior doctor, Dr. Ripun Borbajari. He will have to speak a few words on this particular topic. The burning issue, hot topic. As the temperature outside cools down, the environment inside the hall, the temperature here, it hots up with this particular burning issue. So I hope that we will be able to conclude soon. But the thing is that let us listen to our esteemed speaker.
Debate tomorrow. No, it's not good. Debate. Itu dia. Itu nalage. Ini sample presentation goite presentation itu nalage. না লাগিব তুমি প্ৰেজেন্সৰ স্পিৰিটটো নালাগে এনেই জাষ্ট চিম্পলি হেৰি কৰি দিয়া ক'ত গ'ল এইটো প্ৰেজেন্টেশ্যন ভিউটো কেলে আহে I don't want the presentation view.
Speaker, sir, and the House. 2 or 3 days back, I was a little disturbed by news that the senior citizens of India are responsible for increasing amount of AIDS and HIV. Really surprising news. So I retrospect 20 years back. Did I do any mistake in my life? How the elderly people like me are responsible for increasing amount of AIDS and HIV. Then I asked ChatGPT, is it a fact? It says, yes, it is a fact. And it's true, not only in India, all over the world. Can you please review your statement I don't feel it's true. It says, no, it's true. There are increasing amount of hearing aids, organ aids, aids to the children, so and so. Even hearing aids, then your hair aids. And it says SIV, hair is vanishing. So this is the reply from ChatGPT. So that doesn't mean that I'm supporting the motion, I'm against the motion. Because number one, ChatGPT or Cross, this is not AI. This is killing people. AI, we are making AI. What is AI? This is a man-made instrument of ours, whatever it is. And it all depends how the data we put, how we select or select the people to represent a particular data. So that all happens. If we put something in wrong, then AI will give the wrong answer. It's not that, but the thing is that there are triple aim of healthcare is that improve experience of care, improve health of the population, and reducing per capita cost of healthcare. So how does AI help us to these goals, to reach this goal? Firstly, I must confess I agree with the treasury bands, but on Dr. Simon Madhav, on one thing, using LLM like ChatGPT and Cross in clinical settings to type them symptoms and signs and ask the AI to diagnose and give the advice how to treat the patient is absolutely wrong. I do agree. And considering the tendency of such tools to make mistakes, they call it now hallucination, as they call it. Mistakes, uh, the specific type of AI used in healthcare is not ethical. I must admit that. Where my views differ from those sitting in opposition rank is that they think it too narrow. I implore them to broaden their minds and not throw the baby out of the bathwater. So AI is more than commercial sandbox, and AI in healthcare is not just jotting down findings into a chatbot and asking algorithms for advice. AI can act as a character model to train young doctors or medical students to break down bad news and explain procedures. They can therefore train young doctors to practice what is most important, the ways of communicating, how to communicate with the patient. AI can improve the communication skill of the doctors and all other medical profession. So you have heard of the e-Sanjeevani. It's now running all over the. When the remote areas where doctors are not available, what a non-medical person can record this complaint, a little bit of symptoms and sign from the patient, and send it to the e-Sanjeevani. They are the expert doctor. They verify it and come to a justification that this could be the probable diagnosis, and at least the time matters. When saving a patient urgently, the time matters. And that time coverage is given by AI only, not the human. Even somebody with acute chest pain, if the cardiologist cannot reach in time, it doesn't matter. The patient will go. So one more thing is more likely to common between me and the members of the treasury is that we do not know properly what the standard deviation of a population is and how to calculate it. Because statistics is as far removed from our usual field of expertise or curriculum too. What is the p-value? Most of the doctors did not know. Even I do not know properly what is p-value. So these are the aspects we need to cover while educating the students. And I'll use specific example of screening the diabetic retinopathy because this is the most data available on diabetic retinopathy detection by AI. AI-based screening as compared to the human screening, while different studies have shown the different results comparing AI and human screening, the use of AI with human oversight and supervision has been found the most cost effective.
So cost effectiveness is, however, a double-edged sword. I must agree. It can be used to mistake healthcare people. Remember the words of Bob Dylan. Admit that the waters around you have gone and you better start swimming or you sink to the bottom. This is the situation now because you have to run with the air. Otherwise, AI completely will be taken up by uh, the big farmers and other companies, and they will manipulate in a such a way that doctors do not have anything to do further. So AI is essential, but in a different way. This I have told. So Gulf portal like Sanjeevani, AI can help biostatistics too, and reducing parallel to healthcare. The most important one, an unaffordable healthcare is inaccessible healthcare, most relevant in India. And inaccessible healthcare is equivalent to zero healthcare. So AI essential. It's an aid to the doctors, provided you don't go for the quick uh, the LLMs like ChatGPT, Gauss. If you use AI in a proper way, it will help definitely. And if you do not use the companies, the money earning companies that will be taken over, they will use AI in such a way that you cannot do practice in this chamber. The people will find AI, find their own diagnosis and treatment. And that is the most dangerous part. So we have to cope up with AI. You need to learn and make sure that those who are money making companies or big pharma, they cannot suppress the expertise of the doctors in general. Thank you so much, sir.
I don't have any presentation, respected speakers,
yes,
and I'll not take much of your time. Basically, I'll let you keep on guessing whether I am against or for, right? Me and Nilaksi works in the same organization, which is a India pioneer in AI implementation in healthcare. So I can understand Nilaksi's enthusiasm about AI. I want to start my 2 minutes deliberation with a quote from my mentor. I'll not name him. He once said, if you feed garbage to AI, you will only get garbage. There is an AI race all around the world in almost all sectors. Why we cannot blindly integrate AI in medicine, in medical field? Because we are dealing with an imperfect, ever-changing science. Any information, any data we are going to feed to AI is going to change next month or the very next year. How many times you will keep on changing the AI algorithm? AI is not, and in its current form, AI is not fit for medical science. We don't have a permanent, concrete, fixed data to feed AI algorithm and then expect it to deliver us all the good results. I mean, we are standing here to discuss about the ethical consideration, why it is ethical and not. In the first place, I am not saying AI is going to be that much helpful for us. It's not going to be only limited to ChatGPT. Today, ChatGPT is giving us this things, test. Tomorrow, another diagnostic test will come. It will automatically change. Can we have that simple mechanism in our day-to-day medical field? No. AI has much more practical implication in medical field. I am not against AI, but here I'm against AI so far as its integration to the medical field in current form, and that too rapidly, if it is integrated, it's not only going to violate many ethical aspects, which already my previous lecturers have already spoken about, but there are other further implications also. I am telling you another point. Who are making all the AI tools to be used by us? Are they doctors? Our care is patient centric. But God knows their care is profit centric or patient centric. I'll end my deliberation including only these 2 points because rest of the points are discussed earlier. Thank you.
I hope that he is the last speaker. Yeah.
I'm Dr. Uma. I'm currently practicing as an oncologist at Dibrugarh Cancer Center. We have been using AI for last 2 years. We give all the data for our all new registration patients to the AI. They give us a summary. It's act as a data keeper also. Keep following up the patient also. But the decisions, whatever they take, they don't deliver it to the patients. We only the doctor used to tell the prognosis and everything. So till now there is no problem with us. We are using it for last 2 years now. We have the data also what we have done in the last month, last 1 year, last 2 years still. We our we also compare the decisions of the AI and the doctor also, and whether the decisions are according to the guidelines or not. We have all the comparative data that might be published in few years to come. Thank you.
Thank you. Now I'd like to request Dr. Simanta Madhav Borua, Professor Simanta Madhav Borua, to summarize, since he has initiated the motion. So it is his bounden duty to do the needful.
Thank you, Speaker, sir, the giving opportunity to come back to the stage again. That first of all, I am feeling very much pity to the opposition members, and mainly because they have not understood the topic properly. In the topic, in the very first, I have told that I am not against AI. Our treasury bench is not against AI. Yes, we need upliftment. We have to go with modern technology. But the way in which the AI is introducing to the medical profession, that is the rapid integration. We are opposing that. Before entering AI to the medical profession, need a accurate law, ethics. There must be staff training. There must be that code and conduct must be there. In AI generated, our respected one of the speaker of the opposition bench has told that AI can help in diagnosis of the biopsy. Yes, he has given example of cervical metaplasia that giving by AI. But who will be responsible? Who is accountable? If the party has go to the court, who will be accountable for that AI generated report? That is the question. Nobody is accountable. That law has to be framed first. Before introducing AI so rapidly, law has to be framed first. Secondly, that if the future generation become more AI dependent, more ChatGPT dependent, gradually our brain will be by after 100 years or 200 years, after 1000 years, the brain will be gradually atrophied. That because of like the lengthening of the neck of giraffe, one day after down the line, after 1000 years, the human generation, that the brain will be atrophied. That ethical issues related to the AI has to be addressed. We are not, they are wrongly interpreting, they are giving all that the opposition base, they are telling the advantages of AI. We do agree, there are a lot of advantages with AI. We are not nullifying that advantages of AI. But our point is that before introducing AI in the so rapid way in the healthcare profession, we have to that from the base first, that the ethical issues has to be cleared. Thank you, sir. Thank you.
So thank you, Professor Borua.
So, Neelaksi would like to say some few words. Let's just summarize. Just brief.
So as mentioned in my proposition, I said AI is not to be operated by itself. I made it very clear that we have to have proper guidelines, humans who are formulating those policies and guidelines, and it has to be
Yes.
under supervision because we are in the phase of learning AI. As Nokia CEO had once said, that we did not lose because we did something wrong. We lost because we did not adapt to the change. So that is what we wish to say, that if we do not adapt to the change, like we are not using notes, currencies rampantly. So my learned opponent has mentioned the word rapid. But let me reiterate, reinforce the fact that in healthcare system, rapid word is the bottom line of treatment. We have to be rapid in saving lives. We have to be rapid in passing on the benefits of AI to the huge majority of patients and not deprive them from something which we know is right. Again, my learned opponent had also mentioned that AI can give wrong diagnosis in a 90-year-old gentleman to advise for CABG. Here I would like to state that it is the prompts which we give for AI. So, hence, the need for us to integrate, to adapt to the change that is revolutionizing the present. So, it is the prompts which we give to AI that would give us the correct answer. And in a country where initiation of a life saving medication like statin requires a lot of counseling and 60% discontinue. So, some 90-year-old gentleman having the knowledge of using AI and taking an advice from AI to undergo a CABG procedure is a far fetched dream. With that, I would like to rest my arguments.
So thank you. Thank you, my dear participants, and also the audience who are here till this late in the evening. So actually, what I would like to summarize from this hotly debated topic, that as it has been mentioned in the Srimad Bhagavad Gita, change is the only constant, which was echoed by none other than our ex-president Kalam also. So change will be there. Changes will be there, definitely. He wants to say, oh, so, but it should be regulated or no verdict. Actually, I want to solicit from the house. From the house. So I want to raise the hands. The number is less, but it does not matter. Quantity never matters. It is the quality. For the motion, raise your hands. For the motion. For the motion. 1, 2, 3, 4, 5, 5, 5, 5. Joking. Joking. 5. Against the motion. Against. 1, 2, 3. Dara dukhana tulise. 3, 4, 5, 6. 6. Yes, 6. So 7. I lost the buzzer. So everybody wants sense. No, actually, speaker should be neutral. Neutral. Yes. Yes. হেৰি দিব পাৰি এটা কি বুট বুলি কয় এটা আছে মানে প্ৰভিজন এটা আছে যদি ইকুৱেল হয় দিব পাৰে that has got a name. I forgot actually. তুমি তোমাৰ মনত আছে নেকি এইটো জিকি যায় ইয়াত ইয়াত সেইটো বহুত নাহে So anyway, it was fun, but it was a trend-setting event. I would like to thank you profusely, all dear participants and dear delegates. আৰু এটা event আছে not here.
আৰু এটা থেংক ইউ নীলাক্ষী এণ্ড থেংক ইউ অল তোমাক সকলোকে ধন্যবাদ জ্ঞাপন কৰিছো সভাপতি এখনৰ পৰা তুমি আছা আমাৰ প্ৰিন্সিপালো আছিল চ' আৰু এটা ইণ্টাৰেষ্টিং ইভেণ্ট আছে ডেট ইজ এট দ্য ভেনু অফ দ্য বেংকুৱেট সেইটো হৈছে জোনাকী মেল সাহিত্য অনুষ্ঠান চিকিৎসকৰ সাহিত্য অনুষ্ঠান গতিকে মই সকলোকে তালৈ আমন্ত্ৰণ জনালো যদি কোনোবাই নিজৰ ৰুমত গৈ ড্ৰেছ চেঞ্জ কৰি আহিব বিচাৰে দেন দে কেন ডু দিছ চেম চ' এতিয়াই ৰাইট নাও মানুহ নহয় তাত হ'ব তাত হ'লে জুচটো আৰু বাঢ়িব নহয় এই তোমাৰ য'ত বেংকত হৈ আছে বেংকত ভেনুত হ'ব জিবিএম সেইটোত সেই নেক্সট ৰুমটোত হৈ আছে তাত আমি গৈ আছো সেইটোত হ'ব ফটো চেচনটো থাকি গ'ল